Madam Administrator, are we ready? Webinar is now streaming. Good. There we go. There we go. Good morning, one and all, to the latest edition of the Public Health Committee's public hearings. I am State Representative Jonathan Steinberg from the 136th District of Westport, here with my co-chair, Senator Anwar, our esteemed ranking members, and all the hardy, determined members of the Public Health Committee. We are here today to hear testimony on 15 bills, including some pretty significant ones relating to opioid addiction, suicide prevention, vaping addiction, and a number of other medication-related bills. We afford everybody who testifies before this committee roughly 3 minutes. We'll give you a reminder when that 3 minute is concluding. We give a little extra leeway to the agency commissioners who are presenting, particularly on things that relate to bills that they originated. So without further ado, I'll hand off to Senator Anwar for a good morning.
Good morning, everyone. Good morning, fellow members of the Public Health Committee. It's good to see each and every one of you. Thank you for your commitment to making sure that the public health of our state continues to get better. And thank you for all the people who have signed up. And just as a reminder, we have multiple meetings that are happening simultaneously. So you will see people pop in and out because of multitasking. There is a public hearing for at least 2-3 other committees, and many of us are members of those committees. So you will probably see us intermittently. We will listen and read all of the testimonies, but thank you, Mr. Chair. Looking forward to learning from the community.
Thank you, Senator. It's a good point. You know, everybody out there should realize they're getting more out of each of their legislators these days, because we seem capable of being several places at once, which was not true before. Whether that's ultimately a good thing is for you to decide. Over to Senator Wong. Good morning.
Good morning, Mr. Chair. And indeed, it seems like deja vu all over again. But I respect the fact that every single bill that we raise is important to someone. So as much as we may be in and out of different committees, we're going to be reviewing testimony. We will be able to see this on tape review at the end of the day. Glad to be in the Public Health Committee. Thank you, Mr. Chair.
Thank you, Senator. Good morning, Representative Pettit.
Good morning, Mr. Chair, and good morning to our testifiers. I would note that my list shows 159 people signed up. So perhaps if you're unfortunate enough to be number 101 and you agree with the previous 75 testifiers, you can say that you agree and you can take a look at my testimony. So be brief, but get your points across. Thank you, sir.
What a brilliant idea for everybody to contemplate. I do not see Senator Summers anywhere. Maybe she'll be joining us later. In that event, let me see if I can pull up who's number one on the list. Yes, here we go. The first hour is devoted exclusively to elected officials and agency heads. Number one up is Nancy Navarrete, our commissioner from Demas, with, I imagine, Vanessa Durantes, who, no, I'm sorry, she's the Department of Children. She's coming at number 2. So, commissioner from Demas, followed by commissioner of DCF. Good morning, Commissioner Navarrete.
Good morning. Good morning, Senator Anwar, Representative Steinberg, and members of the Public Health Committee. I am Commissioner Nancy Navarrete of the Department of Mental Health and Addiction Services. Thank you for the opportunity to provide testimony on House Bills 5419, an act concerning the Department of Mental Health and Addiction Services recommendations regarding regional behavioral health action organizations, and 5430, an act concerning opioids. The work of the Regional Behavioral Health Action Organizations, or RBHAOs, is a valuable cornerstone of the DEMAS system. The RBHOs are organizations created by the merging several years ago of the 14 Regional Action Councils, or RACs, and the 5 Regional Mental Health Boards into entities that report local behavioral health needs to DEMAS. The RBHOs have adopted the functions of their predecessor organizations. The 5 RBHAOs are grassroots organizations. Members of these organizations amplify the local voice to DEMIS and assist with DEMIS's behavioral health strategic plan development to reflect the input of community stakeholders. The combination of the regional mental health boards that focused on mental health and the regional action councils that focused on substance use prevention accomplished 2 goals. They created community agencies across the state that focus on integrated behavioral health rather than perpetuating a bifurcated system addressing mental health or substance use. Combining the agencies also achieved fiscal efficiencies. DEMIS works closely with the RBHAOs via monthly meetings with the DEMIS commissioner, myself, and my executive team, quarterly resource link meetings, and bi-monthly grant administration meetings, achieving bi-directional communication. We believe codifying the current regional behavioral health action organizations is an important step in breaking down the substance use and mental health silos, so we respectfully request passage of HB 5419. As you know, DEMIS is the state substance use treatment agency and has been using federal and state dollars to implement evidence-based prevention, treatment, and recovery practices to address the national opioid crisis facing our state. In an effort to mitigate opioid addiction and resulting overdoses, DEMIS has trained providers on medication-assisted treatment, distributed Narcan broadly, and funded outreach to communities. DEMIS has worked creatively with providers to meet people where they're at with mobile MAT or medication-assisted treatment, street outreach, 24-hour treatment hotlines. DEMIS offers a continuum of person-centered opioid use disorder treatment, including outpatient, residential, and inpatient care services. We work with the recovery community, one of the best resources available to address addiction, and we fund recovery coaches to connect with individuals presenting with addiction issues in 20 emergency departments. Recovery coaches are individuals trained to guide and support anyone who would like to enter or sustain long-term recovery. The recovery community is active throughout the state and often connect with each other at another one of our resources, the recovery centers. DEMIS fully supports Section 2 of HB 5430. This section addresses harm reduction by legalizing the drug testing applications by individuals who may use harmful drugs. The federal government allows the use of fentanyl strips as a safety measure by individuals using opioids. Modifying state law to mirror the federal law will allow DEMIS to utilize federal funds for fentanyl test strip distribution, potentially saving lives. Section 3 and 4 remove the requirement that a pharmacist receive appropriate training by the Department of Consumer Protection prior to prescribing naloxone. DEMIS is concerned this section removes an avenue for continued education related to the use of naloxone. While Section 6 appears to increase the access to methadone, the language in this section does not actually increase access and is not necessary. Section 6 appears to attempt to codify potential changes to the federal law. DEMIS is happy to work with the committee on clear substitute language if there is an investment in this section of the bill. Section 7 of this bill is unnecessary as the legislatively mandated DEMIS triennial report, which we will be doing again this year, provides information on all levels of services available across the lifespan, 0 to 99. The report described in this section would strain limited resources at the department and be duplicative. Section 9 establishes a parallel process to the already robust information sharing occurring at the state level, spearheaded by the Alcohol and Drug Policy Council, or ADPC. The ADPC has the expertise to continue the efforts outlined in this section. DEMIS does not have the resources to implement the parallel process envisioned in this section. Thank you so much for the opportunity to testify on these bills. The testimony submitted by DEMIS expands on my brief remarks here, and I would be happy to answer any questions you may have regarding this testimony.
Thank you, Commissioner. I'll start off with a couple of questions. First, with reference to 5419, the regional behavioral health organizations. You mentioned that codifying is extremely important. How is it going to make a difference, and how will it affect the challenges you've had adequately funding these organizations to the full extent of their abilities in terms of prevention and monitoring other programs?
Thank you so much for that question. We are highly invested in the RBHAOs. They're funded at approximately $1.569 million, and that's been pretty stable over the past handful of years. Certainly, as any opportunity becomes available through discretionary grants, block grant funding, we always look to key partners like the RBHAOs to continue to invest in that important infrastructure.
Thank you for that. We're hopeful that they're going to continue to play an important role going forward. And thank you for your comments with regard to the opioids bill. I think you can sense that this was our good faith effort, given the extent of the problem, to put every good idea into legislation. I can't say I'm shocked. There are some things that we need to reconcile, and we look forward to working with you to make sure there's not a necessary duplication or inefficiency, and certainly that we're in conformance with the federal code as well. So we appreciate your input, as has been every year, unfortunately, since we first identified the opioid crisis as one we needed to address. So more conversations coming, I believe. I see Senator Anwar has a question, followed by Senator Wong, followed by Representative Parker.
Thank you so much, Mr. Co-Chair. Thank you, Commissioner, for your testimony. I'm glad you also like the idea about the fentanyl strips. That's been a challenge for all the clinicians who have been managing the illness, and the cost of the fentanyl tests have been quite high, and then this strip is actually reducing the cost and giving the answer right away, so it helps in the management. So hopefully once we pass this bill, that's going to allow our clinicians to manage some of these patients much more efficiently and have the legal protection as well. To your comment on 5419, for benefit of the community and the people who are listening, would you be able to tell the difference between the regional mental health boards and the regional behavioral health organizations?
Sure, thank you for that. So back in 2017, the organizations were split. And as I mentioned in my testimony, one group of organizations was focused solely on mental health, and one set of organizations was focused solely on substance use. They really are a resource link for us out in the municipalities, communities. They fund local prevention councils. They evaluate programming and gaps in services out in the communities, bring that information back to us, put together valuable priority reports for us and bring that information back. But it was done in these two silos. So by bringing them together, I know this is a priority for myself, is to really focus on integrated care and to focus on the behavioral health system, which is inclusive of both substance use and mental health.
Thank you so much, Commissioner. Thank you, Mr. Chair.
Thank you, Senator Senator Wong, followed by Representative Parker.
Thank you, Mr. Chair, and thank you, Commissioner. It's a little bit of a sideway question. The school-based health center expansion working group just filled out and completed their work group study. We had the public health, we had social services, we had education. One of the things that I missed, I thought, was Demas in that. Did your office have any interaction with the school-based health centers, and will your services be somehow integrated in some of their recommendations and interactions in regards to mental health, substance abuse, supportive services?
Thank you for that question. School-based mental health is usually 18 and under, and so that really would fall under SDE and DCF. Demas serves 18 and older, so we would focus on adult services. So I would imagine just in terms of referrals and transitioning youth, we would be involved, but not so much on the ground level with implementing school-based health centers, which is reimbursable through DSS. So they would have an investment and probably licensed under DCF.
Thank you for that clarification. And what about our colleges then, in regards to 18 and older, that you would have a purview with? Is there an established relationship or dynamic with our college and community college and vocational technical programs 18 and over?
A lot of that intersection comes under our prevention department. So our prevention services, our lifespan services. And in that way, we are involved in lifespan. We've done a lot of work with UConn in terms of recovery-friendly campuses, for example. They have shared a lot of that information with us. It's really a promising practice for students who live in dorms on campus. That's one example. There is some funding that goes out to campuses and colleges to amplify this message of prevention and safety and good choices. So in that way, we are involved with young adults.
Well, I appreciate that. Is it predominantly the Board of Regents and UConn, and does it include our independent colleges, but also our community, our vocational technical programs? Will it engage the funding and supportive services, reach out to them as well? Or is it exclusively with the Board of Regents and UConn?
Much of the work would probably fall in the private sector. That being said, our prevention arm is very strong. And so any messaging through prevention, whether it's around smoking or vaping or cannabis or any substance of use or misuse, we would be getting that message out broadly. So it would be very inclusive. In terms of treatment services, there's a small population that would fall under DEMIS, which would be the uninsured, underinsured, or folks with serious mental illness or serious substance use. So a chunk or a cohort under the broad cohort of behavioral health would fall under DEMIS.
Thank you. And I appreciate the answer. And for me, I'm appreciative of the work that your organization does. And I just wanted to be sure that that service and expertise is reached out to a significantly needed population that may just fall in between the cracks. And we want to be sure that your expertise is made available to them. So thank you, Mr. Chair, for the indulging questions. Thank you.
Thank you, Senator.
Thank you,
Representative Parker.
Thank you, Mr. Chair. Thank you, Commissioner. It's nice to see you this morning.
Good to see you.
I want to thank you, you and your team and colleagues at other agencies as well for all the conversations over the last few weeks and months as we've tried to build this legislation and really appreciate the feedback at the time. I wanted to just ask a few questions about some of the comments you shared this morning. Certainly thrilled that there's a lot of strong pieces in this, and hopefully we can move those forward. And then just to sort of get a sense of some of what you referenced that might not be that helpful in this bill, just wanted to start with section 3 to 5, which was intending to help increase access to naloxone. You made the point that the training that's in place is really important, and I totally trust that. I'm curious, can you speak to, and because this is maybe getting at if this is a problem that needs to be solved or not, can you speak to the sense of pharmacists that are actually trained and registered to be able to dispense naloxone? Is it actually quite high as it stands, or is there a gap that we need to try to fill there?
Thank you for that question. I would refer to the statistics on that to my sister state agency, Department of Consumer Protection, because they probably have a better sense of that than I do. I can say anecdotally, I am not hearing that that's a barrier, but they would have the data on that. Okay.
Awesome. Thank you for sharing that. This also might be one that you'd say we'd follow up with DCP on, but going down to section 6, which was about sort of where we stand with regard to the federal methadone waiver, which is allowing a greater period of days for prescribers to give take home to patients. And we had tried to put in some legislation that was going to codify what has been, I understand, during COVID-19 and potentially going forward, a 28-day period. And certainly to the point about maybe incorrectly codifying what's in federal law, especially if it's preemptive or what we, so what we think would go into it, that makes sense to me. So I just wanted to ask if the federal policy changes and potentially it's sort of formulated as, hey, this seemed like it worked during COVID-19, let's go ahead and codify 28 days of take-home methadone for stable patients. If we don't do anything to change our laws, is there anything in place of allowing Connecticut to immediately follow that policy, or will it just mirror that and we'll go ahead in that fashion? Does the question make sense?
Yes. So
Yeah.
usually there is a process involved, but absolutely, Demas and Connecticut in general has always been very progressive, and we have a very strong substance use continuum, including our access to methadone. So whenever we were right on board through the pandemic to be able to give people a lot of flexibility, and we would be right at the front of the line to implement any changes that were approved at the federal level.
That's awesome and really reassuring. Thanks for sharing that. You just referenced two other sections, so I just want to ask about those briefly as well. To section 7, which had contemplated a report about the sober home voucher program specifically, certainly appreciate the opportunity to bring that into the triennial report that exists. I'm just wondering if, and this is sort of off the cuff, but because this had come up and I know some of my colleagues here have really worked hard on this program, can you speak briefly to sort of how that voucher program for sober homes is working right now? And just, remind us of the existing structure for how that will be shared with the committee so that we can make sure we're supporting it as best as possible.
Sure. So Demas contracts with an ASO, Administrative Services Organization, that's Advanced Behavioral Health, or ABH, to run this program for us. So folks can apply for 2 months. We will subsidize, let's say somebody comes out of a residential program and is not working yet, or doesn't have the savings, obviously, because they're early into treatment, then we will help them make that transition through our credentialed sober homes, which means that there's case management on site, which means that we are looking at lengths of stay and working with ABH to make sure people are in a safe environment.
Thanks for sharing that. And thanks for the work on that. I promise, Mr. Chair, just one last question to the final section of the bill. The commissioner referenced section 9, which was about data collection. Certainly, in my sense, the most sort of nebulous piece of this bill right now. Coming from a place of hearing, I think, among providers and community members that in Connecticut, and also sort of just as a concept, the idea for better data sharing and integration and coordination across agencies is going to help respond to a challenge that is always changing and has so many pieces involved. I really am happy to hear about all the work that's happening already, and just wondering if you could expound on that a little bit more. So can you tell us, you referenced it a bit in your testimony, but what are the steps that have already been taken for data sharing across DCP, DEMAS, TPH, DOC? Those are some of the ones we named in the legislation. And in addition to those steps, if there are gaps that exist, what could be taken to better help fill those gaps? Is there anything that we could be doing to support those efforts between you and the sister agencies?
Thank you for that question. I think there are existing pathways. So for example, I'll give you 2 examples. One example, and I see my sister state agency, DCF, is on as well and might be up next. But the Behavioral Health Partnership, so that is a partnership with DCF, DEMAS, DSS, and Beacon Health Options. And through that partnership, we can look across the lifespan at any behavioral health issue, and that would be inclusive of substance use disorder, to see what we're spending, to see how long people stay in treatment, to see what claims are being had, to identify predictive modeling. So our ASO really has over the time that I've been at DEMIS, moved away from being a utilization management company that just tells us, okay, this person meets the level of care and this level of care is being utilized, this level of care is not being utilized. It really has gone up a notch to the next level to be able to predict what type of person or a person with which social determinants of health or under which stressors might be more likely to, you fill in the blank. And we can run that kind of data. And every year we have performance targets for the ASO. And we're always thinking ahead of, we really like to see how effective IOP is, intensive outpatient programming is. Not only is it being utilized, but who is it serving and who is it most effective for? So those kinds of things are happening year after year, and we build on the statistics from the previous year to make that more and more robust. Another example of maybe a specialized question would be our work with Department of Corrections. So being able to look at non-fatal and fatal overdoses and which folks when they re-enter might be at risk and what's a protective factor. Is it MAT a protective factor for those folks? And that work is also very research-based, and we have an IRB right here at DEMIS, and we'd follow the processes in order to get that work done, and that's been very valuable work. So those are two examples.
I appreciate sharing that. And so in your experience, the avenues between your agencies and others are you're able to navigate those, and the MOUs are in place to be able to do it effectively.
Yes.
Great. Thank you for sharing that. Thank you for your time, Commissioner. Thank
Sure.
you, Mr. Chair, for the indulgence.
Thank you, Representative D'Amico.
Thank you, Mr. Chair. Thank you, Commissioner Navarrete, for coming to testify in front of us today. I appreciate it. So I have a couple of questions for you. One has to do with the RBHAOs, and the other one has to do with the CACs, the Catchment Area Councils.
Mm-hmm.
So I'm looking at some testimony from a respected a mental health organization here in the state, and with regards to the RBHAOs, this testimony is saying that the funding for the RBHAOs is based on federal block grant funding, and they're concerned that a larger proportion of that funding is dedicated to substance abuse prevention than mental health promotion. So I'm just wondering, do you feel that is the case? And is there a way to, if it is out of balance, as they're arguing, is there a way to get it back into balance?
Thank you for that question. So unfortunately, at the federal level, the dollars are split out that way. As things are operationalized, it should be an integrated approach to operationalize at our state level. So the short answer to your question is yes, we pull more dollars from the substance use block grant pot than we do from the mental health, because in Connecticut, the larger pot of money is the substance use block grant. And that block grant also contains the prevention dollars. Now, remember, prevention is lifespan, and prevention also is wellness, mental health, substance use. So I don't know that in reality it matters a whole lot in operationalizing the RBHAOs, but it is correct that more dollars come from the substance use block grant.
Okay, fair enough. I just wanted to point that out, and so the other question has to do with the catchment area councils. And again, I'm just looking at testimony. I don't claim to be an expert, but I do give a lot of credence to the testimony, especially from this organization. And they're saying that although the catchment area council they are preserved, as a result of the merger that happened a couple of years ago, but they're arguing that there's now what's being called a top-down approach. In other words, they're saying that the perspectives of people living with mental health and or addiction challenges has been lost in the process, that it's a too much of a top-down approach. Would you agree with that? Or is there some credence to that argument?
I would disagree with that.
Okay.
So the way that, I mean, as I explained in my testimony, there is a lot of discussion, bi-directional discussion with the RBHAOs. I see them every month. Myself, my prevention director works very closely with them. They've been invaluable to us in terms of, for example, getting naloxone out there and doing the training that goes along with that piece. In terms of the gambling work and prevention regarding gambling addiction. So we take their priority reports very seriously, and those that information goes directly into our strategic planning for the department.
So you're referring to the catchment area councils or the RBHAOs?
The RBHAOs in which the catchment area councils feed into.
Okay. Well, again, I wanted to bring it up only because this is seems to be a concern that the catchment area councils are not getting enough input into the delivery of services. But anyhow, that's their perspective. I just wanted to share it with you and bring it to your attention. So thank you, Mr. Chair.
Thank you. Representative McCarthy.
Yes, thank you very much, Mr. Chair, and for this moment, just to make a comment to Demas. I do really appreciate the agency looking at the importance of the regional behavioral health organizations and getting them in statute. I think it was important that we got the functions outlined and that they're protected in statute. I do want to just follow up for a moment on what Representative D'Amico was saying. I hope as we continue to go forward that the regional behavioral health organizations do have an opportunity to recruit and have more of the individuals with lived experience with mental health conditions to hear their voices more. I think that was the one element in the former mental health boards that we really appreciated so much, having those individuals present and there. So I just hope as we go forward, I understand the block grant funding and the piece, but as we go forward that we can continue to look at that area. So I thank you very much to the department. Thank you. Thank you, Mr. Chairman.
Thank you.
Thank you, Representative. Commissioner, I think what you're hearing is we've got a lot of big fans of the regional behavioral health organizations here. We believe strongly that if we invest money on the front end, we save a lot of money and particularly a lot of bad outcomes on the back end. So I think that what we're really asking is not so much about the nature of the funding, but to assure that there's adequate funding for them to do their jobs as this new combined entity with less resources than the separate entities had in the first place. So I'm thinking you hear us loud and clear on that point. The codification is the good first step, but we're going to continue to watch to make sure that they're able to do their jobs effectively.
Thank you for that, Representative.
And again, we'll be in touch on the opioids bill and other legislation. We really appreciate your engagement on that entire subject. Senator Wong, I see your hands up for the second time.
I thank you for the indulgence, and I'll be quick. I wanted to acknowledge the commissioner's commentary in regards to the growing and increasing need of sports and internet gambling addiction services. And I think for us, from an appropriation standpoint, as we've gotten these gains from revenue from gambling, increased gambling, that we should give consumer amount of money to support the addiction services that will ensue. So I just wanted to make that commentary. I appreciate the commissioner bringing it up, and thank you for your work on that area of internet and sports gambling addiction.
Thank you.
Thank you, Mr. Chair, for the second time.
Thank you, Senator. I don't see any further questions. Thank you for being with us this morning, Commissioner. We look forward to talking in the near future as we try to round up these bills in this short session. Next up, we have Commissioner Durantes and her staff, followed by, I believe we have a legislator, Representative Napoli.
So good morning to the chairs, Representative Steinberg, Senator Anwar, to the ranking members and other distinguished members of the Public Health Committee. I'm Vanessa Durantes, Commissioner of the Connecticut Department of Children and Families, and I thank the committee for raising Senate Bill 368, an act concerning the Suicide Advisory Board. It is one of the bills in DCF's legislative packages this year, and we thank you for raising it. This proposed bill renames the Youth Suicide Advisory Board as the Connecticut Suicide Advisory Board and broadens its focus to be a coordinating resource for suicide prevention. Over the years, the Youth Suicide Advisory Board has developed a lifespan suicide prevention approach with strategies and treatment. The board, suicide prevention foundations, and legislators, if you recall, had called for a corresponding amendment to the statute that established the board to be more appropriately reflective of its existing structure and focus. We partnered with the Department of Mental Health and Addiction Services, so to highlight another partnership with DEMIS to work with the existing board to draft the language of this bill. The bill authorizes the expansion of the board membership to include representatives from suicide prevention foundations, youth-serving organizations, law enforcement, religious or fraternal organizations, civic or volunteer groups, state, local, and tribal government agencies, other healthcare professionals, or local organizations with expertise in mental health of children and adults and mental health issues with a focus on suicide prevention. Persons with lived experience, as we just heard, is so important to be included on boards like this. The bill also identifies the commissioners of DCF and DEMIS or their representatives to serve as board co-chairpersons, along with representatives of community providers or foundations for suicide prevention, who will serve as the third or tri-chair. We respectfully request substitute language in lines 36 through 41 to clarify that the tri-chair is a position that should be selected through appointment by the other two chairpersons. Under this legislation, the board will increase public awareness of the risk of suicide across the lifespan, making recommendations for the development of statewide training on suicide prevention, as well as interagency policies, procedures, and coordination of related services to develop these statewide strategies, a suicide plan that identifies, prioritizes goals and objectives, and aligning with national guidance. Thank you for the opportunity to testify in this legislation.
Thank you, Commissioner. Your input is really valued in this instance, so we get it right. I see Senator Anwar has a question.
Good morning, Senator.
Good morning. Thank you, Mr. Chair. Thank you, Commissioner, for your testimony. And I know this bill had originated also in the Children's Committee, and what we felt was that the home for this bill is better to be in the Public Health Committee because of a lot of groundwork that was done by Representative Steinberg and Senator Abrams as well in the previous session, and many of my other colleagues. I think this is a fruit of the labor of both your department and DEMIS as well, and a significant amount of dedication to a number of people who have been doing God's work in this commission and truly saving lives. So we cannot thank you and the entire department for the work that is going on here. I just wanted to thank you for that, and also think about the fact that we have to build on our strength, and this actually allows us to build on our strengths that we have achieved in the last many years. And I know it started with the children, but then included all spectrum of the ages that we look at. And the part that you wanted changed, do you have that in a written testimony that you would like some changes?
Yes, we do, sir. Thank you for acknowledgement of the work that goes into listening to various stakeholder perspectives and aligning our legislation with the activities of this particular board. We would respectfully draw the committee's attention to lines 36 through 41. And I also have one of the existing chairs on standby. If he can unmute Director Tim Marshall. Tim, to Senator Anwar's specific question about what it is and which language we need specifically changed, can you unmute and answer more specifically than I can?
I believe we were just looking to have the ability to be able to support the tri-chair from the foundations as the current existence would, the current structure allows for. So essentially we have a DEMIS co-chair, a DCF co-chair, and a representative from one of the foundations in Connecticut, whom all have been huge partners in the process throughout the integration last 10 years.
So is there a specific statute line that needs to be added or just added to the statute in general, if I understood the spirit of Senator Anwar's question?
Yeah, I don't know if Katie has that line. Yeah, okay.
Okay.
I'm not surprised that Katie has a. Go ahead.
You're talking to me.
Yes.
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 Hi, thank you. Hi, good morning. Thank you for that question. I'm happy to help clarify. The specific language that we're seeking clarification on is in lines 36 right now. It says the language reads, the board shall elect a representative of a local organization with expertise in mental health or a suicide prevention foundation, if such a representative is appointed by the Commissioner of Children and Families. And so the language as written is a little unclear as to whether the board is selecting the tri-chair or the commissioner. So the ask from our department is that the tri-chair be appointed jointly by both the DMIS and the DCF commissioners, who are the other two chairs. And I would be happy to coordinate with the LCO to provide on substitute language, if that would be helpful.
Thank you so much for that. We would appreciate that, so that we make sure that when we JFS this, it's appropriate. Thank you, Mr. Chair. Thank you, Commissioner, and everyone in the DCF.
Thank you.
Thank you, Senators. Thank you, Commissioner. Yeah, we want to get the right people on there, and so they get off to the races quickly and get back to us with recommendations. So much appreciated. I don't see any further questions. Thank you again. Have a great day and week. We'll probably still be hearing people by the time the week is over. Next up, I don't see Representative Napoli, so we may be up to, let's see, I think we might be Judge Strike Kafalis from the Office of the Probate Court, then followed by Catherine Rock-Burns. Good morning.
Good morning. Good morning, Senator Doherty Abrams, Representative Steinberg, Senators Wong, Summers, Representative Pettit, and distinguished members of the Public Health Committee. I am Judge Beverly Strike Kafalis, Probate Court Administrator, and I thank you for the opportunity today to testify to oppose Section 3, subsection A of Senate Bill 369, an act concerning the Department of Developmental Services. I have submitted written testimony that more fully details the basis for this opposition. And at the outset, I do want to share that we are engaged in conversations with the executive branch and their legislative representatives to address our respective concerns. I have reviewed Deputy Commissioner Mason's testimony, and we value in the probate court the critical and important role the department plays in assessing individuals for intellectual disability, providing critical services, and having a skilled team of licensed psychologists to meet these statutory charges. It is important to note that the matters which are the subject of the proposed change set forth in Section 3, subsection A of the proposed bill go to the heart of an individual's constitutional rights and reflects a statutory scheme in the exact language currently set forth in Connecticut General Statute Section 17A 274 that has been in place for over 60 years without confusion or concern. As many of you may be aware, the probate courts have sole jurisdiction to adjudicate petitions for appointments of guardians for adults with an intellectual disability, and relevant to the proposed bill, for the involuntary placement of such adults into the care and custody of the department under certain circumstances. Once an individual attains the age of 18, we all have the right to make all our decisions for ourselves. It is only with due process measures and adjudication by the probate courts of clear and convincing evidence that the rights of an individual with an intellectual disability may be abrogated with the appointment of a guardian, or as discussed in the proposed bill before you, to be involuntarily placed in the care and custody of the Department of Developmental Services. The commissioners presented the proposed change in language to section 17A 274 as a clarification of the role of the department in these involuntary placement proceedings. It is our perspective that the proposed language would in fact actually replace a judicial determination of an intellectual disability with a determination by the department, which raises constitutional concerns for the rights of individual respondents. The proposed language would also cause confusion between the role of the court-appointed independent psychologist and the role of the department in these proceedings. In a proceeding for such placements with the department, the probate court is charged with determining whether the respondent has an intellectual disability and whether other criteria set forth in section 17A 274 are met. In addition to ordering the respondent to be served with process by a marshal or indifferent person, the court appoints an attorney for the respondent if they are without counsel, and as I indicated earlier, appoints an independent licensed psychologist. It is this court-appointed independent psychologist who evaluates the respondent and includes in their report with the court whether the individual has an intellectual disability. This distinction is important in that more than 50% of the petitions for involuntary placement over the past 4 years, the department itself has been the petitioner. The psychologist who independently evaluates whether the respondent has intellectual disability also evaluates the individual's adaptive behavior. After hearing all of the evidence as set forth in section 17A 274G, the probate court must find by clear and convincing evidence that the individual has an intellectual disability and meets the criteria set forth in subsection A of 17A 274. If so, the court then may order the respondent to be involuntarily placed with the department in the least restrictive environment possible. Adoption of the proposed language in section 3, subsection A of Senate Bill number 369, in our view, is not a clarification of the role of the department in these matters, but in fact proposes to replace the probate court's responsibility in safeguarding the constitutional rights of an individual with an intellectual disability, and may actually cause confusion as to the role of the independent psychologist. And we respectfully oppose the language as presented. Thank you.
Thank you, Judge. Let me ask you 2 quick questions. One, you made reference to the agency's recommendation for clarification. Understanding what we're trying to accomplish here, perhaps clumsily, does that address the problem, or do you have a suggestion on how we could otherwise try to address the issue that we framed?
I didn't hear what the concern is that the department has. I know that the deputy commissioner's testimony says that they're trying to clarify the role of the department. But if you look at the totality of section 17A 274, in my view, and as this scheme has been in place for over 60 years, the role is clearly defined. And as I said, we're in communication with the department so that we can better understand what their concerns are. And perhaps if there's other language that would resolve their confusion or the interpretation that's confusion, we'd be happy to review that.
Thank you, Judge. And much of your testimony focused on the legal process. I don't think many on this committee necessarily understand well. I know I don't. But I think the point you were making is that there are broader issues here than even the one that we're trying to address. If we don't have precisely the right target, the right focus, how would you frame where we could best have a positive impact on the system as it is?
Again, without a good understanding of what seems to be a concern about confusion language, I would hate to propose anything at this time. I'm certainly open to continuing conversations with you, Representative, and committee members so that we can resolve the area of confusion.
Thank you. I see Representative Kennedy has a question.
Good morning, Representative.
Good morning, Judge Straight. How are you today? Thank you, Mr. Chairman, and Judge Beverly, thank you for bringing attention to 17A. Chairman Steinberg asked some of the questions I was thinking, so perhaps I could reach out to you and talk offline about some of those changes as Chairman Steinberg as to better understand going forward where we will with that. So I do appreciate you bringing those to attention. You also mentioned section 3A. So I'm just going to look at it, just pulling those up to look at those. So perhaps offline we can have conversations, and it is wonderful to see you. And I just want to take a minute, Mr. Chairman, if you don't mind, and thank Judge Beverly Straight-Capalas for all her wonderful, wonderful years of service to the towns of Milford and Orange. It's great to see you,
Thank
Judge.
you so much, Representative. I'm admiring your photographs of beautiful Milford behind you as well.
Thank you. Thank you, Mr. Chairman.
Thank you, Representative. I don't see any further questions. As we better understand the nature of our clarification issues, we will be in touch. Judge, thank you for your testimony today.
Thank you. I look forward to the conversations. Take care, everyone.
Let's see. Next up, let me just get this straight. Bear with me. We have Catherine Rock Burns and others from the Department of Developmental Services, followed by, I believe, Stephen Zanakis from Silver Hill Hospital, a general, retired general. We'll get to you in a moment, sir. All right, thank you.
Representative Steinberg, this is Peter Mason. I'm the Deputy Commissioner. I'll be testifying.
Please proceed. Thank you for being here, Deputy Commissioner.
Okay, thank you. Good morning, Senators Anwar, Summers, Wong, Representative Steinberg and Pettit, members of the Public Health Committee. As I said, I'm Peter Mason, I'm Deputy Commissioner of DDS. Commissioner Sheff asked that I relay his apologies that he's unable to be here today, but he is happy to follow up directly with any members of the committee on any of the testimonies being offered here. Thank you for the opportunity to testify on numerous bills on the agenda. Today, I would like to focus on the 5 DDS specific agency proposals and provide a brief summary of each. DDS has also submitted full written testimony for each bill to the committee. First is SB 369, an act concerning DDS recommendations regarding various revisions to developmental service statutes. This bill makes important technical changes to the DDS statutes. Section 1 requires that a check of the DCF Child Abuse and Neglect Registry be completed for each applicant for employment by an individual or family who self-directs their DDS services. This change would bring hiring requirements for self-directed services into alignment with the pre-employment practices already used in the DDS and DDS qualified provider hiring process. Section 2 changes one of the governor's appointment to the Council on Developmental Services from a doctor of medicine to a licensed healthcare professional to reflect the modernization of the healthcare system. Section 3 clarifies that DDS must determine that a DDS has intellectual disabilities as defined in Section 1-G prior to the probate court ordering a person to be placed with DDS. DDS did hear probate court's testimony, so I'm changing my testimony a little bit, and listen to the concerns expressed to the committee. DDS will be reaching out to probate to work through the concerns and determine a resolution that's amendable to all. In addition, Section 3 adds the commissioner's designee in several subsections to allow the DDS legal director to act on the request from the probate court to expedite responsiveness to the department. The next DDS agency bill is SB 372. An act concerning the DDS recommendations regarding green initiatives in residential facilities licensed by the department. This bill takes a two-pronged approach to reduce the department's carbon footprint and help meet our state agency's energy goals. The bill will allow for partnership with DDS qualified providers to create solutions to reduce each provider's energy needs and increase their use of renewable and sustainable energy resources. SB 373, an act concerning the DDS recommendations regarding family support services and the Family Support Council simply repeals out-of-date statutes related to a council that has been defunct for approximately 5 years. SB 374, an act concerning the DDS recommendations regarding the reimbursable salaries of directors of qualified providers, allows for increases to the cost allowance for the salaries of executive directors of DDS, DSS, and DEMAS private providers. Allowing for increases in salary helps our providers retain and attract executive directors that can provide leadership and stability to the human delivery service system. The last DDS agency bill is SB 376, an act concerning the DDS recommendations regarding ABLE accounts. This bill allows money invested in an individual ABLE account, contributions to an individual ABLE account, and distributions for qualified disability expenses to be disregarded when determining eligibility for state-administered general assistance as administered through the Department of Social Services. ABLE account encourage and help eligible individuals and families to save private funds to pay for qualifying expenses related to disability or blindness. For individuals supported through DDS, ABLE account savings are an important part of planning for a person with intellectual disabilities future. It would also bring the ABLE account disregard process in line with the Special Needs Trust that exempt or disregard the assets in Special Needs Trusts from consideration in determining eligibility for state administered general assistance, SAGA. In discussion with the Office of the Treasurer, DDS has learned that the Treasurer has amendment language that would make changes to the state's ABLE account statutes in line with federal requirements. If the Office of the Treasurer were to propose an amendment to this bill, DDS would not be opposed to the bill being amended as long as the disregard language for determining SAGA was included in any JFS language. We respectfully request that you support these agency proposals. In addition to the bills I just discussed, DDS also submitted written testimony on 2 additional bills, SB 330 and SB 331. Although these are not DDS agency proposals, they are relevant to the work that we do. And in the interest of time, I will not provide a summary of these bills. Thank you for the opportunity to testify today. I have staff in attendance and we're happy to answer any questions you may have.
Thank you so much, Deputy Commissioner, for your testimony and for your team to be present. And thank you for going over the bills. For lack of a better way to put this, these are technical fixes and there's no substantial policy change in any one of them. Is that a fair way to look at that?
That's a fair way to represent them, yes.
And that's why we don't have a lot of questions or comments for you. We appreciate you being here and thank you for the work that your entire team does. Thank you.
Great, thank you.
Okay, and we will move on to the next person on our list, which is number 14, Stephen Zanakis, Silver Hill Hospital, New Canaan, a Brigadier General.
Good morning. Thank you, members of the committee. It's a real privilege to be here and speaking to you in support of the Bill 5396. I'm a psychiatrist. I'm a retired Army Brigadier General. I developed and directed the COVID resilience program that we started at Silver Hill in March 2020. We've now transitioned to a community resilience program. We provide training and support to our frontline healthcare workers, law enforcement, and schools to cope with the stresses having to do with the pandemic and now with all the other kinds of experiences that are really bearing down on our members, citizens in the community. I want to speak today on behalf of expanding our mental health services when it comes to the use of our treatments for those people suffering with PTSD and treatment-resistant depression. I came into the Army. It was commissioned in 1970. Was with the Army Medical Corps from 1974 to 1998. And as you understand, and I fully appreciate, the strength of our military really rests with the health and the mental health of our soldiers and our families. And I feel strongly that the strength of our communities, of our country, is the same here, that we need to take every effort, make every effort that we can to maintain our families and our neighbors as healthy as we can. Now, when it comes to the treatment of many of the problems that bear down on them, particularly PTSD, treatment-resistant depression, even in the hands of our most experienced and dedicated practitioners, and there's no fault here at all, we understand that at best, half of them are really get help or feel improved, that there's a number of them that still need a lot of treatment, therapy, and services. And that's, again, an issue because of the great challenges that these problems present. So the guiding rule here is let's get the right treatment for the right patient at the right time. We need to have a broad array of services available. And now we have the capability to do that with the developments that have come in understanding the benefit that comes from MDMA and psilocybin and other such agents. And that there's been considerable work in our laboratories and our clinical centers studying the efficacy. We now understand that we can, with other tools, we can take what we've learned in those laboratories, in those clinical studies, and move them expeditiously and very effectively and very thoughtfully into the clinical setting.
Excuse me, Dr. Zanakis, your time is almost up. If you could summarize. Thank you.
I want to support that we do that and that we use our FDA-approved protocols to provide the treatments right now in those clinical settings. Glad to take any questions, and thank you for the time.
Thank you so much, Brigadier Zanakis, for your testimony. Did you have more to say? Because I'd love to hear more if you were in the midst of completing some other aspects.
Well, that there is that what we do in clinical practice is, and how we provide these treatments is really another level beyond what we'll learn in the laboratories and where the clinical studies are done, because those are done at many people that need treatment cannot be entered into a clinical study. So the real world is very different from what we end up studying, and necessarily we have good methods there, but we now need to fast track understanding what we're going to do with real patients in real settings and appreciate how we're going to best provide those treatments. That was the basis of what I wanted to say here to the committee. And I think we need this kind of legislation and funding to do that, because it's complementary. One builds on the other. We've got the studies in the laboratories at our universities, and now we'll have clinical settings. We'll learn from those. We've got plenty of tools to get the data. We can do them in FDA-approved protocols, and we can use that information and figure out what's the best way to provide treatment. And we have a huge need. Look, we've got all these veterans. We've got all these people that have suffered from all sorts of different stresses. And we really need to be very aggressive and very creative in figuring out what to do for them.
Thank you, Brigadier, and thank you, Doctor, for your testimony. I can completely agree with you that with the PTSD that our veterans that are experiencing the challenges, we need to fast track some of the medications and options. And while some of them are being worked by the FDA, you will be following the exact protocols and the documentations. I just wanted to clarify.
Yes, these are all FDA-approved protocols. We'll also be going through other review boards. I mean, these have got to be done by the letter of the law here.
Good. Thank you so much. I see Representative Cook has a question or a comment.
Thanks, Senator, very much. And thank you, Doc, Senator, and for your service. I wanted to just ask you a couple of questions, Stephen, if I might. And it's been a pleasure working with you on such an important topic. So the FDA has obviously made some movements when we talk about expanding access suffering from PTSD and depression. Would you like to address that briefly? And then I wanted to also briefly ask you about the other states or states that have actually been moving in this way and the people that have been helped in that area.
Well, I mean, the FDA has in fact granted what we call breakthrough status for MDMA for the treatment of PTSD. I think that we should understand that if those protocols proceed as they look like they're going to, then within about 18 months, maybe at the outside 24 months, we'll see approval for the use of MDMA for PTSD. They've also given breakthrough status to psilocybin for the treatment of major depression and what we call treatment-resistant depression. That is, people that have not responded to the current best practices. And that's, again, on a track for about 24 months. So there's a lot of good things being done here. There's a lot that we're going to learn from that. Now we've got to understand what we do, again, in the real world setting and with patients that have, in fact, the patients that I see, the veterans and soldiers and others, have PTSD and have depression and have substance abuse and have problems from the IED blasts, which cause depression. So they've got a whole syndrome here. And now what we want to do is we'll take the information from the studies, what's been approved by the FDA, and we'll go into a clinic with people that present all these problems and look at what's the best way to provide that treatment. So that's our goal here. The work done in the other states, I think it'd be best to talk about. There are other agencies here that are providing testimony with reasons for hope, and they really are probably more informed in order to answer your question.
Thank you for that, and thank you for your time. And again, I don't know if we've ever had a U.S. Brigadier General testify in front of our Public Health Committee. Your dedication to our country is beyond words, but now to our veterans is even more beyond words. And I can't thank you enough for partnering with us, trying to get something so vitally important and innovative out the door. So thank you very much for your time and your dedication to this.
Well, thank you. Look, I salute all of you. You all are doing God's work here, and you're helping our nation and everyone be stronger. So I really want to give you all credit for all the good things that you're doing. It's a real privilege to be here with you this morning.
Thank you,
Thank you, and thank you, Senator.
And I see Dr. Pettit has another comment. Dr. Pettit.
Thank you, Mr. Chairman. Thank you, General Zanakis. You've touched on this a little bit, and my question really is for myself and for the committee members and public watching. Can you just talk a little bit more about how you envision the federal, state, local interface working, given the status of these compounds, FDA regulation? Would the studies be run on a federal level and done locally, or would it all be under local and state control? If you could just talk to the interface between the federal government and the state government on this issue.
Oh, I think we're going to have to partner. I think we're going to have the FDA because we know what the protocols are. We know how they have oversight now. They've put in place the first steps for risk mitigation, and we're going to have to follow those guidelines when we do that. In addition, I think the state, because the state's got responsibility for the patients that's being treated here in the facilities that we have, we'll have advisory committees of clinicians that will also exercise oversight to these. So it'll be joint and be coordinated effort by both the federal and the state authorities.
So in terms of, and just one more quick one, in terms of the permissions and human investigation trials, do you envision that being a federal human investigations committee that we could administer, we could look to locally, or do you envision there being two steps, that there'd have to be a federal group as well as a state group to ensure patient safety?
I think that the state could look to the federal group for the safety and for the guidelines. I think, though, if we were to set up clinical services, for example, at Silver Hill, we're going to have to go through an IRB as well, an investigational review board. We're going to make sure that we're doing all the right things there, and that you've got you've got the professionals looking at it, and that we're going to be able to demonstrate efficacy as well as protect our subjects in the studies.
Yeah, I think that makes sense. Probably federal oversight and then the local review of what's been done. I thank you for your comments. Thank you, sir.
Oh, yes, sir. Thank you. Thanks for asking.
Thank you, Dr. Pettit. And I have Representative McCarty, followed by Senator Summers.
Yes, good morning, General, and welcome to the Public Health Committee, and thank you for your testimony. And while I'm supportive of the proposal in front of us today and look forward to learning more about it, I would just like to ask your opinion, and this is sensitive to me and to my family. When we look at our soldiers that have seen active combat, and we understand the trauma that they've experienced in the PSTD, can you comment? And I know this is a broader discussion, and I'll ask the permission of the chair to get your contact number, and we can perhaps talk some more about it offline. But I would like to understand why some of these soldiers are then put back into active combat again, rather than receiving the mental health services right after they've come back from a deployment. Because I think what we want to do, first of all, while we're looking at this expansion, but we want to cut down on the number of our soldiers that are experiencing PSTD. And I can speak from what's happened in my family, that in a unit of 23 soldiers, 17 of them had death by suicide after being deployed. So I think it's an important issue on even a national level that these soldiers receive mental health services immediately after they come back from combat, rather than wait to look at medications that may help with the depression. So I'm sorry, it's a little out of the scope of today's discussion, but somewhat related. So I thought, well, we had you here, that I'd voice that concern.
Well, you've touched on something that is really great. It's bothered me for a long time. And I think that it probably will have to have a longer conversation at another point. I was privileged to advise the chairman of the Joint Chiefs, Admiral Mike Mullen, from 2007 to 2010. We had become friends as new one-stars to essentially take on the question that you've just presented. I mean, what should we do? We know that the combat experiences are bearing down heavily on our service members who go into combat, and that if they're going to be effective, we need to do everything we can to take care of them. And understand, though, that they are also very committed to going back, that they've joined up. They want to be with their fellow soldiers. They want to serve, and they want to take care of them. So there's some very hard, tough questions for us to ask. What is the best for us to do to take care of them, keep our military strong, keep our missions, be able to accomplish our missions, and balance what are really at times competing pressures on them. I will introduce here, and we can have a longer conversation. It's not just PTSD, it's what we now are calling moral injury. That these people have seen and done things that really shock their sensibilities and shock their sense of morality and ethics. And this is the modern world. This is not the world that many of us grew up in or that our fathers fought in. So we've got to also move forward. And I think part of what we want to do in these treatment centers is to learn about that as well, and to understand that this is the experience that these men and women have. And the more we're proactive and the more we reach out, maybe we can take care of this problem. We've got 20 suicides a day amongst our veterans. We've got to do better. And I really appreciate your being able to support this so that we can do better. And I'd be glad to talk to anybody about this and figuring out what are the ways that we can help all these men and women who have done so much for us.
And thank you very much, General, for being here today and for your commitment and your service. I look forward to talking to you at length. Thank you.
Anytime. Thank you.
Thank you so much for the questions. I see Senator Summers had a question or comment earlier. Senator Summers? Probably, okay, well, maybe I can jump in. This is a bigger question, and you can touch on it, and we'll probably have an offline conversation. It is my understanding that the depression, suicidality, as well as the PTSD in the veterans is much more resistant to treatment than what we see in the community. Is that fair? And that's why this bill becomes even more relevant right now.
I think it is. We know that there's plenty of data that supports that. In my own clinical experience, I think part of it is because of the IED blasts, the concussions that have really injured the brain at the level of the neurons, and that over time the patients get more and more depressed as these injuries persist and as these men and women age, so that they're not going to respond to what would be the usual treatments that we use for depression in patients who have not been exposed to those injuries. The other thing is that their sleep cycles have also been completely disturbed. So there are many factors here that need to be brought in, and I heard the words early on about integrated care. So what we're putting in place here is multimodal. That is, we have multiple modalities. The patients have all this broad array of problems, and we're going to integrate and coordinate that. And I think these treatments are going to enable us to do that, because it's really not the medication. Medications are important. It's the wraparound of the therapy that is going to now, it opens up the conversation, and we can now start to work with these people with these very deep down experiences and feelings and memories that they're carrying with them. So I think this really does move this forward a great deal, and it's really an option for us with these patients. And thanks again for asking that question.
Excellent. Thank you, General Zanakis. I will share with you that a number of us would like to have a meeting with you again in more depth, because this issue, unfortunately, isn't going away right now. We have to have a long-term strategy on a number of other avenues that we can collaborate on. So thank you for your testimony today, and thank you for the work that you do every day.
Thank you so much.
And the next person on our list, Lieutenant General Martin Steele. And General Steele.
Thank you, Senator Anwar. Senator Abrams, Senator Anwar, Representative Steinberg, Senator Wong, Senator Summers, Representative Pettit, and distinguished members of the Public Health Committee. Thank you for the opportunity to provide testimony in support of HB 5396, an act increasing access to mental health medication. My name is Martin R. Steele, and I'm a retired Lieutenant General in the United States Marine Corps. I currently live in Tampa, Florida. You have a brief biographical sketch included in my written testimony. I have spent much of my life, like General Zanakis, around active duty combat soldiers and veterans and members of law enforcement who honorably and selflessly serve their fellow Americans, many of whom unfortunately have suffered a mix of post-traumatic stress, traumatic brain injury, anxiety, depressions, substance abuse disorders, and moral injuries, as General Zanakis indicated. And I firmly believe that we have a duty, responsibility, and more than ever, an urgency to help not only these individuals, but all those suffering from trauma to heal and move forward as productive members of our society. I also believe we have failed to do so for a very long time. Reversing these trends requires bold but thoughtful and strategic action. I am proudly testifying in support of HB 5396 in my role as the co-founding board member and the chief executive officer of Reason for Hope, a nonprofit policy and advocacy organization focused on developing the necessary regulatory system for the safe, responsible, and ethical deployment of psychedelic medicines and therapy for mental health care. While we still have much to learn, psychedelic medicine, when used safely, responsibly, and in the right setting, may be our best hope to combat suicide and the opioid crisis burdening our nation. Bringing psychedelic medicines into traditional clinical care settings will be far more complex than a traditional drug approval. The time-intensive treatment process, generally including preparation, administration, integration sessions, psychedelic-assisted therapy, does not fit neatly within our current mental health care system and must carefully consider issues of best, safe, ethical practices, affordability, access, infrastructure, and insurance coverage within this new paradigm of care. These complexities are precisely why House Bill 5396 is sound policy for the state of Connecticut to begin preparing. The state can play a leadership role in addressing these issues and developing the infrastructure in a limited context by providing funding for veterans, retired first responders, frontline healthcare workers, and individuals from underserved populations to receive MDMA and psilocybin treatment at clinics with FDA-approved expanded access protocols.
Excuse me, General Martin, your time is almost up.
I strongly urge Connecticut legislator to pass this bill. Thank you, and I'd be glad to answer any of your questions.
Thank you so much, General Steele, for your testimony. I think one of my colleagues had asked a question, and I think it was suggested that you would be able to answer that. Which other states have had similar laws, and what are their experiences?
Well, I'm familiar with ones that we're working on, Senator Anwar, and I would defer to my partner, Brett Waters, who's going to testify later today to give you the specifics on that answer. But we're working in several states right now. Laws have been passed in Texas and Oregon. We're working in a law in Pennsylvania, but he is the one, as a lawyer in New York, that's been working on the legislative process in these other states. Mr. Brett Waters.
Okay, perfect. Thank you so much. And I see Representative Cook has a question. Thank you.
Thank you, Senator. And actually, that was one of the questions I was going to ask Lieutenant General Steele. I see your name, I don't see your face, but it's nice to have you with us today. I can't thank you enough for all your dedication to our country and to this topic. And I understand that you want Brett to answer the question that the good senator had just asked, that I had asked prior. But I would like to ask you, on a personal note, on all of the servicemen, men and women that you've seen benefit from this, could you address from your personal experiences those folks that do not get help, what their life looks like? And then I know we will hear from some folks that have been fortunate enough to get help from this type of treatment. But just some of your personal experiences as to why this is so vitally important to you and the livelihood of folks that may or may not have the ability to receive this treatment.
Thank you for that question. I have no idea why I'm not visibly on the screen, by the way. I'm technically deficient with that, Representative Cook. I'm trying to figure out why I'm not on the screen. I don't get it, but.
You will see a camera next to the mic. There's a mic sign on the left lower of your screen, and right next to it is a camera. Click on that.
Well, there isn't one on the bottom of my screen, so.
Okay. Okay.
But I don't know why. It's maybe my technology, but I apologize for that. I'm all dressed up for this occasion. But in answer to your question, that has been my experience for the last 20 years, Representative Cook. That is those people who are dealing with treatment protocols inside the Veterans Administration and are suffering from the prescription drugs that they have been afforded by the VA, for example, and that they're not working as antidepressants, or they're not helping them get any better. So most of my experience as a layman is working with them because they turn to me for counsel of what they should be doing and how they can ensure that they have an understanding of the gift of life. And rather than be one of the statistics of 20 veterans a day taking their life, that life is not only worth living, but we can help you get better. And it's a continuous process for me and has been for 20 years. And I say that The thrill is those that you save, that you help save. You get on different protocols, you get to different experiences. Unfortunately, in the case of psychedelics, many of those are outside our country that you're well aware of. It just shouldn't happen in the greatest nation on earth, particularly to these cohorts of people who not only selflessly serve, but were willing to pay the supreme sacrifice, which goes back to what General Zanakis was saying, my experience about the stigma attached to those who, while still on active duty, are hesitant to not go back because they want to serve our country because it's in their DNA. And what we're trying to do is help them and help the ones that are on active duty to be mentally fulfilled and can in fact continue to serve, and then save the lives and get these protocols for treatment as expeditiously as possible into the hands of those veterans to mitigate their current circumstance and prevent them from taking their own lives. The stories are tragic. The stories are full of hope. The stories are, say, anything that you can do to help me, sir. I laugh. We're talking about General Zanakis being the first one, and I think I'm probably the first lieutenant general. But the great humility that I have, that a young soldier or Marine or sailor or will say, I never even spoke to a general before, but you are helping to save my life. And I believe that's what this bill is all about. And that's what I believe that our commitment and resolve and sense of urgency has to be all about in taking care of these young men and women. Thank you for the question.
I couldn't agree more. And the number of 20 veterans a day, 20 soldiers, 20 men and women a day that take their life breaks my heart. And the fact that we are not doing for them what we should be doing is just a disgrace in my world. And I believe that we have the ability in this committee to do much better, at least in the state of Connecticut, which before I let you go, I believe you have a connection to. So I want to see if you wanted to just address that briefly.
A connection to you or Connecticut? Or
Connecticut, actually, as a whole.
Well, I do have a connection to Connecticut. I was involved in the first response after Sandy Hook, which celebrated its anniversary here in December. But one of the children who was slaughtered at Sandy Hook is the grandchild of one of my closest friends growing up in Arkansas. And I left immediately after he informed me, first of all, that his grandson was still in the building and he didn't know whether he made it out. And a few minutes later, he informed me that he didn't make it. Jesse Lewis, the Jesse Lewis Choose Love movement that his mother started, that I was the original chairman of the board of, which looks at alternatives to vengeance and hate, but choosing love, has been a model to emulate. Now, K through 12 throughout the United States and outside this country on the people and the young children and educators that it touches along with their parents. So I'm connected to Connecticut with that. At one time, my leadership consulting firm was headquartered in Connecticut, and I have a long-term relationship with Senator Blumenthal from Connecticut on dealing with suicide issues and suicide ideation and the Choose Love movement. So I could go on. I have a great affinity toward the state of Connecticut. And my dealings with you over this issue, Representative, is profound because you care, you demonstrate that. I think we've got a powerful bill here, and with our continued support, we can take it to where Connecticut can be the leader in the nation in providing alternative protocols in mental health treatment that are going to save our republic. Because I believe we are in a crisis and the urgency is now, and we have a window of opportunity to step through that crisis to change the way we treat all of our citizens of our country in their mental health care. Thank you for the question. I hope I answered it.
You did, and I think my reason for asking was not to bring up the tragedy in Sandy Hook, but we all know that we live that each and every day in the state of Connecticut, but to show that your dedication to our country serves deep and wide. And to our state, you've done some insurmountable things helping the folks that have really suffered traumatically from Sandy Hook and beyond. And so I just wanted to thank you for that, and thank you for being here with us. And again, all the work that you do. It's been a pleasure working with you, and I look forward to the continued relationship. Thank you, Senator Anwar, for the time.
Thank you, Representative Cook, for your work, and thank you, Lieutenant General Steele, for your work, and then we will be following up. I'm seeing no other questions or comments. We'll move on to the next person on our list, which is Representative Jill Berry. Representative Berry, thank you for your patience and welcome.
Good morning, Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. I'm Jill Berry. I'm the proud representative of the town of Glastonbury. I could talk all day about why I personally support SB 367, but I think it will be more effective and in everybody's best interest if I yield my time to Jessica Liu, PhD student and researcher at Harvard University. Jessica?
Thank you, Representative Berry, for that introduction. Good morning, Chairman Anwar, Chairman Steinberg, and esteemed members of the Public Health Committee. My name is Jessica Liu, and I am a PhD candidate at the Harvard Chan School of Public Health. While I'm enjoying the work I'm now doing at Harvard, I previously did my master's in public health at Yale and really enjoyed my time in New Haven. So it's good to be back in Connecticut this morning, even if it's only virtually. Today, I'm here to provide evidence to support Bill SB 367 by discussing with you all recent findings from a soon-to-be-published scientific paper that I wrote with Drs. Lester Hartman, Andy Tan, and Jonathan Winikoff. In our study, we present Youth Risk Behavior Surveillance System, or YRBSS data, suggesting that combustible tobacco use decreased in Oakland, California, following a flavored tobacco sales restriction. A recent study by Dr. Abigail Friedman argued that a sales restriction on flavored tobacco products might increase youth combustible cigarette use, using 2019 YRBSS data regarding the flavored tobacco sales restriction in San Francisco, California. Following this publication, non-academic community members and an organization associated with the tobacco industry have used this YRBSS data to justify their opposition to flavored tobacco sales restrictions. Using additional evidence not previously considered on the timing of the YRBSS, our study showed why it cannot be used to conclude that combustible tobacco use increased after San Francisco's flavored tobacco sales restriction. Through personal communication with the chief branch at the CDC that oversees the YRBSS, we found that the timing of the survey period of the 2019 YRBSS survey in specific school districts varied from one another. San Francisco's assessment period was fall of 2018, defined as September to December. Research on compliance with San Francisco's flavored tobacco sales restriction found that compliance was fairly low at only 17% in December of 2018 and increased through 2019 to up to 80%. Thus, even at the end of the San Francisco YRBSS survey fielding in December of 2018, fewer than 1 in 5 retailers were proactively enforcing the flavored tobacco sales restriction in the city. This lack of retailer.
Your time is almost up. If you could summarize. Thank you.
This point of this is that the 2019 YRBSS survey in San Francisco predated the enforcement and therefore should not be used to evaluate the effect of the policy. And just based on my extensive research and understanding of the literature, having a statewide flavored tobacco sales restriction in Connecticut will lower youth vaping rates and decrease overall youth tobacco use. Thank you, and I'll take any questions.
Thank you so much for your testimony. I appreciate that. I have quite a few questions. First question is, if we can mute Representative. There, good. Jessica, first question is, you've been to Yale and Harvard. This is the environment we say Yale is better than Harvard.
My fiance goes to Yale as well, so this is a difficult question for me to grapple. Yeah, that's my answer.
No worries. Well, I think I agree with your answer here. So the question is, so you mentioned about the Oakland study. And then I know the 3 minutes were not enough, but what you suggested in the Oakland study, what was the timeline for that?
Yes. So the study that we did was looking at we did a very sort of descriptive look at Oakland, just looking at the trend of when they implemented their partial sales restriction. And we did see a trend that it went, smoking rates did go down, but that wasn't like that was just a descriptive analysis. We didn't conduct any analyses. The sort of main point that we wanted to really draw attention to was the fact that in a recent analysis, the 2019 Wire BSS data was used to assess the effects of the policy in San Francisco, when in reality, that data was collected before the policy was fully enforced in the city, and therefore should not be used to assess the effects of the policy in San Francisco.
Okay, so then I'll move on to San Francisco then.
Yes.
But So we brought this bill last year, and I think prior to that as well, at least last year for sure, I think. And every person who sells vapes came and testified, more or less every person, and the emails and messages that many of the legislators who are concerned about vaping in our children and youth kept quoting one study. And that study was from San Francisco, and they were saying like, look, because you want to restrict flavored vapes, you're going to make all the children smoke. And I looked at that study, and then as I looked at that study, I had my concerns. But you've made a very big statement right now. Your statement was, if I heard you correctly, was that the data that was in that study, that single data point, that study was prior to the restriction of flavored vapes. Is that what you said?
Yes, prior to the enforcement. So the policy was in place, but what happened is that there have been studies that have been published that show, and I discussed this in the written testimony as well, but the enforcement didn't actually begin until January of 2019, and the data was collected from September to December of 2018, which is before that January 2019 enforcement beginning. And like I said, in December of 2018, enforcement of the policy in different stores based on that study was only around 17%, so very low.
So, and what is the source of your statement?
Yes, so we communicated with the department at the CDC that conducts this Wire BSS survey nationally, and we asked them, what was the timing or like the season that you administered these surveys to the specific school districts, and they did reveal to us that in San Francisco it was done from in the fall of 2018, which is defined as September to December of 2018. And then for a lot of the other school districts, they were done in the spring of 2019. So even though it says 2019 Wire BSS, sometimes that means that 2018 data might be collected in that, because just because of the way the school year is.
Okay, so I'm just going to repeat this because it's worthy to repeat this.
Thank you.
What the cornerstone of the billion-dollar vaping industry, the multi-billion-dollar vaping industry is that, if you actually stop vapes from being used from children, they're going to go to combustible, is based on one data point from one study. And what you're saying is that data point is inaccurate and was actually taken before the implementation of that. Correctly?
Yes, before the enforcement of the policy. Yes.
I've looked at the bill because I had concerns about the study because, well, even if that, God forbid, if that data point was accurate, single data point, can you speak to using single data points for big policy decisions?
Yeah. So, I mean, even if, let's say that one data point was correct, we do explain this in our full scientific paper that will be coming out soon. But as many researchers would agree, you generally want multiple time points. Not just sort of like one pre and post the policy to conduct more robust analyses. And you also want to give some time for the policy to sort of play out a bit and not just, pick a time point that's so soon. At least in my training that I've done with my statistical methods, we're usually told, like there's a lag time of maybe like a year or two, just policy effects take a long time to take place, be implemented, be enforced. And that's why, that one single data point is not good to go off of when you want to make sort of these big decisions on how effective the policy is.
Okay, I appreciate that. I have more questions, but I think Representative Dr. Foster may have a question as well. So Representative and Dr. Foster, please go ahead.
Thank you so much, Chairman Anwar. Hi, Jessica. It's so nice to hear from you today. I have a couple of questions. So first, I just want to tell you that I saw you on the list last night when you were going through. I was excited to see a fellow academic, and I've opened up some of your papers, and it looks like, similar to me, you have a mixed methodological expertise. I saw a lot of qualitative papers published. So this is an interesting transition you're doing into like nationally representative data. So I'm going to ask a couple of questions. I haven't done nationally representative data work myself, but so I actually am a huge fan of using qualitative research methodology to fine-tune and hone policy recommendations. And I think this is a little nerdy for the group of us at large, but my first question is, like, your recommendation about not using a single data point to inform policy sort of begs my question. If that single data point flags something as potentially risky, wouldn't continuing on without similar data points be similarly risky? Can't that apply in both directions? So if you have a single data point that flags as concern that a policy might be ineffective, my training in food policy would sort of tell research related to food policy. My training would sort of guide me to say, maybe we should try not the same policy again, but a different style, and also similarly evaluate. And so my recommendation, sort of hearing what you're talking about, but I'd love for you to sort of weigh in and tell me if you would agree similarly, would be for Connecticut to consider implementation of a policy that had the same goal, same aspirations, but not the same exact mold, and then to collect data. And so I do want to flag for your advocacy around this issue that we don't, in all of our data collection in Connecticut, like the RFFF data, collect youth flavored tobacco and vape data. So it would be I think risky for us to plan to evaluate that without that in our data collection plan. So I think that's like an advocacy tip that I think might be helpful. So do you think you can comment sort of on what I'm talking about here? Would you recommend that from a policy lens to try something that might have the same goal, but isn't the same in case that flag is cause for pause?
No, that makes sense. So thank you, Representative Dr. Foster, for your question. So just to summarize, you want me to comment on whether or not the policy, like Connecticut, should try something a little different due to the concern of that one point?
Yeah, so, and I would just, before I just have you expand, and then I'm looking, I know you called that one paper and one author, but what about the paper by Yang, Lindblom, Shalom, and Ward, which confirms similar outcomes in the same city?
So let me address your first question, and then I can address your second question. So again, I'm a researcher. I don't have experience. I mean, I'm learning about policy making. And what I do have to say is that I think there's a lot of contextual factors in, different cities. And so I don't want to make a blanket recommendation that, Connecticut should do something specific just because they saw what happened here in San Francisco. I cannot predict that. All I can say is that, I do agree that, like, if one data point is kind of suspicious, maybe we should kind of look into that a little bit more, but I don't think that should hold enough weight to, kind of make such broad conclusions that these types of really important flavor bans or tobacco sales restrictions, which are really beneficial to preventing youth from having access to these products, should not be considered in other places, because I do think that that is still a step in the right direction.
I think you sort of raise an interesting point. So I'd like to ask. So one, I from like a data like accuracy standpoint, I think when we say single data point, I think some of our colleagues on the committee who don't have the same familiarity with data as Dr. Anwar and yourself and others might think that this is a small sample, but it's a nationally representative data set with a specific analysis in the San Francisco city with thousands of surveys related to youth consumption in that city. So single data point, I think what you are referring to is that this is a specific emphasis on that city contextualized with other data happening without similar policies. So I just want to sort of clarify that. But the follow-up question that I have is one of the things that I want to be like explicitly clear. I think that youth tobacco consumption is a huge problem. I in no way, shape, or form ever want to see children becoming addicted to flavored tobacco products or tobacco products of any type. But there are two sort of concerns and reasons for pause that I have with advocacy around the flavor ban in Connecticut. One, that I think we seem willing to detach ourselves from a menthol ban. And I would wonder if combustible menthol. And I wonder if you could tell me a little bit about how that contextualizes in youth tobacco consumption and why related to health disparities that might be reason for concern.
Yes, I mean, so I from my understanding that the Connecticut flavored tobacco sales restriction is not going to include menthol. And in my opinion, I think it should include menthol because menthol just makes tobacco products, nicotine products, cigarettes a lot easier to smoke. So for like nicotine naive or just, youth who've never used before, it's definitely a product that will kind of draw them into using for the first time and using more because it is just so much, the mint and the menthol just makes it so much easier to inhale the product. And what's been problematic about this is that these products have been traditionally targeted to African-American communities. There's a lot of history around this throughout the US. And because of that has created disparities in tobacco use by drawing in a lot of these, again, new tobacco users with this product that is so easy to inhale and smoke. So yeah, I 100% agree that I think that, ideally in any case, a flavor ban should include menthol in it.
Yeah. So one of the things that I always sort of flag is that folks who are at disproportionate risk for cardiovascular disease, like heart disease and diabetes, are also at more risk for consequences related to tobacco use and consumption. And so because menthol products have been disproportionately targeted to Black and African-American folks, that we're going to see worsening levels of health disparity if we ban flavored vape products, but not all of the menthol products as a whole. So one of the things that I have been really interested in and heard proposed and advocated for by Dr. Friedman is a fine-tuning of this policy to restrict access of tobacco products to youth, which is to restrict point of sale of all tobacco products to T20 or 21 plus venues as a whole. And so I think a lot of her work has been really influential in that work, in the T21 work, which has been, I think you would confirm, a huge positive stride towards reducing tobacco consumption. So kids are smoking less because of the T21 efforts. Kids are consuming less tobacco. So I think we're holistically moving and rowing in the same direction. I think our goals are aligned. And so perhaps a point of sale restriction to 21 plus would be the best avenue to catch everyone in this health disparity advocacy space. Perhaps that would be something that could benefit. Now, we don't have point of sale 21 plus restriction data published in this peer-reviewed setting, but based on what you know about the literature, would you think that that would offer benefit and would protect youth?
Again, I think the bottom line is anything that removes or limits access of these products to youth is going to be a good thing. And the the policy you mentioned would definitely, fall under that category, along with, again, continuing to, kind of going back to still restricting the sale of flavored products. I think in general would also still be fine, just because, again, research has kind of shown this too, like generally adult smokers who are looking to use e-cigarettes or vaping products as an like a harm reduction tool, like they don't prefer the flavors of like mango and strawberry or whatever, like, so I think that by having this flavor ban, it will kind of still do both things of, it'll still provide, those who are looking for the harm reduction tool, who are adult smokers, that option, and then also reducing that access to youth as well.
But perhaps not worsen health disparities. If we focused on a point of sale restriction, we wouldn't sort of dig the rivet between health disparities, because every point of sale tobacco sale could be restricted, including menthol, and we would still decrease access to children. And perhaps it would be perhaps it would be a more compromise driven bill in a way that, and I'm not saying we should compromise with kids, with people who are trying to sell tobacco to minors, but when you look at the data for my community around tobacco sales, what I hear from our police when they're talking about how kids are getting access to it, it's a place that wouldn't be allowed to sell tobacco anymore if we had 21 sales restriction. So there's this part of me that says, like, okay, so even if you want to rule out every study that's been published calling out the San Francisco or San Diego data, even if you don't want to trust anything that came out of that city, and there's more than one study, but even if you didn't want to, even if you wanted to say not include that as reason for pause, there would be no reason to say that a policy that restricted point of sale 21 plus sales would be ineffective. It probably would be very effective. And we've already seen a huge reduction in tobacco consumption related to COVID. And in this sort of like limbo year, T21 legislation still taking effect, that this might be what it takes to get us like significantly towards progress. Would you agree?
Yeah, again, I going back to my point, I think anything that limits the access of these products to youth, again, this is something that, I'm very intrigued by. I would want to read a little bit more about the research around it. And I know you mentioned not much has been published, but just reading more into it, learning more about it before I make any big statements here. But again, from my point of view, anything to limit or reduce or remove access of these electronic e-cigarette vaping products from youth is good.
And one of the last question, one of your papers that you published was about marketing language that's being used in access. I'm really interested in that paper. It's very similar to colleagues of mine who do food marketing research. And I see like the view of those messages is really important. And I think that one of your findings is about like the number of times and points of exposure where children are seeing those types of messages. Can you talk a little bit about why visually seeing the products, like so moving it to a 21 plus venue or ban, would be effective because the actual seeing it is a commonplace, like at every checkout counter? Like, why is that a problem?
In my research that I've done, I have found that the tobacco industry and vaping industry have targeted youth, and what youth find appealing in some of these advertisements is seeing the product themselves or the product packaging. And I think that's, again, I didn't look into the science behind why that is the case, but from what I can hypothesize, I think youth see the product and they learn about it. And when products are flavored, they're also more colorful and they have the images of the fruit and the flora and the whatnot. And that is what we found also in that study, is that all of that, the colors and the images and all that associated with the flavors and the product, those are all appealing to youth. So again, going back to why, limiting access, restricting flavors, all good things to prevent youth from using these products.
I really appreciate you taking the time to answer questions. I'd love to ask you some more stuff offline. And
yes,
if you want to connect, I didn't see written testimony with your contact information, but I think there's 2 people with your name at Harvard. So if you wouldn't mind trying to connect with me, I'd appreciate talking to you more.
Yes, I'll write your name. Yeah, I'll make a note of that right now. Thank you, Representative and Dr. Foster.
Excellent. Quickly, I just want to clarify a couple of things. Jessica, just so that you're aware, you may not, maybe you were in Connecticut when this happened. We do have a tobacco 21 bill that's passed, and this public health committee was part of that. So we have that already in place. The other thing it's worthy is that 79.1% of all of the students, according to the MMW report from 2021, shows that the kids actually, MMW, 79.1% use flavored vapes. And again, I want to clarify, because I think you probably did not get the question. The issue is going to be that, do we allow our middle school and high school kids to continue to have 79% of flavored vapes based on one data point, which now you say based on CDC is flawed, and continue that policy? To me, is probably not worth the research to put the next generation of our children based on one or two people's studies, when the CDC and all other researchers have overwhelmingly said that vapes are not safe for children. And vapes are actually dangerous. Now, we've already shown in multiple other studies outside of one study, which we are already questioning based on CDC now, which is amazing news this morning, is to say that the combustible decreases as well. When you actually remove the vapes from this environment, the combustible decreases. And that's what you're saying as well from the Oakland part, but also some of the other places, that when the flavored vapes are removed, the combustibles decrease. Is that what I understood?
Yes.
Okay.
So again, that we noticed that as like a trend in Oakland, and just in general, in my own research, my own understanding of the literature, a lot of youth who use e-cigarettes or vapes, they are also using, or let me flip it this way. Those youth who are using cigarettes, combustible cigarettes, they're usually also dually using e-cigarettes and vapes. So there's not a lot of youth who are just smoking cigarettes, like combustible cigarettes, and that's it. It's generally like they're using the two together. And so it is my strong belief that by removing access to and removing those flavors, so that youth are not vaping flavored products or just vaping products in general, that the rate of smoking combustible cigarettes will also kind of together, that overall substance use will be going down.
Can I also ask you if theoretically some of the researchers who have been suggesting that the combustibles may go up, why is the tobacco industry putting millions of dollars to try and stop the states from banning vapes, flavored vapes? Why is it in San Francisco alone, $12 million were dropped, and then the campaign was millions of dollars? Why would that happen? Does that make any sense to you?
Yeah, I mean, because they want to make money. And when they restrict the flavor or the sale of flavored e-cigarettes and vapes, that's a huge source of revenue. That's because youth are their kind of main customer, if you will say, of those flavored products. So you remove that, that's a huge financial loss to these big tobacco, big vape companies.
Yeah. Now, who are the other researchers that were with you in this study?
Yes. This study I did with doctors Lester Hartman, who is a pediatrician here in Massachusetts, Dr. Andy Tan, who is one of my mentors. He's a professor at the Annenberg School of Communication, and then Dr. Jonathan Winikoff, also a pediatrician and one of my mentors here in Massachusetts.
Okay, and in which university are they affiliated with?
Dr. Jonathan Winikoff is with Mass General, and I believe he has an appointment at the Harvard Medical School as well.
Okay.
Yes.
Okay. And I know Dr. Pettit had raised his hand earlier, and then Representative Gilchrist has questions. So Dr. Pettit, do you want to continue?
Yeah, just a quick, and maybe it's for you, Mr. Chairman, and for Dr. Liu. One of the counter arguments is typically is whether or not some of the flavored vapings help the smokers get off combustibles. It seems to me that argument has lost steam over the last several years. So I wondered if you had a position, or your department had a position in terms of that flavored vaping is allowing people to discontinue smoking completely, and if it's had a role in therapy, if you will.
Senator Alwar, would you like me to respond?
Yes, please.
Yes.
Please go ahead.
Yes. So again, I mentioned this a bit earlier, but in a lot of research has pointed towards those flavors are really what appeal to youth and not adults. I think adults report more like using the like tobacco and those types of flavors, and then youth report liking the fruity, the sweet, the minty ones. And there's multiple studies that have been published to show this. So I strongly believe that if we want to still, I think that, e-cigarettes can be a harm reduction tool for adult smokers who are looking to quit, but they do not need the flavors in order to do that. They don't need the strawberry and the mango flavored vapes. They can use the tobacco flavored vapes to do that.
Thank you.
Thank you for that. Do you have another question, Dr. Pettit, or no? Representative Gilchrist.
Great, thank you, Mr. Chair, and hello, Dr. Liu. Thank you for being here. 2 questions. First, the paper you're referencing, is it peer reviewed?
Yes, thank you, Representative Gilchrist. And just a correction, it's future Dr. Liu. I'm still a PhD candidate. Just wanted to clarify that. But yes, the paper that is imminently or will soon to be published, it will be peer reviewed.
All right, wonderful.
And then peer reviewed.
Okay, thank you. And then my second question, do you think that the federal T21 might confound the findings related to combustible increasing?
Yeah, again, that's out of the scope of sort of the analysis or the study that we did here. But I think this goes back to me saying that I think there's a lot of contextual factors that we need to consider in terms of what policies, like what's happening with the policy. So I definitely think that it's important to consider. I think T21 is a good thing and might be like it should be showing that or tobacco or overall tobacco use is going down in general. And I think sort of that, again, that one data point in San Francisco might just be an outlier in that case.
Thank you so much. Soon to be Dr. Liu. Thank you, Mr. Chair.
Thank you.
Okay, I think Representative Foster has some other follow-up questions that she would like to ask. I think when San Francisco quote-unquote study came out, that did there was T21 was already there. There was a tobacco ban there as well. The other part I just want to clarify is before we try to continue to fight, I mean, there are people who have perspectives, but I know when we were trying to ban the menthol, there was a big argument that it's going to have an impact on the finances of the state because unfortunately the state makes tax dollars from that. And then that's part of the reason that we got such pushback from powerful parts of our state. And that's why I think from a strategic point of view, you want to try to save the children. And then you actually look at other ways of addressing the menthol cigarettes, the combustible menthol cigarettes. But I think the menthol flavored vapes are also a mechanism of trying to entice youth, especially the minority youth. And then the fact that this bill is looking at that is a good, important part to make sure that all communities are protected. Again, the children are children, whether they are in the inner cities or anywhere else, we need to protect them. And the data is pretty scary because it's across the board. Everyone every child in school systems is getting exposed in some respects. So I want to clarify that because I didn't want equity to be confused with keeping tobacco, vapes, and nicotine content for our children in schools for that purpose. Representative Foster, you had a question.
This is just one point of clarity and follow up. I'm sorry. You said that your paper was going to be peer reviewed. Is it accepted pending revisions?
Sorry, it is. It has been peer reviewed and will be coming out very soon. So it's
okay. So it's accepted pending revisions.
there's no more revision. Like it's coming out. Like so, yes, like so it has been peer reviewed. It's accepted. Like it's going to be coming out. Yes.
Peer revisions have been accepted.
Yes.
Okay. All right. Sorry. Thank you. You said it will be peer reviewed, and I was like, ah. Yeah.
Sorry,
Okay.
that was a slip up on my mistake.
Yeah. Thank you.
That is
Okay.
yes.
You got Representative Amy Berger-Giavalo.
Thank you so much, Mr. Chair. I just want to, and I apologize if I missed this because I was also listening to testimony in another committee. So please forgive me. I try really hard not to double up on any of these. But returning to Dr. Pettit's question on this adults and flavors, are there any specific studies that have data that can show us that adults don't prefer the flavors?
Yes, there definitely are. I cannot, like off the top of my head, I can't say the exact citation for you, but if you'd like, I can follow up with some of those.
I would love that. That would be really, really helpful.
I will make a note of that right now.
Thank you so much. I think we can all benefit from that one. Thank you.
Any other questions or comments? Seeing none. Thank you, Jessica Liu, hopefully soon to be Dr. Liu. And thank you, Representative Berry, for your testimony as well. Thank you so much. And we will move on to the next person on our list. Bear with me. I have to change my screens to get to the next person on the list, which is, give me 1 second. Organization. That's a problem when you need to save paper and then use it on a computer screen. Next person I have is number 17, Mukhtar Zalidar. And I'm not sure is there. And then Dawn Hemstock.
Good morning. Are people able to hear me?
Very well.
Thank you. Good morning, Chairman Anwar and all. Thank you for the opportunity for allowing me to provide testimony this morning. My name is Dawn Hemstock. I'm a resident of Brantford. I'm a member of the nonprofit for Cameron. I'm a mental health professional, and I'm a concerned mother and grandmother. I support HB 5430, and I ask the committee to support and pass this legislation. There is a relentless public health crisis related to opioids that is taking a harsh, deadly toll on people in the state of Connecticut. I would like to highlight the urgent crisis of overdose deaths due to illicit fentanyl. There is an immediate need to raise awareness of illicit fentanyl as a poison being ingested unknowingly by its victims through other substances, especially pressed pills cut with fentanyl by drug dealers to maximize their profit and disguised as Xanax, Adderall, and OxyContin, among others. 2 out of 5 pressed pills seized by the DEA in 2021 were cut with deadly dosages of fentanyl. There were approximately 1,250 people who died from overdoses in Connecticut by November of 2021. That number is expected to increase for 2022. 85% of those overdose deaths involved fentanyl. We have recently seen how this crisis is affecting our young people with the overdose death of a 13-year-old Connecticut child in his school and 6 spring breakers in Florida experiencing fentanyl overdoses last week. The state of Connecticut has a history and reputation for national leadership around care for its citizens. For example, mitigating the COVID pandemic and addressing gun violence. It is imperative that our leadership provide equivalent attention to the deadly opioid fentanyl crisis. Based on statistical data, 5 Connecticut residents will die from overdose today. The time to implement adequate and effective prevention and treatment measures is now. Thank you again. I appreciate the opportunity.
Thank you so much for your testimony and thank you for your advocacy work. We truly appreciate it. I see Representative Parker has a question or a comment.
Thanks, Mr. Chair. Thanks, Dawn. It's nice to see you. Just first wanted to thank you for all the time you've put into organizing and advocating. It's been really great to work with you and your teammates at Fort Cameron and all the other organizations that have come together. Just wanted to ask you briefly, I know that this, you spoke a lot about fentanyl and pressed pills and this legislation in the Public Health Committee isn't taking that on as directly, but curious if you wanted to share briefly your thoughts on what you wish could be done with regard to those issues more broadly, just so we have it on our minds.
Thank you so much, Representative Parker, and thank you to the legislators who took the time to meet with the Fort Cameron Demand Zero and other nonprofit collective team to discuss the opioid epidemic and to highlight fentanyl. So we are going to continue to work to see that awareness is raised regarding the fentanyl crisis. It still feels like not enough is being talked about, in particular to what is going on. And based on the brief information that I presented in my testimony, it would seem that there is an immediate need for attention. So we're looking at raising awareness, so that would be preventative measures, thinking about treatment resources, and having the correct number of resources to meet the need that's occurring now. There has been a lot of discussion over the years about a lack of sufficient treatment resources, i.e. beds, right, for detox treatment, for long-term effective treatment, so longer than 90 days. And there's a lot of statistical information to back up the need for that, for treatment to be effective. So those are a few things that we're looking at continuing to advocate for in the future.
Thanks for sharing that, Dawn. I know that we've been thinking about the bed capacity and a variety of other treatment options, and hopefully this bill, the work on M18 here is going to make a difference. But just hear loud and clear that this is something you folks are going to continue working on and advocating for, and we look forward to working with you. Thanks for your time. Thanks, Mr. Chair.
Thank you so much. Appreciate it.
Thank you again for your testimony. Ms. Hemstock, thank you again for all that you do and your entire group for the work that you do and your advocacy. Seeing no other questions or comments, we'll move on to the next person on our list, which is Francesca Gaviglia. Hi.
Hi, good morning, Mr. Chair, members of the committee. Thank you for having me here. My name is Francesca Maviglia. I'm a resident of New Haven, and I'm also a postgraduate research associate at the Yale School of Medicine. And there I work on HIV prevention research with people who use drugs, and in particular opioids. So in my work, I'm based, even though I'm part of a research team, I'm physically based at the Yale operated needle exchange in New Haven. So in addition to conducting research studies, I also help distribute clean syringes and other harm reduction materials to clients of the needle exchange. So I'm here today to support HB 5430, an act concerning opioids. And I also want to offer minor suggestions to improve the language of the bill. So one of the reasons why I support this bill is that I strongly support the first modification to the existing statute included in the bill, which, as I understand it, would remove from the definition of drug paraphernalia items used to test substances prior to consumption in order to prevent overdose. So I really very strongly welcome this modification, as it would decriminalize important overdose prevention resources, such as fentanyl testing strips, which are used to detect the presence of fentanyl in a drug supply. And as you all know, and as we heard from the previous testimony, fentanyl has been increasingly involved in overdose deaths in Connecticut in the last few years. So fentanyl testing strips are a very important and also very low cost harm reduction intervention that allows people to basically be more aware of what is in their drug supply and then be able to pace themselves in the consumption. So in my work at the needle exchange, I often distribute fentanyl testing strips to clients. But the current statute paradoxically criminalizes my clients for trying to take steps to protect themselves from overdose. Moving forward, I also urge the committee and Connecticut legislators to take steps to decriminalize other kinds of drug paraphernalia, including smoking pipes, which my understanding as, of course, somebody who's not a legal expert, but my understanding is that those would remain criminalized even if this bill was passed. We have decades of evidence from syringe exchange programs that show that distributing drug paraphernalia does not increase drug use, but has a positive effect in reducing the transmission of infections such as HIV and hepatitis. While Connecticut took the important step of decriminalizing the possession of syringes a couple of decades ago, we still need to do the same for other kinds of paraphernalia. Clean smoking pipes, for instance, are very important to prevent the transmission of hepatitis B and C through the sharing of pipes that would otherwise occur when people are not able to have their own personal one. And now during the current COVID-19 pandemic, it's also very important to reduce sharing in order to reduce the spread of COVID. So at the Yale Needle Exchange, we distribute pipes to our clients because we want to keep them safe from these diseases. But
excuse me, Ms. Bagavilla, your time is almost up. If you could summarize. Thanks.
The very last thing I wanted to add is that I urge the committee to eliminate from the bill language that describes substance use disorder as abuse, which is something that is repeatedly appears in the text of the bill. The first step to combat drug-related harm and fight the opioid crisis is destigmatizing drug use. And the expression drug abuse has a negative connotation and reinforces the stigma. The correct scientific expression for problematic drug use is substance use disorder, as defined by the DSM-5. So I really strongly believe that laws and state agency communications should use science-based public health terminology and avoid stigmatizing language. So in summary, I support this bill. I ask the committee to support and pass this legislation, take in the future further steps to decriminalize other drug paraphernalia, and modify the text of the bill to replace stigmatizing language with public health informed terminology. Thank you so much for your time.
Thank you, Francesca Mavia, for your testimony. You have a written testimony as well. I want to make sure for some of the changes that you have suggested.
Yeah, I believe I sent it in, but I can also follow up and send it again in case it did not go through. I apologize.
Since you're making some suggestion, I think it's worthy to look at the specific language suggestion that you've made. So
Yeah,
seeing no other questions or comments, we thank you so much for your testimony and the work that you're doing. Thank you.
Thank you so much. Thank you.
Next person on our list is Dita Bhargava. Dita is a friend of our committee. Welcome. Thank you for waiting and then looking forward to hearing your testimony.
Thank you, Senator Anwar. Honorable representatives, I'm Dita Bhargava, an ambassador for Shatterproof. I'm testifying in support of House Bill 5044. I appreciate the many leaders who have tenaciously fought to contain the opioid epidemic and form this bill. Sadly, despite our state's best efforts, overdose rates continue to climb as the insidious disease of addiction spreads. One such victim was my son, Alec Pelletier, who died unwittingly of fentanyl poisoning on his 26th birthday in 2018 while living in a sober home in Canaan, Connecticut. Alec was a warm, vivacious AAA hockey player. As a teen, he suffered from a mild bipolar condition and was self-medicating first with easily available opioids, then with heroin. In the end, Alec wanted nothing more than to live a life of recovery, empowered by the love of his family and friends. The real tragedy is that my family is far from being alone. Over the last several years, we've senselessly lost thousands of young lives like Alec in our state. Our moral, social, and economic obligation is to find solutions to end this public health crisis. HB 5044, well, sorry, I think, have I got the right? I know I asked 5430. 5430. I'm sorry, we'll provide the necessary guidelines on using funding towards this crisis. But we must go further. I urge you to consider the following. Number one, use every dollar impactfully. Make sure that the principles for the use of funds from the opioid litigation published by Johns Hopkins and Bloomberg School of Public Health, that the language is in this bill. Number two, the immediate need for safe injection facilities. This idea may seem like an extraordinary measure, and it did to me too. Then I lost a child. Committee members, I can assure you, regardless of political party, anyone who has lost someone to overdose would turn back time to provide a safe place for their loved one to take their drug and to save their life. Potentially 1,400 lives per year saved, and an opportunity to educate about treatment and recovery provided. Overdose is not a partisan issue, and we cannot kick this idea down the road. The dangers of the fentanyl scourge make this an urgent priority. I have personally spoken to legislators on both sides of the aisle who agree with the notion of safe injection sites to keep their constituents alive. I plead with you to reconsider. And number three, the immediate need to address the deadly fentanyl plaguing our communities, as we've heard over and over again through the testimonies this morning. Fentanyl is responsible for 85% of overdoses. Imagine that the dangerous chemical anthrax was being spread through our state for a moment. A few cases would lead to aggressive measures to find and punish perpetrators. Therefore, I support the proposal from Fiona Freen of Fort Cameron, a fatal overdose task force investigating overdose cases and harsher penalties for drug dealers who knowingly traffic poisonous substances laced with poisonous fentanyl and other poisonous substances, with an admonishment clause for first offenders. Lastly, education. Expand youth programs and institute mandatory K-12 social emotional learning education and warn kids about the dire dangers of illicit substances. Evidence-based K-12 life skills programs have reduced substance use disorder by up to 75%, numbers we cannot ignore. Honorable Chairman and committee members, we don't have time to wait for bold measures. The need was yesterday's. Please do consider these ideas now. Thank you.
Thank you so much, Ms. Bhargava, for your testimony, and thank you for sharing your pain and using it to make sure we protect everyone else. We truly appreciate your recommendations. We will absolutely consider them. I see Representative Parker has a question or a comment.
Thanks, Mr. Chair. Nice to see you, Dita. Thanks for joining us today and for what you shared. Just had one question. You spoke about a number of issues and ideas and approaches to try to manage this really complex situation that crosses a lot of domains. I wonder if you could just speak a little bit on what you think the role of the Public Health Committee can be in terms of helping move the ball forward, particularly when it comes to issues outside of our domain, like education and law enforcement and others.
Sure. Well, thanks again, Representative John Michael Parker, for being such a leader in this space, and it's been a pleasure speaking with you, working with you. Look, you and I have talked about a command center approach, which we have seen in places in the United States, like, for instance, Dayton, Ohio, that had one of the worst opioid epidemics, overdose epidemics in the country. And they applied the command center approach, where groups from different stakeholders, whether they're committees, government committees, or their law enforcement, or their healthcare workers, local communities, navigators, they would all come together, data share, and tackle each and every overdose from a command center approach. And that seemed to work very well in Dayton, Ohio. I think I sent you some of the research there and a report that was written about that. The other place that we must look at that has had a tremendous amount of success mitigating their heroin epidemic is Portugal, which took their heroin epidemic down by 90% in a matter of 7 years. Again, using this command center approach. They also use the safe injection facilities. I cannot emphasize, and this is a public health committee, this is where this notion should be thought about seriously and moved forward. We spoke earlier about how Connecticut should be a leader. Connecticut has to be a leader. We have one of the worst
opioid overdose crisis in the country, sadly. Not sure why that is. I can't figure it out, but because we're doing some great things, but it's not enough, clearly. And these are the type of bold measures that we need to take now, while we have a federal government that would most likely support us now more than they ever have. They've been talking about harm reduction openly for the first time and ever. So I think we could become role models in this, but most importantly, we could save precious lives. And I know that Republicans and Democrats agree that saving a life, saving that child, saving your own child, saving someone else's child by providing that safe place where they can inject and having the opportunity to educate them, who could say no to that? It's harm reduction, and it's a bold measure, but it has to be taken now.
Thanks for sharing that, Dita. And again, so sorry for your loss. Thank you for sharing with us.
Appreciate it.
Thank you, Representative Cook.
Hi, Dita. It's nice to see you, but I'm sorry that we have to continue to harbor down the same path that you and I've spoken about many years ago. If you could please explain, so we all know that there is this negative oversight of safe injection sites. We had the same problem when we talked about methadone clinics and things like that, but we've seen that some of those things have worked. The oversight of the folks, or the expertise of the folks that actually are in these clinics, and how that process works, I think is so vitally important to get that information out there, because such of the misrepresentation of what actually it is and how we get past the stigma. So I know this is a very difficult subject for you, but I know that you are very passionate about changing it to ensure no other family has to suffer the loss that your family has had to suffer. So if you could please just a little bit further explain what, to your knowledge, on what the inside of those facilities might look like, I think would be vitally important, not only for our committee, but for all those folks that are watching, to help us eliminate the stigma to get to a healthy place.
Sure. Thank you, Representative Cook, and it's good to see you, but sad that it is during this bill and these circumstances that we continue to fight together. I imagine that a safe injection facility looks very much like a methadone clinic, where you have a public health worker that would be supervising the clinic. From what I understand from the ones that are in Vancouver, for instance, in Canada, and in Portugal, there is a public health official there. The person would come in, they would not be provided with the drug. They would use the drug that they normally would have used outside of that clinic, and very high chance of dying on it. They would bring that in. The difference is that they would be in an environment where somebody has the expertise to administer Narcan to reverse a fatal overdose. I've toured the van that Mark Jenkins drives around now, first in Hartford, now really all over the state. It would be very similar to that, and be equipped with the same type of harm reduction materials that Mark drives around with, whether it's clean needles, blankets, water, just things to help the person with a substance use disorder feel like there's a sense of trust and comfort in that place. And then, of course, all the materials that one might be given to educate them about treatment and to educate them that recovery is real and that they could be part of that. So in Portugal, this has worked brilliantly. When they are able to come into a place and feel safe and not be judged in using the drug that they're using, they're very open to making that relationship and trusting that the materials and the education that they're receiving is real. And they've had a huge success rate of people seeking treatment and then being in recovery for a long, long time.
Thank you for that. And then my follow-up question to that would be, you hit on the one thing I think that scares people the most, is that they would be using their own drugs that they brought in from wherever they access that from, whether it be on this, the street, their dealer, or what have you, which we recognize that there is an immediate death if you inject with the wrong. All drugs are wrong. I mean, but that's a subjective conversation, right? So if you inject a very toxic and lethal dose, the possibility that Narcan saves you, regardless of where you are, may not be a real conversation. So what is the pushback as far as making these injection sites with a safe drug, as opposed to a drug that you find on the street that you don't know what might be in it?
Look, Representative Cook, I think it's going to be a whole new set of challenges and conversation if a site were to provide the drug. Unfortunately, with the high addictive nature of fentanyl, many are becoming addicted to fentanyl. And I don't think that we will ever be able to advocate for a situation where we are providing the fentanyl for people to inject. Now, I will tell you that, and it's been a while since I've looked into the updated numbers in Vancouver, for instance, but they have this practice, and they haven't, where people bring in their own drug of choice. And when I researched that last, and that was sometime last year, they've had thousands of people come into their clinic. Not a single one has died. And they've had many Narcan administration and saved many, many lives. So the evidence, I think, points to that Narcan, if administered the right way, will reverse an overdose regardless of what the drug is. I think it's going to be very difficult to provide a place where you can actually give the drug, because people are they're addicted at different potency of different drugs. And this is the problem with our state being plagued with the worst type of drug that we've ever seen. It's poison, and people are addicted to this poison. A lot of it is unwitting, but unfortunately, a lot of it is folks, from what I understand, seeking out fentanyl because the heroin doesn't do anything for them anymore.
Thank you, and thank you for that. I greatly appreciate your dedication to this very difficult conversation and trying to save lives. Thank you so much.
I appreciate it, and I'd just like to lastly add, look, I think this is such an important matter, and we've been talking about it for years, and I've been talking about fentanyl for years, and it's only gotten worse. To possibly take a delegation and go visit, the clinic in Vancouver, go visit Portugal to see how they reduce their heroin epidemic by 90%, or be in contact with some of the folks in the other states, like in Dayton, Ohio, and in Oregon. They have some out of the box harm reduction methods. I saw that the governor had this fabulous trip to Israel recently. Great, we should be bringing that business in, but we should be also going out and researching what has worked and what hasn't worked to keep our kids alive. To me, that's the most important thing in our state. It's not just a moral obligation, like I said earlier. Our life expectancy has fallen 4 years in a row, single-handedly due to substance use disorder. This is a long-term social and economic problem, and we cannot put enough investment or time or resources or thought to how to turn this massive public health crisis around.
Thank you, Dita, and thank you, Senator, for the time.
Thank you so much, Representative Cook. Thank you so much, Dita, for your testimony and the work that you're doing. Seeing no other questions or comments, we'll move on to the next person on our list, which is Kathy Flaherty. Ms. Flaherty, you're on.
Members of the Public Health Committee, my name is Kathy Flaherty. I am the Executive Director of Connecticut Legal Rights Project. I did submit a lengthy written testimony on 5 bills. I will try to run through it quickly. I apologize to the staff for only submitting my testimony this morning, which is why you may not have it available on your screens right now. Here to support Senate Bill 330. I think that bill appropriately addresses the systemic ableism that exists in medicine that devalues the lives of people with disabilities, and making transplants more available and accessible to people with disabilities. So I thank you for that. Senate Bill 331, I only want to comment on 2 sections of the bill. Section 6 would require physicians, physician assistants, and advanced practice registered nurses to perform mental health assessments at annual physical exams. But that section says, 1, nothing about the patient's consent to that mental health examination, and 2, it's screening, but with nothing, no provision for services. So I'm worried that like doing a screening, we think we will have solved something when we really haven't. Section 7 of 331 and 5075 both would prohibit step therapy. I wrote in my testimony a long description of my experience as a patient in the mental health system who had prescribed medications, and I'd encourage you to read it. Thank you for HB 5395, which is a workforce issue and addresses the huge shortage we have in the behavioral health workforce. I'd encourage you to think about expanding it to other licensed behavioral health professionals like social workers, marriage and family therapists, and licensed alcohol and drug abuse counselors. I think it also, improves access for people in Connecticut, but also would make Connecticut a more attractive place to move if people know that they'll be able to practice their profession. The last bill I want to testify about, 5419, that's the bill. The legislature and the governor back in 2017 defunded the regional mental health boards and the RACs. That's why regional behavioral health organizations were created, is because the boards and the RACs were defunded, because social services get defunded all the time in this state. So if we really want to talk about what defunding we need to stop doing, it's defunding human and social services. I very much encourage you to consider removing Section 4 of that bill. I very much want to believe that it was simply a drafting error and does not represent the intentions of this committee, but Section 4 of the bill would literally remove the voice of people with firsthand lived experience of mental health conditions and substance use disorders from the state board. That can't have been your intention. I can't believe that that's what you wanted to do. I'd encourage you to look at the testimony that's been submitted by Margaret Watt and Marcia Dufour. They were executive directors of the regional mental health boards. When it was a proposal to defund them back in 2017, we collectively in the mental health advocacy community begged you to save our voices, because the boards and the consumer action councils were the voice of the mental health community. And despite what Commissioner Navarrete said, the reality is those of us on the mental health side of things feel like we have not had the voice that we need to have when it comes to engaging with the department. And there were things that the boards did that are not being provided for and not being done by the behavioral health experts.
Excuse me, Ms. Flaherty, your time is almost up. If you could summarize. Thank you.
I will. The last thing I want to do is add my support for the people talking about 5430 and harm reduction and adding safe use sites and testing strips. That's something I testified about to public safety, because I do think we need to start doing something different than what we've been doing on that side of things. I am happy to answer any questions either now or in the future. Thank you.
Thank you so much for your testimony, Ms. Flaherty, and in the work that you do. We appreciate you a lot. I see Representative McCarty has a question or a comment.
Yes, thank you very much, Mr. Chair. Just very quickly, Kathy, thank you. I know you come in and testify a lot on a lot of our bill proposals. So just a quick question, but you are approving of having the regional behavioral health organizations put into statute to protect their functions, but you would like to see eventually going forward that we have more of the lived experience voices. Is that what I'm hearing?
I appreciate the question, Representative McCarty, and I think that ship has already sailed. The Department of Mental Health and Addiction Services created the regional behavioral health action organizations when the boards and the RACs were significantly defunded. I don't know that we can go back without a significant investment of state funds to have the re-preserve or get back the functions of the boards and the regional action councils as they existed beforehand. So I think reluctantly, I would say I support it because in reality, it's not currently authorized by statute. What only exists is the boards and the RAC. But I wish that we had done something better. I did put in my written testimony that I don't think we could have prevented the mental health crisis that all of you have made your top priority if the boards existed as they used to exist and were functioning as designed. But I think we might have known about it earlier because they would have been that proverbial canary in the coal mine, and doing those needs assessments, making those reports to the department, and it would have become abundantly clear far sooner of the need to address the need for mental health services in the state.
Thank you for your comments. Thank you.
All right. Thank you so much for your testimony. And seeing no other questions or comments, we will move on to the next person, which is number 23, Joseph Ferrin. I hope I pronounce it accurately.
Actually, you did very well. Thank you. You didn't mangle the name. Good morning. Thank you, Senator. Thank you, members of the committee. My name is Joseph Ferrin, and I'm a member of the nonprofit for Cameron here in New Haven. I would like to speak on the raised bill number 5430, an act concerning opioids. Let me preface my testimony by saying I agree with and support this raised bill. I understand this is a short session, and you are trying to get through as much as you can in some abbreviated kind of version to at least get the ball rolling, I would say. But this raised bill does not even touch the tip of the iceberg when it comes to fentanyl, which is disappointing. I am pleased to see this does address, though, the negative social stigma associated with substance use disorder in our state. I do want to say it is about time this is being taken care of, and I applaud your effort in this respect. I am surprised there is nothing here to address fentanyl test strips, expanded free Narcan distribution and education, expanded crisis support, harsher penalties for dealing fentanyl, and expanded treatment services, just to name a few. I respectfully suggest you all look at this through a different set of eyes. You are attempting to address the opioid crisis in Connecticut, but ignoring one of the most important parts, pressed pills and fentanyl. An opioid task force, similar to our gun task force, needs to be formed. I'm not suggesting we're arresting our way out of this crisis, but what we are doing now in all aspects just does not work. Look at it this way. If Cameron left work and bought a bottle of what he thought was tequila from a coworker, and it turned out his coworker knowingly sold him a bottle of rat poison and he died, someone would be in prison right now. Why is it any different if someone sells a pressed pill, knowingly disguises OxyContin, but it's actually fentanyl? What would happen? Right now, nothing. Thank you for your time and all the work you do for the state of Connecticut. And remember, before the day's out, 5 people will have died. Thank you.
Thank you, Mr. Ferrin, for your important testimony. I know Representative Parker has been working very hard on this bill, so he has some questions and I will follow up after him. Representative Parker.
Thanks, Mr. Chair. Yeah, Joseph, just wanted to thank you for being here with us. We're so sorry for your loss and appreciate you sharing that with our committee and continuing to. We hear you when you say that there's so much more that needs to be done. Call my colleagues' attention to the conversations around fatal overdose task force that Representative Gilchrist and I have been having, and maybe that will be directed towards another committee into the future, but we think that's a really promising idea and we look forward to working on it. So thank you for being here and for the comments on this bill that's before us and the next steps that it takes.
Thanks. I agree. Thank you very much for your work.
Seeing other comments or questions, I have a brief comment. I think through the Judiciary Committee, it's worthy to start to look at, and I know many of the fellow legislators would want to work on harsher penalties at various levels in this supply chain, if you will. That's part of the challenge that we do have, that we will have to try to look at, and you make a very important point on that. That's something that we will have to escalate as well further beyond what we are talking about at some point, because in this entire supply chain, there are bigger mechanisms that are out of our country here. But when it reaches here, we have an opportunity here. And then, of course, the federal government can participate and do much more from their agency's perspective as well, which is beyond our scope. But you make a good point. If you want to expand on that, this would be a good opportunity.
I appreciate everything you said. I fully believe that Connecticut, New Haven, Connecticut should be on the forefront of this. We should be able to handle this now. Let the country see what can be done with it. We did it, like someone said before, with COVID. We can do it with this as well. Again, I don't want to arrest our way out of the crisis. I don't. That's not the way to do it. But that's got to be a major point here. You can't just have people selling this stuff on the street at your house. Literally drive to your house and give it to you, knowingly giving you something that's going to kill you. It's just got to stop. So, but thank you. I look forward to working with all of you in the future.
Thank you so much. Seeing no other comments or questions, we will move on to the next person on our list, which is Mary Kathleen Moser. Ms. Moser.
Hello. Hi, thank you for having me. My name is Mary Moser and I live in Darien, Connecticut. I'm speaking on behalf of HB 5364, an act concerning the Tobacco Settlement Fund. While funding $4 million to fight tobacco use is a step in the right direction, I am asking you to consider $12 million in funding. I am a mother, an intern with ACS CAN, and a student working towards my master's in public health. My most recent employment was as a registered nurse at Memorial Sloan Kettering, one of the leading cancer hospitals in the nation. Watching cancer patients, particularly lung cancer patients, fight for their lives is a humble and eye-opening experience. Painful surgeries and fighting for breath are not things one fully appreciates when beginning smoking. Smoking continues to be the leading cause of lung cancer and lung cancer deaths. I have also worked with many patients who have chronic obstructive pulmonary disease, another disease affected by smoking. They are sent home on oxygen and suffer from chronic anxiety, unable to take a deep breath. According to the CDC, cigarette smoking greatly increases the chances of COPD. A study published by the American Journal of Public Health in 2008 showed that state-run tobacco control programs significantly reduce overall tobacco use in adults. In order to make this impact, tobacco control must have significant and sustainable funding. I personally do not want to watch more people fight for breath. I want my daughter to grow up knowing the dangers of smoking and to receive comprehensive anti-tobacco education. With your support for HB 5364, we can fight tobacco use together, we can reduce disease caused by smoking, and we can create a better future for our children. With your support in providing $12 million for tobacco control programs, we can improve health and quality of life across the state of Connecticut. Thank you so much.
Thank you so much for your testimony. Do you mind speaking a little bit about vapes? We do have a bill to try and restrict flavored vapes, and then with the children and protecting your daughter and all of our children. What are your thoughts on the money being used for that as well? Because that is the on-ramp across the country right now.
I wish I had more data to support an educated answer. So I am going to defer to Bright Johnson later when he testifies on the bill itself.
Perfect. Thank you so much. And I could not agree with you more. The cancer, COPD, all of it is preventable. And by the time they have the cancer, it's a little too late. And we can still do a few things, but we cannot go back in time. So I appreciate your testimony. Seeing all the questions or comments, we will move on to the next person, which is Mr. Tanner Bommerback. Bommersback, sorry. Did I mess it up?
That's right, Senator Arnold. That's correct. Dear members of the Public Health Committee, my name is Dr. Tanner Bommersbach, and I'm a physician specializing in psychiatry. And I work in a public clinic that specializes in the treatment of substance use disorders in New Haven. I stand in support of Bill 5430 and several of its provisions that I believe will save lives across our state, including the legalization of fentanyl test strips, enabling mobile methadone, eliminating unnecessary pharmacist recertification requirements for Narcan, and improving data sharing amongst our state agencies. However, I'd like to talk about one provision that I think needs to be added to this bill and also specifically highlight the importance of the data sharing provision. I would like to see a provision added that would require methadone to be included in the PDMP. This may seem like a little bit of regulatory minutia, but as a physician who works with patients on methadone, I can tell you that this frequently impacts patient care. I would refer you to the written testimony of 3 mental health providers, Dr. Emma Lowe, Dr. Claire Gibson, and Karen Cahoon, who all described several patient encounters that had poor outcomes because methadone was not included in the PDMP. But what I want to spend the rest of my time on is highlighting the importance of Section 9 of this bill, which would mandate state agencies to collect, link, and analyze data to help drive solutions. As you know, in 2020, over 1,300 people in our state died of an opioid-related overdose. But in addition to those who died, thousands of others suffered a non-fatal overdose. And data shows that 5 to 10% of these individuals will go on to die of an overdose in the next year. It's important that we're able to answer key questions about these individuals to prevent their future overdoses, what I would refer to as the who, the what, and the where. Who is overdosing? What is causing the overdoses, and where are these overdoses occurring most frequently? But unfortunately, our current data infrastructure in the state is not able to answer these questions in real time to get high-risk individuals the treatment that they need. Representatives from state agencies have said that they're already collecting this data, and this is partially true. However, the data is not robust enough or available in a timely manner to answer key questions that would allow us to intervene most effectively. Some questions that we need to be able to answer, but we're not currently able to answer include, what is the % of overdose survivors who receive treatment after they overdose? What % of individuals who died of an overdose were actually getting treatment prior to their death? And what % of people who overdosed were recently incarcerated in Connecticut DOC prior to their death? Other states like Maryland and Massachusetts have created linked data processes that allow them to answer these important questions in real time. And I would direct you to the written testimony of 2 experts from these states, Dr. Brendan Saloner from Maryland, who's already submitted his written testimony, and Dr. Jake Morgan from Massachusetts, whose testimony will be coming. So in conclusion, I commend the members of this committee for introducing this bill, but ask that the committee consider adding a provision that would require the inclusion of methadone in the PDMP. And I would also ask that the committee pass the bill as written to include Section 9, the data sharing provision. Thank you very much, and I'd be happy to answer any questions.
Thank you so much. This was very helpful. And so I think in the absence of what you're saying is in the absence of this data right now, we do not know the number of people who are actively being treated, and you cannot actually follow them and see how many people are falling through the gaps, if you will, right?
That's right. That's right. We need to be able to answer some simple questions about who is most at risk in our state, how often these high-risk individuals are getting treatment. And right now, we don't have those answers in real time in order to effectively respond to the epidemic.
This is very useful. Thank you so much for your testimony. Representative Parker has a question or a comment.
Thanks, Mr. Chair. Nice to see you, Tanner. Thanks for being here with us. Really appreciate this. And as we spoke with the commissioner this morning, clearly there's a intention and desire, obviously, for the speaking, for DMIS, and I know the other agencies, to really be providing this data and working together on this issue. I'm curious, is there a chance, and we heard the commissioner speak about the fact, I think she specifically spoke about using data in a predictive manner to try to think about where we can best put focus. I'm wondering, could there be a case that you, as someone that's out in the field working on these issues, is not getting access to the same level of data that our agencies are? Could that be maybe where a gap is? Does that make sense?
Yeah, thanks for that question. I think it's a great question, Representative Parker. Yeah, that's I think certainly a possibility. I think one of the barriers is that, as far as I understand it, the data that each of these different agencies is collecting isn't being linked into a central repository, which is then de-identified and shared more publicly to allow researchers from academic institutions to really dig in and analyze this data and help answer these key questions. In Massachusetts, for example, they were able to kind of collate data sets from 23 different agencies into a shared repository that's de-identified and able to be accessed by researchers and other public health officials that can help come up with shared metrics and then track the progress of those metrics so that we can really see the state of the opioid crisis in our state. And so I think to answer your question, what we need to collate all of these different data sets from all of the different agencies and make them publicly available to allow researchers and other officials to access them.
That makes sense. I know you could probably all have a great conversation to learn even more about what's already happening and then the gap between what's happening and what people know is happening and how the folks can use this information that are making sure the people that are best suited to use this information have access. That's one piece of it. And I appreciate you speaking to that and would love and know you'd be willing to join those future conversations. Just want to pivot to one other thing you referenced, which is tracking methadone in the PDMP. Can you speak to why that might not be happening currently? Just what's the pushback there and what might it take to get that done and what would be the value of that going forward?
Yeah. Thank you for that question. As far as I understand, the challenges to getting that done is it will require some more kind of administrative work from methadone providers to actually manually input that data into the PDMP, and also from some state agencies to have a way to organize and input that data. But this is really critically important, because when I go onto the PDMP, I can see things like Suboxone, which is used to treat opioid use disorder, just like methadone is. I can see other controlled substances like benzodiazepines, but I can't see methadone. And from a treatment provider standpoint, I have a hard time understanding why methadone would be excluded. You'll see in the written testimony from Dr. Claire Gibson, Dr. Emma Lowe, Karin Cahoon, they've all had patients who had poor outcomes due to not being able to know that their patients were getting methadone from another provider and had poor outcomes due to that. So this is really a patient safety issue that we have to reconcile.
Thanks for that, Tanner. I appreciate you also bringing up the testimony of Dr. Saloner, I believe, from Johns Hopkins, speaking about the other state perspectives of this. It helps us identify what some pathways would be, and also appreciate this follow-up on the PDMP. That's something I need to learn more about, why, for instance, Suboxone is currently being tracked, but methadone is not, and maybe into the future, what progress we can make on it. So thanks for your time on that, Tanner. I'm all set, Mr. Chair.
Thank you. So Dr. Bommersbeck, I wanted to ask you, who has the best dashboard? In which state do they have a dashboard where they're following this the best, and who can we follow from that perspective?
Yeah, thanks for that question, Senator Anwar. So I think Massachusetts and Maryland really have the gold standards for these dashboards. Other states like Rhode Island and North Carolina also have similar dashboards, but I would refer you to Massachusetts and Maryland, and you'll see Dr. Saloner's testimony is already uploaded on the website to see their experience there. But it's really a robust dashboard that includes over 20 agencies, like I said.
Yeah. I mean, if you look at how we managed COVID, these dashboards were very effective in trying to local and hyper localize the areas that needed more intervention. And then if we can start to do the same thing with the opioid, we can actually become hyper local and identify the trajectories and also identify best practices within the systems, if you will. So there's a lot of wisdom in your testimony. Thank you so much. And I'm going to read all the people that you're recommending about their work as well. I see Representative McCarthy has a question or a comment for you.
Thank you very much, Mr. Chair, and welcome, Doctor. If you would, and thank you for really pointing out the importance of Section 9 in the bill. I agree with you. We need to know of those individuals who have experienced overdose, whether they was fatal, what happened, where those treatment programs where we may have failed with the follow-up service. So I'm particularly pleased to hear you discuss the importance. If you have an opportunity, if you would look at it and see if there's any agency that we're leaving off in the plan, because I was thinking about our students in the universities and whether or not the Department of Education should have a role also in this agency interaction. So if you could take a look at that and give your opinion at some point.
I Certainly will. Thanks, Representative McCarty. And I would also direct your attention to Dr. Benjamin Howell, who will be speaking to you later, who's an expert in this area as well. But I'll certainly get back to you.
Excellent. Seeing no other questions or comments, thank you so much for your testimony. We'll move on to the next person, Michelle Devine. Ms. Devine.
Hello, good morning, Senator Anwar, Representative Steinberg, and the Public Health Committee. Special thank you to Representative McCarty for her continuous support on this bill. I want to take the opportunity to offer testimony regarding HB 5419 and also Bill 368. My name is Michelle Devine. I'm the Executive Director of the RBHAO CRAC for the 41 towns in Eastern Connecticut. My colleagues have submitted or will be testifying today and share different aspects of everything that we do. The RBHAOs are uniquely situated, and we get to work with across different agencies such as DPH, DCF, DCP, colleges, schools, towns. So we have a really unique position. Today, though, specifically, I'm going to talk to you about our focus of the last few years around suicide prevention and postvention. Prevention, by definition, is decreasing the chance that someone may be impacted, and in this case, suicide. But we cover lots of other issues that you'll hear about. Postvention is social care given after an experience of a traumatic event. We work across the lifespan. Through DEMIS, all 5 of the RBHAOs have grants and dollars to do suicide prevention and postvention work. Many of us have applied for additional funds to expand and do more work. Why? Because we have found through youth and community surveys, focus groups, work in our towns, we are entering a new era post-COVID. Suicide prevention and postvention are rising to the top of our concerns in the state. This is evidenced through our work in our regional priorities. Seniors, adults, and youth are all facing anxiety and depression at higher rates than we've ever seen before, and each of them have different ways of dealing with it. Our outreach has had to shift to be targeted and relevant to the group we are working with. There is no more one size fits all. This has caused our agencies to keep up to date with trainings, be willing to pivot according to concerns presented, and available to respond when a traumatic loss has occurred to assist our communities in evidence-based support. Our calls for training have increased in the last year. In fact, my entire staff is out today training an entire school, student and staff at a tech school. We provide professional development on a regular basis to many of our partners. Our staff has doubled from 4 to 8, 2 specifically working on suicide prevention and postvention. And I have enough work to hire 2 more staff, and I do not have the funds to do that right now. Prevention has taken a hold, and people are very aware of what we do now, and the calls are just coming in. Our 5 agencies are ready to respond with many resources. Our work in postvention has increased over the last 3 years, and we became trained in post-traumatic stress management. Our work has been with police departments, schools, fire, colleges, places of employment. Loss reaches all of these sectors, and we don't always think of the tertiary groups beyond the family. The RBHAOs focus on these groups and the impact of that traumatic loss that it has on all of the other groups. In addition, the RBHAOs also help communities create plans and teams to address these issues before the loss occurs. Prevention, knowing who are the key informants in each one of our towns, what is safe messaging, who needs support, and by making sure we have contact with them. All of this is technical assistance provided by our agency, and it's hands-on with each of our towns because we know each of our towns are different and have different resources. Our current fiscal structure is based only on grant funding that comes into DEMIS. We cannot function on this roller coaster anymore. We need to have confidence that we are supported in our prevention work through not only state statute, but also funding. In the future, we hope to receive dollars from the very systems we are collaborating with. For example, gambling, cannabis, alcohol, tobacco, mental health. We have so much more that we can provide, and we have plenty of work that can be done with more staff. We thank you and would like you to support Bill 5419 and reinstate RBHAOs into the state statute.
Thank you so much for your testimony. I see Representative McCarty has a question.
Thank you, Mr. Chair, and welcome, Michelle, to the Public Health Committee. If you may comment, and thank you for all the great work that all the RBHOs are doing throughout the state and CRAC in my community. You mentioned a lot of the work that's being done with the schools. Could you comment, and particularly with the suicide prevention and all of the various trainings that go on in the district, but would you be able to comment? We know that we have a very serious need for providing more mental health services throughout the state, and we're looking at that. Would CRAC be able to do more work in trauma training if it gets to the point with professional development in the schools? Would you be equipped to work in that area? Thank you.
Yes, thank you for the question. We have been trained by a phenomenal group out of Massachusetts that does have a contract with the state to do trauma response, and that's Riverside Trauma Center. We were trained by them. And the system that they have in Massachusetts is very robust. We definitely could provide training to the school systems for professional development, or any system, whether it's mental health system, the treatment providers. We're getting called about that regularly to do, entry level training for them, but also they are looking for more, again, robust training. And we would be happy to do that. It is, again, time consuming. So we don't have always the staff to do that, but we try to make it work as best we can. For example, one of the areas that I'm sure someone else will speak about, but my area specifically, I'm working with 23 schools to get to review their policies around Narcan and get them Narcan after the loss, in Hartford. So 23 just in Eastern Connecticut right now, and just helping with get their staff trained in that. So there's professional development training, there's trauma training, there's working with our communities preventatively before a loss occurs. And then there's the post-traumatic, many layers to all of this. It's nice that we have other departments in other parts of the state that are doing this work, and we try to collaborate with them as best we can. But sometimes it's not always as simple to get them out to our part of the state. It's not simple to get, they don't have the resources. So since we have 5 of us in the different parts of the state and we are a hub, it doesn't always work to centralize, the work that needs to be done in our topic areas.
Thank you again, Michelle, and thank you for all the great work that CRAC is doing. Thank you.
Thank you.
Thank you, Representative Lee. And seeing no other questions or comment, thank you so much, Ms. Devine, for your testimony. And the next person on our list is Daniela Arias. I hope I got your last name correct.
Close, Arias, but thank you. Good afternoon, Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. I thank you for the opportunity to testify. My name is Daniela Arias, and I am a program coordinator at the Hub, the Regional Behavioral Health Action Organization for Region 1, Southwestern Connecticut, and I'm here today as a member of the Connecticut Prevention Network. I am here in support of SB number 367, an act concerning electronic nicotine delivery systems and vapor products. We are currently in an e-cigarette epidemic among youth. A concerning number of youth believe vapes and electronic nicotine delivery systems do not contain nicotine, but instead consist of flavored air. The most popular brands of vapes and e-cigarettes contain the highest levels of nicotine. Vapes and ends increase the chances of nicotine addiction in youth in as little as a few puffs. From the National Youth Survey conducted by the U.S. Food and Drug Administration and the U.S. Centers for Disease Control and Prevention, they estimated more than 2 million U.S. middle and high school students reported using e-cigarettes in 2021 alone, with more than 8 in 10 of those youth using flavored e-cigarettes and 4 out of 5 youth who have used tobacco started with a flavored product. Connecticut is surrounded by states who have all enacted bans on the sales of flavored e-cigarettes. It would be in the state's best interest to join the ban. The regional behavioral health action organizations work with their local prevention councils, whose goal is to reduce vaping rates among youth by 2025 and increase awareness of vaping risks and prevention. A flavor ban is a vital necessity in the prevention and cessation of adolescents using nicotine and tobacco products. Thank you.
Thank you so much for your testimony. Could you tell me about your organization, please?
Sure. The Hub, we are the designated regional behavioral health action organization from Southwestern Connecticut. We work with the 14 towns from Greenwich to Stratford. We work with the local prevention councils. Our focus is on behavioral health as well as mental health, suicide, and problem gambling.
Okay. And so you're dealing with nicotine addiction in youth as well in your work?
Yes. So we work with the local prevention councils who all over the state of Connecticut, is first goal is to reduce vaping among youth from 12 to 18-year-olds by 5% by 2025.
And do you believe, based on your experience, that the vapes are the on-ramp for nicotine addiction for our youth?
Yes. We did, when we complete a priority report every 2 years. Each RBHAO has to do one. In our most recent one, we concluded that there was a slight decrease in vaping itself, but we are associating that due to the pandemic and youth not having access to the vapes. But now, as we are moving into post-pandemic life, we are seeing an increase in youth continuing to vape. Some local prevention councils and police officers have noted that youth are continuing to vape even in schools and on school properties. They're continuing to do it in the bathrooms. They're skipping lunch and going to the bathroom to vape. So it's still continuing to be a large issue.
And would you be able to comment on the nicotine content that is accessible in our state to our youth? In the vapes, the nicotine content, part of the bill is restricting the nicotine content as well. There have been situations where they are selling vapes which claim to be without any nicotine, but it has very high nicotine content. And that's caused our youth to get addicted as well. So we're trying to, of course, we're trying to prohibit the sale of flavored vapes, but we're also trying to reduce the nicotine content and bring it in line with most of the countries, rather than what we have in our state right now. Any thoughts on that?
So I don't have the exact numbers, but I know there are popular brands such as puff bars that have extremely high levels of nicotine. Juul was very popular for a while, and they claim to have 3% to 5% nicotine content in their vape products. But we know with some of these other newer ones that are coming out, there are no regulations as to how much is in it. So they're seeing, higher percentages up to even, 11, 12, 13, 14, 15% nicotine. So it's easier for you to become addicted in as little as a few puffs because there's a higher nicotine content in it.
Based on your experience, would you consider that this is a very urgent issue to protect our youth?
Yes.
Okay, so thank you. I have Representative Berger-Giavallo who's got a question.
Thank you so much, Mr. Chair. And thank you for representing your organization. My question for you is, first, can you repeat what that goal is for 2020, 2025, you said, right?
Yes.
So what can you just
to reduce vaping amongst youth ages 12 to 18 by 5%.
By 5%. And do you see anything, does your organization see or recommend anything that would need to be done in tandem in order to reach that 5% reduction, or is this enough?
I think overall, if it was possible, banning vapes and electronic nicotine delivery systems, all together. But the flavors plays, excuse me, a huge role in it, working with the youth and the local prevention councils, seeing youth surveys locally and then on a national level. Youth are just so taken over by the flavors. There's just an obsession. It is on all social media things, huge platforms such as, TikTok. You scroll through, it's constantly there. And when speaking with youth, they're like, oh, have you tried this new flavor? There's this new flavor. It's all around the flavors.
Okay, and I'm with you on that. I don't mean to sound that I'm oppositional. I'm just wondering, is there more we could or should be doing to help you to get that to you and to help us to hit that goal? So certainly we would be happy to hear from your organization should other recommendations arise. So thank you.
Yes, absolutely. Thank you.
Thanks, Mr. Chair.
Thank you, Representative. Thank you, Ms. Arias, for your testimony. Thank you for the work you and your organization do. The next person is Honorable Lisa Wexler. Honorable Judge, thank you for your waiting for us, and we are ready for your testimony.
Hi, thank you, Senator. Nice to meet you. Nice to see some familiar faces and people here, Representative Steinberg, Senator Wong, others. Hello, everybody, and almost good afternoon. We're right in between. We're good morning to good afternoon. I'm here to talk about the raised bill number 369, an act concerning the Department of Developmental Services recommendations regarding various revisions to developmental services statutes. That's sort of a mouthful. But when I saw this, I felt like I wanted to testify about this because what is being presented to you as something that is merely technical, I think is not really the case. I think what is being presented to you is something that will have a substantive change and affect the lives of people with intellectual disabilities. And that is of concern to me as a probate judge, because as you know, it is probate judges who see these families on a regular basis, who appoint guardians for these families, who are required to do 3-year reviews, and who very often, more than every 3 years, have these families in our courtroom, and we watch over them with great oversight. And it's a very important role that we play. So I have some written testimony, but I want to say at the outset, I'm also sending you, Probate Court Administration is sending you a copy of the case, and I would really like you to read it. I know you don't have a lot of spare time. Some of you are lawyers, some are not. I try and write cases to the non-lawyer, but this is a case that came before the court with respect to someone with intellectual disabilities. The name was redacted for confidentiality purposes, was published in a recent edition of the Quinnipiac Law Journal because I really wanted it to have wider circulation. And given what's going on with this statute, I think you'll see why. So, dear chairs and members of the committee, I am the probate judge of the Westport Probate District since 2013. That also includes Weston. In that time, I've presided over hundreds of hearings involving families of those with intellectual disabilities, and DDS is a valuable participant in those hearings. But I have real concerns with the proposed bill before you, and therefore I ask you to reject the following proposed changes for these reasons. And what I did is I went through the line. In other words, it was easier for me to go through the lines as if I was a legislator like you and looking at changes. So line 16 substitutes the existing requirement that a doctor of medicine sit on the Council of Developmental Services, instead substituting language of a licensed medical professional. To me, this is unwise, and I'll tell you why. Number one, they don't have a definition of licensed medical professional. A licensed medical professional could be anyone from a licensed practical nurse, an LPN, to a registered nurse, to a medical doctor. Could it be a psychologist or a clinical social worker? I don't know. I do know that a prestigious council such as this is deserving of someone who has earned the highest professional credential in their field, which would be a medical doctor. Dr. Pettit, I think you'll agree with me on that. Persons with intellectual disability, which I call ID because it's a mouthful in the written testimony, such as those with Down syndrome, are known to have medical issues specific to their conditions. They're known to get early Alzheimer's disease. They're known to have specific joint problems. And I don't want to see the council lose the benefit of someone who could contribute to discussions based on their own intensive medical training. So I just think that that's an unwise change. Sorry. Yeah.
Actually, Honorable Judge Wexler, please continue.
Okay, thank you. You can call me Lisa.
My question.
You can call me Lisa. It's perfectly okay. Line 49 substitutes DDS for the probate court. This goes to a little bit to what Judge Beverly Strike-Kafalis was talking about earlier today. And this is the substantive meat with respect to my role as probate judge. So line 49 substitutes DDS for the probate court in deciding who has an intellectual disability for purposes of placement. Line 58 substitutes DDS for the probate court again and requires that both DDS and the probate court make findings as explained in the statute, which basically gives them a veto power. And in my view, these changes are unwise, and I'll tell you why. The statute was originally permitted, and as written now, to permit a probate judge, a member of the judiciary, to make an important decision involving the civil rights of a person with an intellectual disability. This decision will impact the totality of the person's life. We're talking about placement. The totality of someone's life. Placement decisions hereunder are contested proceedings. They are not uncontested. They are contested proceedings. The person with an alleged intellectual disability has to have counsel appointed to represent his or her own interests. Probate courts have no conflict of interest. They have no built-in agenda when they make their decisions. If a court decides on placement, DDS has to find housing for that person. They have to find appropriate housing for that person. Why would we create a situation where DDS, the entity which has to pay for the placement, would have control over who would be placed? As an entity, DDS has an obvious conflict of interest in that they have to pay for every person deemed to have an intellectual disability. And moreover, and specific to this statute, there may be instances in which DDS knows the history of a person and doesn't want to place that person. Okay, that's a reality, like in real life. They may not want to place that person. There may be a history that the probate judge may know or may not know. People have long histories. If you permit the changes suggested here, then DDS will have veto power over placement, even if a probate judge would have deemed the placement necessary. I submit to you it's unfair to the family, to society, and to the person with an intellectual disability. Number two, if these changes are made, DDS would be overstepping its prescribed role in these matters. DDS is a state agency with an enormous impact on persons and families of those with an intellectual disability. What is its role? Its role is to provide care for those with intellectual disabilities. Its role is not to be the judge and jury to decide over who has an intellectual disability. While DDS makes its own decisions and findings in order to determine whether it will, as an arm of the executive branch of the state, pay for the care of certain people, those decisions are sometimes appealed. I'm sure you legislators and representatives know when those decisions are appealed. We look to judges. We value impartial determinations. The statute of change would shift the balance of power away from judges and give more power to DDS than it currently has. And the third reason that I submit to you to reject this is this. I have conducted many hearings with families of persons with intellectual disability and those persons themselves, obviously. There is ongoing debate and real concern in our communities that DDS is unwilling to recognize the many documented situations where a person has both autism and an intellectual disability. Autism Speaks estimates this as many as 40%. In other words, they deny benefits to many persons whom the families feel are in desperate need of care, state care. In my court, in one particular case, DDS overstepped its bounds and argued with its own DDS counsel that a young man should not have his own parents as his guardians because he didn't really meet the definition of intellectual disability under our statutes. DDS is not an interested party in these matters. They are supposed to be neutral, yet they took a position adverse to the petitioning parents. My opinion was published in the Quinnipiac Law Journal, as I just referenced, and you're going to be sent it under separate cover right now. I urge you to read it just to see the story, just to see what our families endure. If you make these changes that were presented to you as merely technical, in fact, you will be enlarging the authority of DDS at the expense of our judicial system. You will be creating more barriers to families who already face great obstacles to create safe, healthy, and happy homes for their loved ones. I ask you to reject these changes. I'm always available to chat with each one of you individually, and I thank you for consideration of my thoughts. Happy to take any questions.
Wow, this was very helpful, Lisa. I cannot thank you enough for your testimony and helping shine some light on some of the areas. I just want to make a quick little comment. I know my colleagues have more comments to make. You know, when we were informed about some of the changes, we said we were going to modernize, quote unquote, modernize the bill because we're going to use licensed medical professionals. And I've used the term modernization to take the most educated person and then put them lower down in the tier as a modernization. And it's almost changing the concept what modernization means. These are complex issues, and you need the highly trained individuals who have dedicated their time and life and intellectual resources for a long time to get to that point. And modernization now means that you can have anybody perform that role, whether they did that for whatever time they did. So that's part of our challenge right now, and this is a problem. So, and the other points you make are very, very important, and I truly appreciate you coming in and waiting for the time that you did to share that with us. I have my co-chair, Representative Steinberg, who has a question or a comment.
Senator Anwar, I just want to say to your point that I was looking at the statute and I noticed that the rest of the people appointed to the council are political appointments. There's nothing wrong with that. They have a role to play too, but I don't think you should water down the medical.
Yes, I hear you.
Hi, Hi, Representative Steinberg. How are you?
I'm well. How are you this afternoon, Judge Wexler?
Fine, thanks.
Let me start by saying, yes, you really helped us better understand what has been put before us as potential modernization legislation. And we are fully cognizant of the delicate balance between that agency and the probate court. Do you surmise perhaps that one of the reasons this was suggested is because we are so concerned about an already overburdened probate court and its ability to handle these kind of issues?
Well, I don't think probate courts are overburdened. So if there's a perception that we're overburdened, that's not right. I think that we do the job that we are set out to do, but I would not call us overburdened as a system. I just think we're doing our jobs. I think that what we do is a lot of family law, and we require and ask for the support of the legislature every year to help us do our job, but I don't think we're overburdened. I think we're doing our job. Maybe
at least underfunded in that.
Well, you know, that's a chronic thing for all agencies. But you know what I think, Representative Steinberg? I'm not sure, and I don't know that you've asked, and I wasn't present for all the testimony as to what is prompting these changes, but I'm concerned of a little bit of camel's nose under the tent. Because they're starting, this DDS technical changes is starting with placements. Placements are only a dozen or so a year throughout the entire probate system. What is far more common, what we do, are the guardianships themselves. And the reason I brought to your attention this particular case is because I was sort of astonished that DDS's counsel took an adverse position to parents in the hearing. Now, if they're doing that in my little court, I have no way of knowing what they're doing in other courts. It's part of a piece of taking what should be a neutral position. We care for these people that have ID. To know, we're going to assert ourselves as to who we think should be having intellectual disability. I think that's a very different role, and I think the legislature needs to take a really close look at that role.
Thank you for that, Judge. Yeah, and I think you were touching on a number of issues that you've identified within the system, the process, so to speak, that could be improved on. And even though perhaps much of that by way of change might not even fall neatly in this committee as opposed to other committees of cognizance, would you be prepared to help us identify not merely the problems in the system, but potential solutions
Yes.
that really speak to justice, equity, and good process.
I would be more than privileged to do it. I mean, I had a legislative appointment on the JJPOC for juvenile justice, and that expired several years ago. I was on that committee for 4 years or so. I don't currently have a legislative appointment. If you were to create something like that, that is a legislatively appointed committee to look at this, I would be more than happy to serve. And even in a non-formal way, more than happy.
Thank you for that. Well, we look at good advice from any quarter we can get it. Before I hand it over to my esteemed colleague, Senator Wong, I just want to take note and commend you for your other role, that of radio commentator. For example, I was listening to your radio show on the way up to the Capitol on Friday. Very interesting discussion on zoning issues, but more importantly is your regular feature of feel-good stories, which we really could use a lot more of. That kind of positivity, I think, lifts everybody's spirits. And I just want to thank you for all the work you do, helping inform the electorate about what's going on in Hartford, but also just some of the bigger, broader issues we all ought to be thinking about. I find your show very inspiring. Thank you, Mr.
Thank you. That's so nice of you to say. 11:30 on Fridays, the kindness of strangers. It was suggested by a listener, and it's really taken off. People, they call in with feel-good stories of when someone was kind, and we pay it forward. It makes people feel good. Yeah, thank you. Thank you.
One more thing for me to look at. Thank you, Mr. Co-Chair. Next is Senator Tony Wong.
Thank you, Mr. Chair, and a very nice welcome by Representative Steinberg. Good morning, or is it afternoon? Good afternoon, Judge Wexler. You bring up a very interesting point from a standpoint of the unique roles of DDS versus probate. And this bill pretty much interjects that kind of a span of control. I know what you do in talking to so many probate judges. You're not just a judge, but you are a counselor. You are a referee in some cases, but ultimately, as I've learned from you so many times, you are an advocate for the families. And I think when I heard you and read your note to us, it was that call to action that really motivated you. Can you express a little bit more of the unique role that probate has in our state? It has a unique role, and this bill would pretty much usurp that. And move it into a bureaucratic role.
I think so. And it's interesting you should say that, because my feeling is that these families, they already have a lot to deal with. The last thing that they can be worrying about is somebody submitting a technical change to a statute in front of a short season of a legislature. Like, hello? Do you know what I'm saying? Like, they're doing their best every single day to figure out how to get medical care and happiness and enrichment. And they're coming out of COVID, where so many of the programs were canceled. You know how much, these families are basically just getting back up to speed to try and reconnect their loved ones with their day programs. This is, it's sort of an obnoxious time to be putting this in right now, because the families are just sort of like coming up for air, frankly. And in terms of the role that we play, it's really interesting, because the statutes allow us to appoint guardians. We can only appoint guardians for people with intellectual disabilities. Otherwise, we're in a different category, which is conservatorships. And DDS has taken a position, which personally I think is not in the statute. You'll read my case, in which So the statute basically says that if somebody has been found to have been intellectually disabled before the age of 18, then they can be considered intellectually disabled for purposes of the statute 11G. But DDS takes the position that if there's any evidence at all that shows within that 18-year period, if there's any testing at all that shows that they've had an IQ of over 69, they're out forever. They never get state services. So you can have a kid who's been in 0 to 2 birth, Giant Step schools, which recently closed, but was a school for kids with intellectual disabilities. You can have a kid who tested as a 58, a 62, a 65, and then once had an anomaly of a score of a 74 And DDS will say, I'm sorry, you never really had an intellectual disability because you have a score over 69 before you were 18. And the family's like, are you kidding me? Are you kidding me? And there is clear and convincing evidence before a judge like myself, clear and convincing evidence from schools and psychologists and neuropsychologists and parents and teachers that this child really has an intellectual disability. I don't care what one anomalous test said, you have a lifetime of 18 years and the kid is out. So that's because DDS is taking a very specific, aggressive stance right now in our communities as to who does and doesn't have an intellectual disability. Now, to your point, I think someone's not on mute. To your point, Senator Wong, the only thing probate judges can do is appoint guardians. We cannot insist on services. When you're appealed throughout the DDS administrative system, eventually it gets to a judge. That judge may overrule a DDS determination as to services. So our role is actually pretty narrow. All we get to do is say that you should be a guardian. But there are probate judges in the system who feel that the statutory construct of 11G is too strict. It's just too strict. And that IQ should not be the only determining factor. And again, as I say to you, DDS has taken the position that if there's any testing at all that shows before the age of 18 that somebody for one moment in time appeared to have an IQ of over 69, they will be denied state services for the rest of their life. So it's a big issue.
You raise such an interesting point, because when you talk about IDD, you use the example of autism. The wide spectrum of autism. And also our schools have done a tremendous effort in mainstreaming and coping and adaptive skills. What you're literally saying is the fact that if there's a measure line and they don't fall within that, they get zero services after 18.
That's correct.
The other important part that is really the crux of it, and it's not any policy, but in talking to so many parents with IDD children and the struggle that they have every single day is, as a parent, you have no greater role than to ensure that you take care of your children when you're no longer there. And I will never doubt any parent's desire and unconditional love of their child to do what is best. What you're saying to me is the fact that this bill has demonstrated some potential trends of an adversary role of DDS against the very parents that are trying to do the best for their parents. And you see that because you serve that unique role in our probate guardianship relationship. So I think it's important to point out that these are dynamics that exasperate and frustrate, and in some cases, anger so many of the parents that you see in court. And I'm so appreciative that you are speaking up for those individuals impacted by IDD, but also their parents that are at their wits' end, and that perhaps we need to get state government to be much more responsive and to be more appropriate in supportive services. So I wanted to acknowledge that, but if you want to expound on that and just offer that kind of context. Because
the only thing I want to say, thank you, Senator Wong. The only thing I want to say is this: for parents who know that their children have both autism and an intellectual disability, if a child is categorized with a primary diagnosis of autism and is not recognized for their intellectual disability, they go into a different bucket for state money. That bucket is empty for autism, according to the testimony that was in my court a couple of months ago. So do you realize what that means for a family? Okay, that bucket is empty. So if a child has a primary diagnosis of autism and the intellectual disability is not considered as such, the family has no money to turn to right now to the state of Connecticut. So you can see what's at stake. And that's why this bill I object to, because DDS should not be the arbiter. They have too much of a conflict of interest. They should not be the judge and jury over who they have to take care of. They have a big enough job taking care of these people, and it's an important job, and they do it very well. but I think they're encroaching from what their job should be.
Well, thank you, Judge Wexler, and always great to see you, and welcome to the Zoom world. Thank you, Mr. Chair.
Thank you. So, Judge, what do you really feel?
Right.
I'm just
exactly.
joking.
I'm such a closed book, Senator. I'm so closed. That's right. Yeah.
Thank you so much for your testimony. Truly appreciate it. And we'll move on to the next person. But before we move on to the next person, I wanted to make a quick little comment and hand over the management of the committee. Oh, Senator Wong has a comment before I go do that. Senator Wong
gets. I want to make a closing comment. Now you know why we love Judge Wexler. So thank you, Mr. Chair.
I hear it and I feel it loud and clear. Feel it loud and clear. Earlier, I had mentioned about the dashboard and looking at the hotspots for opioid, and I got a message, an update that we in our state of Connecticut also keep track of the hotspots, and DPH actually is in charge of it, but works in collaboration with DEMIS, and they use the SWORD data, SWORD data, which is a way to track the opioid hotspots. So I wanted to make sure I mentioned that, because in that conversation, I talked about other states, but did not talk about Connecticut. And with that, our Vice Chair, Senator Julie Kushner, is going to take over running the public hearing for a little bit. Thank you, Senator Kushner.
Thank you, Senator Anwar. Next up, we have Jesse McLaughlin, number 33, and he will be followed by Victor Cabral, number 35. Go ahead.
Thank you, Madam Chair. It is so good to be with you all today. Madam Chair, Mr. Chairman, ranking members and members of the committee, it's so very good to see you, to be here and testify in support of House Bill 5396. For 6 years, I had the distinct honor of representing my hometown and community as their state rep. And as you all know, when you're doing your duty as a public servant, you spend a lot of time listening to folks and you learn the intimate details of their lives. And during my time, mental health was always an issue, but it didn't become a mainstream issue until the pandemic hit. And that's when I feel like we really got a grasp on the underlying mental health crisis that had always existed, but because of stigma, had never really surfaced to the forefront of our minds. And during the pandemic, in a very unlikely turn of events, psychedelics have emerged as a ray of hope in the treatment of mental health and addiction disorder. Exciting research suggests that psychedelic therapy, when used in controlled, supervised settings, is safe, effective, and has tremendous potential to provide healing to folks who need it most. And you're going to hear from some breathtaking firsthand accounts of folks as to how their lives have been changed. In 2017, I got out of my comfort zone and began taking my own mental health seriously. And I was lucky to receive the care that I needed to overcome depression that probably stemmed from deep-seated childhood traumatic events like we've all experienced. And I was lucky enough to get the help that I needed, and it's greatly benefited my life, but others haven't been as lucky. This month will mark the 1-year anniversary of where the world lost another beautiful soul to the lethal pain of mental health disorder. For 15 years, I was lucky enough to call Connor my friend. He fought a silent battle with courage and grace, was a wonderful person who loved life and loved people, and yet was unable to find effective care to alleviate his pain. In times like these, it's impossible not to ask the question, what if? What if psychedelic therapy could have relieved Connor of the burden he carried every day? Would he be here today to share his story of healing? We'll never know. What we do know is that psychedelic-assisted therapy has the potential to prevent needless suffering, and this committee is in a position of tremendous influence to help accomplish that. By passing House Bill 5396, we can position the state to maximize the public benefits of psychedelic therapy and establish it as a national leader in what might represent the greatest improvement in mental health care treatment in decades. I thank you for your consideration, and I look forward to answering any questions and working with you to help pass this bill. Thank you.
Thank you. Thank you, Jesse. And I appreciate the time that you've spent educating me on these issues. And I'm happy that you're here today to testify. Let me just see whose hand went up first. I believe it's the Honorable Chairman Steinberg whose hand went up first.
Thank you, Madam Vice Chair. And Jesse, really good to see you, even though you seem to have a little less hair the last time I saw you.
Politics has that effect.
Yeah, well, you should have seen me. I'm only 12.
It's good to see you too, Mr. Chair.
I wanted to thank you not only for the heartfelt story that you shared with us, but your courage in general in taking on this subject. I can't help but note the recent death of William Hurt, who starred in that famous breakthrough film Altered States, which sort of defines the default paradigm of what we think about things like psilocybin. And look where we are today, which is really a totally different place. That this is now a medication that has been proven to have benefit for those who are often otherwise lost, who are not in a position necessarily to find an alternative treatment. That this is actually a solution is remarkable to me. And I want to thank you for your perseverance in continuing to push this subject. Yes, we need more federal testing. Yes, we need a lot more information before it becomes something that is widely used. But even then, we're talking about a very narrow context. When I say widely, it's still a very small group of individuals for whom this would be an appropriate therapy. But only by our willingness to push the bounds are we going to find these kind of options for people. So I don't really have a question, Madam Vice Chair, other than to say thank you for your advocacy in this area, and we'll see if we can continue to make headway. Thank you.
Thank you,
Mr. Chairman.
Berg. Next up, we have Representative Cook.
Thank you, Senator. And Jesse, thanks for bringing this very important topic to my attention. Not that it is something that we're not all aware of, but I think to the depth of the magnitude of what we are missing has been brought to my attention by you and the incredible group that you have surrounded yourself with. As I say to you every time we talk, you chose to leave us, but I'm very happy to see you in front of us. My question for you, and I know that you've done yeoman's work bringing in the heavy hitters and making sure that we are educated on this conversation. To your knowledge, the states that have benefited from something like we are proposing, maybe not exactly like what we're proposing, or maybe doing this without any type of a legislative, ask at all. Could you speak to those at all, or would you be willing to speak to those?
Absolutely, and thank you for the question, Representative, and thank you for your leadership on this topic. Connecticut certainly is an early mover, but Republican states have actually moved before us. The Texas legislature passed last year in overwhelmingly bipartisan fashion House Bill 1802, which may have been the most bipartisan issue to ever go through the Texas legislature, funding an FDA-approved clinical trial. There are bills that are flying through the legislatures of Oklahoma, of Utah, and Missouri. And so what we're proposing is not a radical concept. We're proposing a framework, a pilot program, so to speak, that is in accordance with federal law. We're not asking to get ahead of the FDA. In fact, we think that there's a synergy between the FDA's expanded access program and the bridge that we need to build, a bridge of information, of infrastructure, and of more real-world application of what this treatment looks like outside of the clinical trial setting, to be ready for when the FDA does approve MDMA in 2023 and psilocybin in 2024, because when that happens and these therapies begin to enter the mainstream, there will be a deluge of patient intake. And where we need to be prepared is not on the drug development side at all. It's the real issue is, will there be enough trained therapists to process the massive demand? And that's why I think we have a crucial period of 18 to 24 months to educate stakeholders, to think about issues like equity, like trained facilitator and therapist training, credentialing, cost considerations, insurance reimbursement for a healing modality that really isn't like anything that we have, because it's combining elements of clerical work with clinical work. And it's incredibly exciting, but we have some work to do to be ready for when it becomes a reality for the public to benefit from.
Thank you, and thank you for that. I greatly appreciate your outlook on the fact that this is not something that is 10 or 15 years down the line, but a mere matter of months that will be right in front of us. Again, I can't thank you enough, and I'm overly appreciative of your heartfelt story about your friend. There is no words for when we lose a loved one, regardless of their biologicalness to us. But at the end of the day, I think that you've taken that loss and championed something that will save so many from feeling the pain that you have. I can't thank you for that more than I'm thanking you right now. So thank you.
Thank you, Representative Cook. Next up, we have Representative Kennedy.
Thank you, Chair Kushner. Well,
you muted yourself.
Sorry. Thank you, Madam Chair. Good afternoon, Jesse. How are you today? It's great to see you. I don't know if you've been on this call since the beginning this morning, but we had, excuse the voice, General Brigadier Nexus, and he alluded to, started talking about breakthrough status. Could you give us probably just a little bit more on that? He talked a little bit about it. I wonder if you could just elaborate a little bit more on that.
Sure. We're gonna, I'm happy to touch on it. We will have some brilliant clinicians and researchers who will be able to provide a more in-depth analysis. But in between 2017 and 2019, the FDA, in recognition of the early clinical data being produced by flagship research institutions from across the country, acknowledged and recognized psilocybin and MDMA as being breakthrough treatments. And essentially that means that their processing through the FDA approval system would happen quicker. And it really marked we put a flag down for the excitement and tremendous potential of what these therapies can offer the greater public.
Thank you so much, Jesse. I really appreciate it. I appreciate the ability or the opportunity from you to work on the working group. Learned a lot, learned even more today listening to some of the testimony. It's just so sad. Our men and women have given so much to our country, and to learn today, I'm not sure I've ever had it put that way, that you're losing 20 people that have given so much to our country a day is rather, it just breaks your heart. So I do appreciate your advocacy. I do appreciate everything you've gone through. I'm so sorry, very sorry for the loss of your friend. And we'll see where we go with this legislation. But I thank you so much. And thank you, Madam Chair.
Thank you. I don't see any other hands at the moment. So thank you, Jesse, for being here with us today and for telling your story. And we all really appreciate your work on this issue. Thanks so much.
Thank you, Madam Chair. Thank you, everyone.
Next up, we have Victor Cabral. And after Victor, we'll have Kimberly Estes. So Victor, go ahead.
Hello, good afternoon. I want to start off by thanking the members of the Public Health Committee for this opportunity to testify. My name is Victor Cabral, and I am the former Deputy Director of the Governor's Office of Advocacy and Reform here in Pennsylvania, and I currently serve as the Director of Policy and Regulatory Affairs for Fluence Training, which has trained over 1,000 therapists in psychedelic assisted therapy. And in addition to that, I'm also a licensed social worker and psychotherapist, certified clinical trauma professional in private practice. And I am also trained in MDMA assisted therapy and ketamine assisted therapy. And I'm here today to talk about House Bill 5396, which would provide psychedelic assisted therapy to veterans, first responders, and historically marginalized communities. Have experience working both at the VA and with historically marginalized communities for the majority of my career. And I myself have suffered from major depression, CPTSD, and anxiety as well as racial trauma. And I'm a first-generation immigrant here to the United States. And so I wanted to share my personal story today with you all. As I stated, I have struggled with my own mental health in the past, and I had the opportunity in 2016 to try psilocybin for the first time to deal with my mental health, and it completely changed my life. I was able to address my mental health, the intergenerational trauma that has been handed down to me through the experiences of my mother, for example, who in her trip to make it here to the United States was lost at sea for 6 days, and really struggled to be able to give me the opportunity to thrive. And psychedelic assisted therapy gave me the chance to move from surviving to thriving. And this is why I'm before you today with all the education and all the opportunities that I've had to be an advocate for my community, as well as veterans and first responders. And I urge you all to please take into consideration this bill, because not only do I think it's that we owe it to our veterans and our first responders, but I also think that it could really help historically marginalized communities, as we know, who face several disparities in health outcomes and in other areas. And that's all I have to share today. Thank you.
Thank you, Victor. Thank you for sharing your personal story and for your experience and your work on behalf of the people also in government and in your community. I do see Representative Cook has a question.
Hi, Victor. Thank you for being here and telling your story. You had briefly mentioned the significant change from before and then after your use of the psilocybins. Could you, if you're comfortable, briefly touch on what you consider to be a significant change and how it absolutely affected you? I think for a lot of folks who don't understand what this is or what it can do, it would be extremely helpful for us to be able to move this forward. And thanks for everything that you're doing.
Thank you. Yeah, sure. So before my psilocybin experience, I had been in therapy for about 3 years consistently, trying to work through my childhood trauma and, within my family system and also within my community and the environment that I grew up in. At the time, leading up to my first experience, I was taking Zoloft, Xanax, Adderall, and Wellbutrin to manage my symptoms. And I have not, since that experience, I have not needed any medication at all to deal with my symptoms. And I no longer meet criteria for major depression or anxiety. And I've been able to really concentrate on working through complex trauma, intergenerational trauma, and working on really changing and breaking the cycles in my family to be able to offer something better for the future for my children and also for my community.
Thank you. And thank you for that. I greatly appreciate it. And I'm wishing you the best of luck moving forward as well. Thank you, Senator.
Thank you. Next, we have Senator Anwar, Chairman Anwar.
Thank you so much, Madam Chair. I wanted to thank you, Victor, for sharing your testimony with us. May I ask how long of a treatment did it take for you to turn things around, and did you have any side effects?
So and I'll be quite honest, my personal, it was personal use, so it wasn't in a therapeutic setting at the time. And through my training now, I have had experiences that are guided. I would say that within, after the first experience, I saw immediate benefits, which allowed me to really, which I saw sustained over the course of the years. And I've continued to do my work, my personal work and healing myself and mental health. I can give you some of the results from studies that we've done with veterans. So for example, I know this question was asked to Jesse earlier. In the MAPS phase 3 study, which is the organization that's studying MDMA assisted therapy, the average participant in that study had been dealing with PTSD for 14 years. And after 9 sessions, which included 3 initial sessions for preparation, 3 sessions with the medicine, which are about 8 hours long, and then 3 integration sessions, which come afterwards. After 3 months of that protocol, 68% of the participants no longer met criteria for PTSD, and many of them were combat veterans.
Okay, and so I was reading about this because obviously not many clinicians have any experience with this. So you're probably the first person I'm talking to who's taken this. That's why I was asking the question. But they claim that it's almost rewiring the brain and addressing some of the pathways, which helps out. So this gives a little bit of hope in some of the challenging cases. So thank you so much for your testimony. I truly appreciate it. Thank you. Thank you, Madam Chair.
Thank you. I see no other hands at this time, but thank you, Victor, again for being with us today.
Thank you.
Next up, we have Kimberly Estes, followed by Elizabeth Hicks.
Good afternoon. Thank you, everyone, for providing the time to share. I am here to talk to you today about vaping flavoring bill SB 367. As a healthcare professional, I was open and honest about educating my children regarding the dangers of vaping as they entered middle school. We had discussions about the risk and the lure of flavorings. Sadly, our efforts as parents did not prevent one of our children from being intrigued by the infamous bubblegum scented vaping cartridges. While we did not know it at the time, his vaping journey had begun at the early age of 10 years old after being introduced to this scented vaping in middle school. His continued vaping since then has been dictated completely by which flavorings he likes and which he avoids. Non-flavoring products make him gag. He requires the flavorings to make nicotine palatable. I cannot get the vision of my 10-year-old child vaping out of my mind. It is this image which compelled me to volunteer with Parents Against E-Cigarettes in order to advocate for the children of our state. According to the CDC Morbidity and Mortality Weekly Report, e-cigarette use among middle and high school students, the National Youth Tobacco Survey of 2021, of the current youth e-cigarette users, 84.7% used flavored e-cigarettes, including 85.8% of high school users and 79.2% of middle school users. The most commonly used flavor types among both middle and high school students were fruit, followed by candy, desserts, or other sweets, mint, and menthol. Another CDC report titled E-Cigarettes Use Among Youth and Young Adults, a report of the Surgeon General, Atlanta, Georgia, U.S. Department of Health and Human Services, the CDC Office on Smoking and Health from 2016 reported that nicotine exposure can cause harm to the adolescent brain. While the research is compelling, I would implore that common sense also should prevail. When an addictive and dangerous chemical is altered by adding flavorings which mimic children's products, such as cereal, candy, or gum, the end is inevitable. Young children will continue to be lured into tobacco use. Those children who are predisposed to addiction or mental health issues are even more vulnerable and require our protection. Despite ongoing efforts to help him quit, our family now lives with my son's nicotine obsession, chronic cough, decline in pulmonary function, and the knowledge that he will be part of an entire generation with long-term health effects. It is therefore up to us as adults in our society to step up and protect our children by banning flavorings in all e-cigarette forms. Thank you.
Thank you, Ms. Estes. Really appreciate your time and your testimony here today. I see Chairman Anwar has a question.
Thank you, Madam Chair. Thank you, Ms. Estes, for your testimony. I truly appreciate it. And I want you to know that you're not alone. There are thousands of parents in our state, just like you were mentioning about the youth behavior survey. We know that this has been a major challenge despite the Tobacco 21, despite some of the issues around enforcement and also the marketing that is ongoing at this time. So putting a face and a story to your challenge helps us as well. So the question I wanted to ask was, what would you say to academicians or legislators who say, hey, let's do some more research and prove it's really worthy to ban the flavors? What would you say to that situation? Should
well, in terms
wait
of
for
proving,
a few more years?
No, absolutely not. Every time is critical. I can say that with my son, each time he goes to the pulmonologist, his pulmonary function is declining. And he goes every 6 months at this point because of the decline that only started to occur after he used e-cigarettes. We don't have any more time. Time is running out. The long-term health effects are already setting in. So if we need more, the research already exists showing that it's addictive, showing that it's luring, and to the children of our state and across the country. We need to step in and act immediately because we have to stave off these health effects so that we can hopefully prevent the next generation. Each grade level that goes by is exposed. So every year these kids get together and they get exposed, and we have a new generation every single year where this path has started. The nicotine, as was discussed earlier, is so addictive and is coming out stronger and stronger. The kids at such a young age of 10 or 11, they don't have the safety awareness to understand what they're doing. They just know it smells good and tastes good. And then before they can stop, they're hooked. So we need to step in as the adults in society immediately and not wait any longer and pass this legislation.
Thank you so much. I tend to agree with you. Thank you so much as well. Thank you, Madam Chair.
Thank you. Thank you. Next up is Representative Pettit.
Thank you, Madam Chair. And Mrs. Estes, no questions. I think you gave superb testimony. You were on point and direct and told a great story for everyone to listen to. So thank you very much for taking the time to come and do this today. Thank you, Madam Chair.
Thank you.
Thank you. Thank you. I don't see any other hands, so we'll move to the next presenter, and that would be Elizabeth Hicks, followed by Samitha Raman.
Great. Thank you, Madam Chair and members of the Public Health Committee. My name is Elizabeth Hicks. I'm the U.S. Affairs Analyst at the Global Consumer Advocacy Group, known as the Consumer Choice Center. I'm here to testify in opposition to Bill 367 today, an act concerning electronic nicotine delivery systems and vapor products, and I want to thank this committee for their time. Simply put, this bill will do more harm than good if passed. Enacting a flavor ban for vaping products will push adult consumers to switch back to smoking combustible tobacco. Sadly, 4,900 citizens of Connecticut lose their lives to smoking-related illnesses every year. Considering that studies have shown vaping to be 95% less harmful than smoking, ensuring that adult consumers have access to the vaping products they prefer will ultimately lead to fewer cigarette smoking-related deaths in Connecticut. About 6% of Connecticut's adult population uses vaping products, which accounts for about 200,000 citizens throughout your districts who have switched to a healthier alternative to combustible tobacco. Banning flavored vaping products will encourage these former smokers to switch back to smoking cigarettes and will ultimately lead to increases in smoking-related healthcare costs, which are already costing Connecticut's taxpayers over $520 million annually through Medicaid expenses. Additionally, if a flavor ban is enacted in Connecticut, then consumers will look towards the black market in order to get access to their preferred flavored vaping products. This presents serious concerns for public health in Connecticut, as vapers will be purchasing unregulated products that could be extremely dangerous to their well-being. In addition to endangering public health, pushing consumers to the black market through a flavor ban will also be to the detriment of many vape shops throughout the state, as their products will no longer be available. After already suffering through the economic hardships of the pandemic, this bill could effectively kill many of these small businesses who are already struggling to stay afloat. For perspective, Massachusetts enacted a ban on flavored vaping products in 2019, and the results have been disastrous. Since the ban has been enacted, there has been a massive influx of interstate smuggling of tobacco products, which has resulted in a thriving black market, lost tax revenue for the state, and criminalization of adult consumers who are just trying to make the healthier choice. Instead of copying Massachusetts' failed policies, I encourage Connecticut legislators to learn from them and do better for the consumers within your state. I appreciate that this bill is certainly well-intentioned, but it's important that we look at the evidence showing just how misguided a flavor ban actually is. If this committee wishes to protect public health, small business, and consumer choice within Connecticut, then I strongly encourage you to reject the ban of flavored vaping products within this bill. Thank you for your time, and I'm happy to answer any questions you may have.
Thank you. I see Senator Anwar has his hand up.
Thank you, Ms. Hicks. You mentioned that you're part of Consumer Choice Center.
Yes, sir.
Could you tell me that back in 2017, your company had received 3.98 million euros from undisclosed locations? Do you know what those locations were? And then you received another €1 million after that.
We received donations from a variety of outlets, some being individuals, some being industries, and other avenues. So it's a variety of sources that our funding comes from.
That's a pretty healthy sum of money in one shot, 3.98 million euros. So you don't know it's like charity work that's going on that you think, or what, I'm not sure.
So people donate to our organization because we represent consumers across the globe. So yes, we do receive large donations from folks who are aligned with our vision and our mission. So that it would be from somebody who would be aligned with what we're doing, which is advancing consumer choice throughout the world.
Okay, all right. So and the other question I wanted to ask you was, you said that there was a disaster in Massachusetts. Tell me about that disaster. I did not read that in the newspapers yet.
Yeah, so they enacted a ban in 2019 of a ban on flavored vaping products, which only encouraged many folks to go outside of the state, smuggle tobacco products back in, and created a lot of issues there. I submitted written testimony that has a link to that report. I highly encourage you all to take a look at that. It outlines very nicely all of the negative repercussions of this. And again, I really do want to reiterate that I do think this bill is well-intentioned. I think it's important to protect the youth.
No, I'm trying to understand your claim that it was a disaster, because so you think that if somebody went to New Hampshire and a small percentage of people, that became a disaster? I'm trying to understand a disaster definition.
Yes, Senator, I would definitely classify it as a disaster for the state of Massachusetts. What happened is because the consumers within that state could not purchase those products anymore legally, they would either go to the black market and purchase them illegally, which then it's unregulated. So now you have tons of consumers buying unregulated products. We know prohibition doesn't work. I know there's been other bills in this committee being looked at today, and we've heard about the dangers of prohibition. This is what I would consider a disaster for the state of Massachusetts. You're now criminalizing consumers, adult consumers, who want to have access to these products so they don't smoke cigarettes. But when you ban these things, they have to go out of state to do that. Therefore, Massachusetts is losing tax revenue from tobacco taxes. So okay. It's not an effective policy.
we'll probably get pediatricians who would in Massachusetts at various institutions who would probably disagree with you, and they do know their source of revenue. They don't get lump sum from unknown sources, but I can tell you that looking at the background of your company and what you represent and what you do, I don't find you very credible. But thank you so much for your testimony. Thank you, Madam Chair.
Thank you. Next, I see Representative Pettit.
Thank you, Madam Chair. Mrs. Hicks, I just wonder if your organization has a view on how a flavor, some flavors could be continued to be available to adults and keep them out of the hands of children appropriately.
I think that's a fantastic question, and thank you for asking that. Again, I think it's very important that youth do not have access to these products. That's absolutely not what I'm advocating for here. I'm advocating for adult consumers to have access. In order to prevent youth from having access to these vaping products, I think one very viable solution is ensuring that the age limit is 21. If you're under the age of 21, you should not be able to purchase these products. One reason that is so helpful is it widens the gap between where high school students and younger typically get vaping products from. If you look at the data, it's typically from either older peers or older siblings. Vape shops are not selling to 13-year-old kids. They shouldn't be. It's against the law. And if we increase that age to 21 and really enforce that, then we're going to widen that gap between those who can legally purchase and those who may be attracted at a younger age and who should not be having access to these products. So I think really enforcing that 21 age limit is a viable solution for this.
I don't think that per se is a huge issue in Connecticut, but I think it still will be purchased by people 21 and older and given or sold to kids. So I'm not sure how we avoid keeping it out of their hands. I would think we also need to strengthen penalties for the online sale of unregulated products is sort of a separate issue, related but separate from this bill. A difficult issue. Thank you for your testimony today. Thank you, Madam Chair.
Thank you.
Thank you. I see no other hands, so we'll move to the next speaker, and that would be Sumitha Raman, followed by Jim Williams.
Thank you, distinguished members of the Public Health Committee. My name is Sumitha Raman, and I'm a primary care doctor and a resident of New Haven. I work at the Addiction Recovery Clinic at Yale New Haven Hospital, where I treat patients suffering from addiction to opioids. I'm here today to support HB 5430 and Act concerning opioids. Specifically, I want to draw attention to Section 9, which directs state agencies such as DMIS, DOC, and DPH to share data relevant to the opioid epidemic, such that a shared database can be created to identify the needs of patients who are prescribed opioids, have an opioid use disorder, or who have experienced an overdose. In 2020 alone, Connecticut had the 10th highest death rate from opioids of all states in the country. Although Connecticut state agencies have established a variety of services to prevent opioid-related deaths and provide life-saving treatment to its most vulnerable residents, I believe that the state's ability to further its response to the burgeoning epidemic is hindered by the lack of shared data among agencies. As a doctor treating patients with opioid addiction, I am privy to the relapsing course of this disease, as well as to the stigma and the co-occurring psychological and social burdens patients with the disease face, making their interactions with treatment facilities fragmented at best. It is not uncommon after I first meet a patient and start treating them for an opioid addiction, for them to relapse, to then experience homelessness, to be hospitalized with a complication from using opioids, to be discharged to the streets, to return to my clinic and be restarted on medication, to then be incarcerated where they may or may not receive treatment, to be released from prison and overdose again, this time to die. In this span of time, my patients have often interfaced with a myriad of addiction-related treatment and support services, all administered by different state agencies, such as mobile needle exchange vans, state methadone clinics, homeless outreach services, and treatment centers within jails. Unless we link individual level data held by each of these agencies, we will not be able to evaluate existing strategies and services, identify trends, or design effective interventions. For example, we know that the days following release from prison are extremely high-risk periods for opioid overdose death, but we do not know what proportion of people in Connecticut treated for opioid use disorder while incarcerated are connected to treatment once outside of jail. This metric requires data linking between agencies to assist the state in creating targets to improve the metric and ultimately save lives. Other states, such as Massachusetts, Rhode Island, and Maryland, have all established similar linked databases across state agencies, which have provided important insights regarding their opioid response. Researchers familiar with establishing such databases in Massachusetts and Maryland have provided written testimony outlining their findings, including on ways to protect confidentiality and not place undue burden on state agencies while creating such databases. HB 5430 is the next step forward in furthering a data-driven response to the opioid epidemic in Connecticut. I support HB 5430, and I ask the committee to support and pass this important legislation. Thank you for your time, and I would be happy to answer any questions.
Thank you, Ms. Baumann. Next, I see that Representative Parker has a question for you.
Thank you, Madam Chair. Thanks, Dr. Rahman, for being here with us. We appreciate your time and the conversation leading up to this too. I want to try to zoom in a little bit on this because there's been conversation throughout the day about what may be a gap between what's actually being collected and what healthcare providers are aware of and able to utilize. And so I sort of want to try to understand that and then again, be able to see if there are steps that need to be taken that would be helpful. Dr. Anwar shared previously about the SWORD database, which is being collected in terms of overdoses. And I just kind of clicked around there and saw in addition reports on the use of naloxone and all that's very helpful. I'm wondering from your perspective as a physician and a provider, can you speak about what the better data linking that you're asking for, what would that look like in practice for you? What specifically would you be able to access and what difference would it make in your ability to provide treatment? Trying to take this from a little bit of a intellectual conversation down to the specifics of what could actually be more helpful to you and to your patients and community.
Sure. Thank you so much for that question, Representative Parker. So absolutely, there is data that is currently being reported by state agencies in Connecticut, and I really commend those agencies for doing that. So SWORD is one example. You know, I think the Department of Public Health also has a dashboard that they have with data that they collect. I think the issue, though, is that this data is siloed within state agencies and that it's not shared across agencies. And the reason that that's so important is because, as I demonstrated, patients with addiction and addiction to opioids really travel between different agencies in their course of time. And so, you know, for instance, we might know I know that the Office of the Medical Examiner, for instance, releases data with toxicology reports, you know, urine toxes of patients that overdosed with opioids. So you might see that someone that recently overdosed had fentanyl and another substance like benzodiazepines in their urine. But what we don't know is whether they were being prescribed those benzodiazepines, who they were being prescribed those benzodiazepines from, whether they had received treatment for opioids. And we don't know that because a lot of that was happening, you know, it was under the purview of a different state agency. And so it's really important to have that information, individual level data that we get from various sources in order to be able to understand trends, so to say. So, you know, I provided the example of patients recently incarcerated, and we know that the risk of death from opioid overdose is really high right after they leave jail. Similarly, we know that the risk of overdose, fatal overdose, is really high in patients who have had a non-fatal overdose previously. So even though an agency might report data on the percentage of patients that have non-fatal overdoses or on who is having non-fatal overdoses, we don't know if those patients are getting treated, if some of those patients that are mine are receiving treatment, you know, from a different agency that's not my clinic, and how we can better support those patients in order to make sure that they're receiving the treatment that they need.
Thanks for sharing that. And so presumably if we had some of those specific metrics, we could create policies, whether it's at the state level or in practices and providers to better serve people. I'm not a physician. I see that a physician has raised his hand, so I'll shut up in a minute here, or a researcher. But just last question from my end is, are there issues with privacy that we get into with this kind of linking? Is that a challenge that we need to overcome? And do you have any thoughts on that?
Yeah, I think that's a really good question. I think, you know, it's a question, and it's important to think about because it's important to maintain confidentiality. What I will say in response to that is that I would really encourage you to take a look at the written testimonies that were submitted by researchers and experts from Massachusetts and Maryland in relating, about the databases that they created, because they were really able to create shared databases that protected confidentiality. And so I think that that's very much possible to do.
Thanks for your time, Dr. Rahman. Thanks, Madam Chair. I'm all set.
Thank you. And Dr. Rahman, I apologize for not correctly addressing you. Now call on Senator Dr. Anwar.
Thank you so much, Madam Chair. Thank you, Dr. Rahman, for your testimony. I just wanted to correct my colleague, Representative Parker. He actually knows more about opioid and the opioid epidemic than most doctors in our state too. So he's been doing amazing work in the last entire session. He's dedicated himself, which is a blessing. Dr. Rahman, I think that's part of the challenge is that the HIPAA laws are becoming a hurdle. And there's a fear because of the federal law for us to be able to have a seamless transition across agencies and across clinicians. And I think that's part of the problem that we will have to identify and navigate. And the other challenge is that patient's autonomy is also part of the hurdle in the acute situations where the person gets a Narcan, they wake up and they say, I don't want it, and then I'm going. And then we are left with a situation where we know that the half-life of Narcan is a matter of minutes. And a few minutes later, this person is going to have the actual long-acting medicine come back and impact it. And so many people die just from that alone. So the second part needs a legislative fix too. And the first part, in the absence of the federal government making a major intervention, we will need to figure out a strategy around this, because frankly, all agencies that are working, the state agencies, I mean, they are part of being HIPAA partners, and the clinicians would be HIPAA partners, and arguably the state is a partner in the process, because this is an illness where we will, unless we get all of this seamless transition and continuation, we will not be able to make the bigger dent. Do you want to reflect on my statements?
Yeah, thank you so much, Senator Anwar. I think, as I mentioned before, I absolutely agree. I think, we need to find a way in which we can maintain confidentiality, we abiding by HIPAA. Again, this is something that has been done. It has been done in other states, that also abide by HIPAA laws. And so I think that it's absolutely doable. And I would, again, ask you to refer to the testimonies and the information and contact information of our experts that have been involved in actually creating such databases. I will add that I recognize that there is some data that's actually being shared currently already between state agencies. We heard that earlier this morning and have seen it in the form of testimony. And this happens, I think, primarily in the form of MOUs. But as you all know, MOUs can really vary in their scope and they can take a lot of time. And so I think that a legislative directive is really important in order to really enhance what we're currently doing and make it more efficient, more timely, and available to the public.
Thank you so much. Thank you, Madam Chair.
Thank you. Thank you, Dr. Rahman. I see no other hands at this point. So we will move to our next speaker, Jim Williams.
Thank you.
Jim will be followed by, just check there, I think it is Nikki Sky.
Yes, good afternoon. My name is Jim Williams. I'm the Government Relations Director for the American Heart Association. I'd like to thank the leadership and members of the Public Health Committee for the opportunity to speak on House Bill 5364 and act concerning the Tobacco Settlement Trust Fund. And I'd like to start off by reading a few numbers for you. $2.3 billion is the annual amount of healthcare costs directly caused by smoking for Connecticut. $473 million is how much Connecticut brings in every single year from tobacco revenue and settlement dollars. $32 million is what the CDC recommends that we as a state spend annually on tobacco control, which is such activities such as education, prevention, and cessation. And then there's $0, which is what Connecticut has largely spent with state dollars on tobacco control since about 2015. 4,900 adults die every year from their own smoking, and 56,000 Connecticut kids today under the age of 18 will eventually die from their own tobacco use. We feel that this bill should be amended to more clearly guarantee a minimum sustained state investment of $12 million. Whenever possible, I find it helpful to, when asking for funding, to also suggest a logical funding source. In this case, the good news is that the funding source exists and has for some time. It's the $100 million that Connecticut gets every single year from the master tobacco settlement and the approximate $373 million that it gets every single year in tobacco revenue. One additional amendment that I would strongly suggest including in this bill would be that any legislatively appropriated funding for tobacco control or funding provided to the state for tobacco control shall follow the current evidence-based recommendations made by the U.S. Department of Health and Human Services Centers for Disease Control and Prevention, which follows strategies that have shown strong or promising evidence of effectiveness. I thank you very much for your time and would welcome any questions either now or in the future.
Thank you, Jim. It's always good to see you. Thank you for your testimony. It definitely underlines the point of what we're considering here. So thank you so much. I do see Chairman Stein.
Jim, good to see you, and thank you for your testimony today. I think that it's not a partisan issue to want to see those settlement dollars go towards their original intended use, which is prevention, education, cessation to the degree that we're capable of doing that. Why is it, do you think, that when we first came out of the gate, when we first got the tobacco settlement funds, that funds weren't devoted in those directions to the degree that we would have expected?
Well, that would go before my time, Representative Steinberg. Well, my strong suspicion is that at some point the state found itself in a deficit. The dollars were swept into the general fund, and then that slowly but surely became sort of the norm throughout the lifetime of the tobacco settlement.
Yeah, that's my surmise as well. And we find ourselves in a situation that for the first time in over a decade, the state is not quite as desperate as it usually is. And this seems like an excellent time to restore the original intent of the settlement fund and to see what we can do to reduce nicotine addiction in our state. I want to thank you for your advocacy on this, and I appreciate your comment that we should perhaps consider an additional change that would assure that the funds are used for the purposes that we've identified. Thank you, Madam Chair, Vice Chair.
Thank you. Again, Jim, always good to see you here, and we do appreciate your advocacy. Next up, we have Missy Sky.
Good day, Senator Anwar, Representative Steinberg, Senator Summers, Senator Wong, Representative Petit, and members of the Public Health Committee. Thank you for the opportunity to testify opposition of HB number 5419, Raise Public Health and Act concerning the Department of Mental Health and Addiction Services recommendations regarding regional behavioral health action organizations. When I sat down to write and submit my testimony, I was just writing out my thoughts of what I've been observing, and being a poet, staying aware of how I'm expressing myself. It's always good to be validated by others. Thank you, Representative Mike DeMecco and Representative Kathleen McCarty for hearing the concerns of the voices of the people using mental health services to be heard, and not just the voices of the people running these regional behavioral health organizations. And to Kathy Flaherty for validating and sharing her experience of what the organization was before, what it is now, and what it needs to be. My name is Mitzi Sky, and I am a registered voter in Stamford. I work at Advocacy Unlimited in the Advocacy Education Department. It is part of my job to continue learning, educating, and supporting the community that we are a part of and serve. We're working towards a system of transformation that sees the possibility for everyone to live up to their best human experience. I've spent time sitting in with at least one of these regional behavioral health action organizations and seen their services to the community. After a decade of witnessing, I see them as gatekeepers to continue the language and treatment of emotional distress and behaviors as the disease model. Their research and formulas show that what they're doing is not working, as they ask for more money and more services in the name of prevention and illnesses. They share statistics and fear, but don't see the possibilities for people to live beyond the disease model of labels they continue to push and support. Places like Connecticut Legal Rights Project, CCAR, Advocacy Unlimited, Keep the Promise, Perch at Yale, led by Dr. Cheryl Bellamy, have people whose life experiences of moving through the worst situations in their lives, finding ways to support others experiencing similar suffering. I'm not saying any of these places are doing it perfectly. As a matter of fact, sexism and ageism and racism is a problem, but everyone is on the same foot in those situations. But the government giving the power to people with the privilege of their title roles that they know best, and they get to push fear on others is injustice. The road to hell is paved with good intentions, and their work is with good intention, but there is a better way than pushing statistics and causes fear, but they don't share the statistics of works that without illness or disease lens that is supporting people to get beyond these labels for their pain and suffering. I'm going to skip this paragraph but I have submitted my testimony. I'm going to read this last paragraph. Listen, I'm aware that these regional behavioral health action organizations are doing precisely what they were created to do in the mental health system. I'm sharing what I have observed as a person working in this business of recovery that the federal government has included as part of the mental health care system. DEMIS has been working with agencies in the community and talking about system transformation. I'm just pointing out that if we want change, we need to remove the gatekeepers using their privilege to pit mental illness. For psychiatric services in a society that promotes fear over love, we need transformation and not a paper certificate and a glass award handed out by these regional behavioral health action organizations showing they have the power to people who want to be seen and heard by them. We need people to know that support is necessary, but they are fully worthy and valued. I want to thank you for taking the time to listen, and I'm going to resubmit this.
Thank you, Ms. Guy. I do not see any hands at this time, but thank you for taking the time to testify and providing written testimony. We appreciate it. Next up, we have Phoebe Lampos by Cheryl Richter.
Good morning. My name is Phoebe Lampos, and I am a junior at Lime High School. I'm testifying in support of Senate Bill number 367, an act concerning electronic nicotine delivery systems and vapor products. To prohibit the sale of electronic nicotine delivery systems and vapor products that are flavored or that have a nicotine content that is greater than 35 milligrams per milliliter. As a student, I've seen how many teens and adolescents are tempted to try vaping due to the appeal of flavored tobacco products. These flavored vapes are available in a variety of sweet, fruity flavors that appeal to younger students, beginning as early as 6th or 7th grade. Most of these students think vaping is healthier than conventional cigarettes. They believe that vapes are just flavored water vapor and are missing the point that each vape contains a concentrated dose of highly addictive nicotine. Recent data from a survey conducted by the Lyme's Youth Service Bureau in Old Lyme indicated that over 45% of 12th graders reported having used electronic cigarettes in their lifetime. These students are enthusiastic about the various sweet flavors of the vape pods and do not generally understand them to be tobacco products. Many students feel that vaping is not as harmful as cigarettes, but in fact they are much worse, and the nicotine in one vape pod is equivalent to approximately 20 cigarettes. Nearly 20% of all students in 7th to 12th grade report that they are using e-cigarettes or Juuls, and that's not wrong at all. Fruit and candy flavors are very popular among students because they make vaping seem like a treat, unlike conventional cigarettes. Furthermore, there is a culture among teens based around these flavors, as different flavors are traded or sold like trading cards or collectibles. Eliminating these sweet flavor options would prevent younger kids from being tempted to start vaping. New York, Rhode Island, Massachusetts, and New Jersey have all passed bans on flavored vapes. Connecticut should move swiftly to do the same. Removing flavored vapes from the marketplace clearly sends the message that e-cigarettes and Juuls are tobacco products, which are just as harmful as cigarettes, if not more so. Despite the fact that the law expressly prohibits people under 21 from purchasing vape products, nearly 20% of all students in the 7th through 12th grades report that it is very easy to obtain e-cigs and Juuls. These products are finding their way into our middle schools and high schools at an alarming rate, and a large part of the reason is the allure of sweet flavors that appeal to kids. I strongly urge the committee to pass the bill banning flavored tobacco products. It will make our schools and communities safer and kids less likely to engage in harmful practice of vaping. Thank you for this opportunity to share my views on this important issue.
Thank you so much for your testimony, and it's great to see young people engaged in our process, our government process. So really appreciate you being here, and it was well spoken and well crafted. So thank you. I do see Representative Pettit has his hand up.
Thank you, Madam Chair. Thank you, Ms. Lampos. I realize you haven't studied it, but I wonder what your perception is. The majority of kids that you see and observe, do they obtain these products from older kids who obtain them legally, or is most of it done online? What do you see? What's your observation?
I think it ranges. A lot of the time people have older siblings and friends where they get these products from, and also once these younger students have them from older children, they'll distribute them in their grades, and then soon it just becomes something in their grade, and they can sell them or trade them or just share. So
Thank you for that. Thank you, Madam Chair.
Thank you. I don't see any other hands at this time. Again, thank you for participating today.
Thank you.
Next up, we have Cheryl Richter. Is Cheryl here?
Yes, I'm here. I'm sorry.
Okay, go ahead.
Hi, I'm Cheryl Richter. I'm the Executive Director of the New York State Vapor Association. I'm also a 29-year resident of Stamford. And we represent the independent mom and shop vape shops and small manufacturers. We take no money from big tobacco. We take no money from pharmaceutical companies, and we have no unknown sources of funding. So I hope you think that I'm a credible person to speak to. I'm 58 years old, and I started smoking when I was 13 and continued for 30 years. I was able to quit immediately after I had my first e-cigarette. And I thought this was a wonderful thing, and I decided to not only advocate for these products, but I started my own business. I did very well in it, and then I had to close it last year due to New York's flavor ban law. Before New York banned flavors in the middle of the night during the COVID crisis, we warned the legislators of some dire consequences that we could see coming. That there would be an immediate explosion of a dangerous black market, that kids and adults would buy online from domestic and international sources, or they would do it themselves dangerously, because e-liquid is very easy to make. It's also very easy to get wrong. And flavors are available in every grocery store in the country. That there would be massive store closings. In 2018, we were a New York industry of over 700 vape shops, which is roughly the same number of McDonald's as there are in the state of New York. We have estimated now that 90% of them are closed. We warned that there would be thousands of layoffs. We employed over 4,000 people. We now believe that we have lost 3,500 of those jobs. There was no change in the ability for kids to get these products. The change was in the ability for adults to buy regulated, safe products, because kids get them online or they get them from other sources, but they're not allowed in our independent vape shops. Our independent vape shops are 21 years and older to enter. We suggested, and I suggest strongly to you, that you look into making these available only in age-restricted environments, like a liquor store, like a dispensary, like a nudie bar. When you have these products in every gas station, in every convenience store, in grocery stores, in delis, right next to candy, that's where the kids are seeing them. And I'll tell you something, if the owner or the employee of a gas station has no problem selling this to a kid, they have no problem continuing to sell flavors. And so what we did not expect in New York when this flavor ban went through was that we thought there'd be some enforcement. But unfortunately, as the gentleman prior to me just testified, there's no money for enforcement.
Excuse me, Ms. Richter, but your time is almost up. If you could please summarize. Thank you.
Quick things, yes. 95% of adults use flavors. I have 13 studies showing that flavors are imperative to a smoker's successful quit attempt, and that the flavors help them distance themselves from their former habit. So that is a falsehood that's been touted around. And also, just quickly, in San Francisco, just because enforcement didn't start when that study took place doesn't mean that the retailers weren't abiding by the law, having no knowledge of when enforcement was going to come into their store. So I'm debunking that as well. I'm happy to answer any questions.
Thank you, Ms. Richter. I do not see any hands. So next up, we have Neri Susar and Noor Rana. Neri?
Yes, hello. Thank you. Dear members of the Public Health Committee of the Connecticut General Assembly, my name is Aneri Suthar. I am a first-year MPH student at the Yale School of Public Health studying health policy. Thank you for allowing me to speak today in support of HB 5430. I grew up not too far from here in White Plains, New York. By the time I graduated high school, I knew 3 kids who passed away from opioid overdoses. And perhaps as tragic as any life cut short is the knowledge that that death was entirely preventable. And perhaps even more tragic is the fact that these kinds of deaths have only been on the rise, with almost 97,000 overdose deaths in the US from March 2020 to 2021. Fentanyl testing strips and access to naloxone and methadone treatment may have saved the lives of my classmates, as they have proven to do for countless Americans. We cannot continue to turn a blind eye. Our state has among the highest opioid-related overdose death rates in the country. Stand with the millions of opioid users, those in recovery, their loved ones, healthcare workers, and public health officials who have now for years reached a consensus on the importance of this type of legislation. As elected officials, I know you all know too well what can happen when there's a lack of data and state agency silos that shape policy, which is why this bill's inclusion of overdose data monitoring is critical to better understanding and mitigating this issue. Additionally, over a decade into this epidemic, I think it's beyond time we move past moralizing and stigmatizing language. So we also urge the committee to replace the bill's references to substance abuse with the science-based, accurate, more modern terminology of substance use disorder as defined in the DSM-5. We implore you to take these crucial steps to help end the opioid epidemic before it ends even more lives. Thank you again, and please consider that the fate of HB 5430 is linked to that of your community members.
Thank you so much for testifying here today. Really appreciate the research you've done, the studies, and the program that you're in, informing us, and also being able to link it to your personal experience being a young adult. So I really do appreciate it. And it's an experience so many of us have had, losing loved ones and friends of our children. So we really need to be reminded of that. I really appreciate your testimony. I see a hand from Representative McCarty.
Yes, thank you very much, Madam Chair. And thank you, Doctor, for being here today. A little bit earlier today, we did talk about the makeup of the data sharing and the different agencies that would be involved. And I asked one of the doctors to look, because I think we do have a gap on that as well. So if you'll take a look there. But I did want to comment about and drawing our attention to the reference on the language we use, because I do think some of the battle that we still face is directed to the stigma. And as you know, we did put that in statute to use substance use disorder rather than abuse. So I just wanted to thank you for bringing that to our attention again. Thank you, Doctor.
Thank you. Thank you for being here. Seeing no other hands at this time, I will move to Noor Rana.
Thank you to the members of the Public Health Committee for this opportunity. My name is Noor Rana, and I'm a first-year Master's in Public Health candidate at the Yale School of Public Health. And I'm here to express my strong support for SB 367. Over the years, youth e-cigarette use in the United States has skyrocketed to what the US Surgeon General and the FDA have called epidemic levels. The 2021 National Youth Tobacco Survey shows that 43.6% of high school students and 72.2% of middle school students reported using e-cigarettes on more than 20 of the past 30 days, and the daily use was 27.6%. Evidence also shows that flavored e-cigarettes have fueled this pandemic, and the recent Surgeon General report on smoking cessation very clearly states that the role of flavors in promoting initiation of tobacco products use among the youth is well established, and flavors are among the most common reasons for using e-cigarettes among the youth. As Speaker 41 earlier claimed that e-cigarettes are 95% safer than cigarettes, popularized by an estimate in a 2015 Public Health England report, are totally unfounded. Significantly, not a single US health authority or government agency has supported this claim. In fact, the claim is widely disputed by US government agencies and medical associations. A recent article concluded the 95% safer estimate is a factoid, unreliable information repeated so often that it just becomes accepted as a fact. The opposition also states that e-cigarettes aren't as addictive and don't have serious health consequences, but that is also far from the truth. There's alarming evidence that e-cigarettes increase the susceptibility to long-term addiction, and youth are not just experimenting. They go after the flavors and they use them religiously. With no foolproof way to help youth quit, I believe banning flavored e-cigarettes will help kids from ever getting hooked in the first place. Flavored e-cigarettes also threaten to reverse decades of progress made in reducing youth tobacco use, since there is evidence that using e-cigarettes increases the likelihood of youth smoking cigarettes. Actually, FDA researchers have estimated that as of right now, 43,000 current youth cigarette smokers who might not have become smokers without e-cigarettes. And one of the biggest arguments is also that e-cigarettes help smokers quit, but no major scientific body in the United States has concluded that e-cigarettes are an effective tobacco cessation device. There has not been a single randomized controlled trial to assess the impact of flavored versus non-flavored or tobacco-flavored e-cigarettes on smoking cessation outcomes. And FDA has gone as far as to say that there is not sufficient evidence to conclude that youth and young adults are using e-cigarettes as a means to quit smoking. And they've also said that the claim that vaping helps smokers quit in meaningful numbers remains completely unproven. So in conclusion, we should all recognize that we are facing an epidemic, and Connecticut's youth deserves all the protection this bill would provide, because this problem will not resolve itself. It requires action by the legislation. Thank you.
Thank you so much for your testimony here today. It was really helpful to hear you debunk some of the testimony that might mislead people. I think your testimony was very, very effective in that regard. I see Senator Anwar has his hand up.
Thank you. Thank you, Noor, for your testimony, and thank you for, as a Yale MPH student, your work that you've already initiated to try and increase awareness. And Noor, earlier there was somebody from an entity that is believed to be representing the interests of the tobacco industry, who claimed that if we ban flavored tobacco, that is going to result in increased men or increased adults, would be taking combustible cigarettes. Do you know any data to support that?
So you cut out any what?
Do you know of any data that supports that tobacco for adults, combustible cigarette use would increase if we prohibited flavored tobacco?
Yes, I did a lot of research on it, and there's a lot of people who say it, but they don't have any research as of right now to prove it, or at least nothing I could find. But there has not been any randomized controlled trial to support that argument.
I think that's very important to know, because but we have enough data to show that it's an on-ramp for the children.
Yes, because there is data that shows that people who use e-cigarettes, there are kids that they would start using tobacco after. So there is a lot of data that shows that.
This is helpful. Thank you so much for your testimony. Thank you, Madam Chair.
Thank you. Thank you, Ms. Rana. I do not see other hands. So we'll go to the next. We're going back to number 54. That will be Jordan Fairchild, and Jordan will be followed by Lisa Dean. Jordan, are you with us?
Yes, I am. Thank you, Senator Kushner. Good afternoon, Senator Anwar, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Jordan Fairchild, and I am the coordinator and community organizer for Keep the Promise Coalition. We are a grassroots group of advocates with lived experience of mental health, addiction, and co-occurring conditions. I'll be testifying on a few bills today, starting with the bills that have to do with step therapy, a policy which allows insurers to play doctor, withholding authorization for prescribed medications until a patient fails first on cheaper drugs. Due to the unique nature of people's individual reactions to these drugs, this can severely worsen a person's mental health and put patients' lives at risk. Therefore, we support HB 5275 and SB 331, sections 7 and 8, which would prohibit the use of step therapy in behavioral health applications. We also support HB 5395, which would enter Connecticut into 2 interstate licensure agreements. Choice of behavioral health providers is both extremely personal and impactful on patient outcomes. However, when moving to another state, many lose access to their chosen providers due to state licensure limitations, something which many people I know can attest to. This proposal would respect clients' choices and increase access to care. We encourage you to go even further to also expand this to other behavioral health professions. I also want to echo some of the concerns raised by Kathy Flaherty, Tom Burr, who has yet to speak, as well as Marcia DeFore and Margaret Watt about HB 5419 regarding the Regional Behavioral Health Action Organizations. The federal block grants, which fund the RBHAOs, prioritize substance use prevention rather than mental health promotion. We encourage the legislature to restore state funding for RPHAO operations as needed to rebuild our focus on mental health promotion, which is especially needed during this time of crisis. It was mentioned earlier that RBHAOs support substance use prevention initiatives by distributing funds and providing technical assistance to local prevention councils. This is something that builds and strengthens the capacities of local stakeholders to address local issues in the substance use world. However, this bill makes no requirement of RBHAOs to provide this type of support for the catchment area councils to study and evaluate the delivery of mental health services. Wouldn't it be great if the RBHAOs were also responsible for providing this financial and technical support to the catchment area councils on the mental health side? This was a duty assigned to the regional mental health boards that has not been transferred to the RBHAOs in the proposed bill. I also would like to echo some of the concerns about Section 4 of this bill, which would remove any language from the existing statute that requires that individuals with lived experience comprise a portion of the State Board of Mental Health and Addiction Services. We encourage the legislature to restore their inclusion on the state board. I've included the removed language and more detail on this bill in my written testimony. Thank you for the opportunity to give testimony, and I'm happy to answer any questions.
Thank you. Thank you, Jordan. I am going to suggest Representative Steinberg, our chair, has his hand up. I'm going to turn the chairing of this public hearing over to him at this time so I can go co-chair another meeting. But thank you for your testimony, and Representative Steinberg, thank you for taking over.
Thank you for being in control, Senator Kushner. There's no rest for the weary. You're off to doing the same thing for another committee. We greatly appreciate it. Jordan, thank you for your testimony. You made reference to the opportunity, if you will, to have more effective oversight over the mental health piece. You likely recall the situation in Connecticut before we merged our regional entities, which has perhaps created the gap in oversight that you refer to. Do you have any sense about what it would cost for our existing regional health boards to take on those responsibilities?
I do not, and I would actually defer I'd recommend that you ask that question to perhaps Margaret Watt or Marcia DeFore, who will be testifying on this later. They were both formerly executive directors of the regional mental health boards in their regions, and I know they're going to be speaking about this later. It was a little before my time.
Thank you for your candor as to your tender age, as well as your suggestion to talk to Margaret, who I know quite well. I don't see any further questions. So Jordan, thank you for your testimony. We really appreciate it. Obviously, we're very pleased that we're giving the regional health behavioral health organizations more focus than we have in the past, and that Demas is supportive of the codification. Seeing no further questions, I think we can move on. I was looking for, let's see, I think Rana Noor, has she had a chance to speak, followed by Lisa Dean? I guess Lisa Dean is here. I don't know if Rana is. Or perhaps not. Then why don't we move on then to Ali Amur Hushmand? Do I have that correctly?
Close enough. I've been called worse. Thank you. Good morning. My name is Ali Amur Hushmand, and I reside in Washington, D.C. Distinguished members of the Public Health Committee, thank you for the opportunity to provide testimony on the HB 5396, Enact Increasing Access to Mental Health Medication, and considering this important legislation. I served for nearly 10 years as a policy staffer working for senior Republican members in the United States Senate, House, and leadership. And if someone 5 years ago would have told me that today I would be appearing before this committee to talk about psychedelics, I would have said they were crazy. That was until I participated in a Johns Hopkins University psychedelic-assisted therapy trial in 2018. I experienced firsthand the treatment potential of this medicine to tackle the mental health epidemic and to end suffering for countless Americans. The profound impact of this treatment led me to devote my life and career to raise awareness and to destigmatize the research and science behind psychedelic medicine. As a result, I co-founded the Apollo Pact, a medical research and education nonprofit advancing psilocybin and psychedelic research for mental health. Research conducted at leading institutions and universities nationwide is showing that in a medically controlled setting with expert screening and preparation, psychedelics can relieve anxiety, depression, PTSD, and addiction. These trials are showing dramatic results, and it could be more effective at treating some psychiatric disorders than existing treatments, and without having to take medication every day. Johns Hopkins University and NYU are advancing FDA-approved clinical trials using psychedelics for treatment of addictions and other mental disorders. The Dana-Farber Cancer Institute of Harvard Medical School is about to begin a clinical trial using psilocybin for hospice patients. Yale University is performing multiple trials assessing psilocybin for depression, headache disorders, and OCD. Whether it be depression, anxiety, PTSD, addiction, or other disorders, this committee is already aware of the unfortunate statistics of the mental health epidemic. These numbers do not discriminate based on the color of your skin, your gender, age, socioeconomic status, or party affiliation. As such, if not today, then in the future, someone you know may be suffering. It could be the person you sleep next to at night, the person you drop off at school every day, the person at your Thanksgiving dinner, the person sitting next to you on the dais, the person who answers your constituent letters, or the person you stare at in the mirror. As a result, the importance of this legislation cannot be overstated. I applaud this committee for its consideration, and I urge passage of HB 5396. Thank you.
Well, thank you for your testimony. You know, it was just last year that this committee first entertained the prospect that psilocybin could be beneficial to anyone. We were pleased we were able to at least initiate an effort to shine a spotlight on it. Let me ask the question that's probably on a lot of people's minds. Why should we be confident or comfortable that psilocybin can be safely administered, even with the safeguards and restrictions that you describe. You know, we've all grown up to believe that psilocybin is almost an extreme chemical compound. Yet you seem to have more experience than the rest of us, at least, with its actual scientific efficacy and the even if limited clinical experience we have. Could you just comment on that briefly?
Absolutely, and thank you for your question. You can rely on the science and the data and the research coming out of the world's premier institutions, so don't take my word for it. Work coming out of, as I mentioned, Hopkins, NYU, now Harvard, Yale, and universities across the country are showing the efficacy of this treatment and its potential to treat individuals. You can also look at the FDA and the fact that it's designated this medicine as a breakthrough medicine twice already. The science and the research and the data simply show that the outcomes and the efficacy of this medicine have the true potential to be able to save and heal many people.
Thank you for that. Any other questions? Yes, Representative Pettit jumps right in at the very moment.
Thank you, Mr. Chairman. And thank you. About the question I asked earlier, and you said you worked with Congress, and I know it's a very broad question, but how do you see the issues, the interaction between the federal government, the FDA, and the state interacting either to work together or to bang heads and slow the process down?
Excellent question. What we're seeing is that Congress is usually the entity or the body that's slower to act, that these efforts percolate at the state level. And once it starts getting the attention of federal officials, then Congress starts focusing on it. But the biggest challenge out there, as you face, is just the fact that the stigma and the misinformation and the lack of awareness of what's happening. The vast majority of elected officials do not even know what's happening at some of the universities in their backyard. As a result, their context and their frame is, you know, the war on drugs from the 50s, the 60s, the war on drugs from the late 60s and the 70s, and the counterculture. These researchers at these universities, you know, follow FDA protocols. They work very closely to make sure that the results they're finding and producing are based on science and research and proper methodologies.
And just a quick follow-up. So do you think that a change in schedule would be helpful ahead of time, or you think that's unlikely to happen until the studies are done and the data is there for them to say, yeah, we're going to change the scheduling of these compounds?
I think it's a combination of factors out there. The largest thing that the federal officials will be looking at will be the data and the science, and looking to see what the FDA and the DEA, do. If it's helpful, I don't know if it's already talked about actually what happens in a psychedelic assisted therapy. If you're interested, I can talk about my experiences and the protocols in place, or I can follow up afterwards as well.
I'll defer to the chairman on that.
Well, as long as we're here, this is what we're here for. If you can give us a brief synopsis of your experience.
Sure, absolutely. My experience at Johns Hopkins and the universities taking place consists of doing 3 or 4 pre-integration sessions of talk therapy, in which you work with your trained professionals there to identify the issues you want to work on. The actual session itself, so it's psychedelic assisted therapy. So the actual psychedelic session is bookended by several sessions of talk therapy before and after. And then during the actual day, you're given the medicine, you're invited to put eye shades on, listen to a music playlist, and then lay on your back. And for the next 6 to 8 hours, it's a very inward experience in which, well, I'll just leave it as it's a very inward experience. After the experience, and then during the session, you're there with 2 trained professionals. In my instance, I had a trained psychiatrist and a trained psychologist with me the entire time to make sure I did not have any adverse reactions. After the experience, I was followed up with several sessions of talk therapy as well. So I had about 8 sessions of talk therapy, and it was, and then in the middle was a psychedelic session itself.
Thank you for that. Are you aware of others who applied for this therapeutic option who were denied because they didn't qualify?
Absolutely. The big challenge is are the volunteers who are able to qualify for these trials taking place at these universities right now. They're primarily focusing on folks with depression, folks with addiction, etc. And then they also have exclusion criteria, family history of schizophrenia or bipolar as well. I was very fortunate enough that I was able to participate in a study looking at healthy, normal people. Coming out of that experience, I learned that there really is no such thing as a healthy, normal person when it comes to mental health. Everyone is on a spectrum, and it's a lot like the weather. Some days it's sunny and some days it's cloudy. For me, the marked contrast I had coming into the experience before and after just showed me the true potential of this medicine, that if it could be so helpful for a quote unquote healthy person, what could this do for people in far worse situations myself, as I mentioned, dealing with addiction, PTSD, and a whole host of other mental issues.
Thank you for that. Yes, I think we'd all agree that mental health can be a precarious thing. We're all susceptible to stressors of various types, and that's why this committee is giving such serious attention to addressing mental health issues this session. I kind of usurped you there, Representative Pettit. Do you have anything else you'd like to ask?
No, sir, all set. Thank you.
Thank you. I don't see any further questions. Thank you for your testimony,
Thank you for your absolutely, and thank you for your leadership on this important issue.
Thank you. I see Lisa Dean is back. Sorry we missed you on the last pass.
I'm sorry about that, sir.
You're here now. Please testify.
Good afternoon, everyone. Thank you for the opportunity to speak. My name is Lisa Dean, founder of Demand Zero. Demand Zero is a 100% volunteer nonprofit organization, a proud community partner of the New Haven Police Department, working to stem the flow of deadly narcotics into the state of Connecticut, and educates adults and students on the dangers of counterfeit pressed pills. I reference House Bill number 5430. Connecticut will realize at least 1,500 deadly overdoses, of which 85% were illicit fentanyl poisonings for 2021. The opioid fentanyl crisis disproportionately affects our Black and brown populations. New London, New Haven, and Hartford counties have the highest number of fatalities. The number of overdose deaths has risen every year since 2018, and the 3 years before that. The crisis is a drain on our economy, up to $10 billion a year, and Connecticut's escalating violence can be directly linked to drug trafficking that cost the life of a 13-year-old boy in Hartford in January. It's time to pivot. We're at this point because there is no one in position of power whose responsibility and priorities are to coordinate the state's efforts to save lives and control this national health crisis in Connecticut. Through the efforts of congressional representatives, we've received tens of millions of dollars to combat the epidemic. A forensic evaluation of money spent, how it is distributed, and the results of those programs or initiative needs to take place immediately. We have an incredible federal, state, and local resources working on the epidemic. We should be leading the country in effective programs. I ask respectfully, what are the evidence-based programs? Which ones are working exactly? Because the evidence many of us nonprofits see is a disastrous climb in overdoses and poisonings, double-digit % increases year over year. Governor Lamont made a campaign promise to appoint an opioid czar, his words, if elected. We are calling for such a position outside of state agencies to be appointed as soon as possible. The state of Connecticut is in desperate need of an office with not only the singular responsibility of bringing this crisis under control, but also the power derived from the governor's office to coordinate these efforts across a multitude of agencies. Key is working with the agencies. This action cannot wait till next session, let alone next week. Please understand the severity and help us lessen the 1,000 phone calls that went out in 2021. The call that every parent fears most. The call that I received on December 7th, 2018. It's too late for my son, Joe, but we can save those that still have time. I support House Bill 5430, but ask for immediate, bolder, life-saving measures to be taken. A special session may be in order. At least 5 citizens will have lost their lives during this hearing on our watch. Thank you very much.
Thank you, Ms. Dean, for your testimony. Yes, I think we'd all concur that since we have failed to stem the continuing epidemic of opioid deaths that we need to be bold, we need to be innovative, consider new ways of getting it done. I'm not surprised necessarily that the governor, once in office, realized that creating czars is not as easy as it sounds, but improved coordination is clearly part of the puzzle that we're looking to develop here as part of this bill. So thank you for your testimony. I don't see any
Representative.
I don't see any further questions, but again, thank you for your very strong testimony today. Next up, we have Zachary Green. I'm sorry, Zachary Green, followed by Dr. Jordan Schlosshauer.
Hey, Mr. Chair, can I just make a quick comment to Lisa?
I'm sorry, I
raised
didn't
my
see
hand,
your
but
hand. I
maybe I didn't.
apologize.
Thank you.
Please.
Sure thing. Lisa, just wanted to thank you for joining us today. I'm so sorry for your loss. And I know how many times you've had to recount your story and your passion for this issue on behalf of our Madison community. And of course, the whole state is very inspiring and moving. And so we're grateful for you. As Chairman Steinberg mentioned, as we've thought about ways to help move some of that bolder action, we've thought about coordination, we've thought about data sharing, as we've heard a lot about today. I just wonder if you can speak briefly, Lisa. I know you've done some research about, as you reference, an opioid czar position and efforts that other states have been making. Could you talk a little bit about what you've learned from some of those conversations that Connecticut might be able to at least learn from, if not do the same? Or maybe Lisa's no longer here as I look around my screen.
She's no longer here.
That's my fault, Representative Parker. I apologize. I wish I had seen your hand earlier.
No worries. I'll reach out to her. Thank you. Thank you, Bev. Thanks for letting us know.
All right, now we're ready for Zachary, please proceed.
Hi, everybody. Good afternoon, everyone. Good afternoon, Representative Steinberg and other distinguished members of the Public Health Committee. I'm not going to lie, I'm reading my testimony up on the above screen, so it looks like I am not looking at you. That's why. But my name is Zachary Green, and I've been a longtime resident of Connecticut. I was born and raised here. I'm a UConn graduate student. I'm trying to go for my master's in social work. I'm graduating in May. I shouldn't say trying anymore. I'm graduating in May. But I also represent the Students for Sensible Drug Policies, and specifically as the UConn Hartford chapter president. I'm also a recovery coach to adolescents struggling with substance use disorder. I work in the mental health field, and I also am a social work intern with Connecticut's Department of Mental Health and Addiction Services on the opioid services team. Last but not least, one of the most important things to me is I am a person in long-term recovery from an opioid use disorder. And I am actually here to support HB 5396, an act increasing access to mental health medication, even though it sounds like I was leading towards something else. As while I'm here navigating the overwhelming amount of deaths from the opioid epidemic, it's no surprise to anyone here that the mental health crisis in the country resulting from, in particular, from the struggles endured from the past 2 years in the pandemic related measures and stress have been really overwhelming. While I'm specifically talking only about 5396, the research I have that I'll have in my submitted testimony is in connection to using psilocybin to support relieving the addiction of nicotine and alcohol, but also in supporting the mental health of many veterans, and including those who have cancer and end-of-life illnesses. As somebody who's been working in the mental health field myself the past 2 years, and I'm now not even looking at my testimony, I'm just talking to you from my experience, things are crazy out there. Things are tough, and I'm getting emotional just talking about it. And this is my state. I love this state. I came back here after college because I want to be a part of something. And as a person in recovery, as a state who's promoted lived experience of those who have an opioid use disorder, Connecticut has done that. Check out Live Loud. I'm ready to utilize the next steps in mental health treatment. And there is positive research supporting, helping those who are addicted to. And while I would love to talk about these other bills and everything as well, I am here to advocate in support of HB 5396. I do think it would be beneficial to expand the definition of, I believe it's healthcare workers, and kind of what that means, because the people who have been working in the field in addiction, like recovery coaches, shout out to all the recovery coaches, it's been difficult, and I think there could be some support there in expanding, even what recovery supports mean. So thank you very much for your time. I will submit a written testimony with all my references as well. And thank you.
Thank you for your testimony. To your point, we are looking at the entire continuum of caregivers and practitioners to see if we can be more supportive of them. We wish we had the resources to really support all of those who support those with mental health issues or addiction issues. It certainly would be our intent. And we continue to look at the best way to help people stay supported through what for most of them is not something that simply can be cured, that requires constant support. I don't see any questions. So again, thank you for your testimony. Much appreciated. We
Absolutely.
have next Dr. Schlossauer, followed by Susan Halpin. Welcome, Doctor.
Hi, everyone. Madam Chair, Mr. Chairman, and members of the committee, thank you very much for the opportunity to provide testimony on House Bill 5396, an act increasing access to mental health medication. My name is Jordan Schlossauer. I'm a psychiatrist, researcher, and faculty member at Yale in the Department of Psychiatry. I live in New Haven. And for the last 6 years, I've been conducting research, clinical research on the therapeutic potential.
I hope that all of these sort of, that this vision plays
Someone
out
is,
into reality.
Thank you. For the past 6 years, I've been conducting clinical research on the therapeutic potential of psilocybin and have worked with around 30 patients with difficult to treat depression in these clinical trials. This has been extremely gratifying work and really become the focus of my career. And I now serve in some leadership roles, training other psychedelic therapists, and I'm a board member on the new American Psychedelic Practitioners Association. Training in psychiatry here at Yale, I became acutely aware of the limitations of many of the current treatment strategies for treating depression, PTSD, and other mental health conditions. As many of us are aware, the current medications need to often be taken daily. They address only some symptoms. They often have significant side effects and don't work well enough for too many patients. Psilocybin and MDMA-assisted psychotherapies have recently been granted breakthrough status by the FDA for major depression and PTSD, respectively. And that designation reflects that these treatments represent important advances, potential advances over currently available treatments. And in fact, so many of the patients that I've worked with personally have told me at the end of these studies that the therapy that they received in the trial, psilocybin-assisted psychotherapy, was by far the most effective treatment that they had ever received. And these are patients who, on average, had struggled with depression for over 20 years and tried many, many different forms of treatment. Certainly, more research is needed to definitively establish the efficacy of these drugs for these conditions and figure out exactly where they're best suited and how to deliver the treatments for the depression, PTSD, as well as they're being looked at for a number of other important indications like substance use disorders, obsessive compulsive disorder, eating disorders, and even others. And in fact, my colleagues here at Yale and I are involved in many of these pivotal studies that need to be done. However, there's very important limitations to the current clinical trials that are being done, especially as far as that only a very small percentage of patients who are in need and apply for these trials actually end up enrolling. To give you a sense of that, it's only about 2% of patients who applied to a recent trial that I finished with for major depression and psilocybin that were able to enroll due to a range of barriers, but especially very strict entry criteria, burdensome trial requirements, and there's other barriers.
Excuse me, Dr.
So-
Schlosshauser, your time is almost up. If you could please summarize. Thank you.
Absolutely. So the bill 5396 sets out to take a very reasonable step given those limitations, which is to create this pilot program to increase access. That's going to both address this issue that so many patients aren't able to get into the trials, and it'll give another pathway to access. But importantly, it'll create infrastructure within Connecticut so that when these treatments do and will likely be approved within 5 years, that we have some infrastructure in the state as far as a few treatment sites and a number of providers who are well positioned to deliver this care once they are approved. So happy to take any questions. I support that bill and ask the committee to support it as well.
Thank you, Doctor, for your testimony. Two questions that are related. What would you calculate as the percentage of your patients who would even be appropriate for this? And what process would you go through in order to determine whether or not they would be appropriate? Would they have to have gone through other traditional therapies first for you to consider it?
So every trial has a little different criteria, but all of them have had a very stringent screening process, and some have, I would say, have been very cautious in who they recruit and what restrictions are placed on patients, and so that's why a lot of patients don't qualify. I think that was done initially for a good reason to really, get good data, show that this treatment can be safe. And I heard your questions about safety, and the field really has demonstrated excellent safety profiles when done in this cautious approach of screening thoroughly, and as the last speaker mentioned, doing it in a very supportive setting. So I think over time we will have to loosen up the criteria, but still we would screen, we build rapport with people, make sure they don't have any serious medical conditions or serious psychiatric conditions that could make this treatment more risky for them.
Let me ask that a little differently. If you were not talking about qualifying specifically for a clinical trial, but this was generally available, what's your sense about what percentage of patients would be appropriate for this? That, we're at a point now in theory where we've already done all the research. What would be your response to that?
I think for depression and PTSD, that you might see psilocybin and MDMA therapy not actually be limited to only those with refractory conditions, but actually could become one of a frontline treatments given the safety profile and efficacy. So it could be a pretty high percentage down the road. I think for what this bill is trying to do as far as create expanded access pathways, that probably would be focused more on patients really in need for whom other treatments haven't worked.
Thank you. The reason I asked the question is I wanted to see if there was opportunity to help more people, that this was not some sort of, I hesitate to use the word boutique drug that could be used in very limited circumstances, but indeed could have broader applicability.
There will be access issues, and that's an important piece that we bring equity considerations into this kind of work. But absolutely, one of the drug sponsors for psilocybin Usona is their breakthrough status was actually for major depressive disorder, not treatment refractory depression, and so that actually reflects exactly what you were saying, that the treatment could be applicable to all people who qualify with that diagnosis, not just those who have proven refractory.
Thank you. I see Senator Anwar has a question.
Thank you, Mr. Chair. Thank you so much, Dr. Schlosshauser, for your testimony. I wanted to ask you, with the data that we have right now, how would you define an ideal patient who you would say is likely to benefit?
I guess it depends if it's for psilocybin therapy or MDMA, which have been tested for different indications. I mean, certainly, so those are two pretty different patient populations. In depression, again, the people that we've been working with are folks who have proven refractory. I don't think that that's necessary. We do need to establish good rapport, and as I think has been expressed, this is a drug-assisted psychotherapy. So essentially, we're doing therapy with people and then adding in the drug sessions to make that whole process more efficacious. So in my opinion, patients who want to do some psychological work. They're motivated. They're not expecting just a magic bullet. It's not just, this isn't just a magic treatment that you lay back and poof, things disappear. You know, there is active work that needs to happen with patients. So we need to have that relationship. There needs to be some motivation for change there. And it is, the time commitment is a little high. So we need to be able to work with people in a fairly sustained way.
That takes me to the next question. What is the cost of the medicines, and what is the total cost of this treatment? And insurance industry, should we be seeing a bill like this in the next year in the insurance committee to cover this?
It's a really good question, and there's starting to be some more cost-benefit kind of analyses that have been done. There actually was a really good paper published by MAPS, who's the drug sponsor for MDMA, that showed really good data supporting cost efficacy for MDMA therapy of PTSD. I'm sure others have spoken to the huge costs of PTSD to our society, and although these treatments are fairly heavy investments up front as far as the time, I mean, it's like therapist time. The drugs overall themselves, because it's such limited dosing, we're only talking about 2 to 3 doses of these treatments. So the drug costs are actually not that high. It's a lot of therapy time, but that time is really, when you consider any other procedure for a medical problem, is actually pretty low. And if you can actually address someone's depression or PTSD in a way that allows them to function better in the long term, you save a lot of money. So we're starting to see there needs to be a little more research on the costs, but so far it's looking very good in that domain.
And after the treatment is completed, are they off their other medications?
So again, that's something that's evolving. For the studies that have been done with both of those medicines to date, that it has required that people come off of their medicines, their current conventional antidepressants. In the future, that may look a little bit different. So we have, and that's been a big problem in the research, is to ask people to come off, because many people cannot come off. So that'll be a future phase of research, is actually doing some of these studies with people still on their medications and finding out what can be done safely in that regard. As of now, it's been done with people coming off. And then some people, after they're done, some of my patients have stayed off of all psychiatric medications for a year or more afterwards. Others have gone back on.
Okay. This is very helpful. Thank you so much, Mr. Chair. Thank you, Dr. Schlossauer, for your testimony. Thank you.
Thank you,
Senator, and thank you, Doctor, for your testimony. It's good to get a more on-the-ground insight. We really appreciate it. Seeing no further questions, we have next up Ms. Halpin, followed by Fiona Cullinan-Farine.
Hello all, can you hear me?
Yes, we can.
Good afternoon. It's a pleasure to be with the Public Health Committee today. For the record, my name is Susan Halpin, and I am here today on behalf of the Connecticut Association of Health Plans, which is comprised of Aetna, Anthem, Cigna, Connecticut, Harvard Pilgrim, and United. And I'm here today to respectfully urge your opposition to the two-step therapy bills that you have before you, Senate Bill 331 and HB 5275. Forgive me if I'm stating what many of you already know, but I think it's really important to underscore that this legislation, as well as a lot of other legislation that's before the legislature this session, would only apply to about 30% of the market. And that is the fully insured market. And it's often the most price sensitive portion of the market. It's your small employers typically and your individual policy holders. The large part of Connecticut's market, 70% approximately, is self-insured. Self-insured means that the employer actually puts together a bank account and then hires an administrator to administer the claims, like an Anthem or an Aetna or a Cigna or any of the other carriers that I mentioned. It's interesting. The state of Connecticut is one of the largest self-insured plans, as are municipalities, are our hospitals, as are manufacturers. So there's a large portion out there. I often get questions of, why doesn't this mandate that the legislature passed, why isn't it being followed? And the reason, very honestly, is because it's that the person is insured under a self-insured plan. And under self-insured plans, employers follow federal ERISA law, not state law. But I want to get onto the bill really quickly. After just laying that little bit of groundwork for you, there are three things I just want to leave you with. One, that step therapy is as much about quality of care as it is about affordability of care. Step therapy allows and ensures that evidence-based practice is being followed, and that the most efficacious drugs with the least side effects are being used before those that may have additional side effects. There is no question that the vast majority of providers out there have nothing but the best interest of their patients in mind. But we all know that there are unscrupulous actors, and we all know that patient care can be varied, which is why there's been such a push for evidence-based care. And step therapy really is the embodiment of that evidence-based care. The FDA, for example, is one of the treatment regimens. What they put out there is what many step therapy protocols are based on. They're also based on specialty society recommendations. They're put together by pharmacy and therapeutic committees that are made up of clinical practitioners that participate with the health plans in developing formularies and step therapy protocols, among other things. So,
excuse me, Ms. House. Your time is on. Thank you.
I will. So the second 2 points are, one, affordability can't be taken out of the equation. In many other proposals before the legislature, you're all seeking to control pharmaceutical costs. I think we have to look at step therapy in that lens. And lastly, I just want to assure you that there are a number of statutes already on the books that are a check and balance on step therapy to assure that members get the coverage that there is warranted. So with that, I'm happy to answer any questions, and you should have my written testimony.
Thank you for your testimony today. It is very important to us to hear from those who are directly involved, and certainly it's not our intent to do away with any important restrictions or guardrails. I see Representative Carpino has a question for you.
Thank you, Mr. Chairman. Hi, Sue. I got to start with, I'm disappointed. We spoke about this bill last June, and you were going to follow up with Representative Cook and I with a number of our questions. And now it is mid-March, and we've not gotten an answer to our questions. So I have to tell you that I'm disappointed, to say the least. I asked for a number of questions that I thought would be very helpful to understand for both myself and committee members. One was, how many patients actually appeal this process? How many are actually granted or denied? What is the actual cost differential? And yet I'm waiting, but I'm going to ask you a couple of quick questions with so many folks testifying. I'm sure we can follow up online, but you just mentioned that patient care is varied, and yet the opposition to this would force patients to fail first rather than have their individual provider make the actual decision. Help me reconcile those.
Well, first, to your first point, my apologies if we did not follow up on something. That was certainly not our intent. I know that there have been conversations going back and forth, and I consider both you and Representative Cook friends, and I'm happy to sit down with you at any time. So I'll start with that. Secondly, the fail first, I think, is just a different, it's a term that's used that doesn't really, I don't think, capture the full content of what step therapy is. And I didn't get a chance in my 3 minutes to really highlight some of the protections that are in statute. To your point, the statute provides an override if the provider at hand believes that they need that particular drug. There are processes and procedures in place for them to get that override. Number two, the way the urgent appeal process works is the carrier has to turn that around within 24 hours. So that provision was added just a couple of years ago. And thirdly, I would add that health insurers are barred from using step therapy for more than 60 days. And at that point, if the provider deems it clinically ineffective, then the coverage is provided. And I've been through step therapy myself. I mean, I've done it. I try to go through everything personally that I can to better understand why these provisions are in place. And, at the time that I went through it, I can tell you that the brand name drug was $500 for a 30-day supply. I have a high deductible, so I have to pay that $500. The alternative, I took 3 times a day, which I needed to either get up in the middle of the night to take, or I had to take it during the day, and it made me tired. So I went through the initial process. I appealed without any outside help and sought to get the 1 time a day drug. But the difference between those 2 drugs, on the one hand was $500, on the other hand was $10. And your question around data is a good one. I know that the department is looking at data. I know there's the all-payer claims database, which is also a major piece of legislation passed, whereby all the health insurers contribute their claims data to one central repository that's available for query. If people or policymakers or others have questions, they can query that database. There's been a series of things, as you know, over the years that have passed around these provisions and are in statute. And I'm hoping that folks will avail themselves of those provisions before we take the next step and add additional prohibitions in statute.
Mr. Chairman, if I may continue, Sue, I appreciate your response, but whatever conversations you had since last June certainly weren't with me. I'm concerned that we're mixing apples and oranges. I understand step therapy when you're talking about perhaps an anti-inflammatory for a bum knee. I've been there myself, but we're talking, and I just want to make sure that everyone listening and everybody on this committee is quite clear about what we're talking about. We're talking about a small subset of individuals who are struggling with mental health conditions. This is not carte blanche. I need everybody to understand that up to 60 days is a really long time for an individual to wait for an insurance company to determine that his or her physician is wrong. I'll ask one question before I turn it over, sir, but you made a quick comment in your opening, Sue, or perhaps it was your testimony about most physicians, and I'm paraphrasing, I don't mean to quote you, or well-intended, but you have to worry about unscrupulous actors. Are there evidence or data about unscrupulous actors in the state of Connecticut who have taken advantage of this policy for those with mental health conditions? Through you, sir.
I would certainly be willing to provide you with follow-up information. I think the Medicaid agency has taken action against certain providers of note that are out there. I think that in other states, we've certainly seen firsthand experience with that. And I don't want to leave you with the impression that the 60 days is the only piece in statute. There is an automatic override portion in statute. There's also an automatic urgent appeal in statute. So there are additional provisions in addition to the 60 days. And like you, I've been up here for a while, so I remember just a few years back where we were concerned about psychiatric drugs being prescribed to kids or to others because it was creating suicidal ideations. So the pendulum does swing from place to place at different times. And I think we're talking about a number of issues here today and in other committees about off-label drug use. We're talking about new products and services potentially coming to market. And we also like to talk a lot about benchmarking and evidence-based practice. And step therapy is one way to put those types of measures in place through coverage. So I know that you and I and Representative Cook and I, we can agree on a lot of things to agree with on other issues or on other measures, but on this, I'm guessing we will agree to disagree. But I do think the conversation is an important one to have, which is why I wanted to come before you today.
Thank you, Mr. Chairman. Thank you. My last comment is that they are doing this in other states. And if we're going to do it now is the time as we're addressing mental health across the state, because we had a chance to act last year and through powers beyond my control, it didn't get done. So if any time is right, now is the time. Thank you, Mr. Chairman.
Thank you, Representative. And I share your frustration that you've been trying to engage and get answers to your questions. And I would submit that we will be strongly influenced by the responsiveness of those parties in opposition to this bill to actually answer the questions that have been put forward. It is very frustrating that here we are a year later and we have the same unanswered questions. I see Senator Anwar, followed by Representative Cook.
Thank you so much, Mr. Chair. Thank you, Susan, for your testimony. I agree with Representative Carpino. Hear me out for a second. Behavioral health and mental health is a different issue. This is not an issue where you actually have the luxury to wait around for many months. If you talk to psychiatrists, they would tell you, based on the person's age, their severity of symptoms, their overall other factors and suicidality, they would know what would be the best treatment to go forward. The step treatment requires you to go through the steps. For a medicine to work and know whether it's working in an individual, it takes almost 2 months, unfortunately, for psychiatric medications. And then you actually have to, if it doesn't work or it causes a problem, then you have to have a time for it to wash off, if you will, and then to have second one. And then you sort of mix and match both. So you got the 3rd month in. And then you actually have to wait for 2 more months, and then you have the 5th month in, and then you actually try to get that off. And then by the time that the person is going to get the medicine that they need, you'll be about 8-9 months into the trial and error option, where some of the psychiatrists know right off the bat what would be the best treatment. So those 9 months of life, if the person makes it and does not harm themselves, is a big deal. And because we are carving out a very specific issue, I think it's very worthy to look at it from a different angle as opposed to a lot of other illnesses. But mental health is a different situation, and I just want to. I know that you represent the industry. I know that it's your responsibility to address that. But the industry also are humans. They have their loved ones, and statistically, they also have mental health illnesses because it's so prevalent. And the litmus test is we should have the treatments that we would want for our loved ones to be the ones that we should allow others to have it, because that's how we should approach this. So I would urge you to work with your industry and then reconsider your position for this. And you can reflect on what I've said. Thank you.
Senator, we always appreciate your comments. And we do appreciate it. I mean, I certainly am not somebody who has been immune from the mental health crisis or the substance use crisis. I mean, like everybody, that's on this panel today or watching, I certainly have had personal experience with both. So I understand exactly what you're saying. I think when we look at things like this, we have to take a holistic approach, right? And take some of the emotion out of it. Because it can be very emotional, and I understand that. And I think we need to, go back to making sure there are safeguards in place, which I think there are, if there are more safeguards that can be in place. But I also still want to go back to that first part of my comment, which I think is really, really important as we go down this path, which is, let's just say that we pass this, and putting aside behavioral health for a second. And because there's been other proposals both this year and in previous years that talk about, full elimination of step therapy. And I can tell you that, one large health plan estimated that cost at about $5 million for their small employer and individual market segment. And if a self-insured employer picked that up, they said it would be about $10 million. Now, if people can't afford coverage, we're not helping them either. So I think, again, always willing to work with you, always willing to work with Representative Carpino and Representative Cook. And again, I will restate my apologies if we fell through the cracks there. Certainly not our intent, but I do think the conversation is a big conversation, because we are talking on the other side, in other committees, about how do we control drug costs. They're escalating at an unsustainable rate. And, I often get asked on the insurance side, what are you doing to control drug costs, right? Where is the insurance industry in controlling those drug costs? And yet what we see is tools kind of being taken out of the toolbox to keep that process, at least somewhat, in accordance with evidence-based practices.
And I would just say to you that the physicians who have spent 3,000 hours to train to look at individuals in all of these situations, they would know better than the person on the other side of the phone rejecting it, insurance companies. Unless you have the same level of training on the other side available within 5 minutes, I am for this bill. Thank you so much.
I understand, and I respect your position. I will say that the protocols filed that are followed by the health plans are done in accordance with, the specialty societies, P&T committees that have clinicians on them. So, I respect, where you're coming from on it, and thank you for the comments.
Thank you, Mr. Chair.
Thank you. Representative Cook.
Thank you, Mr. Chairman. Hi, Sue. It's nice to see you.
Nice
I do have to agree with my counterpart in this piece of legislation, Representative Carpino. We did have conversations in LinkedIn. I believe that you had actually reached out to the Speaker's office at the end of the last legislative session, trying to put a halt on what we were attempting to do. And in essence, that's what happened. But we haven't heard back since then. I will bring to everyone's attention that Maine, our New England state to the north, has actually passed this legislation, and it is working quite effectively. So I think we need to look at that. This is not a model of which we are trying to come up with on our own. It is something that's already been put into place. I think what frustrates me is I understand your position, and I do. I understand that you have a responsibility to advocate for the groups of which you work for and represent. And then, as you know, we have that same responsibility to work and advocate for those that we represent. There is an overlap in that we all should represent the people that needs our care, but in some situations, some things get in the way of certain decisions. I'll give you an example. I had to have a colonoscopy done a few months ago. I have them done every 18 months. And my colonoscopy prep was denied because my insurance company wanted me to go through a step therapy process for a colonoscopy. Now, that is ludicrous if you ask anybody that has any sense about it at all. My doctor's office knows me very well. They've been treating me now for 28 years, and they know what works best. The insurance company felt that they knew what works best for me. This brings me to the point of the conversation that we're having right now. We have to have faith in our doctors that know what works best for the patients of which they care for. And in theory, we all have insurance coverage. And in the insurance industry should not play my doctor. My doctor should be my doctor. And I should have to have trust in them. And the insurance company should actually have trust in the doctors at making some decisions. So when you had mentioned, and I believe Representative Carpino tipped on it a minute about the bad actors, if you will. What's happening to those bad actors? Because there's no reason why some bad actors should get in the way of good medicine for good doctors. So could you explain to me, if there are bad actors and we're afraid to make good policy because of the bad actors, what's happening to those bad actors so we can make good policy and also deal with them?
I think typically what happens with bad actors is the Attorney General begins to look into them. I'm not an expert on that. I can get back to you, with those details if you'd like. I mean, the thing I would point out, and I don't want to presume this, but in your example, I'm just wondering if it underscores my earlier point about self-insured. Just, if I'm presuming, perhaps incorrectly, that, you're a member of the state employee plan, those benefits and those steps, if you will, are put in place by a self-insured employer because they have seen some kind of, value in that. I can't speak to the exact circumstances, but if this legislation were passed, I just think we all have to remember that it's not going to apply in the self-insured market space. It's only going to apply in the 30% of the market that is fully insured. And I can't say enough, that's the part of the market that is the most price sensitive. So, if there's an uptick in insurance costs, 1%, 2%, 3%, I think you'll see a corresponding number of folks that can no longer afford insurance. So, I thank you. And I always enjoy hearing from you, even when we don't agree. But I respect where you're coming from on it. And I think, in many ways, we're aiming towards the same place, but through different, approaches.
So thank you for that. And I would respond to two things. So we can actually legislate things that cover the state insurance plan. We actually were very successful in doing that over several years when I just got the dental insurance for children up to the age of 26 finally covered by all. Mm-hmm. So it is absolutely feasible. We work with the comptroller's office and that can get done. And so if we put this policy into the place, we would actually be able to make sure that it covers all parties, not just 30% of the parties. The second component to that I would make would be this. When we talked, the only reason why I used the example of the colonoscopy was because I thought it was just a little bit bizarre that after so many years, my insurance company would tell me that I had to do a step-up plan. So upon doing research and talking to several people, it was made very clear that the prep that they wanted me to use was nowhere near what I needed to because I didn't have a colostomy bag, but that's what the insurance company wanted to give me. The other thing was that the prep that they were using, that they had told me I could only use, was not as effective as the one that my doctor wanted to use. And that 80% of the time people had to go back for a second colonoscopy because it didn't do the effective, the effectiveness of what it needed to be to have your procedure done in an appropriate manner. And quite frankly, the one the insurance company wanted me to have, not the one my doctor wanted me to have, was $35 more expensive than the one that my doctor actually prescribed. And the woman on the other end of the phone said very clearly, Michelle, I don't know who angered somebody at the insurance company, but that's why yours is not covered. And the fact that there are people that have the ability to have certain things approved and not approved, and I'm not saying you, Sue, so that is not a direct to you, but I'm saying there is a much bigger conversation to this than what we actually want to agree to. And for me, it is about the person that needs the treatment. And I know that if I had to wait for my procedure after one prep to do another prep and then another procedure, I could have a horrible outcome to where I am at right now. And that's what I think we're looking at. Nobody should have to wait 30 days, 60 days, 120 days, regardless of the 24-hour turnaround that you're talking about. Certain medications take 2 to 3 weeks to get out of your system before you can start another one. And when people know that they can trust their doctor and their provider, and the doctor and the provider knows what works for them, that's what we should trust. And that's really where I think that we're coming from. And I'm hoping that we can figure out a way to get there. I don't want to be on the opposite side of this with you. I want to get to the right place for all of the people that need us and that can trust that we're doing the right thing for them. So thank you. Thank you, Mr. Chairman.
Thank you. Well, we've had a spirited conversation, Sue. But what's in front of us is still really the more important part, which is we need to come to terms with this and be as evidence-based as we can be. As you can see, there are members of this committee who are very eager to try to move this forward. So let's see if we can get to resolution real fast. How's that?
Thank you.
Further questions? We'll go on to Fiona Cullinan-Farine. If I pronounced that incorrectly, I do apologize. And I will figure out who comes after Fiona. Please proceed.
Good afternoon. Actually, you pronounced that perfectly. That's really impressive. That happens rarely to me. So good afternoon, Chairman Steinberg and all members of the committee. Thank you for your work, which brought us here, and special thanks to Representative Parker and Representative Gilchrist for their continuing hard work and their generosity of time. My name is Fiona Cullinan-Farine. Represent For Cameron, a nonprofit that advocates for substance use disorder harm reduction and to break the stigma associated with opioid addiction. My daughter and I founded For Cameron after the death of our son Cameron 4 years ago this week. Cameron died when he purchased from someone he trusted what was represented as OxyContin. It was unadulterated fentanyl pressed and stamped to mimic OxyContin. It takes 2,000 micrograms of fentanyl to kill you. Cameron was given 11,000 micrograms in one pill. That's 9,000 micrograms over the absolute death dosage. Poisoning by illicit fentanyl has become the crucial crisis in this opioid crisis. I testify today in support of House Bill 540-30, an act concerning opioids. I want to highlight the following measures: legalizing fentanyl test strips, allowing up to 28 days of take-home methadone doses to stable patients, requiring DEMAS to provide a report on sober living homes and their voucher programs by January 1st, 23. But I urge you to take action now to provide additional state oversight of sober living homes, increase the amount of available beds and resources, and expand the voucher program. Deaths by fatal overdose far exceed deaths by gun violence, car accidents, and cancer. Data gathering and reports must occur in conjunction with bold action now. In January of this year, the American Medical Association issued a report stating 2022 is a critical year to address the worsening drug overdose crisis. They stated, as policymakers take action in 2022 to update rules and laws that are enabling our worsening opioid epidemic, more Americans will die. In addition to asking you to pass the measures I've already listed, I urge the committee to go further than the bill raised and take action on the appropriate committee to create the Fatal Overdose Task Force as we have requested and proposed. Most overdose deaths involving illicitly manufactured fentanyl go uninvestigated. In closing, I also strongly request you consider the proposals of Adita Bargova, Dr. Bommerbach, Dr. Raman, Anthony Morrissey, Dawn Hemstock, Kelly Choquette, Scott Choquette, and Lisa Dean have raised or will raise within this hearing. During the time this hearing takes place today, 5 Connecticut residents will die on our watch. Nationally, a death by fatal overdose happens every 11 minutes. Thank you for your time and your consideration today.
Thank you. I see Representative Parker has a question.
Thank you, Mr. Chair.
Good afternoon, Representative Parker. Thank you for everything you're doing for us and on this horrific crisis.
Yeah, well, thanks for saying that. And thank you for your leadership. You've been working tirelessly to coordinate so many of the folks that we're hearing from today, including a number of the names you just mentioned. And so I really want to just lift up your leadership in the way that you've been such a important connector across the community. You preempted the questions I was going to ask you, so I appreciate you mentioning what you think is a good start in this bill and some of the other pieces. And so as we've talked about, I just will say I look forward to continuing to work with you, especially thinking about how we strategize across some other committees to move forward ideas around Fatal Overdose Task Force, some of the insurance pieces, and just thank you for your time and this week of all weeks to be here testifying again. So sorry for your loss and grateful for you and your family's work. Thanks, Mr. Chair.
Thank you very much, Representative Parker. I actually think that it's so appropriate that this week I'm testifying and trying to make a positive change in Cameron's honor. So I really appreciate this opportunity.
Well, thank you, Representative Parker. And again, thank you for your testimony to work of your organization and everybody who has been so dedicated to trying to make a difference. We really do appreciate it.
Thank you very much.
We have Sarah Wall, followed by Cynthia Levy, Dr. Levy. Sarah, welcome.
Thank you, Mr. Chair, and thank you, distinguished members of the Joint Public Health Committee. My name is Sarah Wall, and I'm the Government Affairs Manager for the Northeast region at R Street Institute, which is a nonpartisan think tank that promotes limited effective government across many issue areas, including tobacco harm reduction. I'm also a resident of Hamden. We are concerned about the provisions in Senate Bill 367 that disregard the health benefits reduced risk tobacco products provide for Connecticut smokers. The R Street approach to harm reduction recognizes abstinence-only approaches to risky behaviors do not work at the population level, and that less harmful alternatives should be widely available. The committee has heard several other bills today on the harm reduction approaches at the front of combating opioid addiction, which is another platform in R Street's integrated harm reduction approach. We would ask this committee to apply a harm reduction lens to nicotine use as well, because not every nicotine delivery product should be treated the same. Multiple health research organizations, including the US Food and Drug Administration, FDA, have recognized nicotine products exist on a continuum of risk, with e-cigarettes at the lower end near traditional nicotine replacement therapies. Contrary to previous testimony, the New England Journal of Medicine published a randomized control trial that found smokers who switched to e-cigarettes were able to sustain abstinence from combustible cigarettes at nearly twice the rate of those who used traditional nicotine replacement therapies. These substantially reduced harms make e-cigarettes an important tool in the arsenal of tobacco cessation for adults. Flavored products are an important part of incentivizing the switch. In one study of over 4,500 former smokers who now use e-cigarettes, 91% had switched entirely from combustibles to e-cigarettes, and all participants called the variety of flavors very important in their decision to switch from combustibles. 40% reported flavor invariability would have made it less likely for them to switch. R Street shares the concerns of this committee over youth uptake of e-cigarettes. In fact, we were one of the first national think tanks to advocate for raising the age of purchase to 21 so that they were less likely to fall into minors' hands. But flavors are not the primary reason youth begin using e-cigarettes. According to a study from the US CDC, only 22% of minors cite flavors as the primary factor, while over 55% cited curiosity. We continue to urge this legislature to take action to effectively continue preventing youth uptake of these products. For instance, the Maryland State Senate has introduced measures to restrict the marketing and advertising of these products among youth, as well as their sale within 1,000 feet of a school. Educational measures requiring health classes to inform students of the addictive nicotine content in these products should also be considered at the state level. But curbing youth uptake should not come at the expense of the health of nearly 425,000 Connecticut residents who smoke combustible cigarettes. Thus, we respectfully urge this committee not to pass Senate Bill 367. Thank you, and I'm available to answer any questions.
Thank you. I believe we'll start with Representative Pettit.
Thank you, Mr. Chair. Thank you, Mrs. Wall, for that testimony. Can you tell the committee what the absolute numbers were in that New England Journal study? That is a doubling of effect. If it went from 1% to 2% absolute, it's not very important. If it goes from 40 to 80, it's a big deal. So do you know the absolute numbers in terms of the decrease?
Sure. Yes. Thank you, Representative. This study is cited in my written testimony. You can find it under citation 6, I believe it is, the second one in that list on 6. According to these results here in the abstract, there were 886 participants who underwent randomization. The 1-year abstinence rate was 18% in the e-cigarette group, compared with a 9.9% abstinence rate for 1 year in the nicotine replacement group. So that would be the patch or nicotine gum.
So about 19 to 9. All right, so 1 out of 5 versus about 1 out of 10 using. I hear your point on the CDC's numbers, but at the risk of making the viewers and people on the committee laugh, I realize it's curiosity, but if the flavors were liver and onions and asparagus, they probably wouldn't sell quite as well as bubblegum and blueberry. So I think it probably depends on how you ask that question. I think it's a little of both. But I'll just follow with, since we have the age of 21 in Connecticut, what do you think is the best way to allow, and what would smokers of combustibles need to work towards abstinence, and what would be the best way to keep them away from kids who we know will never be perfect because they got lots of spare time to figure out how to get vaping stuff. So some of them will find out a way to get it no matter what, and get it from adults who buy it legally or buy it on the internet. So what are your thoughts there?
Sure, thank you. I will say, and I realize this is completely qualitative, but my brother is a former opioid addict who kind of switched to combustible cigarettes in his addiction, and thankfully has now switched to e-cigarettes. I should mention he's 26, and that flavor invariability would probably, he would be one of those who would find it much less compelling to use tobacco flavoring in his e-cigarettes. In fact, he's told me as such. And part of that is because it's sort of the flavors assist him in disassociating that pleasurable feeling that he at one point received using combustible cigarettes. And to your second question, I'd be happy to send over the kind of model language being considered in the Maryland State Senate. Of course, this isn't an issue that is only being seen in Connecticut right now. This is kind of being considered all over the country, and people are asking the same question that you are, Representative. So I appreciate that question. The kind of some of the areas that they've looked at there, as I mentioned in my testimony, are prohibiting the sale within a school, using or removing any kind of advertising materials that resemble what might be appealing to children, removing them from any advertising publication that goes to young people at a rate of, I think, over 15% of readership. And also, I think what I know, so I'm a millennial myself, so I grew up in the era of like the DARE program. And I think that education around the nicotine content within these e-cigarettes would likely be quite useful as well, kind of shoring that up and increasing those educational programs, purely because I think, as someone mentioned earlier in their testimony, many young people don't understand or know that these products even contain nicotine. And part of that is because they came onto the market without regulation about a decade ago. And that kind of educating children now that these products are addictive, that they contain the same nicotine as a regular cigarette that has definitely been conditioned out of use for many young people, I think would be one very useful way. But I'm very happy to connect you as well to our integrated harm reduction team, who would likely have other suggestions around this issue area as well.
Well, I thank you for that. And I think we've had this discussion in the past, and I think Senator Dr. Anwar is not a big fan of the New England Journal study, so he's up next, I think, and he'll probably continue the discussion on that paper.
Thank you, Representative. I think I might actually disagree with you, though. I think an asparagus flavor with a nice hollandaise could be just great. So let's keep those things in mind. Senator Anwar.
Thank you so much, Mr. Chair. I just wanted to ask you, I lost you. There you are. Ms. Wall, could you help me understand what is the relationship with R Street Institute with Altria?
So I am not sure. I am relatively new to the R Street team. I am on the government affairs team, as I mentioned at the beginning. If you have any questions, our 990 is on our website, and I am also not a part of the development team. So I'm not sure who our partners are, but again, I would refer you to our website.
Okay, I can tell you, Altria is a group that is actually promoting vaping industry. So since 2014, it has been funding your organization. And then that's an organization that actually wants to promote everybody to take vapes, irrespective of their age groups. That's how at least they started. I don't know what they're doing today, but that's where their stuff is. So I think that's important to know because obviously where you get your money, what's the sustainability for the organization. Can I also ask you, is the current position of R Street to believe that climate change crisis is a real issue?
Actually, it's funny you mentioned that. So we were founded in 2010 as a split off group from an organization that did not, 2012, excuse me, from an organization that did not believe in the climate crisis because we disagreed with their position. So I would encourage you to look into that, but we are absolutely in favor of kind of advocacy around preventing climate change.
And you were offshoot of a group that was actually against climate change. In 2012, you became an offshoot because at that time, the broad groundswell resulted in recognition that the credibility of the group was very low. So they actually moved on, but they started to take on other projects. And now this one is another one of a source of funding coming to try and sell things to the communities, which are making some people very rich and then some people very sick. I think that's the bottom line that we have to recognize is that what we're trying to do is we're trying to protect our children. And the data is quite clear. There's an on-ramp and the off-ramp has a large number of other options that are FDA approved. And the on-ramp is creating the next generation to be addicted to nicotine. And then we heard some of the people that path and what that causes and their illness. So, and the relationship between the vaping industry and the tobacco industry is symbiotic. And that's why whenever somebody's trying to block the sale of flavored vapes, the tobacco industry pours millions of dollars into that arena because they feel that they will actually lose the next generation of customers. I think that's what is up in front of us. So I appreciate you coming in. Again, the fact that your group is funded by Altria and some of the other organizations that are their stated agenda is they want most of the people to pick up vapes and increase their capacity. I have to look at you with very low credibility for your presentation, but I appreciate you coming in. Thank you so much, Mr. Chair.
Thank you, Senator. I don't see any further questions. Thank you for your testimony today. We will next move on to Dr. Levy, followed by Scott Choquette.
Good afternoon to the Joint Public Health Committee. I am speaking today in favor of HB 5396, and I'd like to give you a little background on myself. I'm a 66-year-old woman who does not smoke or drink. I didn't take pills or any of the hippy-dippy stuff George Carlin talked about when I was in college. I graduated with a master's in international law from the Fletcher School of Law and Diplomacy when I was 21 in 1977. I have a master's in public administration from the Syracuse University Maxwell School and did my PhD research there on the congressional and legislative process, and also have a PhD from the Hungarian Academy of Sciences and Military Strategy. I was the senior legislative assistant for Foreign Affairs and Intelligence for Orrin Hatch and for Senator John Chafee. I served as the Assistant Secretary of Defense under Caspar Weinberger in the 80s, and I was the Assistant Provost of the Naval Postgraduate School for External Affairs. That's a thumbnail, just to tell you that I'm not some lunatic who wants access to psychedelics. But currently, and throughout my career, have worked with special operators. I was in the intelligence community myself back when there were 3 channels, no computers and no cell phones. So while special operators work in teams and someone already has their back, I was deployed to the Soviet Union alone. Having said that, I have suffered from depression for various and PTSD for various things that have happened in my career, and understand that I was in the Prozac trials in 1980. I have taken every antidepressant known to man for the last 42 years and thought I was doing great. And people looked at me and said, what a career, aren't you something? When I worked in the Senate, there were only 2 women who had senior LA jobs. One worked for Gary Hart and the other one was me. Anyway, the point being, about 4 weeks ago, I was in such bad shape that one of my friends who was a SEAL who had just come back from Peru said, you have to go and get a weekend of psychedelic medicine treatment. I said, you're out of your mind. I'm not listening to gongs. I'm not meditating, and I'm not taking that stuff. And he said, fine, I have a funeral suit, and I promise you I will look fine when I go to your funeral. And that's how bad it was. Between COVID, losing my mother, having my dog run over by a car. I mean, we could go over this for a while. I'm 3 weeks out from taking this weekend with psychedelics. I didn't know the sun could shine and it would actually be bright outside. I didn't know that I could wake up and not be worried about the rest of the day falling in on me. And I am so sad that all of the funerals I have gone to over the last 25 years for my brothers and sisters who work for the intelligence community, I apologize. And as special operators, didn't have these psychedelics available to them. I want you to know I'm not sitting in my house in Virginia Beach, proud home of SEAL Team 6, and eating mushrooms. I went with skilled and trained professionals who helped me get my brain back reset so I could be a functioning human being and smile during the day, not as an act, because I got to be a very good actor over the last 40 years, but because I actually feel hope for the rest of the day. I believe that HB 5396 is very important for all of my friends who have committed suicide and for all of my friends who hopefully will get the help that they need by having this bill pass. I apologize for being weepy because I'm one tough broad and I'm not usually weepy. So thank you very much for listening.
Well, thank you. I choose to focus on your sincere smile now versus any weepiness. Let me say thank you for your service to our country and our condolences on your losses that led you to the point where you were able to find this life-saving therapy. It's a very interesting story, which has a certain newness about it. You're, as you say, only weeks away from the experience. It's very pleasing to see what good spirits you're in, given everything you've been through. I see Representative McCarty has a question.
Yes, I'll be very brief. Thank you, Mr. Chairman, and welcome, Dr. Levy, and thank you for sharing your story. I'm just curious because we heard a lot about this new approach and wondering, were you able to reduce any other medications having gone through this therapy? And if you could just comment about that. Thank you.
Yes, as a matter of fact, I didn't know there was something called resistant to antidepressants. Well, I've been taking them for 42 years. As a matter of fact, I took so many that insurance didn't even cover the amount I took, and I paid for the others myself. And for 42 years, and I was told I had to get off of these antidepressants before I could go to get the plant-based therapy. And it would take 6 or 7 months. I said, forget that. And I just went cold turkey, which is not fun because I know what a heroin addict feels like now. I never knew I was addicted to drugs until you try and stop taking antidepressants after 42 years. Anyway, rephrase the question. What am I looking for to tell you?
No, I think you answered it pretty well. I was just looking to see if you were if you had to reduce your if you were taking and if you had to reduce those medications and how you
I have
feel now.
not taken another pill since then. And I'm telling you, my days are better. And I'm not taking all of that medicine. And it's just amazing.
All right. Thank you. And I wish you the very best going forward.
Thank you so much.
Thank you, Representative. Representative Cook has a question or comment.
Actually, Mr. Chairman, I don't. I just wanted to thank Cynthia for sharing her story and her passionate, open, and honest path and journey in life. And thank you for being here with us and making us understand the complexities of the things that we're deciding today. Thank you so much.
Thank you. This is very important, and I thank you for working on it.
Thank you both. I don't see any further questions. I think we can offer you the suggestion that you have a happy day, because at least that's a prospect now.
Thank you.
Moving along, we have Scott Choquette, followed by Ms. Alderman. Can't hear you, Scott. You need to unmute.
Thanks. Thank you, Chairman Steinberg and members of the Public Health Committee. My name is Scott Choquette, and I represent For Canaan, a nonprofit that advocates for substance use disorder, harm reduction, prevention, treatment, recovery, and reducing the stigmas associated with opioid use and addiction. My wife and I lost our son, Nathan, to a fentanyl overdose in 2018, as many of us in our organization had. And this was after seeking adequate and effective treatment for him in vain for many years. We thank you for the opportunity to speak on House Bill 5530, and I testify in support of the bill. However, it does not, in my opinion, rise to the occasion of meeting the urgency of the crisis that we face today. Fentanyl test strips serve a purpose and save lives, and there's certainly a legitimate reason to make them more widely available with the prevalence of illicit fentanyl in our state. I also agree with making methadone and other medically assisted treatment more accessible. These are good measures, and that's why I support the bill. However, they don't address the fact that in our state, one of the wealthiest in the nation, we still have inadequate resources to provide treatment and recovery services. In January of this year, we presented 5 areas needing immediate attention to the members of the committee. And although we're chipping away at it, we're disappointed that none of them are really in this bill. And I'll speak to just 2 of them today. Currently, there's dozens, if not hundreds, of families who are searching for inpatient treatment towards recovery who can't find it because we have a devastating shortage of rehab and recovery beds available in the state. And I can tell you, when an addictive person is ready to seek help, waiting days or weeks can slam that window shut, as most of you know. And then according to the National Institute on Drug Abuse, the research has shown that unequivocally good outcomes are contingent on adequate treatment length. And adequate treatment length by that study and many others who have studied this issue is 90 days or more in order to have limited effectiveness with follow-on outpatient treatment afterwards. Most insurance carriers cover 21 days or cover up to 21 days of treatment. And that is just something that absolutely has to change. The bill is written kind of response to this emergency by gathering more outcomes on treatment and studying the problem. I believe the problem has been studied to death and we're kind of kicking the can down the road, and we can't afford to do that when 4 people during the time that this committee will hear testimony today will die in the state of Connecticut. It's likely that 1 or more of those people who die have sought treatment in the last month unsuccessfully or were in recovery for an inadequate amount of time. So there's 3 things that I'm asking for. Either modify this bill to accelerate addressing the treatment and recovery components, somehow consider a special session to address the shortfalls in this bill if the short session doesn't provide enough time. And I confess I don't know how that's done. And thirdly, use the powers that you have to ensure that this advisory committee that's being established by House Bill 5044 addresses this inadequate treatment facilities issue and helps us while we work with you in the insurance committee to address the proper and adequate treatment lengths for patients and outpatient follow-up for inpatient and then outpatient follow-up. Thanks for considering the testimony and working with us to address this crisis. It's urgently warranted.
Thank you for your testimony. Frankly, I don't see much prospect for a special session, but the good news is we're not done with this one yet. The things that you're raising, unfortunately, require usually significant increases in reimbursement and funding. Some of the things that you mentioned, unfortunately, fall under the bailiwick of the insurance committee, which we don't have purview, but the points you make are valid, and we've heard you, and we hear you before. I promise you we will look with fresh eyes at your testimony and see what we're able to do. I see Representative Parker has a question.
Thanks, Mr. Chair. Yeah, you spoke to some of what I wanted to say, mostly just to thank you, Scott, for joining us and sharing your testimony. We also received written testimony from Kelly, which we have on file too. Appreciate your reminder of the urgency and need to do more. And we'll look forward to continuing to work on, as the chairman noted, connecting better with other committees into the future to pick up some of those issues as well. So thank you for being here and for sharing.
Thank you for what you've been doing.
Thank you. So stay with us, Scott. You shouldn't give up, and we're not giving up. So we're continuing to fight for the right answers. All right. Next up, we have Nancy Alderman, followed by, I'll figure that out. Why don't you go ahead? I'm sorry, I called you Nancy.
You did. Nope, her daughter-in-law, Linda. Hi.
Right. Sorry about that.
That's okay. Esteemed members of the Public Health Committee, my name is Linda Alderman, and I live in West Hartford. I'm the Connecticut State Lead for the American Cancer Society Cancer Action Network, and I'm testifying in partial support of proposed House Bill 5364, an act concerning the Tobacco Settlement Trust Fund. I thank you for the opportunity. In fiscal year 2022, states will collect $27 billion from the 1998 tobacco settlement. But nationwide, only an average of 2.7% of those funds will be spent on tobacco cessation and prevention programs. Although the CDC recommends that Connecticut spend $32 million on tobacco cessation and prevention programs each year, Connecticut has spent $0 on those programs since 2016. Connecticut is tied for second in the United States for cigarette taxation, but its lack of spending on tobacco control puts Connecticut in the unfortunate ranking position of dead last in the country. And this should be a tremendous embarrassment to our state. But more than an embarrassment, this egregious lack of funding is having a significant impact on Connecticut residents, and most importantly, is detrimentally impacting Connecticut's children. Childhood smoking is up. 20% of high school students now use e-cigarettes, and over $2 billion is spent on healthcare costs in Connecticut that are directly attributable to smoking. All of this is happening without Connecticut using $1 of its tobacco settlement funds for tobacco control. And while the tobacco industry spends $55.5 million annually in our state on advertising, we need to do better. Connecticut's children need your protection right now, and this can't get put off for another year. I support this bill, but the proposed $4 million in funding that it would restore to the Tobacco Control Health Fund is not enough. That would be only 12.5% of the $32 million the CDC has recommended that Connecticut spend on tobacco control. I would ask that the amount in the bill be increased to $12 million. My family was directly and detrimentally impacted by my father's inability to quit smoking. My father, who enlisted in the U.S. Army Air Force in 1942 at the age of 17 to defend our country in World War II, quickly became addicted to cigarettes because the tobacco industry targeted the military to create a generation of cigarette smokers. Although he desperately tried, my father was never able to break his addiction to nicotine, and he eventually died of lung cancer after years of suffering. He often told me that his addiction at such a young age led to his inability to quit smoking. I'm here today testifying because my father cannot be. Please take the important step this year to support proposed House Bill 5364 so that the 1998 tobacco settlement funds are put towards their intended purpose of tobacco education and cessation programs. But please increase the allotted amount from $4 million to $12 million. Thank you for this opportunity, and I'm happy to answer any questions.
Thank you for your testimony. Let me address the $12 million first, because we were all scratching our heads about this bill when we saw it as well. Believe it or not, even though it's hard to sort of figure it out, there is 12 million in there. This language actually mirrors the language that was brought forward to the Finance Committee. We've been assured and reassured that it's intended to provide $12 million of annual funding. And you can bet we're not going to get out of this until we assure that that's absolutely the case. So it was strangely divided up in different buckets in the bill, but we continue to believe that there's $12 million worth of funding in there. Now,
can you give me a little more detail about that? About how we could, no.
I'm taking it on the word of those who are more involved than I am, but your continued concern makes me remain concerned that we better trust but verify.
Okay, I appreciate it.
Our
Thank
intention
you,
to have $12 million, and that's where we're going to go. So thanks for pointing it out again, but we've been down this road with those who have drafted it, and we're following the Finance Committee's lead because we want to make sure that the conformance between the two committees will lead to the outcome that we desire. So thank you for that. And let me apologize again for calling you Nancy, but I have high regard for your mother-in-law, so I don't think you should be in any way insulted by that.
I am not at all, and I thank you. I'll let her know.
I don't see any further questions. So thank you for your testimony. Stay vigilant. Make sure we follow up on what I just promised. But we really appreciate your dedication to seeing that the funds are used appropriately.
We'll hold you to task. Thank you so much.
Thank you very much. Let's see. Next up, we have Laura Stanczyk, followed by Karan Cahoon, if I did that even slightly well.
Hi, my name is Cynthia Stremba. I'm reading on behalf of Lori Stanczyk, who very much wanted to be here but couldn't attend due to work commitments. Here is Lori's testimony. Good afternoon, everyone. I'm a volunteer with Parents Against Vaping E-Cigarettes, or PAVE. I'm also a prevention specialist and a resident of Avon, and I want to thank the committee for hearing this bill. I fully support SB 367 to end the sale of all flavored e-cigarettes. E-cigarettes and all flavored tobacco products are specifically targeted to children. Tobacco use has been on a decline for decades. Then flavored e-cigarettes with enormous amounts of nicotine came on the market and reversed that trend. According to the 2009 Connecticut School Health Survey, current use of electronic vapor products rose to 27% among our high school students. Current use reported by youth increased by grade. Our family has experienced this harmful trend firsthand. Our son is presently struggling to quit vaping after years of flavored vape use since high school. He suffers with many medical issues due to this addiction, including tremors, breathing problems, and high blood pressure. Quite simply, I blame the flavors. The sweet, kid-friendly ones like chocolate chip cookie dough and strawberry shortcake that the tobacco industry used to lure my son and millions of kids like him into vaping. Here, I'd like to point out that 90% of tobacco users started before the age of 18, 99% before the age of 26. There's no denying that the tobacco industry targets our kids for lifetime addiction. E-cigarettes are extremely attractive to younger and younger kids and account for high levels of addiction. As has been previously stated, in Connecticut, 79.1% of kids who vape choose flavors, including menthol. Mental health issues that are prevalent these days among middle and high school kids because of bullying, not feeling comfortable in their own skin, learning issues, just not fitting in. And frankly, who doesn't feel that way in adolescence? Mental health issues make kids susceptible to substance use. Flavored vapes are sweet and candy-like and are just so easy for kids to use. They're comfortable for what the future Dr. Liu called the nicotine naive. As a prevention specialist, I also want to bring attention to the need for adequate funding for education, prevention, and surveillance. And I urge you to support funding beyond the funding in Bill HB 5364. Connecticut is surrounded by states that have already enacted an end to flavored e-cigarettes, and it just simply doesn't make sense for Connecticut to be an island where kids go to get products. Let's work together to put an end to flavored vapes and ultimately e-cigarettes in general. Thank you for your attention to this issue in Connecticut and on behalf of our children. Thank you.
Thank you for your testimony. Let me just ask the question that others have been asking. Are you concerned at all about the impact on those who are trying to use these products for smoking cessation? Because some people feel that flavors are essential for them to complete that process.
Right. Well, I think that we have, we're in an area where there's not extensive amounts of research due to the limited amount of time that these products have been on the market. And more recent studies have shown that e-cigarettes as a cessation device is simply not effective. And some of these studies, of course, I think there were some studies cited, but they haven't been extensive studies. I've heard of, 5-day studies, 30-day studies. This simply doesn't work for substance use, which we know takes a number of times to actually quit. And, also, we've seen enough negative effects from e-cigarettes. We have decades worth of research on tobacco products, but combustibles. But more recently, we have seen that. I'm sorry, I totally lost my train of thought. Can you just push me back over that edge again?
I'm not sure I'm prepared to push you over any edge, but the question was, some argue that
Yeah.
vaping flavors are the only means by which certain people can achieve smoking cessation.
Right. So I was talking about studies and length of time for these studies and the need for people to, and that, we have to be open to the fact that people have to, will fall back and have to start up again on cessation. But I don't think that these, with the information out there, it really does not point that cessation is helping people get off. Oh, here's the point I was going to make. There's all of these, I think that this whole kind of that e-cigarettes are not harmful thing kind of stemmed from the fact that there wasn't tar in combustible cigarettes, but there are many, many, many ingredients, and when heated at high heat, that morph into other ingredients in e-cigarettes. And, we have seen over and over again that, this simply is not this is not a harmless product. So they're switching from one product that is harmful to another product that's harmful. And, so if they switch off, even if they switched off combustibles to e-cigarettes, they're still addicted to another product that is harmful.
Thank you for that. I see Senator Anwar has a question.
It was just a quick little comment, a couple of things. We just saw another representative earlier who spoke on behalf of the industry, who is using the term harm reduction treatment. And that has caused a perception in the young boys and girls that this is a safe product. And then when the study was done, that was in MMWR in 2021, it showed that amongst the youth, there was a perception that this is a safer product that is being used. And I think that's a brilliance of this industry, how they're able to get to us. But I just wanted to mention that please let your friend on whose behalf you spoke to let her know that we hear her loud and clear, and hundreds of parents across our state, very loud and clear. And thank you for your testimony.
I will do that. Thank you. Can I add one thing in here? In terms of the perception of lack of harm, and these kids have gotten into this product because they were actually told that it was harmless. And, you know, I represent Parents Against Vaping E-Cigarettes, and I have to say that the reason that this organization got started is because what turned out after much, you know, delving and digging, what was a dual representative came into the schools of the parents, the moms who developed this organization, and basically, you know, under the guise of an anti-addiction talk, and told the kids that this was harmless, that it was about, and this is in 2018, harmless, about to get FDA approval, and, you know, actually took out a Juul device and showed them how to use it. So, you know, this perception of lack of harmlessness has been cultivated for a good long time.
I'll just thank you, Mr. Chair. 1 out of 5 kids, well, the almost 16-17% range, believe it is harmless, and that has been the efforts by the industry, and that's why they're giving it to their friends as a gift and spreading out. But thank you so much for your testimony. Thank you, Mr. Chair.
Thank you, Senator. Thank you again for your testimony. Next up, we have Karan Cahoon, followed by Lieutenant Sarko Gregarian.
Good afternoon. My name is Karan Cahoon. I am a psychiatric mental health nurse practitioner specializing in the care of individuals with substance use disorders. I've been delivering healthcare for over 25 years and currently reside in Milford, Connecticut. Distinguished members of the Public Health Committee, I want to thank you and I salute you for supporting the legalization of fentanyl test strips. I am testifying in support of HB 5430, an act concerning opioids, but would like you to consider adding into HB 5430 a new provision, which would mandate the inclusion of methadone for the treatment of opioid use disorders in the Prescription Drug Monitoring Program, the PDMP. I want to highlight that methadone is included in the PDMP only when it's used for pain management and not for the treatment of opioid use disorders. To demonstrate why this is such an important patient safety issue, I'd like to share a couple of patient stories, personal stories. I had an elderly gentleman, grandfather and recent widower who had been enrolled in a methadone treatment program, and he was receiving prescribed benzodiazepines from a provider unaware of his methadone use. This combination of medications resulted in a non-lethal overdose and emergent hospitalization. My second story is of a successful businessman who contacted me by phone in dire need of medications to manage his opioid use disorder. The gentleman was familiar with the buprenorphine, which is used to manage opioid use disorders, because he had been on it in the past. So home induction was considered a safe alternative to his IV fentanyl use. I prescribed the buprenorphine to be started at home when he was in moderate to severe withdrawal. Unfortunately, I was not aware he was also prescribed methadone for his opioid use disorder. And unfortunately, he experienced precipitated acute opioid withdrawal. And sadly, he resorted to IV fentanyl to manage his symptoms. Now, this is my concern. It's been very evident with everybody that has presented today that these individuals with the opioid use disorder are at extremely high risk for overdose. And they're reaching out to us for help. And so when we're trying to help them, we don't have access to the material we need because we cannot get into the PDMR and look if they've been prescribed methadone in an opioid treatment program. So that's very concerning to me. So as a prescriber, before I prescribe anything, I look at the PDMR. But you know what? What's concerning is I don't have access to everything I need to be a safe provider. So I do acknowledge that passing this bill may create additional administrative work for methadone providers and state agencies alike. However, these critical patient safety concerns must take precedence over administrative concerns. I support HB 530 with the provision that methadone for the treatment of opioid use disorders is included in the PDMR for the prevention of needless harm. Thank you for the opportunity. I would welcome any questions about this topic.
Thank you for your testimony. We really appreciate your insight into the issue and suggestions for making it better. I don't see any questions, so thank you for your testimony today. We really appreciate it, and we'll definitely take it into consideration.
Thank you.
Next up, we have Lieutenant Sarko Gregarian, followed by, I will get to that shortly. Welcome, Lieutenant.
Hello.
Hi.
Hello, Madam Chair, Mr. Chairman, and members of the committee. Thank you for the opportunity to provide testimony on HB 5396 and Act Increasing Access to Mental Health Medication. I am Sarko Gregarian, and I am on from Winthrop, Massachusetts. I'm speaking in support of HB 5396. I'm a police lieutenant by day and a psychotherapist by night. I've been working as a peace officer for over 12 years. I have degrees from accredited universities in religion, philosophy, and psychology, and I'll be starting doctorate level work in depth psychology this April. I take stress exposure, trauma load, and human suffering very seriously. And I'm here to tell you that the currently accepted methods used to treat mental health conditions are both vastly insufficient and tragically unjust in comparison to the modalities and medications that have been fast-tracked by the FDA over the past few years, namely MDMA and psilocybin-assisted psychotherapy. Society expects the unimaginable from our first responders and service members who on a daily basis meet or exceed these expectations. I find it to be tragic that when our people are called into harm's way for the sake of our country and develop mental health challenges as a result, they're given Band-Aid medications that only serve to mask their symptoms at best or cause more harm at worst. Meanwhile, psychedelic-assisted therapy medications have been shown to push disorders such as PTSD into sustained remission and offer reprieve from depression for extended periods of time. Our men and women in uniform deserve the best that modern medicine has to offer. They deserve access to cutting-edge psychotherapeutic modalities of care that will save lives. They deserve access to psychedelic-assisted therapy. We currently lose more police officers to suicide than we do by attacker on the street. In 2019, 228 police officers died by suicide. A police officer experiences 188 critical incidents in the course of their careers. A critical incident is a situation that most Americans may never experience, and if they do, they may have one or two in their entire lives, never mind 188. Can you imagine what 188 critical incidents over the course of a career does to the biopsychosocial systems of our brave men and women in uniform? Here's one of the things that it does. The average life expectancy of a police officer is 57 years old, 21 years less than that of the general public, average of 78 years. They sacrifice their lives for us. I know the power of MDMA-assisted psychotherapy firsthand. I was blessed to have access to federally sanctioned research protocol that afforded me legal access to everything the research is showing. As a descendant of survivors of the Armenian genocide, which was perpetrated by the Ottoman Turks, and the repository of historic multi-generational trauma related to the atrocities and following displacement, I can tell you that the experience was a numinous gift. It was an apex healing experience I will never forget. You too can have a hand in ensuring that people most in need have access to the gift of healing, as I did by passing HB 5396. I believe this bill is a thoughtful and responsible step forward that positions the state to help people who need it most. On a final note, it is my sincere belief that all our working first responders and veterans should have access to whatever they need before their lives fall apart, without concern about stigma and fear. Thank you for your care and consideration of this very important matter. I will take any questions that you have, and if I can answer them, it will be my pleasure.
Thank you, Lieutenant, for your passionate testimony. We're all inclined to make every therapy available as long as we're assured that it's safe and appropriate. I see Senator Kushner has a question for you.
It's really a comment and a thank you. When I was hearing testimony earlier today, I had many thoughts about bills that we passed recently in the legislature to support our first responders who suffer from a post-traumatic stress injury. And I was thinking about that when I heard the other testimony. So I really appreciate you adding your voice to it. We have worked to try and make treatment available to first responders under our workers' comp system. I think we've been effective in doing that, moved the ball forward on that. But now adding a treatment that we've heard a lot of very positive responses to is really helpful. So I really, I specifically want to thank you because I think you're one of the priority groups of people that we try and address the needs of. And it was really helpful to hear from you today. Thank you.
Thank you for taking the time to say that to me, ma'am. I appreciate your work and care.
And thank you, Lieutenant, for all your good work, not only advocacy here, but in your other role. Seeing no further questions, we'll thank you today. Next up is Jonathan Chair, followed by Stanton Glantz.
Thank you, Chairman Steinberg, Senator Anwar, and members of the committee. I'm John Scher. I'm the Executive Director of the New England Convenience Store and Energy Marketers Association, testifying on SB 367 this afternoon. We appreciate the committee considering a bill that narrows the focus of youth nicotine use to ends products, but SB 367 is still too broad a policy. It bans menthol, a flavor the FDA intentionally exempted when it restricted pod-based flavors to just 2. It creates a nicotine cap of 35 milligrams per milliliter, and it excludes FDA's PMTA-approved products. When Massachusetts debated banning the sale of all flavored tobacco, a great deal of effort was made by the proponents to conflate all tobacco products under the banner of flavor. It didn't matter that vape and other traditional tobacco products like cigarettes had entirely different rates of youth usage. The only thing that mattered was flavors, and every flavor by their standard was the same. They were successful, and the state enacted a ban on June 1st, 2020. Today, the cross-border smuggling of untaxed flavored ends products, cigars, menthol cigarettes, is the primary challenge for tobacco enforcement, according to the state's Illegal Tobacco Task Force. I see similar conflation going on today with 367. And it's important we draw some bright lines or risk a policy recommendation that goes way too far. In 2020, the federal government banned all pod-based vape flavors except menthol and tobacco. It focused on pod systems because that is where youth were using it in the greatest numbers. Juul, for example, is a pod system. Today, the culprit is disposable vape products. They are cheap and come in countless flavors. These are devices you should be thinking of when you hear the term unicorn tears, or even cherry or grape for that matter. But SB 367 treats all vape systems and all flavors as though they are the same when they're clearly not. Notably, Congress last week acted, and the FDA will now have broader jurisdiction to enforce disposable and synthetic nicotine. In fact, they will now be required to file PMTA applications. Treating all vape devices the same ignores the statistics and different youth profiles. And treating menthol as the same as every other flavor ignores the FDA's guidance and common sense harm reduction concepts. The other issue is the bill excludes language that would allow PMTA-approved products back to the market. This is something I would think a public health committee would want included. The FDA's PMTA process is science-based and will only allow ends products to be legal if the product application demonstrates that it is appropriate for the protection of public health. Our recommendation is for the committee to follow the lead of the FDA for flavors and product availability. Any alternative state legislation will result in gaps in access, availability, and enforcement that will be outside the state's ability to address as it can today. Happy to answer any questions.
Thank you for your testimony. And yeah, I agree. We need to go after these disposable products, and I'm glad that Congress has granted FDA the discretion to look at them as well. Yeah, and as far as menthol goes, we've been scratching our heads about what's the best answer on that for a while. And I will just say, frankly, I'm disappointed that FDA has not taken the bull by the horns in this regard and given us all good guidance on what they intend to do. You know, putting our trust in FDA is something I think we'd all prefer to do, but their rather deliberate approach to addressing this entire area has, in my mind, been a little bit disappointing, and we're still waiting for answers. And I think this legislature is considering not waiting for FDA to figure out what they want to do and do what we think is right. I see Senator Anwar has a question or comment.
Hi, Jonathan. Good to see you. How are you doing?
You too, Senator. Good, thank you.
Jonathan, I wanted to ask you, some of the vaping products, they're the material, what's inside. Is that still coming from China as the biggest source?
I don't know what the source of it is. I do know that this, as somebody had stated earlier, it's easy to manufacture this stuff. In fact, if you think back to 2019, when E-Valley was going on, that whole problem that ended up being THC tainted vape, there was lots of information about people being able to create this stuff in their at home in their bathtub. I mean, the term bathtub gin was used. So whether it's China or even here domestically, Senator, I don't know, but it's very easy to manufacture this stuff.
And in the past, they were doing this study on the vapes that were claimed to be without nicotine. These squares keep changing, so I'm looking for you. Yes. So they looked at the vapes that were claimed to be without nicotine, and there was a pretty high nicotine content. How is quality control being managed in some of these at this point?
Do you mean nicotine, or do you mean tobacco-derived nicotine? So the difference between synthetics and tobacco-derived?
Nicotine, total nicotine content, because they addict children either way.
Yeah, so Senator, I want to stay in my lane. We represent convenience stores, so we sell legal products to adults. So you're asking me questions that I'm afraid are outside my my scope of knowledge.
Right. So the other question was that let's say Connecticut hopefully does what this bill does, and then move on to New Hampshire. Then we pretty much have covered this entire region, and this black market. Obviously, one of the arguments you're making, well, people will go to Florida and get it, but the chances of driving easily to one place to the other would be decreased once New Hampshire gets on board with Connecticut and rest of the neighboring towns, neighboring states, sorry.
I guess I have a question back for you. What indicates that New Hampshire would get on board?
No,
and I asked that question because in my experience with that legislature, there doesn't seem to be, in fact, when Massachusetts did its ban, and I'm sure you're well aware, but I can provide you with information on what happened in New Hampshire with the sales, not just for vape products, but also for all tobacco products. They expanded greatly. So I don't know if New Hampshire is going to do anything. And also evidenced by supporting that is the fact that their excise tax rate is dramatically lower than every other state in the region. So I worry that what you're hoping for is probably not going to manifest anytime soon.
Well, let's start with Connecticut. That's our primary goal right now. But I hear you. Thank you so much for your testimony, and thank you for representing the group that you represent. Thank you.
Thank you, Senator.
Thank you, Mr. Chair.
Chairman Steinberg, could I address something that you you spoke to?
So Representative Steinberg did have to step away, and so I'm stepping in as chair. So maybe you could follow up offline.
Yeah, sure. I just was going to speak to a little bit about what the FDA is doing, but I'm happy to do it offline or take 30 seconds now, whichever.
Sure, go for it, dude. Yeah, take 30 seconds.
Yeah, I guess I was going to say, I can, and I've heard this a lot, I can understand certain people's frustration with the process the FDA is going through, but I think it's also important to understand and recognize that what they're doing in general with menthol, with PMTA, these are very complicated processes with a number of unintended consequences that they want to try to avoid. So if you think back to all that has happened just since 2019 in the federal government, which is 3 years, let's call it 3 years ago, it's remarkable how much has happened in the span of just 3 years. And the reason 2019 is an important date is because that's when people were really waking up to vape. Parents were becoming aware. E-Valley was happening. And then since then, the PACT Act was expanded. PMTA was well underway. FedEx and UPS no longer deliver products, ends products. The age was raised to 21. So much has happened. So when the FDA with PMTA and menthol and disposable vapes is on the 1 yard line, I think now is the wrong time to become impatient with them. That's what I was going to say. So thank you for the time.
Thank you. You're welcome. Thank you so much for testifying today.
Happy. Thank you.
All right, next we're going to hear from number 89, Stanton Glantz.
Hello, thank you. My name is Stanton Glantz. I'm a retired professor of medicine at the University of California, San Francisco, where I served on the faculty for 45 years. In the last 20 years, created and ran their Center on Tobacco Research. I've done a lot of work on secondhand smoke, on e-cigarettes, on the economics of tobacco control and the tobacco industry itself. And while I'm retired, I'm still collaborating with my former colleagues. We have a paper coming out shortly that shows that the money California spent on its tobacco control program had a 231-to-1 return on investment in terms of reduced healthcare costs, which isn't relevant to the flavor ban, but is relevant to the other legislation people have been testifying about. And in fact, I published a paper a couple of years ago that showed that if Connecticut reduced its smoking rate by 1%, you'd save $34 million in Medicaid costs the next year. So you might want to actually put more money into your tobacco program. I've also studied the fights over an implementation of flavor bans, beginning with the one here in San Francisco, which was the first comprehensive flavor ban, and beginning in 2019, after a huge fight with the tobacco industry, the city has actually done quite a good job of implementing it and achieved very, very high compliance. The one other thing that we've worked on is looking at the effects of e-cigarettes on smoking cessation, and shown quite clearly, and in fact, a paper from another group just came out today showing that smokers who use e-cigarettes as consumer products have a harder time quitting smoking than smokers who don't use e-cigarettes. So the whole harm reduction argument just falls apart. But the main point I just wanted to make is the best evidence that this proposed legislation banning flavors or the sale of flavored products will work is the fact that the tobacco companies have probably spent over $100 million around the country opposing these bills. And if the claims that they would be ineffective or counterproductive and increase tobacco use were true, the tobacco companies would either be sitting on their hands or actually quietly working to get the legislation through. And so I think, there's a lot of technical arguments people are making and statistical arguments they're making. But I think if you look at the real politique of this and what the tobacco companies are doing, including, as Senator Anwar pointed out, funding organizations like the R Street, to act as third parties on their behalf. They wouldn't be doing any of that if these laws weren't effective. New research that came out last week from the CDC and the FDA showed that 79% of kids who use tobacco products use flavored products. And if the experience is when you ban flavors, especially menthol, which is probably the single most important flavor, it helps people quit smoking. And that's what we're really talking about here is if you pass this bill, it's gonna reduce youth uptake. It's gonna make it easier for established tobacco users to quit, and the tobacco companies are gonna lose money. And that's what the fight's really about here. And the state will end up saving a lot of money because when people think about smoking and healthcare costs, they usually think about cancer. And it's true that it takes a while for the cancer effects of smoking and e-cigarette use and other things to kick in. But when you talk about things like heart disease, asthma, complications of pregnancy, those benefits start to appear right away when you either start or stop using these products.
Excuse me, Professor Glantz.
Yes.
Your time is almost up. If you would
Well,
please
that's
stop.
good because I just finished.
Great, thank you.
So I'd be happy to take any questions.
Great, sorry about that. We do have a question. Senator Anwar, go right ahead.
Thank you, Madam Chair. Professor Lance, can you repeat the numbers of, if I heard you right, you said that spending $1 for reduction in cigarettes is equal to how many dollars in Medicaid saving?
That number I wasn't the number I quoted. I'd have to go look that up. But what we found or estimated is if you increased smoking prevalence, or pardon me, decreased smoking prevalence by 1 point absolute, like going from 15 to 14%, that would save $34 million in Medicaid costs the next year in Connecticut. And then the other number I quoted, we looked at the return on investment over the life of the California Tobacco Control Program, which was 30 years. And you got the program over that 30 years cost about $2 or $3 billion, and it saved $500 billion in medical costs. And I'm not talking about things like lives saved or work productivity. This is just dollars out the door paying doctors, hospitals, medicines, things like that. It was $500 billion. So it's a 231-to-1 return on investment. And again, that's because the medical benefits that you get when you reduce tobacco use start appearing almost immediately. I mean, if you stop using an e-cigarette or stop smoking today, your cardiovascular system is working better tomorrow.
Okay, this is published, or it's?
Oh yeah, I can send you the papers.
Okay.
Yeah.
All right. This is very helpful, and I think this is relevant. I know you spoke for 367, but there's another bill which is asking that the tobacco settlement fund be used for tobacco cessation. This becomes relevant for that because we have not used the money for tobacco cessation in this.
Right, that's right. I've been actually listening to the hearing, and the reason I stuck that in my testimony was it's highly relevant to that. But what people have found in places that have put flavor bans in that include, if they include menthol, is that leads people to quit smoking. Not everybody. Some of the people switch from flavored tobacco products to non-flavored tobacco products, but overall, the total product use drops. Menthol is a particularly important flavor because it interacts with nicotine and makes the tobacco products more addictive. And the FDA, by the way, has said that next month they're going to release a rule to ban menthol cigarettes. So the FDA is finally, after all these years, starting to deal with menthol. But the fact is that process will take at least a year, and then they'll get sued, which God knows how long it'll hold things up. And that's why I think the real way to deal with flavors is by what you're doing, which is to pass state and local legislation just saying, you can't sell these products. That's where the real progress in dealing with the flavor problem has been coming from, not from the FDA.
Thank you so much for your testimony. Thank you, Madam Chair.
Thank you.
Thank you. We do have another hand raised. Representative Pettit, go right ahead.
Thank you, Madam Chair. Thank you, Doctor. I don't know if I'm getting more clarity 7 hours into this or less, but what are your thoughts on the advantage to combustible smokers using the vape to get off cigarettes? Do you think that the cost, if that does help, the cost of the money that saved is dwarfed by the money that is saved by not exposing other people to the flavors in general?
Well, it is true that there are a few randomized clinical trials that show that if you use an e-cigarette as a medicine, as under medical supervision, usually combined with counseling as a smoking cessation intervention, as a clinical intervention, that does help people quit smoking. But that's not what we're talking about in this bill. We're talking about people going to a local convenience store or a gas station or a vape shop and just buying an e-cigarette. And there's about 75 or 80 studies looking at the population level effects of e-cigarettes. And we actually published a huge meta-analysis on this about 1.5 years ago, which is when you basically average everything that's out there. And what we found, if you're looking at the population level studies, which is the appropriate thing to look at for consumer products, is that they don't help people quit smoking. And so the whole argument that that if you make it harder for people to get flavored e-cigarettes, it's going to be bad because you're taking away this effective smoking cessation tool. It just doesn't hold up. And in fact, the more recent studies, since we did our work, in fact, one just came out today, show that people who use smokers who use e-cigarettes to try to quit, it actually makes it harder to quit. And these are newer studies with longer follow-ups than the ones we looked at. These are following people for like 3 or 4 years, a gigantic national data set that the FDA collects. So the argument that you need flavors to help adults quit smoking with e-cigarettes falls apart for 2 reasons. One is, as consumer products, e-cigarettes don't help people quit, and they may actually make it harder to quit. And the second thing is that the flavors are much, much less important to adults than they are to kids. There just aren't that many, out there. My favorite flavor is unicorn poop, which when I heard about it, I thought it was a joke, but go on the internet. Unicorn poop is a big thing for middle school students. And it's just the evidence that flavors are an important element in adult cessation. I mean, there are a few studies out there, but they're mostly done by the industry and they're not very good.
So thank you for that insight. And my second and last question would be, with a flavor ban, what's your perspective on pushing the kids to the internet and obtaining poorly regulated or unregulated products? Is there much precedent for that creating another type of harm, or because it's another step and more difficult to do, that it ends up not being a big impact upon society?
Well, there's not a lot of literature out there on that specific question, but as I think the fellow from the convenience stores pointed out, the PACT Act was amended about less than a year ago to include e-cigarettes. So it's much harder to get them on the internet than it used to be. And the fact is that the main place that kids get e-cigarettes is from their parents and their friends. But if you get rid of flavored e-cigarettes and all, my understanding is the bill is a comprehensive bill, and I think that, that's what you want. But they're just, if they're not available easily, then most kids aren't going to get them. I mean, there'll be a few. There is a little bit of leakage. I mean, that's what all the studies show. But there are some people who just switch to the unflavored products. That's the evidence is consistent on that too. But if you look at the total consumption, it drops. And that's really the important thing. It's not like, are there a few people who go get them on the internet or a few people who switch to another tobacco product? If you look at overall total tobacco product consumption, it's lower in places that have had these bans than in the places that don't. And exactly how much it drops varies from place to place, but there's always a drop.
Thank you for that insight. Thank you, Madam Chair.
You're so welcome. Thank you. And we have an additional question. Representative Foster, go right ahead.
Hi, Dr. Glenn. Thank you very much for being with us today. I am a little confused listening to this public hearing. So I just want to first preface what I'm about to say by I really, really want to see youth smoking less tobacco products. I want to see everyone smoking less. Yeah. I'd like to see less tobacco use, but I've been sort of checking on things that people are sharing as they're talking. And in the meta-analysis that you just referenced, the results that I'm reading say in these studies, all adult smokers and e-cigarette consumer products was not used daily e-cigarette use was associated with more daily e-cigarette use was associated with more quitting, and less daily use was associated with less quitting.
Yes.
So daily e-cigarette use was associated with more quitting.
Right. So what we did in the meta-analysis that we did, we actually sliced the data several different ways. The main analysis just said, if you compare all smokers who are using e-cigarettes with all smokers who are not using e-cigarettes, is there any difference in their quitting of cigarettes? And the answer to that is no, that there was no statistical association between e-cigarette use and quitting cigarettes, if you just looked at everybody. In the subsidiary analysis that you're talking about, we divided the people up between daily e-cigarette users and non-daily e-cigarette users. And in that, we found that the people who were the intensive users, the daily users, did actually quit smoking more than the people who weren't using e-cigarettes. But we also found that the people who were non-daily users were quitting significantly less. So among the daily users, there was some quitting benefit. Among the non-daily users, it was actually depressing quitting. So when you put it all together, there's no effect. And in fact, most e-cigarette users are non-daily users. So the fact is, though, that if e-cigarettes were a prescription drug, what this says is that if you're prescribing an e-cigarette as a regulated medicine, you should tell people to use it every day if you're using it as a quitting device. But when you talk about e-cigarettes as a consumer product, which is what we're talking about here, you don't have that kind of control. You can't say to somebody, well, use this e-cigarette, but if you use it to quit smoking, you've got to use it intensively. You don't have that control. If it was a prescription medication, you would. And that's why if you read the paper that you're quoting from, at the end it says, well, maybe the e-cigarette companies should submit in fact, this is what I think, should submit the e-cigarettes to the FDA, not the Center for Tobacco Products, which regulates e-cigarettes as a consumer product, but to the Center for Drug Research and Evaluation, which regulates drugs. And if the e-cigarette companies put e-cigarettes into the drug part of the FDA to get approval as a regulated smoking cessation medicine, if they can make the case for that, which they might be able to do, that's fine with me, but that's not what we're talking about here. What we're talking about here is just somebody being able to walk into a store and buy it as an unsupervised product.
And to be clear, I have zero interest in that being the case. What I feel like what I'm hearing in the amalgamation of evidence that's been presented from an assortment of authorities is that there needs to be some significant regulation of access to children, and that regulation of access to children should also include advertisement and messaging and promotion of products to young people. I want to make this absolutely clear. In no way, shape, or form do I think that any business should ever be promoting consumption of tobacco products to children. And I feel very squeamish about anything about the way that I'm talking about this being aligned with a pro-tobacco perspective, because in no way, shape, or form is that where I am aligned. But what I'm curious about is teasing out the actual nuance of what would be effective for a policy. And what I am wondering is if there's merit to using continuously the WireBS and BRFF data and trialing another type of reduced access program. We don't want, I think this bill dying again would be problematic for protecting youth. But perhaps there's another way to restrict access of tobacco products to youth that might be more meritorious than an all-out ban. And I'm curious what you think about that.
Well, I mean, that's the argument you hear from the industry's position.
I'm not talking about the industry. I'm talking about academics funded by scientific resources
Okay.
Let's take the industry out of this and pretend they don't exist. And I know that that's
Okay,
really
well, there's one study out there that by Abigail Friedman, who's testifying later, I saw, using the YRBS, which for those of you who aren't into alphabets, that's the youth risk factor survey the CDC does, in which she concluded that the San Francisco flavor ban was associated with more smoking, and that's a bad thing. And I don't want to steal the thunder of one of the witnesses who's following me, but there's a huge problem with that study.
Well,
and if you look, but the thing is though, I think, if you ask, should we be pursuing other policies like Tobacco 21, like increased taxation, like including e-cigarettes and clean indoor air laws? I think we should be doing all that stuff too. But the fact is that these flavor bans, if they're implemented properly, work. You get high compliance with them. There's a big drop in sales of these products, and it's beneficial. And you don't. I mean, while just 1 second, the discussion has been focused on kids, but e-cigarettes screw up your cardiovascular system when you're an adult, and these tobacco products are dangerous. And you don't want to be saying, well, if some adult goes off and has a heart attack that's brought on by e-cigarette use or develops erectile dysfunction or something, we don't care about that.
So respectfully, sir, in no way, shape, or form am I saying that. But what I find sort of problematic in this narrative, and I'm saying this as a female PhD research scientist, is this urge to call out the single paper when there are other, that data has been triangulated in a different methodological study, also published in peer-reviewed journal, findings that sort of triangulate that work, which is the goal of science, right? If you get a finding one way, and then you repeat the study in a different way to see if you get confirmation. And so in the peer-reviewed paper by Ward et al., the findings were similar. And so I'll just say, first, I feel largely uncomfortable with people continuously calling out one research scientist whose work is credible and published. But secondly,
I agree with you. I totally agree with you. And that's why in the meta-analysis, we looked at I don't remember the numbers, 75 or 80 papers. And it's true because there's statistical randomness in all of these studies. But if you look at there are now probably a half a dozen or dozen studies looking at the effectiveness of properly implemented bans on flavored tobacco products. And some of them use survey data like the one we've been talking about. There are other ones that look at things like supermarket barcode scanner data and looking what the actual sales are. And if you look at all of the studies, which I totally agree with you, that's the way you're supposed to do this, is don't just look at one study, look at them all. What you see is that these laws work and that they substantially reduce the sales of flavored tobacco products. The specific numbers you get vary from study to study, as you'd expect, but they do, properly implemented, you get big drops in the sale of flavored tobacco products. And there is, as I said, there is some increases in non-flavored tobacco products. There's some leakage, but overall it's a net decrease. That's what, if you look at the whole literature, at least that I'm familiar with, that's what it shows.
So, this is, and I think any research scientist would tell you what is my wheelhouse is my wheelhouse and what is not my wheelhouse is not. But when I am looking at what I've seen published more recently, and if I weigh in the caliber of journals and the type of analysis used and the type of conclusions that can be drawn from the type of the analysis, and even your own paper, that seems like a reach. And so I want to just be absolutely clear. I think we should restrict youth tobacco access in any way that we can that is effective and that might not also have negative consequences. And so I think I think that this needs a little bit of fine tuning, but I appreciate your time and answering my questions. And the paper you've been referencing is just out today. I would love it if you'd send that because I'm not familiar with what that is.
Okay, I'll send it. I don't have your email, but I can send it to Senator Anwar and he can forward it on to you. But this question about whether e-cigarettes help people quit smoking, e-cigarettes is consumer products. It's really important to make a distinction between the population studies of e-cigarettes as consumer products and the randomized trials, which are looking at them as supervised medicines. That data is remarkably consistent in showing no benefit or a negative effect.
And I think that there's probably nuance if you differentiate between people who are using the product for cessation goal versus sort of like.
Well, that's what the paper that just came out today looked at. They limited themselves to people who were trying to quit, and that's where they found that actually a bigger negative effect than we found in our meta-analysis. It's a good paper. I'll send it along. I'm happy to talk about it more if you're. And the guy who wrote it, who's a professor in Florida, is also very approachable. I'm sure he'd be happy to talk to you about it too.
I appreciate it. Thank you very much.
Thank you.
Great, thank you, Representative, and thank you so much, Mr. Glantz. I don't see any other hands raised, so we're going to move on to number 90, Ben Howell.
Thank you, Representative Gilchrist. Thank you, Senator Adams, Representative Steinberg, and the members of the Public Health Committee for the opportunity to give testimony today. I'm testifying in support of HB 5430, specifically the Section 9 regarding sharing, linking, and reporting of data between state agencies. My name is Dr. Benjamin Howell. I live in New Haven. I'm a board-certified addiction medicine physician and faculty in the School of Medicine and the Yale program in addiction medicine. My research is focused on the use of data to address the ongoing opioid overdose crisis. This testimony represents my views and not those of my employers. Our state has already taken many important steps to address the overdose crisis, but the continuing rise in deaths speaks to the need to do more. Our state's policymakers, agencies, and healthcare providers need to use the data they are currently collecting more effectively, so data is shared, linked, and evaluated in a timely manner to establish meaningful, targetable metrics to lower overdose deaths. Without data on underlying drivers of the crisis, the best way to address it is unclear. The provisions of HB 5430 on data sharing are necessary for a data-driven public health response to the opioid overdose crisis. People with opioid use disorder interact with different agencies and healthcare providers that can affect their risk of overdose, access to treatment, opioid and benzodiazepine prescriptions, prior non-fatal overdoses, and incarceration all affect the risk of subsequent overdose. Currently, the state collects important data in these areas that is largely siloed. Without understanding how individuals are moving across these settings, we have only a partial picture of what is occurring in our state. Importantly, we are missing the crucial context of rising overdoses that can be targeted to lower risk. Just to give one example, a non-fatal overdose is a strong risk factor for subsequent fatal overdose. Treatment with medications like methadone can cut that risk in half. Currently, we don't report publicly what percentage of people in our state who survive an overdose are accessing treatment, which requires individual data linked from DPH, DMIS, and DCP. There's only one example of many in how multiple sources can influence the overdose risk and be targets for efficient, effective, data-driven policy response. I want to acknowledge the efforts of DPH, DMIS, and other agencies, as mentioned earlier today, in generating important data for addressing overdoses and doing work in line with what is proposed in HB 5430. My concern is that given the rising overdoses, these efforts are insufficient. It is time for our state to take bolder action and enhance our efforts to generate timely, meaningful contextual data to drive our public health response. Second, I also acknowledge the work of the Connecticut Alcohol and Drug Policy Council to develop a statewide integrated substance use plan and a triennial report. Since the publication of the most recent report in 2019, over 2,000 Connecticut residents have died from overdoses. In the face of a fast-changing illicit drug market, I would respectfully suggest that this data is already out of date. I see this bill supplementing that council's efforts and providing them with more rapid, measurable targets for addressing the overdose crisis. During COVID, we have become accustomed to daily reports and data-driven targets on testing, hospitalizations, and deaths. I believe that we need to take this urgency and data-driven policy focus to the opioid overdose crisis. We can build on the expertise and experience of our state and others in this area and other states to be a leader in data-driven public health policymaking. Linking data to address the opioid overdose crisis is feasible and can be done in a way that preserves patient confidentiality. Several states, including Massachusetts and Maryland, amongst others, have established similar linked data sets and have found it crucial in planning their response. The committee members will find testimony submitted by Dr. Saloner from Johns Hopkins and Dr. Morgan from Boston University on those states' experiences. And I'm happy to connect interested legislators with researchers and public health professionals in other states if there are further questions. Also, currently I'm part of a team partnering with DEMAS to link data across state agencies similar to what HB 5430 proposes. Our work demonstrates that data linkage in Connecticut is feasible, though a challenge. The experience of other states demonstrates that this is more is possible and it is necessary for addressing the ongoing overdose crisis. Enacting the changes to data sharing and linkage described in HB 5430 are necessary to create actionable data that can inform sound policy and practice to address the overdose crisis in our state. Thank you for your time and attention, and I'm happy to answer any questions you may have.
Great, thank you so much, Mr. Howell. I do see a hand raised. Representative Parker, go right ahead.
Thank you, Madam Chair. Thank you to my colleagues for letting me ask all these questions today. I promise I won't go on for too long, but Dr. Howell has been particularly important in helping come up with some of the ideas that went into this legislation. So I really want to draw a little bit of this out. Dr. Howell, in your testimony, and as you just referenced, you mentioned one specific metric here. For instance, we don't know what percentage of people in our state who survive an overdose are accessing treatment. Can you help us understand what would be different if we did know that metric? What would you do differently? What would your colleagues do? Help us get a sense of why this matters.
Sure. Well, I think, first of all, you got to measure what matters. Like, you have to know this number first before we can take any actions to address it. And I think in Massachusetts, a state I referenced that did a similar effort to what is being proposed in this bill, they found after linking these data sets that only 3% or around there people who survived an overdose were accessing treatments like methadone or buprenorphine, which I think is unfortunately low. So you got to start with where you are. And I think if you have that number, it can say, oh, policymakers or public health professionals can then say, well, what interventions can we do to bring that number up? And I think you can say, well, our target should be 15%. I mean, I'm making that number up, but you just have to choose some target for it and then implement policies and then regularly check in on that number to see if it's moving forward. So honestly, I think it's mostly for public health professionals and policymakers to have the opportunity to just know where we are and to shoot for an improved number and see how that affects subsequent overdoses.
That's helpful. And what feels particularly resonant is also having metrics to work towards, so we know what success looks like, and if we're reaching that in certain cases. So I appreciate you sharing that. I appreciate also that you referenced the ADPC. It's a body that we hear a lot about even today in terms of where this work is already happening, and so thinking about not being duplicative but rather building on. Can you talk about what your experience is as a provider with the ADPC? Do you attend those meetings? Does that sort of work in the context of you and your colleagues and the groups you're a part of? And maybe if not, what would better connection there look like? Or maybe you're super involved. I don't know. Can you speak a little bit to that?
So in full disclosure, I have not attended ADPC meetings. I know they exist, and I know other faculty in the program in addiction medicine do attend. I also know people from DEMAS and DPH and other agencies that do regularly attend those meetings, and it's great that our state has made that investment as a place where multidisciplinary sort of groups can work together across what can be sometimes siloed entities. That said, I think that group, I mean, they're doing great work, but I think they just need to move faster. And I think they need more support and more data, kind of like what I'm describing, that the triennial report, which is fantastic, is only every 3 years. And I think we just need to be moving faster, and that sort of more rapidly updated data, like I'm suggesting, would help support the council's effort and sort of feedback to the agencies that are participating in that group.
That makes sense. Thanks for sharing. My last question for now, and just in some of these conversations about where the infrastructure is potentially, or where, again, without being duplicative, we can build to support this. I've heard people mention, I think actually you were the first one that asked me about an initiative called P20Win inside of OPM. Can you speak a little bit about your understanding of that initiative and if there's a connection here?
Sure. I mean, I think that's a great example of how our state already has some expertise in this. So for I actually don't know a ton about P20Win, but my understanding is an effort by OPM to similarly link longitudinal individual data across agencies to affect labor statistics. And then they have a very standardized process, so people, other agencies and or outside researchers can then access that data. And I believe it's a way to just sort of say, we know that this data is important when we're planning for our workforce and workforce efforts. we need to just have it all together in one place and have a efficient process for people to access it and utilize it as needed.
Yeah, that checks out with my understanding, of initiative inside OPM that was beginning to be built on in the education and I think workforce space, but starting to branch out and get other agencies involved, and potentially offers a roadmap for how to create MOUs and policy among agencies and not build a duplicative infrastructure in other places for how we share this. So just, I wanted to highlight too that that's something to maybe look towards if we're trying to bring more agencies into that in the way that it could support the work we're trying to do here with opioid use disorder. That's all my questions for now, Madam Chair. Thank you so much.
Thank you, Representative Parker. Sorry for referring to you incorrectly, Dr. Howell. We do have another question. Representative McCarty, go right ahead.
Yes, thank you very much, Madam Chair, and welcome, Dr. Howell. So I understand that you did a lot of work on Section 9, and I had asked earlier, and I think Representative Parker was touching upon that, but do you think there would be use in this? Because I know while the overdose deaths may be smaller on some of the campuses, but there are pharmacies and access to and we talked about the pressed pills today and how they're laced with fentanyl. Do you think that having the Office of Higher Education data also reporting to DPH would be useful in this section? We're all concerned about the health of all of our youth throughout the state. And I just thought that they must have some data that could be useful for us in trying to look at who goes on for extra treatment, what the programs are at the universities, the education. So just thought I would pose that question to you. Do you think if that would fit into that section?
Sure, Representative McCarty, appreciate the question. I think the bigger question for me is how do we, so as an epidemiologist, we think about exposures and then outcomes, and the outcomes we're here are worried about is overdose, both non-fatal and fatal overdoses, and then just thinking broadly about the exposures that can feed into that. And that's really where you have to think about sort of exposures that are captured in different agencies. So absolutely, if there's data captured by our state educational institutions that could speak to those exposures that are affecting people's risk of overdose, absolutely, I think that data should be considered to be brought in, along with obviously DPH, DCP, DMIS, OCME, and things like that.
Thank you very much for that insight, Doctor, and thank you for your great work.
Thank you, Representative McCarty. Representative Parker, do you have another question? Is your hand just?
I wanted to ask one more question, but
sure, you've got it.
I can hold. Thank you. Just especially building on what Rep. McCarty just said and Dr. Howell, to all your points, I want to acknowledge that we've received testimony today from the commissioners of DPH, DMIS, and DCP, all sharing concerns with this part of the bill. And so respectfully knowing that these are the folks that would potentially have to run and work on whatever it is we come up with, I really hope that we'll be able to have a conversation. And I know that I've been able to be in those already with representatives and liaisons from those agencies. So we really look forward to continuing that because we want to get something right that works and actually helps move us forward. And so we'll have to figure out what the timeline is for that and get into this in the details. But Ben, I hope that you'll still be involved with this as we move forward and figuring out what the solution actually looks like, because the last thing we want to do is make their work harder. We want to help set up better policies. And folks like you and your colleagues that have been a part of these conversations all along really help us understand what that looks like in your experience sort of on the front lines. So thank you for your future involvement too.
Yeah. No, just to say I'm happy to always be part of these conversations. This is something that's very, I think very important and I'm passionate about. I'm sure myself and other faculty here in the program of addiction medicine are happy to consult. We also are happy to connect sort of members of this committee to people in other institutions or in other states who have done this work. And I will just highlight, I was able to solicit testimony from Dr. Jake Morgan and Dr. Brendan Soloner from Maryland and Massachusetts, who are able to speak on those states' experience and their experience working with this data. And just to highlight, Dr. Morgan is actually talking to people across states, and they really highlight Massachusetts' effort, which used legislation to mandate this process to really move it forward more quickly, unlike what Connecticut has done in the past, and frankly, what we're proposing in this bill.
Thank you.
Sorry, I'm doing two things at once, which I shouldn't. Thank you, Representative Parker. Thank you, Dr. Howell. I don't see any additional questions. So we're going to move on to number 92, which is Win Everts.
Good afternoon, everybody. Senator Abrams, Representative Steinberg, Senator Summers, Senator Wang, Representative Pettit, and the rest of the esteemed members of the Public Health Committee. My name is Win Everts. I live in Norwalk with my wife and 31-year-old son who has an intellectual disability and an intractable seizure condition. I'm also the executive director of the ARC of Connecticut, and I'm testifying in support of HB 5275. When a healthcare provider recommends and prescribes a certain medication to a patient, there's a mutual trust between the provider and patient that the selection of that particular drug is based on the provider's professional assessment of the information and symptoms the provider has learned about during their process together. When an insurance company implements a fail first policy where patients are not allowed to get their recommended prescriptions until they've failed on a number of less expensive insurance recommended medications, the insurance company has violated the patient-provider relationship. Finding the right medication is a skill and an art, and there shouldn't be a debate on cost. Medications are not a one-size-fits-all type of thing, as our medication, my personal medication and experience in our family with our son has taught us. Our son takes 4 seizure medications each day, as well as some dietary supplements to partially control his seizures. When a substitution of a different drug occurs, which seems to be on almost a cycle, despite strict prescription notes to only prescribe these 4 medications, we either see things that we've not seen before and need to consult with his doctor, or more usually, we see more seizures, administer emergency meds, and consult with his doctor. Either way, this phenomenon does not lower the cost of our healthcare. In my opinion, the practice of fail first should be stopped. Thank you very much for your time.
Thank you, Mr. Everts. We do have a hand raised. Representative Carpino, go right ahead.
Thank you, ma'am. Wynn, I just wanted to say thank you for your testimony and for supporting this, but most importantly, putting a name and a face to this policy. I think it is important for folks to understand that this fail first policy impacts real people and real families, and it's not just the individual with the health concern, it is impacted by family members as well. So at number 92, I want to thank you for both your time and your patience, and for everything that you do in your profession.
Thank you for those kind words.
Thank you, Representative Carpino. Thank you, Mr. Everts. I don't see any additional hands raised. Thank you for your testimony and your time.
Thank you.
Next, we will have number 95, Tim Andrews.
Thank you very much to members of the committee. Tim Andrews from Americans for Tax Reform, speaking against the proposal to ban flavors for e-cigarettes. So thank you once again to all the members of the committee. I know this is a long day, and it's a credit to your passion about this issue that you are spending so much time looking into this. Now, I want to start by saying that policy needs to be based on evidence and on science, and not merely on conjecture. And unfortunately, a number of previous witnesses have stated things that simply aren't supported by science. And I wish to draw committee members' attention to the facts. So first of all, the study which found that that reduced risk tobacco harm reduction products like e-cigarettes are 95% safer wasn't a factoid. It's not baseless. This was a study commissioned by the UK government, who commissioned a meta-analysis of all available studies, 185 studies, and came up with this conclusion. You can't call the UK government a tobacco industry puppet. This same number, again, an independent study, a meta-analysis conducted by the Royal College of Physicians, the oldest medical group in history in the entire world, came to the conclusion 95% safer than combustible tobacco. The Cochrane review, considered the gold standard of meta-analysis, looked at all of the available studies on smoking cessation, population studies, not randomized controlled trials like a previous speaker tried to imply, but population studies. Every single study looked at found between 2%, between double and 6 times the level of efficacy of all other quit smoking aids. According to Georgetown University Medical Center, which commissioned a dozen of the US and some internationals, leading cancer experts, if a majority of smokers in the United States made the switch to vaping products, 6.6 million lives would be saved up to over the next decade. In the state of Connecticut, this would equate to 75,000 lives saved if a majority of smokers moved to vaping. In terms of flavors, once again, there has been unsubstantiated claims that, oh, vapors appeal to kids. In the same way that there are flavored alcohols that adults have, flavors are a key driver for adults. Once again, studies have repeatedly demonstrated this. I recall a previous speaker when asked, well, show us the studies that don't matter, said they exist, we'll tell you later, but they don't exist. All of the studies demonstrate that flavors are vital for adults quitting, and that if you remove flavors, adults will go back to smoking. About 43% of adults, it's estimated, will go back to smoking. Further evidence is that you need to put this into context of youth daily vaping is at about 3% according to the CDC. This isn't an epidemic. Like, it's definitely a problem, and we need to do more to address youth vaping. But trying to do what is proposed with a flavor ban is using a bulldozer to squash a walnut. This is something that will have
Andrews, your time is
significant
almost up. If you could summarize. Thank you.
As a father of a 17-month-old, I want him to grow up in a smoke-free world. As someone who has lost family members to smoking, I want smoking cessation to be a thing. This is personal to me. It is moral to me. This has the potential to save lives. And unfortunately, while well-intentioned, flavor bans will have the side effect of leading more people to smoking and more people dying as a result. And I urge you all to look at the evidence, look at the peer-reviewed studies, look at the science, and not simply baseless assertions. I'm happy to take any questions.
Thank you so much, Mr. Andrews. I don't see any hands raised. Thank you for your testimony and your time today.
Thank you.
Next, we're going to hear from number 96, Ben Shaken.
Good afternoon, Madam Chair, members of the committee. My name is Ben Shaken. I am the Director of Government Relations at the Connecticut Community Nonprofit Alliance. The Alliance is a statewide association representing community nonprofits in Connecticut who, as you know, serve over 500,000 people in the state every year. We have submitted testimony on a number of bills today in support of House Bill 5275, and with comments on two that I'd like to spend a moment on. One is on Senate Bill 331, which is a bill containing a number of changes, including similar language around step therapy that is in House Bill 5275. But I wanted to focus a little on the Section 4 of the bill, which would establish a task force to study the DDS level of need system. I just wanted to, again, sort of caution the committee to make sure that if this task force is created, that the committee does it with sort of full understanding that the LON system in Connecticut is not just an assessment of a level of need of people with intellectual and developmental disabilities, but that the scores assigned to people under that system directly impact funding for services that is paid to private community providers. And so as such, any changes to that system are going to have a very direct funding impact on nonprofits. Not saying that changes aren't warranted and that it shouldn't be looked at independently, but the committee and the legislature need to understand that funding and rates for those services are directly tied to what providers are paid. And I've included an example chart in my written testimony on that. Secondly, just to spend a moment on Senate Bill 374, this bill would raise the statutory cap that private providers are allowed to pay out of reimbursable funds their executives when they contract with DEMIS or DDS from $100,000 to $125,000 per year. We are very grateful for DEMIS and DDS requesting this bill's introduction. It's a tricky issue to talk about. It's not something we talk about often. But we would actually advise that the committee, rather than raising the cap, simply pass Section 3 of this bill, which would repeal the underlying statutory language that created this cap. There's no other industry that contracts with the state where the state prescribes an exact dollar amount, the salaries that are paid to the staff of their contractors, and capping salaries at this level very much prevents community nonprofits from attracting top tier talent. Since the last time the statute was adjusted in 2007, the nonprofit community provider system has grown exponentially more complicated with the passage of the Affordable Care Act, its Medicaid expansion, with the advent of electronic health records. DMIS and DDS providers are now managing extraordinarily complicated healthcare organizations, some of whom are very large and complex, encompassing the entire state. So we appreciate that this legislation would be helpful as it's been proposed, but we suggest that, given that this requirement doesn't exist in statute anywhere else, that we instead consider repealing it in its entirety. So thank you very much. I'm happy to answer questions about any of those issues or any of the ones I didn't have time to get to today that are encompassed in our written testimony.
Great. Thank you so much, Mr. Shaken. Good to see you. I don't see any hands raised. Thank you for your time today.
Thank you.
Next, we'll hear from number 98, Ruth Kenobi.
Hi, yeah, thank you. Distinguished members of the Public Health Committee, my name is Ruth Kenobi. I'm the Director of Advocacy for the American Lung Association in Connecticut. And I want to thank you for really prioritizing policy to address tobacco as the very serious issue that it is. You clearly understand that there is a case for strong action to combat the burden tobacco places in our communities. You have and will hear a lot of numbers on this. And so I just want to leave you with one here. And so the most recent National Youth Tobacco Survey data was released just this last Thursday and found that 65.3% of students in the US who currently use tobacco products were seriously thinking about quitting the use of all products, and 60.2% actually had made a quit attempt in that year. So this is significant and frankly quite sad. And so Connecticut needs to have a fund in place to help make sure that kids, that basically we need to make sure that we do more to prevent them from getting there in the first place, and that they have access to services to quit. A robust and sustainable state tobacco control program to fund evidence-based CDC best practices is imperative. The CDC recommends that Connecticut spend $32 million every year on its tobacco control program, yet the state has not spent that cumulatively in 2 decades. When we consider the fact that we have the second highest cigarette tax in the country and still get more than $120 million from the master settlement agreement, our funding status is especially egregious. Connecticut was the only state in the country that provided $0 to our state funding for its control program in 2021. The investment in tobacco prevention and cessation programs not only saves lives, but it does save money. A study conducted by the University of North Carolina concluded that when Connecticut did fund these programs, the state saved $2.48 for every dollar invested. And Professor Glantz pointed out the potential for return on investment that other states have realized with more sustainable and robust funding. We are encouraged that this bill includes $4 million dedicated to tobacco control, but I've heard it mentioned today that it does a lot for $12 million annually. So I'm unclear of that and would welcome the opportunity to talk about what this is. We certainly urge that we invest $12 million annually. Additionally, we must find a way to keep history from repeating itself. From 2003 to 2018, we saw the Tobacco and Health Trust Fund swept 80 times, and the transfer of the funds stopped or diminished anytime there were gaps needed filling in the budget. The language is all back budget narrative language that makes it easy to divert these funds. And so as a means for making this funding more transparent, I ask that you consider creating a line item or something that really just helps us follow this, because it happens kind of beyond our knowledge. And so that's really challenging. In terms of the flavor policy proposed in SB 367, while I know this is certainly well-intentioned policy, the Lung Association has taken the strong position throughout the country on all policies being considered that anything short of removing all flavored tobacco products leaves too many kids unprotected, and that we should not pick winners and losers of these public health protections based on the modality of their nicotine addiction, especially because those who will lose those balances are those that are most burdened by health inequities. And so I just went through that real fast, but I wanted to try to get my points in those 3 minutes. And so thank you so much for, I just want to recognize the leadership within this committee and looking at the burden that tobacco has on our communities and doing all that we can to address that. So thank you very much.
Well, thank you so much for your testimony and for the work you do. I don't see any hands raised. Thank you so much for your time today. Next is number 99, Rick Del Valle.
Yes, hi, can you hear me?
Yes, we can. Go right ahead.
Hi, my name is Rick Del Valle, and I'm in support of HB 5430. I'll be testifying today, and I would like to thank everyone here in this committee for allowing me to testify. My name is Rick Del Valle, and I'm a man in long-term recovery. I'm the founder and president of the New Beginning Recovery Houses and the Redemption House Foundation. My recovery journey started February 5th, 2008. I was fortunate enough to have the willingness to get clean. The consequences were a motivating factor in my life. I am forever grateful for MAT. I was on Suboxone for 18 months and it served its purpose. I remember going to the clinic once a month to get my Suboxone. What didn't happen was any type of recovery services being offered to me. There was no talk of an exit plan to come off. I was encouraged to stay on. I was self-motivated and found the services I needed on my own. I started attending 12-step meetings and got the peer-to-peer support that was very important in my recovery. Today, I work with individuals who are on MAT treatment. They live in my recovery houses. MAT does work if there's an exit strategy and recovery services are in place, and there is a recovery community, and even better if they move into a recovery home. The success stories that come from MAT are the ones who follow this plan. The people who it does not work for are the ones who don't have an exit strategy, recovery services, or peer-to-peer support. I know many individuals that have been on MAT for many years and their lives don't seem to be getting better. And they still use illegal drugs and some even die. Unfortunately, what we have in place.
They're just doing it zip code or.
I'm sorry, hold on one second. Mr. O'Flaherty, thank you for muting. All right, go ahead, Mr. Del Valle.
Yes. Unfortunately, what we have in place isn't working. Change needs to start today. I'm on the front lines. I am in long-term recovery. If we provide MAT services with recovery services and an exit strategy, we'll start to see better results. There needs to be accountability with both the provider and the individual getting the services. If nothing changes, nothing changes. I have some solutions that really can work. I testified last week and offered some solutions to the pandemic that is killing our loved ones, our husbands, our wives, our moms, our dads, our children. Not one person has contacted me about my solutions. Real change comes from knowledge when it is acted on. Again, I offer myself to this committee. Please contact me, spend a day with me, and I can show you what true change really looks like. I have real life experiences with addiction, both using and serving those that still suffer. If the state of Connecticut wants to partner up with my organization, the New Begin Recovery Houses, Brian Cody's Law Redemption House Foundation, and many others that we've heard from here today that are on the front lines making a difference, let's start today. Don't let this be a missed opportunity. Don't let this be a conversation that goes nowhere. I'm begging you to be that change. Thank you.
Thank you, Mr. Del Valle, for being here and for your testimony. I don't see any hands raised, so we're going to go to number 102, Kevin O'Flaherty.
Thank you, and I apologize for not being on mute earlier. Good afternoon. We're almost evening. First, I wanted to thank you, Rep. Gilchrist and Chair Steinberg and Anwar, other members of the committee for giving me time to speak today in strong support of both HB 5364 and SB 367. But I wanted to take my time today to focus on a couple of key points about the latter. First, protecting our kids' health should be the top priority. The evidence is clear that flavored e-cigarettes are what's driving the youth vaping epidemic and are responsible for the recent increases in overall tobacco use by youth. Secondly, in Connecticut, we say we value the safety of our children. Other folks today have talked about how we can't do anything that would negatively impact adults who might want to quit in order to protect kids. I would say they are flat out wrong, and I think the majority of the members of this committee would probably agree. To sacrifice generation after generation of kids to a tobacco addiction because we're afraid to either lose revenue from those sales or even to help a relative amount of handful of adults to quit, I think is reprehensible. Third, this is not a total ban on e-cigarettes. This law would allow the continued sale of tobacco-flavored e-cigarettes in Connecticut. If e-cigarettes are something that help people quit, they will still be available. In fact, the single best study out there promoting cessation among smokers comes from England. And in that study, they actually gave their participants tobacco-flavored products, not gummy bear, not unicorn poop. And one aside here, from all the testimony you've heard today about e-cigarettes helping people quit, you might be shocked to hear that the FDA actually forbids any e-cigarette manufacturer or retailer from making that claim. Please think about that as you're evaluating the arguments you're hearing from opponents today. How is it possible that that is a ubiquitous argument if the industry is following the rules and is actually concerned about public health? Fourth, FDA pre-market pathway exemptions will not protect kids. This is a loophole that's being used by the tobacco industry to keep these harmful products on the market and undermine enforcement of the ban on products that haven't actually received an authorization. More important to this conversation today, the applications required of companies when they apply for that type of authorization do not even require that they show potential impacts on youth initiation or addiction. The sad fact is that the FDA and Juul were probably the two entities that are probably most responsible for the youth e-cigarette epidemic that you're trying to deal with today, and they have not demonstrated any reason to warrant your trust on e-cigarettes. That's why all of our neighboring states have already done this and why you should as well. 5, loopholes for particular types of products will undermine the effectiveness of the law. Every time the FDA has banned a particular flavored product, the kids have migrated to what's left. There are countless examples of this through the years, including all the examples that Mr. Scher cited as examples of FDA successes. Lastly, e-cigarettes are not a valid harm reduction tool. Valid harm reduction strategies help get people from one damaging behavior to another less damaging behavior, but do not actually increase the public uptake of either the initial more damaging behavior or the less damaging harm reduction tool. E-cigarettes have been used by far higher percentages of kids than adults, and there's growing evidence that the use of e-cigarettes by kids actually leads them to combustible tobacco product use like regular cigarettes. This is harm creation, not reduction, and it's income retention for the tobacco industry. Please don't be fooled. Thank you for your time and the opportunity to testify today, and I'm happy to answer any questions you might have.
Thank you so much, Kevin, for your testimony. And I do have some questions, but I'm going to actually yield to Representative Cook. She asks better questions.
Well, thanks, Senator. I'm honored by the yield. Thank you very much. Hi, Kevin. I just had a really quick question. I'm sure that you've listened intently today to the testimony and support and opposition, and you've heard many people talk about the disaster that happened in Massachusetts under a similar policy that we're discussing here today. In your opinion, do you consider the Massachusetts situation a disaster? And what you feel in that regard that you might be able to bring to our attention? Thank you.
Yeah, no, sure, I appreciate that. Well, we do not consider it a disaster at all, or a failed experiment, or any of the other things some of the folks on the opposition or the retailers in the industry have been calling it. You know, first off, you know, the reports that have been put out there that are talking about these large revenue losses and that they're using to characterize this as a disaster were entirely regarding the decrease in tax collections on combustible cigarettes. The bill, that might have been an argument worth digging into more deeply last year, but the bill you have before you today only addresses flavored e-cigarettes. So the impacts on revenue for the state, as well as the impact on retailers, would be very different. Now, of course, that won't stop the industry from arguing it both ways. I'm actually sort of amused in a kind of sad way. Last year, I don't know, those of you on this committee might remember that many people in the industry were saying, you know, it's e-cigarettes the problem, just take care of those, leave menthol cigarettes alone. And now this year we have a bill that, you know, for better or worse, and we think that menthol cigarettes should be addressed as well, but this is a compromise to address those concerns and the fact that the support didn't exist in the legislature to do that. And now they're saying, no, you can't do that either. Anybody who's dealt with the tobacco industry for a while will know that's the case. But this is the reason why Massachusetts is different here. From our perspective and the perspective of public health groups in Massachusetts, as well as the legislature that voted on this because they were looking at the overall health of the Commonwealth, including addiction and health and the business interests in the Commonwealth, they see it as an unmitigated success. The only parties who saw this law as a failure are the tobacco industry and their retailers. And they opposed it all along, and they were not likely to give it a fair shake, regardless of what actually happened. The reason the legislature and the leadership supported the law and continued to do so is that the goal of the bill wasn't to reduce smoking among adults. The goal was to reduce smoking and vaping initiation among youth by getting those products that are designed to addict kids out of the stores where they see them and out of their hands. And there's zero evidence to suggest that the law has not been effective in that regard. You know, the reason the tobacco sellers want to say this is a failure is because they discount the benefits of reducing youth initiation and point only to the argument that adult sales of these products cross the border into neighboring states. Well, any argument about the black market or cross-border sales fall apart when you're looking at this bill, because Connecticut is already surrounded by states that have banned the sale of all flavored e-cigarettes. So it becomes much harder. A kid who wants to get flavored e-cigarettes or an adult who wants to get them for a child would have to go to Pennsylvania or Vermont or New Hampshire, and that's a much longer trip. Plus, recent changes to the PACT Act, a lot of people are talking about online sales, and recent changes to that law actually make online or delivery sales of those products illegal as well. So a lot of those concerns about black market and the quote unquote disaster in Massachusetts just don't add up as long as your priority is protecting kids from these products.
Thank you. And I think it's extremely important that parents recognize that when they say not my kid, it very well is, it's going to be your kid. And, you know, it's hit every home that I have friends in one manner or another. And so I really hope that people pay attention to what we're talking about and not looking at eliminating something from somebody, but really trying to help somebody. And I believe that the way that we look at things is really kind of backwards oftentimes. So thank you, Kevin, for your answer. It was very thorough. I appreciate it. And Senator, thank you very much again for the yield.
Thank you, Representative.
Kevin, I wanted to ask you, and you're probably not expecting this question, but you're being completely consumed trying to do this for quite some time. What is your inspiration?
Well, I mean, not to get too personal, but my mom died from tobacco use. She was lucky enough to live to be almost 91, but she smoked 2 packs a day for 50 years. She quit when she was 70, but she lost her vision in her early 70s, and that diminished the quality of her life dramatically. And 3 years before she died, they found a small mass in her lungs that was caused most likely by 50 years of tobacco use, and that cancer then spread to her bones, and she died of that. And you know, that's the thing that is so interesting about this debate, Senator, is that, you know, people talk about this as an ask any smoker. They all started as kids, or the vast majority started as children. And so, you know, you can say this is an adult issue and this is an adult product, but when, you know, 90 to 95% of the adults who smoke started when they were kids, you know, that's not really true or fair. So I want to do everything I can to reduce smoking. I don't want other people to lose their mothers or their fathers or their uncles or kids, especially.
Thank you for that. I'll tell you, as a lung doctor, I'm losing a patient either to end-stage COPD or to lung cancer, 2 or 3 a month. And these were all preventable. and nicotine is one of the most addictive chemical known, because I know many people who have been able to give up opioids, which we're talking about them, and cocaine and alcohol, but they cannot give up nicotine because of its addiction potential. The experience in some of the other states, what has happened in the other states? Because that's also a part of concern to at least some people.
Well, I mean, specifically, you know, and it's a little bit of a problem for us, Senator Anwar, I'll admit, because a lot of these policies just passed in the last 1 or 2 years. While we've seen sales go down of these products across the board, the surveys that would really show whether youth use has declined, you know, in those states as a result of these policies, we just don't have that data yet. Now, the studies that have looked at cities that have done this and have looked at other, you know, data sets that would you know, indicate whether this is a solid policy or not, have, you know, basically said that this is the right direction to go, and that these policies will reduce youth use and youth initiation of these policies. And that's you know, what we're basing this on. I think also when you just, you know, look at the tremendous, you know, the fact that 80% of all kids who ever start using a tobacco product start with a flavor and can easily get access to these products, that this is a product that really doesn't deserve to remain on the market. And that's another reason why we would approach that.
So the on-ramp argument is a far bigger argument than a theoretical small off-ramp argument for adults. Is that a fair way to summarize this?
Well, absolutely. And former FDA Commissioner Gottlieb, who actually owned stock in e-cigarette companies, he said that very same thing, Senator, that we cannot allow the on-ramp of addiction to be, you know, so large that it offsets any potential benefit from the off-ramp to addiction that adults are using on this. And I think that's, you know, critical when people make this harm reduction argument. Methadone doesn't encourage a bunch of people who never, you know, used cocaine or heroin to get on it. A needle exchange doesn't promote drug use or provide drugs or make it easy for people to use that. Solid harm reduction strategies don't actually expand the marketplace for the very product that they're trying to, you know, ostensibly get people off of. And that's what we're seeing with e-cigarettes. Not only, I saw one study that the estimate of how many kids were addicted to e-cigarettes as a ratio to adults who quit was so astronomically high as to be laughable. It was tens of thousands. And that's not a good trade-off. It's also not a good trade-off. You know, you might have a few thousand e-cigarette vape shops across the country, but, you know, we've got, you know, 3 million kids in this country who are addicted to e-cigarettes. That's a bad trade-off as well. So if you're looking at harm reduction in the real definition of the phrase, you know, e-cigarettes just don't meet that standard.
Thank you so much. Thank you for your work and your commitment to try and help out in helping our children in the next generation. Seeing no other questions or comments, I will move to the next person on our list, which is Brett Waters. Mr. Waters.
Madam Chair, Mr. Chairman, and members of the committee. My name is Brett Waters. I'm an attorney at Winston & Strawn in New York City, and testifying as the founder and executive director of Reason for Hope in support of HB 5396. This morning, you asked some questions to General Steele and General Zanakis, which they deferred to me, and I look forward to addressing them at the end of my testimony. On Wednesday, March 9th, was the 4-year anniversary to the day since I lost my mom to suicide. My grandfather, her father, a World War II fighter pilot, whose plane was shot down in the South Pacific at 16 years old, also died by suicide when I was young. I'd planned to spend that day, as I normally do, on the anniversary of her loss, reflecting, reading a series of suicide notes that she had left behind. But that morning, I'd learned that this hearing had been scheduled and this bill was being considered. So I instead frantically began preparing with my team, coordinating witnesses and testimony to ensure that there was no doubt in the committee's mind that this bill should swiftly pass. some of the powerful testimony you've already heard earlier today, with several others still to come. I didn't have time to do my normal reflecting process on the anniversary of her passing. I spent this morning reading the series of suicide notes that my mom wrote at various points in time before taking her own life, so that I could viscerally remind myself why it is that we spend all this time frantically preparing. I'm going to read one of the comments that she left behind so you can understand the pain that she was dealing with. I fight to live so that my kids do not have bad self-images of themselves. It is so hard. I hope my children realize that if I one day choose to die, it is only because the fight is too hard for me to live. Reason for Hope was founded in my mom's memory, Sherry Hope Waters, a group of volunteers primarily connected by the loss of loved ones to suicide or substance use. Our group is focused on developing policy and advocating for desperately needed reform to our system of mental health care, which has badly failed too many like my mom over the years. For the last year, we've devoted countless hours to drafting legislation, preparing policy proposals, educating legislators and government officials, not just in Connecticut, but Pennsylvania, New York, Congress, and the Biden administration, about the urgency to further research and develop the infrastructure needed to facilitate the real-world use in a safe, ethical manner in both clinical and non-clinical settings so we can make this powerful treatment widely available. This is a complex process. There's a lot to do, and we know that with the great power that these treatments offer also comes great responsibility. We do need to get the pieces in place to ensure that use of these treatments in a therapeutic setting are done safely and ethically.
Excuse me, Mr. Walters, your time is almost up. If you would summarize, please. Thank you.
I think my question is for you to continue your testimony and finish this, please.
Sure. I'll share just, you know, the final driving force behind what it is that's you know, brought me to this work, which was my own, you know, it was not, I did not start this work until I found the research, but I had my own experience with psilocybin in college, just recreationally, inadvertently treating an eating disorder that I'd long struggled with. Traditional medications did not even come close, you know, therapy, I tried everything, nothing even made a dent. And all of a sudden it was like for 6 months, it just disappeared. For whatever reason, I just never made the bigger connection between those life-changing effects and the broader potential for these substances to help people like my mom struggling with depression and suicidality until I had discovered all the groundbreaking research you've heard about today from places like Johns Hopkins, NYU, Yale. And that delay in realizing, making the bigger connection has really caused some intense periods of guilt and doubt and feelings of failure, that I was not able to act sooner. And now, we meet all of these new people who have these inspiring life-saving experiences from psychedelics that really demonstrate the urgency to bring about this change. And these people are now the driving force motivating our work, because we know that there are many others out there like them who are suffering, for who it is not too late. And so I really just, implore you all to recognize your power to save lives by facilitating safe access to this treatment. For you all, it is not too late. And I am happy to answer, specific questions about the elements of the bill, the policy. I helped a lot with the psilocybin study working group behind the scenes. A couple members of our team, Dr. Averill and Jesse McLaughlin, were on the working group. We followed the report very closely that was submitted to the legislature. I saw some testimony submitted in the middle of the hearing from Demas that opposing the bill, and in a little bit of a confusing fashion, saying that it went, far beyond the scope of their recommendations. I don't think that's accurate, and I'm happy to further discuss, potential confusion over the law or process with anyone from Demas or with the committee. But ultimately, this bill is not legalizing anything that could not already be done through an FDA expanded access program. That's all it is. All it is doing is funding patients who would not otherwise be able to afford treatment and who are deserving of urgent care: veterans, retired first responders, frontline healthcare workers, those from underserved communities, to receive MDMA-assisted or psilocybin-assisted therapy in an approved treatment site, which would have to have an FDA-approved expanded access protocol. State really does not have to do anything to oversee that. They're just approving the sites who apply with that approved protocol to receive the funding. It also provides for matching grant funding for a potential total of $4.5 million for deserving patients who can't afford to wait to receive treatment in a real-world setting. A lot of people have already discussed earlier that it's really difficult to get in clinical trials. There are very few people out there with just depression, just PTSD, these very, clear-cut patients. Most people are complex symptoms and comorbidities, and this is a chance to give those people access. It's a chance to train more therapists, develop the infrastructure, protocols for safety, follow-up care, best practices, gather data for, I know there's a question about cost, the cost benefit analyses, and there are some really promising early studies on that. That MAPS just released a new one recently on MDMA, but this will be a chance to really develop a lot more information that can be used for insurance purposes, because without reimbursement, there's very few people who are going to be able to afford this treatment. It's very time intensive, but it's also very powerful, and we know it can really help a lot of people. And I think there's strong reason that we need to start pursuing these treatments now, both to save lives and to build that infrastructure that we're going to need before FDA approval. So we're really ready to deploy these treatments when they are really only a few years away from mass deployment. So I'm happy to answer any further questions, and thank you so much for the additional time.
Thank you so much. I think the first person who should ask question is Representative Cook. She has worked hard on this bill with all of you. So Rep. Cook, please go ahead.
Thank you, Senator. And Brett, thank you very much for being here and waiting it out with us and sharing your very emotional story of loss and how innovative treatments can actually find people a sense of peace, I guess would be the way I could explain it. And I find it interesting, in all of our conversations, I did not know about your eating disorder, and then what you had shared about your use and how things had changed your life. And I think it's vitally important, Senator, that when we talk about moving things forward, we can see that it's just everyday people that are really struggling with things that often people don't want to talk about, that need help in this situation, out of the box help. So Brett, I know that you've been on all day, and I know that you've been listening. I talked about the different legislation that's happened in different places. We talked about Texas and a variety of other things. Moving forward, short of passing this legislation and getting things done, is there anything else that you feel that we as the Public Health Committee, or we as the public who are watching, need to know to ensure that the passage of this legislation doesn't miss us?
So, I think there are a lot of things that can be done in the next couple of years before treatment's ready. I think that there is absolutely so much more that we have to learn, so much research that was lost over the last 50 years. But I also think that, as we keep mentioning, that there really is a limitation to the clinical trials. Even the results, that I've seen from the most recent psilocybin clinical trials, for example, that, there were some concerning results over, patients that ended up experiencing suicidality after receiving treatment. And, there are a lot of people who, I think feel that to give somebody a treatment of this sort that might bring up really powerful emotions, and then to sort of cut them off because that is, this is the protocol, and not continue to, provide them that ongoing support, whether it's even additional psilocybin sessions or just additional therapeutic support because, it doesn't fit the way that you're studying these treatments. I mean, that is, could very well be part of what's leading to those reactions is that, they're just not following the best protocol for those patients. And what we need to do is bring these into the real world and, provide that aftercare, figure out what is needed, what kind of ongoing support, what the best dosages and, therapeutic methods are. There's still so much to be done, but I think that for the state's purpose, spending money on clinical trials, kind of subsidizing industry is not an efficient use of the state's funds. I saw in the Demas report something about, and the work group report about, funding research, but that's, the state will get a lot more benefit for its money by providing real world treatment to actual patients. Everybody gets treated, and, the training money can be spent on training and, setting up these infrastructures and really, figuring out how this is going to work in the real world, because it is just so different from the research lab. I do also think that there's going to be a lot more involvement of the federal government and HHS over the next couple of years. We included provisions in the bill to automatically adopt guidelines from HHS that are issued when they're published in the Federal Register. Having an automatic provision to adopt those measures can really streamline the regulatory process, as well as the automatic rescheduling of MDMA and psilocybin when they're rescheduled under federal law. These are things that seem minor, but like they can really save a lot of time and streamline the process. I think that I know that Demas also, referenced the FDA and REMS as kind of taking care of a lot of this. I think that that's not quite accurate, that it will not, the FDA is not going to control as much over the practice of medicine as I think Demas is, potentially foreseeing right now. I think that it's having that broader language in there will, be the safer way to make sure that the regulatory system gets set up, quickly with input from not just the federal guidelines, but also, an advisory board of stakeholders that will be able to more quickly provide input and, real-time updates that can help make sure that it is affordable and, accessible in the state of Connecticut, because, Connecticut, New York, Montana, they don't all necessarily need the same, have the same needs. There's going to have to be different ways that this is done and accessed, because it is going to be very expensive at first. And there's, a lot of complexities to this that there is a good reason that states should be able to, set up their own systems and have flexibility to, figure out ways to help the most people that they can.
Thank you. Thank you, Brett, again. And Senator, I promise that would be my last question on this for the rest of the evening. I just want to make sure that folks pay attention to the written testimonies. We had a Navy SEAL and his wife that were supposed to testify, and they're actually in the process of moving, but they have both submitted testimony. I just really implore the committee to read the written testimony. We know that 3 minutes is just a snippet into somebody's world. And every one of the folks that have testified on this piece of legislation has been willing to come and meet with us or talk to us further. So I encourage everybody to do that as well. And I would be remiss to say that this was a solo effort. I mean, Jesse helped spearhead the things with us, but I know that Representative Ryan and Representative Kathleen Kennedy was also involved in our working group over the summer. And so with the experts that have come to the table, I think that we've heard some testimony that we should not put behind us and that we really need to act, because with every inaction is going to be a loss of life. So thank you, Brett. Thank you for being here and your stories. And Senator, thank you very much for calling.
Thank you, Representative. Thank you, everybody.
Thank you, Brett. Truly appreciate your testimony. You have touched, I would say, each and every one of our hearts. We benefit from the Zoom because we can be in multiple Zooms at the same time, but there are days like this when you want to go and hug somebody and thank them for what they do. And today's one of the days I wish I was physically around and you were in the Capitol LOB and we would be able to hug you and thank you for what you do.
Thank you.
Thank you for your testimony. Thank you. Seeing no other questions or comments, we will move to the next person, which is Nikki Colley.
Can you hear me? Okay.
Yes, we can. We can't see you, but we can hear you, Nikki.
I wonder why you can't see me. I'm sorry about that. I don't know how to turn the camera on. So anyways, good evening to the distinguished members of the Public Health Committee. Thank you guys for bearing with us today and listening to us. I'm going to start by saying I'm Nikki Colley, Director of Legislative Affairs at the Connecticut Energy Marketers Association. We represent over 600 family-owned heating, oil, gasoline, and convenience stores retailers across the state of Connecticut. I'm submitting testimony in opposition to SB 367. And I'll start by saying that we are 100% supportive and committed to the goal of eliminating underage smoking in Connecticut and nationwide. We also do support the sale of legal products to adults 21 years and over. Since the federal government and Connecticut have deemed that tobacco products are legal to purchase by people who are 21 and over, we believe that flavored products like menthol should remain available for purchase. The FDA has taken regulatory action and banned millions of flavored electronic cigarette and flavored nicotine liquid products. In addition, the FDA will also soon have purview over synthetic nicotine products, which is the current loophole that allows for flavors. With the FDA taking these actions, the need for state flavor ban bill is not really necessary in our opinion. Banning the sale of flavored vapor products that have already been introduced to the market and have been for years will consequently shift sales of these products from law-abiding retailers to potentially illegal sources who do not check IDs and who do not care who they sell to. The black market does not have state borders. I've heard multiple people talk about, the surrounding states and how they are also banning these products. But again, the black market just doesn't have borders. Our Connecticut retailers take the proper precautions to prevent the sale of tobacco products to underage individuals, and those that are not following the laws and restrictions should be and are reprimanded. Our members probably participate in the We Card program, which is designed to help train employees to comply with federal, state, and local laws on preventing age-restricted product sales to minors. Our members are on the front line every day at their convenience stores with trained employees that implement age verification methods to ensure that only people who purchase these products are legal age. These retailers are members of the community, their grandparents, their parents, their aunts, and their uncles. Focusing solely on licensed retailers ignores other access points such as social sourcing and online sales, which is not always safeguarded to protect the youth and consumers. And that was all I'm going to say today, because again, there have been other people that have testified saying similar things. So thank you for your time today.
Thank you, Ms. Colley, for testimony. Thank you for waiting for a long day for testimony. I don't see any questions or comments. We'll move on to the next person, which is Mr. David Daniels.
Thank you.
Mr. Daniels, you're on.
Yes, can you hear me?
Very well, but we can't see you.
My camera is on. I'm not really sure what the problem is. I can't see it, but hang on for a second.
There,
better?
There you go. Yeah, very much.
All right, good evening to all assembled. My name is David Daniels III. I'm a retired Bridgeport Police Lieutenant, City of Bridgeport resident, and a bit of a community activist. I would like to thank you for this opportunity to speak on the proposed legislation, SB 367, to consider the ban on all flavored vaping products. Let me emphatically state that I do not vape, smoke, or utilize tobacco-based products. I also believe that we should do everything we could to discourage our children from consuming such products for obvious and health reasons. I do, however, have a problem with menthol being included in this ban on flavored products such as cigarettes, in that over time, I believe that such a ban would have unintended consequences for adults, mainly Black and brown people, that have openly and legally enjoyed this for at least 100 years. I understand that this proposed legislation is aimed at sellers, but the laws of supply and demand would also allow this to evolve into a look into people that process and use them if the desired effect cannot be realized, negatively adding to the tedious relationship between cops and community. Moreover, the people that consume these products will not stop wanting them or buying them. They will merely travel to other cities or states to secure them. Any action could spawn an illicit market to fill this niche. That market will not have the same quality control and safety measures that our federally regulated tobacco companies already have. This is a short-term solution to a long-term problem that may ultimately lead to more problems down the road. I hope that you'll reconsider this action. I'd like to thank you for your time and consideration.
Thank you, Mr. Daniels. Actually, our bill does not have combustible menthol restriction. So that's as fast as we heard your concept.
Thank you.
That's service in the state of Connecticut, right? From legislators. Good. Thank you for your comments. Thank you for your testimony. And like I said, the part that you're worried about, that's not in the bill.
Okay, but things start out one way and they end another because, you know, people are well-intended, but they don't realize how things could disaffect other people. And that's why I'm testifying.
Thank you for that. Thank you,
You're
sir.
welcome. Have a good day.
You too. And the next person on the list is 109, Sam Hellemeyer.
Good evening, Chairman, Madam Chair, and members of the committee. My name is Sam Hellemeyer, and I'm here this evening on behalf of Pharmaceutical Care Management Association, otherwise known as PCMA. I'm testifying to you to oppose Senate Bill 331 and House Bill 5275, both of which are a ban on step therapy for behavioral health. PCMA is the trade association representing America's pharmacy benefit managers, which administer prescription drug plans for millions of Americans. I did submit written testimony on these two bills separately, but tonight I wanted to share some key concerns of those testimonies that I submitted. These bills will remove one of the tools that PBMs use to provide a high quality benefit and put the downward pressure on the rising cost of prescription drugs. Step therapy is this tool. Step therapy would require an enrollee to try a medically appropriate first-line drug, which is typically a generic alternative to a more expensive branded product when a new therapy is initiated. Some of these drugs have harmful side effects or have a very high list price, and step therapy encourages trying these proven safe and cheaper alternative therapies first. Every plan does have an established exceptions process that will permit the coverage of a drug that is on a step therapy list, or if a physician provides information about harmful side effects that the patient might experience from that lower tiered drug, or offers another documented medical reason. Plans and PBMs use P&T committees that are comprised of independent experts, including physicians, as well as pharmacists, to develop evidence-based guidelines using step therapy. And they use these to assure cost controls do not impair the quality of clinical care. I do empathize with those who have testified before me today regarding their loved ones in the struggle with mental health. These are very complex health conditions. But again, the companies that I represent apply step therapy as a cost control while not impairing the quality of care. For the concerns that I shared, we must respectfully oppose Senate Bill 331 and House Bill 5275. And I'm happy to work with the committee and key stakeholders on these bills, and also happy to answer any questions of the committee at this time.
Thank you so much for your testimony. PBMs are a problem. The only country in the world where we have PBMs is United States. And in the United States, we pay the highest price for medications. And you will have a conversation on chicken and egg, but the reality is the PBMs their only purpose is to work with insurance company to try and identify ways of restricting access to medications to the patients. So as a physician who have seen people suffer and sometimes even die because of the PBM's policies, I have very little sympathy for PBM's positions. So I wanted to just say that to you so that there's no confusion, Sam. But I wanted to thank you for your testimony. And I don't see any questions or comments, and we will move on to the next person. Thank you.
Thank you, Senator.
Next person on the list is, I want to make sure, it is Carly Rowe. I just want to make sure we have that. And I don't see Carly Rowe. Well, I see Eugene Regnier. 115, Eugene. Oh, Ms. Adams, just wait for 1 second. There's somebody just ahead of you. Eugene Regnier, going twice. All right.
Can you hear me now, sir?
Yes, we can. Thank you so much. We're almost about to give up on you, but I'm glad you're here. And then can you actually turn your camera on if you want to?
I honestly don't know how to do it. It's will I hit live up in the corner?
Yes,
I'll try it.
that little camera.
Well, sir, I'm unable to do that apparently. But I would like to speak.
We can hear you very well, so go ahead.
Okay, sir. Thank you for your gentility. Thank you for your compassion, the whole committee. I am really almost reluctant to speak in the heels of all the people I've heard speak so deeply and compassionately before this. So nonetheless, allow me to go. I'm unaffiliated, and I wanted to mention that I'd like to associate myself totally with the earlier remarks from Kathy Flaherty. Secondly, I want to ask, do statutes matter? For 5 years, since 2017, the cooperative relationship between the catchment area councils and the regional mental health boards has been severed. Before 2017, Connecticut statutes were followed. The regional mental health boards supported the catchment area councils, who functioned as grassroots reporters of the health of Demas's many services from the perspectives of those who actually have experiential knowledge of those services, and from the perspective of family members whose intimate understanding of mental health issues proved to be invaluable in their systematic assessments of the strengths and weaknesses of our mental health system. The voices of the mental health community passed through the CACs, then through the regional mental health boards, then on to the commissioners of Demas for their attention to those grassroots reports. Demas didn't create nor have responsibility for the statutory protections of the regional mental health boards, the RACs, and the catchment area councils. The Connecticut legislature did. What basis allows Demas the right to pull funding and dismantle those entities that, quote, shall receive federal, state, and local funds, unquote, to sustain them in their statutory mandated responsibilities to keep mental health services at their best? Please ensure that the catchment area councils resume their independent grassroots oversight function with the funds that will allow them to do the work assigned to them by law. The regional mental health boards again and the RACs had their funding pulled by Demas in 2017 in the absence of legislative changes that might have permitted them to do so. The effort now to codify the RBHAOs sends the message, I feel, that the laws are for some people, but not for all. Thank you for the opportunity to mention the need for vibrant catchment area councils and to address in a brief manner an elephant in the room. I commend the Public Health Committee for their compassion and involvement with concerns facing them today, especially around fentanyl and the enormous personal losses that I heard about today. Thank you. Any questions? I'm glad to talk about them. Thank you very much.
Thank you, Mr. Renier, for your testimony. And I would just add one comment to your testimony. Your testimony is, again, part of some very critical, important testimonies, and we've heard you clearly, and we appreciate your testimony. Thank you, sir.
Thank you, sir.
And no questions or comments, so we'll move on to the next person on our list, which is Victoria Adams. Ms. Adams.
Hi, good evening, everyone. Thank you for allowing me to talk about this important topic. My name is Victoria Adams, and I'm the Tobacco Program Coordinator at Southern Connecticut State University. And I'm here today to provide education and awareness about Bill 367, an act concerning electronic nicotine delivery systems and vapor products, and Bill 5364, an act concerning the Tobacco Settlement Trust Fund. So as the Tobacco Program Coordinator at Southern, I provide tobacco prevention, cessation to youth and young adults. I support community members at Southern, other colleges in the state, and middle and high schools in Connecticut. This work has been grant funded through the Connecticut Department of Public Health and the Tobacco and Health Trust Fund for the last 5 years. We have had meaningful impact at Southern and across the state because of this grant funding. Some of what I do is that I oversee a peer-to-peer vaping prevention program where Southern undergraduates teach middle and high school students about the risks of vaping. To date, we have reached 21 schools and over 300 teenagers in Connecticut. After each session, students are surveyed about their experiences with nicotine vaping. Including student respondents that do not vape, 34% said nicotine vaping makes it hard to pay attention and difficult to concentrate at school. 20% do not want to use the bathroom at school due to those vaping in the bathrooms. About half of the students said that flavors are one of the main reasons that their peers or themselves started to vape. Flavors is the overall theme we see when talking with young students. Our youth are enticed by the variety of palatable flavors and develop misconceptions of risk from the sweet taste. This grant-funded work has enabled me to provide vaping prevention and cessation education at over 90 community events, reaching over 1,500 participants. Requests for nicotine vaping education come mainly from colleges, middle and high school students, and prevention organizations. Vaping is a major concern for those that work with our youth and young adults. Over the last 5 years, I've seen an increased knowledge of risk, but there are still many, many misconceptions. Our youth deserve to know the truth about these products so that they can make informed decisions for themselves. Principals I speak with are exhausted from trying to enforce a vape-free school. Many schools confiscate multiple devices each day. Some districts have students as young as the 5th grade are caught vaping. Again, the products they see are flavored. As a tobacco treatment specialist, I provide tobacco cessation services mainly at Southern. All the students I've worked with reported using flavored nicotine vaping products. They were unaware of the amount of nicotine in the products and the level of harm that they could cause. Wanting to improve their health was their top reason for wanting to quit. They can already feel what vaping has done to their mind and body just over a short couple of years of using these products. This grant-funded work has provided the opportunity to assist 4 colleges in Connecticut to implement tobacco and vape-free policies on their campuses. Albertus Magnus, Wesleyan, Northwestern, Connecticut Community College, and Sacred Heart University have all partnered up with Southern to implement comprehensive policies in order to address the growing concern of vaping on their campuses. Programs like this, as well as other tobacco prevention programs, have the potential to reduce nicotine vaping rates for kids and young adults. Our kids deserve to live a nicotine-free life.
Thank you so much, Ms. Adams, for your testimony. This is very helpful. I think you're giving us an insight into the ground realities, what you're seeing every day. And I'm sure each and every one hears you, and we will deliberately do whatever is in the best interest of our children. Thank you for that.
Thank you, I appreciate it.
Thank you for your time and waiting for the testimony today. So seeing no other questions or comments, we'll move on to the next person on our list, which is Jonathan Lubecki.
There we go. Yes, my name is Sergeant Jonathan Lubecki, U.S. Army retired. I spent 4 years in the Marine Corps and 8 years in the Army, deployed to Iraq, 2005, 2006, where I was blown up in a porta-john, one of the crappier places to get blown up in Iraq. It's okay to laugh. I get to tell that joke. When you get blown up in a porta-john, you get to tell that joke for the rest of your life. So I came back and unfortunately came back to an empty house. My now ex-wife had left, took my dog, sold my motorcycle. My life was a country song. Crippling PTSD and being a National Guardsman who didn't have access to on-base services and support meant that the Christmas after I got back in the early hours of the morning, I put a 9mm to my temple and I pulled the trigger. I've done that twice. The first time was a manufacturer's defect in the ammunition. The second time a spring broke. I've slit my wrists twice and I've tried to overdose once. I spent 8 years with crippling PTSD, unable to work. I lost my house. I lost everything. And then after my final suicide attempt, while I was in the hospital, the VA asked me, what can we do to make things better? The only thing they could really offer me was weekly counseling, which did help a little bit. I'm very fortunate they did that because an intern was filling in on one of my counseling sessions one day and slid a piece of paper across the desk. And she told me to put it in my pocket and hide it because she might get fired for telling me about it. I opened it up after I left and it said, Google MDMA PTSD. So I did. And I found out that the Multidisciplinary Association for Psychedelic Studies was doing a clinical research trial in Charleston, South Carolina, where I live. And so I called them, I explained my situation, and they accepted me as the 26th person in a 25-person study that had over 5,000 applicants. That is how many people are seeking these kinds of treatments. I went through a 4-month protocol. I did 8 hours of psychotherapy under the influence of MDMA, the active ingredient in ecstasy. And then I had some 12 90-minute regular non-drug therapy sessions along with that. Here I am 7 years later. I've only done MDMA 3 times in my entire life. It made all of my suicidal ideation completely disappear for 7 years. My PTSD is gone. I haven't had nightmares. And the most amazing thing for me is the universe likes to use me as a guinea pig for this therapy, because in the past 7 years, I've been in a car accident that totaled my vehicle that replicated being blown up in Iraq. I had a gentleman drown in the lake behind my house. I dove in, pulled him out, did CPR until EMS relieved me. He did not make it. I ran towards gunfire in Charleston to render aid to a gunshot victim who also did not make it. And then my son almost died on a cruise ship and had to be life flighted by the Coast Guard, and I thought he died in my arms. To this day, I still do not have PTSD. Going through this therapy also taught me that therapy works, and that that therapy is close to trauma is critical. This bill is asking the state to look at the current research, which says that MDMA will be FDA approved in the second half of 2023. Psilocybin is following very shortly behind that. Because of how—
Mr. Lebecki, your time is almost up. If you please summarize. Thank you.
Yes, ma'am. What veterans are asking for is for the state to take the actions necessary so that when these things are approved and available, that they immediately have access. With the number of veterans that are committing suicide every day, this is critical to take these steps now before FDA approval, because it's going to take months, if not years, to set this up, regardless of when it's FDA approved. These therapies are the reason that my son has a father instead of a folded flag. And I'm more than willing to answer any and all questions you may have.
Thank you so much, Mr. Lebecki, for your testimony and very, very powerful testimony. And thankfully, it convinces me that this is everybody who is resistant to treatment should have this option available. And this is what this bill is about. I have Representative Kennedy who has a question or a comment.
Thank you, Mr. Chairman, and thank you, Mr. Lebecki, mostly for your service, but very emotional, powerful testimony. Just to clarify, so you're not going through any treatment right now, or do you still seek treatment? I just wanted to clarify.
The only time I have sought treatment was I went and talked to a regular counselor for a month or two following the traumatic events that I had mentioned, so that I could process those things. I'll be perfectly honest, the gunshot victim, I actually did a 1-hour therapy session while I was waiting on the detectives to show up to interview. So when I have issues, last October, my father passed and I went and talked to a counselor for grief. When things come up, I go talk to someone, but I'm currently on 0 medications and I'm not in any sort of ongoing therapy, only like need-based on life issues. And it's been 7 years. As a matter of fact, this November 22nd, I returned back from Iraq November 22nd. I took my first MDMA pill, and that was 2006. My first MDMA pill, November 22nd, 2014. So this November 22nd, I will have been completely free of PTSD for the same amount of time that I had PTSD. I am living proof that acquired mental illnesses can be healed if people have access to the right treatments and medications that they need.
And that's so good to hear. And, I'm so sorry you had to go through those additional personal tragedies, but I just want to send you continued strength and prayers as you continue on. And thank you once again for serving our country. Thank you, Mr. Chairman.
Thank you, ma'am.
Thank you. Thank you for your testimony. Seeing no other questions or comments, we'll move on to the next person. And that is number 119, Ingrid Gillespie.
Hi. Yep, I'm
Hi.
here. We'll adjust accordingly. Good evening. I guess it's good evening. My name is Ingrid Gillespie, and I am a director of prevention of liberation programs. It's a large behavioral health organization here in Fairfield County. And I'm also a member of MATCH, which is the coalition of 50 organization really focused on reducing tobacco and tobacco illness in Connecticut. I want to thank the distinguished chairpersons and members of the Public Health Committee for the opportunity to share some testimony on Bill 5364, an act concerning the Tobacco Settlement Trust Fund. So I'm not going to read from the testimony that I submitted. See that? I guess I was excited to see this bill because I've been doing prevention work for 17 years now. And in that time, I've had an opportunity to look at tobacco prevention and cessation from a few different perspectives, certainly teaching youth and parents about smoking and now vaping. But for many years, I facilitated with a former person from a regional mental health board. We facilitated an initiative that really focused on smoking cessation for those living with mental illness and those with substance use disorders. As well as in that work, I had the opportunity at that time to advocate for funds for the Tobacco Health Trust Fund. So I can't thank you enough for seeing this proposed bill. So my experience have been such that really to hopefully support the need for dollars for this fund. And earlier I was going to say we urge you to have $12 billion, but from what I understand from Representative Steinberg, that is there. So I very much thank you for that. But what I'm seeing typically on the prevention end, and let's talk about youth, we've heard a lot of the testimony about vaping and flavors. I can tell you from being with over 1,000 kids this past year, and back in the classroom, which has been fascinating because their eyes literally light up when you talk about flavors, light up, because they're like, whoa, look at those flavors. If they're in grade 6, their eyes light up. If they're in grade 8, it's like they will verify. That is the main reason why young kids are starting. They don't understand, and we spend a lot of time looking at a cigarette and a vape. And we have pictures that show these chemicals coming from each. The concept that they're both serve the same purpose, to get nicotine to your brain as quickly as possible and in a very pleasant way, is not something that is rarely thought of unless you're in the classroom with these kids. And the message has to be shared, as the CDC recommended, in a variety of ways, on an individual basis, on a mass basis, etc. Repeatedly in a lot of different ways. They're not getting that message. What they are getting is the advertising. And that is, we need to be able to have the funds to counterbalance that. In the fields of, when I'm looking at people with substance use disorders and those living with mental illness, Dr. Anwar, your earlier comment about the difficulty and the challenges of quitting reminded me of a story many years ago when listening, and one young man was being asked how he was able to quit heroin. How were you able to address that? And his response was, when I quit nicotine, I knew I could quit anything. It speaks to the strength of the nicotine addiction. And within those groups, we were making headway in terms of looking at some of the norms, addressing some of the myths as to why people weren't even being asked about it, to we have incredible stories of people with serious mental illness who have quit.
Excuse me, Ms. Gillespie, but your time is almost up. If you please summarize.
So
thank you.
Yeah, so those were just sort of what we're seeing on the ground in terms of why we need these dollars. So I just want to say thank you for the 12 million that you're recommending, because it really is needed for consistent, intentional, multi-strategy focus. Thank you.
Thank you so much for your testimony, and seeing no question or comment, we will move to the next person on our list, which is Maria Chadukovics. And I'm sorry if I did not pronounce your name accurately, Maria. Going once. 120, Mariah Chadukovics.
Hello.
Hi, yes, we can hear you now.
Yes, hi.
And
Can you
if
hear me
want to
okay?
we can hear you, but we cannot see you. If you want to turn the camera on.
Hello.
Yes, we can hear you. There you are. Good. Your camera is not on, but go ahead.
Okay.
There you are. Okay.
Hi. I hope you can hear me okay. My internet connection is not the most stable, but thank you so much. Thank you, distinguished members of the Public Health Committee, for hearing me today. My name is Mariah Chadukovics. I'm a resident of Cromwell and a Master's of Social Work student at UConn. I'm also a survivor of suicide loss, and I want to briefly remember today Joey Parmalee, Christine Mathena, Evan Boyd Knoll, and Justice Joy. I'm here today to testify in support of SB 368.
I think Mariah's internet connection is a little weak, so we may have been disconnected. If it's okay, I'm going to, there was 113 that I was waiting for that we may have missed, but I don't see them right now. So we're going to go to Vicky Marnin. Miss Marnin, you can go ahead, please.
Okay. Hi, this
my
is
name
Vicky
is
Barnon.
Hasna. Can you hear me?
Yeah.
my
Actually,
name
Ms.
is
Martin, if
Hassan.
you want to wait for 1 second and we'll listen to Mr. Gondel. Go ahead, Mr. Gondel. You're on the phone, I guess, right?
Yep, that is correct. My name is Hasnan Gondal. I am a representative of the Roadrunners gas stations here in Connecticut. I am speaking today in opposition to SB 367. I understand that this bill was introduced to protect the youth. I believe this should be a goal of all of the people speaking today and all citizens, in fact, to protect the youth in any way possible. However, I believe that responsible retailers are the wrong target of this bill. We work very hard to try to ensure that the products are not sold to the wrong audience, which includes children. However, the truth is that minors are not buying flavored products from responsible and licensed retailers like all of the other attendants here who are speaking in opposition to this bill. The adults who are breaking the law will have access to find flavored products somewhere else. I said this last year, and I would like to remind everyone, I am doing business in states that have banned these flavored products. The only benefit that the state has with the ban is that responsible retailers are not selling the product. However, the target of this bill is to protect our youth. I strongly believe is not happening. Children and teens have connections to obtain the banned products through unlicensed retailers, unchecked retailers who are not paying any fines because they are not under any radars of the state. Adults are importing these products from other states, and they are reselling to the children at a higher margin. And I do not believe that this is preventing the children from accessing the products that we want to prevent them from having. The fact that this bill is going way too far by including a menthol as a banned flavor. Menthol is a flavor that all adults can use to move from more harmful cigarettes to anything else. I believe the FDA is about to complete their PMTA process and announce which products are illegal. I believe the FDA has done more research than the Connecticut Department of Public Health in vetting out the products which should be allowed and which should not be allowed. The fact that SB 367 is doubling penalties for retailers demonstrates that the state does not understand that we are not the primary source for youth sources. There is not a single reason to increase the fines. It is unfair and unjust to the retailers who are responsibly selling these products. The state will only increase these fines for the licensed retailers and not the unlicensed retailers who are operating out of their vehicles, their homes, and dealing with the youth through social media with apps such as Snapchat and Instagram. And with that, I would like to complete my testimony, and I thank you for having me here.
Thank you, Mr. Gondal. I understand that you have a place in Ellington, your facility.
The Ellington facility, I am a fuel supplier for that site. That is not my own site. I do not operate that site.
That works under Roadrunner's Gas, and I just want you to be aware that there have been complaints of selling vapes to children over there. The police has been informed a few times, so whoever you work with, you may want to inform them. So that sort of goes against the first sentence that you had said.
That is
so
not my business, but I will. Right, I will look into that.
That is your business associate, so you may want to check on that and please follow up. Thank you so much for your testimony, and we don't have any other questions or comments. And we will go back to Vicky Marnin. Thank you, Vicky, for waiting for a little bit, and we would love to continue to hear your conversation.
Hello. Trying to figure out how to make my camera work. I'll start talking though while my daughter helps me with this. Good evening. My name. I live in Madison, and I am here to testify in support of raised bill 5396 regarding increased access to mental health medication. If you met me in the hallway, my elevator speech would tell you I'm 58 years old. I am the mother of an almost 21-year-old who is a college junior. You would also learn that I've been practicing as a certified nurse midwife for more than 25 years and have delivered or caught over 2,000 babies. I had my own private practice here in Connecticut for close to 20 years. What you would never know about me is that I've struggled with depression almost my entire life. My depression has come and gone through different periods of my life, but worsened in my late 30s. I had significant postpartum depression, and since that time have been on and off over 15 different types of medication and spent hours of my life in therapy. I became a workaholic, the fast-paced momentum of being a business owner in a healthcare field, making it nearly impossible to find time to feel my feelings. However, with my daughter off to college and the closing of my business, I was facing a huge looming problem, time. And what time was revealing to me was the depths of my depression. For most of the past 2 years, the moment I was aware of waking from sleep, my first thought would be, oh my God, I have another day to fill. I've tried multiple medications and treatments. I spoke with a therapist weekly for years with minimal change in the mood, just the constant reminder that it would be devastating to my daughter if I were to kill myself. About 15 months ago, I became aware of new studies about the expanding use of psychedelic medications for treatment-resistant depression. I searched the NIH websites for studies and applied to 4, and a month later, I was accepted into a study at the West Haven VA hospital. The vetting process was thorough, and I was anxious that something would come up to preclude me from the study. They took a comprehensive health and psychiatric history and performed a physical with blood work and a drug test. After multiple questionnaires and interviews, I was accepted into the study. The study team prepared me in every way possible, explaining what to expect physically, mentally, and emotionally. The environment was specifically designed to be safe and comfortable. Before I started the session, we spoke of my intentions and my hope for how the medication would help me. I took the capsule, put on an eye shade and headphones, and within 30 minutes, things started to feel different. There are many different details I would be happy to share with you, but my time is limited. But during the 5 hours or so I was affected by that medication, I developed some deep compassion for myself. I was able to see many patterns I had learned which were contributing to my depression. I cried on and off for several hours. I made more progress in helping my depression in those 5 hours than I had in the previous 10 years. At the end of the study, I asked the investigator how to continue this work, and literally there were no options for continuing because this treatment hadn't been legalized in the state yet. So I am here to respectfully ask that you allow these excellent researchers and clinicians the opportunity to provide psychedelic medication as soon as possible to not only the focus group that the bill speaks to, but all people. It was life-changing and life-saving for me.
Thank you. Thank you so much for your testimony. And we'll have Representative Parker ask has a comment or a question.
Thank you, Mr. Chair. Thanks, Vicki. Thanks for being here with us. And thank you for the bravery of sharing your story, especially with Sophie right there with you. We really appreciate your insights. You started to mention what it was like to go through this treatment. I think you mentioned the eye shade going down and then some 5 hours of interesting feelings. Can you tell us a bit more about what the experience is like and how it differs from other therapeutic experiences that you've had?
Well, it's kind of indescribable. You see different visions, and basically what was interesting to me is that I was having conversations inside of my head about, I would see a kind of a vision of something, and then the other part of my brain would say, what is happening? What is that about? And sometimes I could verbalize it to the two people who were sitting with me during the experience. Sometimes I couldn't verbalize it, but it made my brain interested in looking or hearing the things that usually are suppressed. And, the thing that I'm aware of as a healthcare provider is everybody has trauma. Every person you meet has trauma. It's just a matter of how you've been nurtured through trauma, how you've been taught to deal with trauma. In my family, if there was a hard thing, you put it in a little container and you never talked about it and you never looked at it and you never addressed it. And there was a loyalty in my family to keeping everything in those little containers. And literally for me, I had this experience of those containers just melting, just dissolving. And finally I could see, oh, wow, when my parents got divorced, this is what that experience was like for me. And it happened over the course of this 5 hours. And when I got my bearings and things stopped moving around, I said, I need to do this like 5 more times because I'm not done with what I was trying to process.
Thanks for sharing that. As someone who's experienced my fair share of talk therapy, that sounds like a supercharged session with lots of insights revealed. So I really hope that we're able to make this continue to be possible for you and other folks in need of this treatment. Thanks for sharing, Vicki. Thanks for your time, Dr. Arnold.
Excellent. Thank you.
Vicki, for your testimony. I see no other questions or comments. We will take Mariah. She's back. Mariah, sorry we had you wait. Hopefully you're in a better spot. Please continue your testimony.
Thank you so much. I hope the connection is better now. So as I was saying, I'm here to testify today in support of SB 368, an act concerning suicide prevention. In the course of my MSW internship, I have participated as a member of the Connecticut Suicide Advisory Board and been honored to witness and contribute to the important work the board does. I support this bill because recognizing the structure of the Connecticut Suicide Advisory Board as addressing the lifespan will allow the board to more effectively support suicide prevention, intervention, and post-vention grief support in Connecticut. We know that suicide is a major public health problem associated with the mental health crisis that has far-reaching personal, social, and economic implications. In 2021, 367 Connecticut residents, and there were 39,092 emergency room visits in Connecticut for suicide ideation or attempt combined, most under age 24. Some members of the committee may be concerned that changing the language from Youth Advisory Board to a lifespan focus will take attention away from children's mental health. I'm confident that the board believes the mental wellness of children in Connecticut is vitally important and recognizes that these children exist in a world surrounded by adults. The parents, guardians, teachers, and other adults in children's lives influence their mental health and the resources they have access to. If these adults don't have support systems necessary to maintain their own mental health, they can't provide the resources and support necessary to keep children healthy and safe. With a lifespan focus on suicide prevention, all will benefit. Furthermore, despite the current language, the board has shifted its focus in recent years to operating with a focus on the lifespan. So effectively, this legislation will further support those efforts, not significantly change the work that the board is currently doing. Recognizing the current structure and focus of the Connecticut Suicide Advisory Board will also allow the board to continue to implement strategies and goals of Connecticut's strategic plan for suicide prevention. This plan, developed by the Suicide Advisory Board, sets forth the strategies which the board currently implements, as well as goals which can be implemented with further resources. These strategies include, but are not limited to, prevention, effective care and treatment, crisis response, intervention, reducing access to lethal means, increasing help-seeking behavior and connectedness, and postvention response. By supporting this bill and providing support and funding to the Connecticut Suicide Advisory Board in the future, the board can more effectively implement these goals. I hope this committee will vote favorably to support SB 368, an act concerning suicide prevention, and will continue to support the Connecticut Suicide Advisory Board going forward. Thank you so much for your time, and I'm happy to take any questions.
Thank you, Mariah, for, first of all, your perseverance in dealing with your technical glitches, but also more importantly for your testimony. Representative Carpino has a question.
Thank you, Mr. Chairman. Mariah, it's good to see you. I have a question that's a bit outside of the bill's scope, but I think you might be a good one to answer it. Do you think there would be any value in putting the suicide prevention hotline phone number on student IDs so that students know where to reach out if they need help? I know it wouldn't be an end all be all, but I'd be curious to see if you think it would be another helpful tool.
Yeah, I do. I think this is a topic that has been discussed as a means, among the Suicide Advisory Board, and other states have implemented this as well. And we do have, very soon next year, we'll have access to a 3-digit number, 988, for the National Suicide Prevention Lifeline. So that number will hopefully be easier to remember and access. And in the meantime, we have 211 in Connecticut for accessing the mobile crisis. And the National Suicide Prevention Lifeline 10-digit number is also available to access the National Suicide Prevention Lifeline. So having those numbers available wherever, whether it's student IDs or any other, easily accessible places, can definitely help connect people to that resource.
Thank you. Thank you for your perspective. And that's exactly why I asked. I know that conversation has been out there multiple years, but it'll be much easier once we can put 988 on the back of a student ID. Thank you, Mariah, and thank you, Mr. Chairman, for your time.
Thank you, Representative. Great suggestion to bridge us over to the 988, which we look forward to. I don't see any further questions. So again, Mariah, thank you for sticking it out and making sure you got a chance to get your testimony in. We greatly appreciate it. Next up is Jesse Gould, followed by Dr. Kristen Reese.
Madam Chair, Mr. Chairman, members of the committee, my name is Jesse Gould. I'm the founder of nonprofit organization Heroic Hearts Project. I'm located in Manhattan, New York, and I'm speaking in support of HB 5396. I was a sergeant in the U.S. Army Rangers. I had 3 combat deployments to Afghanistan during that time, and was in charge of 30 plus individuals in both training and combat environments. When I got into the military, or when I got out of the military, I went into finance and quickly hit my own mental health walls, and quickly found out that the options available were severely limited, and really didn't understand the issues I was going through, and oftentimes had very negative side effects. I found my way to a psychedelic experience called ayahuasca, which has thousands of years of history in South American culture and has been used safely, effectively for spiritual, medicinal, mental health reasons for those years. And because of my own profound healing experience, I founded the nonprofit organization Heroic Hearts Project. And for the past 5 years, I've been on the front lines of the mental health crisis within the veteran community. And I'm not exaggerating when I say this is an epidemic, a suicide epidemic, a mental health epidemic. And some of the facts that I want to iterate today is you've heard from some other veterans, and one of the questions is, so why does this need to happen now? Why are we proposing this bill? Why are we in support of this bill? This is the psychedelics is already coming. This is already a wave that is taken over, and it's already been shown to be an effective part in mental health. Johns Hopkins University, Yale University, Stanford University, around the world, some of the biggest major institutions, research institutions have already come in support to some degree of psychedelics, including the former director of the NIH. And we've already seen some amazing results in comparison to anything else. The other thing I want to relay is that what we've done so far is just absolutely not working. And it's just sort of a maintaining and delaying the inevitable, that we do actually have to find a solution for the veterans suffering from mental health crisis. Our wait list for our program that connects veterans to these psychedelic treatments is already at 1,000 veterans, and myself and other similar organizations have already served thousands of veterans. This is already happening, and we can either get behind it and support it and build infrastructure and research to help these veterans, or we can continue to ignore it and then just let us hit this wall when things finally do change, when the tide does turn. But I want us to be prepared. I want us to have training. I want us to have research and understanding for something that is already happening. And that's why I'm here today. So in terms of that, right now, currently, there's a huge gap. And despite tens of billions of dollars in suicide awareness and program funding through the VA, we have not been able to put a dent into the suicide epidemic for veterans. And right now, the only option are for veterans to do this illegally in the US, which is happening, or going to other countries where they can access safe and legal psychedelic therapy. And that should be an embarrassment to everybody on this call, that these nation's heroes have to go to another country to get effective mental health care. We should all take a pause and consider that. And that's what we've been doing for the past 5 years, essentially building an infrastructure where there's not there on a daily basis. And again, this is not exaggeration. I get people who have fallen through the VA healthcare cracks, who are on 10 different medications, desperately just looking for some glimmer of hope. And the current mental health system has absolutely failed them. And when they do get access to these psychedelic treatments, it is one of the most beautiful things, because it's the first time in 10 years, 15 years, 20 years that they see this hope, that they actually have reaffirmation of their life, that they actually want to live. And that's why so many of us are in such support of these modalities. And we just want the infrastructure around us to support the work that we're doing that's already happening. And
Mr.
so,
Gould, your time is almost up. If you would please summarize. Thank
absolutely.
you.
And so those are the points that I want to reiterate. This is already being accepted in the medical communities, and this is already being pursued by thousands upon thousands of people. And we have this opportunity now to get ahead of it and train people.
Well, thank you for your testimony and for your service to our country and for creating the organization that is seeking to help others. I don't think we can help but be impressed by the number of veterans who not only seem to have urgent need, but are willing to, typically might be more conservative, but are willing to consider such therapies because their need is so great. It tells us we've got a problem we need to address in a variety of ways. I see Representative Kennedy has a question or comment.
Thank you, Mr. Chairman, and thank you, Jesse, for your testimony. And it was very explicit. And also thank you for your service to our country, more importantly. But you had mentioned about filling the infrastructure, but you also talked about over 1,000 veterans. How do you see, if this bill should pass, how do you see it going? How quickly will we get to 1,000 veterans? Is a lot, plus probably some that haven't even applied. Could you just walk me through that a little, how you see us proceeding should this pass?
Yeah, absolutely. I mean, the biggest thing there is we have to start somewhere, right? We can't necessarily look at how do we treat 1,000 veterans today when we haven't started. We need to look at how do we start and what can we do today? And this is what we can do today or in the next few days to, one, start the conversation, start having a brainstorming session of how are we going to address these big issues, because I promise you, there is tens of thousands, if not more, of veterans who are just holding on and who have a ton of medications, but it's not helping. And we are coming at the end of 20 years of continuous war, and we're about to have to pay that tab. And psychedelics can actually offer us a resolution to that. So this is the first step. This is conversation. This is bringing it into the light. This is possibly getting some funding and some research, because before, for the past 50 years, research has been severely limited. So our understanding is limited as well. And so what needs to happen is increase our understanding and then have practitioners who are familiar with this and then start those training process. So that starts at the government level, because only the government can provide the funding, the support, and the voice for these things to happen.
Well, thank you very much, Jesse. I know that between your testimony and everyone else that's testified, you've given us a lot of insight and a lot to certainly think about. So again, I thank you for your service to our country, and thank you for spending the entire day with us. Thank you, Mr. Chairman.
Thank you, Representative. And I agree. You've laid out a roadmap for us. It's up to us to be able to follow it if we're going to help as many people as we can. Thank you. I don't see any other questions. Thank you for your testimony. Next up is Dr. Kristen Reese, followed by John Buchanan.
Thank you. My name is Kristen Reese, and I'm a pediatrician in New Haven. I'm currently a resident physician, and I care for children in many different settings, including the primary care clinic and adolescent clinic. I'm testifying today in support of SB 367, an act concerning electronic nicotine delivery systems and vapor products. E-cigarettes and vaping products contain harmful chemicals and are unhealthy for developing lungs. The nicotine in e-cigarettes is addictive, and youth who use e-cigarettes are more likely to smoke traditional cigarettes in the future. As part of my pediatric training this year, I spent about a month in the adolescent clinic, which specializes in the needs of kids about age 12 to 21. When an adolescent comes for their annual checkup, we always gather a social history, which includes screening for the use of cigarettes and vaping. And far too many of these kids I met are using vaping products. And in reality, many of the adolescent patients that I care for and spoke with have no idea that the vaping products they use contain nicotine. And for many of them, they have no idea that they're addicted. E-cigarettes have been marketed to young adults and adolescents through the use of candy and fruit flavors. According to the 2019 National Youth Tobacco Survey, from 2017 to 2019, e-cigarette use more than doubled among high school students, from about 12% to 27%, and tripled among middle school students, from about 3% to 10%. Flavored e-cigarettes have driven the e-cigarette epidemic. 97% of youth e-cigarette users report using a flavored product in the past month, and 70% cite flavors as a reason for their use. E-cigarettes are touted by some users as safer alternative to smoking and as a way to quit smoking cigarettes, but the FDA has not approved e-cigarettes as a quit smoking aid, and more research is really needed on whether they're effective for quitting smoking. Preventative medicine is at the heart of pediatrics, and it's one of the reasons that I love my job. We must do a better job protecting youth from the harmful effects of e-cigarettes and vaping, and we must do a better job preventing youth from using these harmful products in the first place, and removing flavors is a great first step. I ask the committee to support and pass this legislation. Thank you very much, and I'm happy to answer any questions you might have.
Well, thank you, Dr. Reese. We certainly take all testimony very seriously, but you're really on the front lines of seeing a lot of the ramifications of teen vaping, and that's critically important to our deliberations. I see Senator Anwar has a question or comment.
Thank you so much, Mr. Chair. Thank you, Dr. Reese, for your testimony. In your work as a pediatrician, could you share about how the nicotine addiction is manifesting in children?
Yeah, I mean, like I said, it was surprising to me when I first learned this, but a lot of the kids that I take care of don't even realize that there's nicotine in their vaping products, and they don't realize that they're addicted. It's just part of their everyday habits, and it can really affect, honestly, like long-term brain development too, because their brains are growing till they're 25 years old, and it's scary.
Thank you. Thank you so much for the work that you do, and thank you for your testimony. Truly appreciate your time today. Thank you, Mr. Chair.
Thank you. I see Representative Kennedy has a question or comment.
Thank you, Mr. Chairman, and Dr. Reese, welcome, and thank you for being here. You mentioned when you see your patients, your young patients, you do like an inquiry with them. I would just be curious, do they ever indicate how they're obtaining their vaping products? Are they getting them online? Or, I mean, I don't know if that's a part of your questionnaire.
That's a really great question. And I'm not sure. That doesn't usually come up, but
okay.
I can ask the things in adolescent clinic if they know.
Yeah, I was just curious. I know when my kids were in that pediatric age and seeing their pediatricians are always great for asking those questions that they're not going to answer to their parents, but they're certainly going to give it to. So I was just kind of curious if when you do your inquiries, if that ever came up. I would just be curious. But thank you for being here, Dr. Reese, and thank you, Chairman Steinberg.
You Representative, yeah, I'm curious as well, but even knowing doesn't necessarily mean that we shouldn't try to make every effort we can to shut down any avenue where they're getting the product. So, it'd be good to know, but we need to do what we need to do.
Absolutely.
Thank you for that. I don't see any further questions, Doctor. Thank you for your time. I know you've probably already had a busy day, and I hope yours is closer to being over than ours. Next up, we have John Buchanan, followed by Anthony Morrissey.
Hi. Let's see. So I've got a little trouble with my computer right here. I just want to make sure that you can see and hear me.
We can't see you, but we can hear you. So that's up to
Okay.
you whether you want to keep trying to be seen.
Nope, that's okay. I'm just setting up, catching up a little late. I know you guys had a very long day. I very much appreciate your time, patience, and leadership listening to our support in favor of this legislation. Senator Abrams, Representative Steinberg, other distinguished members, listening to the testimony of this legislation, I am happy to be talking with you today. And I know it's been an extremely long day. I find it amazing you can do this and sit through this all day. So my name is John Buchanan. I'm a retired Air Force Airman who served multiple deployments inside Special Operations Command and Air Force Special Operations Command throughout Afghanistan and Iraq over a 15-year period. Today, I live here in DC. I'm an active member of Reason for Hope at this nonprofit policy and advocacy organization. And I find this element extremely important while I observe other friends, close associates, even family that struggle with post-traumatic stress, serving inside the wars and inside law enforcement. And I come here and I'm an advocate for watching what doesn't work. And I know I say that kind of loosely because there are so many elements that go into it. My position is more or less behind the hope that we have all access to various forms of health, mental health treatments and support mechanisms. And this is just one more avenue that I think has been building up a lot of research and data to support its passing. And I know it's in good company because conservative states across the country, including Texas, Oklahoma, and Utah, are passing psychedelic reform with overwhelming bipartisan support. I've seen some of the signatures that have gone on so far, and I encourage Connecticut legislature to do the same. And I'm open for any questions. And I can let me see, and I can also turn on my video if that helps out, but I don't see it on my end.
Don't worry about it. We really appreciate your testimony and everything you've done for our country. I can't help but remark once again how struck I am by the number of veterans who find themselves in these circumstances. The need is clearly present and broad, and I think it just adds to the urgency that we're not doing right by our veterans. So thank you for your testimony. I don't see any questions, but we really appreciate your hanging in with us and taking the time to share. So we really fully understand the depth of the issue.
Very much appreciate your extended time throughout this. I've been able to check in and out.
Well, many of us wish we could check out, but we're very dedicated to this process. This is just the way we do things.
It's comfortable to hear.
Hearing from everybody really matters to us, so thank you. Next up is Anthony Morrissey, followed by Andrew O'Bright.
Good evening, everyone. Thank you so much for your time today and for allowing me to speak once again. It's good to see so many of my friends on the call, continuing the battle, against the opioid epidemic. I'm here to wrap support around HB 5430. I want you all to know, as some of you already know, 947 days ago, we lost our beloved son, and our lives have been forever changed. Over the last 900 days, I have teamed up with organizations like For Cameron, Demand Zero, the Redemption House, Glorious Recoveries, and dozens of other organizations that don't get the attention that we should be getting, because we are providing direct line, frontline services to those struggling with addiction and substance use disorder. Not too long ago, last summer, I reached out to some of you folks for assistance with some people that we were trying to help. We had some people that were being discharged from a detox center, and they were being discharged to a homeless setting. I made calls to my representatives in the local area begging for help. I was directed to the DEMIS 211 and the hotline. These people were put on lists and told basically to figure it out until they can get called, their number gets called. In the time since, of the numerous people that we were helping, one of them has passed away. Every time somebody dies from an overdose, it's like my son died all over again. And this is my third year coming to these legislative hearings, begging for change. And I know that everybody is got the same desire as I do. And I know there's a lot of good work going on. But when I see language in 5430 that we have to study this or analyze that, I'm here to tell you, I've done it for you. And you already know it. We don't need to study this anymore. We need to shore up things like a voucher program. We need to make it easier for people to go from an inpatient setting into a sober living environment. We need to make it easier for people to get MAT services. Why in the world is the MATS van only subsidized for 12 hours a week? This is a perfect vehicle, literally, in which to provide MAT services to those who are on the street because there's no housing available to them to get the services they need. Please, I'm begging you. We have to open up, our mindset. We have to stop getting into analysis paralysis, and we need to just do the work that's required, which is to wrap not only MAT services and housing support services around the people who are struggling with addiction, but also provide them with recovery coaches and other services that will help them get through this. It's proven that when we put people into settings where they have the time and the resources and the medication to deal with their substance use disorder, their recovery is possible.
Excuse me, Mr. Morrissey, your time is almost up. Thank you.
Thank you, Ms. Panaza. I'm going to wrap up here by saying that this is my third year in a row. I too am an Army veteran. I pledged to fight all enemies, foreign and domestic, when I signed the dotted line, and we're falling short, right, of the promise that we made to protect our citizenry. And it's the fourth year in a row that we've had overdose numbers toppling the numbers from the year prior to. We can do better than this. Please, let's come together. Let's make real action. I'm happy to answer any questions you may have. Again, my name is Tony Morrissey. I'm the founder of Brian Cody's Brothers and Sisters Foundation, and I thank you for your efforts here, but I beg you to please keep going.
Well, thank you. You're right. We can do better. And I think you should look at the legislation we're contemplating this year as a testament to the fact that we're trying to do better. Certainly, we would love to be reminded of your suggestions vis-a-vis MAT treatment and where we can do the most good, given the fact that the main reason we haven't done many of the things you suggest have to do with limited resources. And we really need to put our dollars where we're going to have the greatest benefit. I see that Representative Zanakis and Representative Parker have questions or comments. Representative Zanakis.
Thank you, Mr. Chair, and thank you, Mr. Morrissey. Thank you for your service to our country, and I am sorry to hear about your son. As you know, this is a horrible disease and troubling state that we're in with the opioid crisis. I would appreciate, as the chair said, if you would send along some things that you feel would need to happen to really make a difference in this. I find in the legislature, a lot of times what happens is we keep doing more and more. And as the chair said, funding is always an issue, but I don't ever see going and analyzing what we're doing taking place. So I'm always of the mindset that we need to bring the right people to the table, which would be someone that's in it like you, to help create legislation. I also believe that we need to look at what is being funded now and say, is it working and is it not? And if it's not working, let's stop funding it. And then that would give us more resources for things that do work. So with that being said, if you know of things that are being funded right now that are not working, but we're continue to funding, because we're always working on these things. We're always trying to work on opioids and to stop people from suicide and stop the drug pandemic happening. But I never hear of us stopping to doing funding anything ever. And so I want to make sure that what is being funded is analyzed and making sure what is being funded now is working. And if it is, let's keep working on it and moving it forward. But if it's not, let's stop funding it. And then that would give us more resources for things like what you're suggesting and other folks are suggesting. So that's a long way to say, if you know of any of those types of things, I would appreciate if you would send it to us also, and what you think would be working going forward.
Thank you, Ms. Zupkis. I will point out that I have shared this information with Mr. Buckby, Mr. Steinberg, Mrs. Kushner, Mrs. Gilchrist, Mr. Parker. I'm happy to send that information along to you as well. I know that in January there was a session with a bunch of nonprofits, not just Brian Cody's Brothers and Sisters Foundation, but for Cameron, Demand Zero, some others. One example would be the MedCab system. In tracking the work with one particular brother that we've been helping for over a year, we found that the MedCab system failed to pick up this individual 6 out of 14 days for their methadone, for their journey down to the methadone clinic. Now, if we go more than 2 days without our methadone, our MAT, we are literally at risk of an overdose, a relapse and an overdose. So it's areas like that that serve as examples for what you're talking about. Maybe we rethink that. Maybe we take the funds from that MedCab and we put it into the van, the MAT van, where we can actually extend the service hours and offerings to people in the community. Instead of bringing everybody to a methadone clinic, we actually have the van go out into the community and distribute those medicines and such. But Ms. Zupkis, thank you. I'd be happy to reach out to you with the package referred to as Brian Cody's Law that was introduced by Mr. Buckby in 2020.
Okay, thank you. I would appreciate that.
Thank you, ma'am.
Thank you, Representative. Representative Parker, followed by Senator Summers.
Thank you, Mr. Chair. I lost you on my screen. Oh, there you are, Tony. Thanks, Tony, for being here with us. Just wanted to acknowledge, and I know you just referenced it there, and then in my colleague and Representative Zupkis's comments, I wanted to acknowledge the work that you have done to share some specific ideas with us along the way, and the working group that you've been a part of. As we've heard from other folks throughout the day today, the bill that we're hoping to move forward in 5430 takes just a few steps, and there's still so much more that needs to be done. I'm especially excited about some collaboration that the Public Health Committee can do with our colleagues on insurance, on public safety, and ultimately, of course, where the money comes through to make some more progress here. So thank you for continuing to share with us and for your time and all of the effort that you put into this work.
Thank you, Mr. Parker. Thank you for your work.
Thank you, Representative. Senator Summers, followed by Senator Kushner.
Yes, good evening. And I wanted to, excuse me, thank you for your words tonight and express my condolences on the loss of your son. And also, really, you have my great respect in all that you've taken out of a tragic situation and turned it around and all the good that you're doing in the community. I would ask that you would send that package to our administrator, Beverly Henry, and she could disperse it to the entire committee so that we can all have a chance to digest it. It sounded like maybe you sent it to half of the public health leadership committee. So if we are all involved in, receiving and reading that information, it would really be helpful. And the public health committee also has a subcommittee, a working group for opiates. And we have many community members on that. I would like to invite you to join us in that. I think you would be, a wealth of information and experience for all of us. And I know it's difficult at times. We do have different organizations or agencies that are trying to do their best and are committed to, helping with the opiate crisis, but we're government, so we do tend to get stuck in our ways sometimes. And sometimes, the agencies are, pretty set in the way they do things. And it's sometimes difficult to come up with alternatives or new ideas. So having that working group and someone like yourself helps us sort of press and push the needle in a direction that may not be something that the agency wants per se, but is something that the citizens are demanding. So we're hoping that we're making, incremental steps in 5430. There are obviously a lot of steps that we still need to take and continue to push the needle. But I will say this committee has really done a lot in the past 6 years. I think, we were one of the first states to have sort of landmark opiate legislation, and we hope to keep continuing it until we don't have to have this problem anymore, hopefully someday. So I want to thank you again for your testimony and for sharing your story and your ideas. It is really invaluable, and I look forward to getting the information that you're going to send to all of us.
Thank you, Senator Summers. I'd be honored to be part of the working group. I will definitely send that information over to the larger group here. And please hear me right. I am so appreciative of the work that you are doing. Last year, the Navigator program getting approved. I know that you all were behind that. Such a big initiative and big endeavor. Here in New Milford, Connecticut, we've seen the results of the Navigator position. We are one of the few areas where overdose deaths have gone down, and it's directly attributable to the Navigator program. So I know you're invested in this and you're trying hard, and I do appreciate that. So thank you.
If I can, that's a really good example. We passed a Navigator bill last year, and then there was no funding to expand it. And the funding, so, our agency is trying to get federal grants for that funding, but those are sometimes the disconnects that happen. And I know there's a lot of folks that want to expand that Navigator program, but we haven't even gotten off the ground with the pilots that we were going to expand last time. So sometimes government gets in the way of itself, so to speak. But that's why it's really refreshing to have somebody like you on our group, and you can help us keep pushing that. And, we're committed to making sure that that is funded and that we can move that along. We have a Navigator system down here in New London that I know Representative McCarty has been involved with also, and it's phenomenal, and it really does save lives. So thank you so much for your testimony tonight.
Thank you, ma'am.
Yes, indeed. We would love to see the things that we put forward as legislation get appropriately funded, and we will continue trying. Senator Kushner.
Thank you, Chairman Steinberg. I just want to say hello to you, Tony. The work you've done in New Milford has had a direct impact in Danbury, and you've worked hard to create those relationships because Danbury is nearby, even though we're not in the same district. You've done amazing work to bring together the people that have the same lived experiences that you do. And really linked arms. And so I really appreciate that. And you just want to say hello to you and to Tracy. And thank you for the new bonds you created with my good friend Elvis. and bringing us all into this important work. So we really appreciate everything you're doing.
Thank you, Mrs. Kushner. Thank you for all the side phone calls and the guidance that you've provided over the last 2 years. We appreciate your collaboration. And Denver is my hometown. That's where I was born and raised. So glad to be helpful.
People here might not know this, but Tony doesn't just work on policy. When there's like a person in our community that has an issue that needs immediate help, Tony will call me and say, oh, we've got somebody who's homeless. We really need help. I mean, he is really out there in the community doing this work on a daily basis. And so, we really appreciate you in a very big way. Thank you.
Thank you, ma'am. God bless.
And to you, sir, making a difference gives us all courage to work as hard as you do. I don't see any further questions, Tony. Again, thank you. Have a good evening. We will next move to Andrew O'Bright, followed by Thomas Steen.
Hi, thank you, Chairman Steinberg. Hello, esteemed members of the Public Health Committee. My name is Andrew O'Bright. I am the president of the Connecticut chapter of the Smoke-Free Alternative Trade Association, and I'm here to oppose SB 367. I always get surprised when I listen to and participate in our state hearings. I never imagined I would see so many doctors and experts use the words I feel or I think. I would rather bring you the perspective of peer-reviewed researchers, unlike the ones who we've seen today. Dr. Stanton Glantz, who we heard from hours ago, was forced into retirement partially due to his now retracted study published that counted cardiovascular events that happened before a smoker ever started vaping as in an event due to vapor products. That's been reiterated today by other associations as like the American Heart Association and the American Lung Association. Dr. Pettit has been asking a question today, so I'll answer for everybody. Over 70,000 adult vapers were surveyed in 2017, and nearly 90% claim that flavored vapor products were required to switch completely away from combustible tobacco. Senator Anwar has also been questioning participants' funding today in opposition of this bill. I'm a volunteer who sits here in front of you on behalf of adult-only establishment retailers. Michael Bloomberg is a large indirect contributor to many campaigns, and he is currently seeking FDA pharmaceutical approval for a vapor product that uses exactly the same technology and ingredients that our industry uses. I would also like to address the on-ramp and off-ramp that has been talked about. If you feel that these products do not work as an off-ramp for adult smokers, then why has the adult smoking rate taken its steepest decline in history over the last 10 years? Is it that failed policies magically started working? No. Vapor products came out on the market and gave adults the opportunity to ingest nicotine without the side effect of death. The 2021 National Youth Tobacco Survey is out, and I'm here to announce that the epidemic of youth use is now over. Less than 3% of youth use vapor products on a daily basis. While you may believe that this is because of the pandemic, our children have had the same amount of adult supervision over the last 7 years of this federally funded study. As far as the on-ramp of youth switching to combustibles, no peer-reviewed science agrees with the feelings expressed today that youth switch to combustible cigarettes after initiating with sole vapor usage. Flavors are imperative to adults' abilities not to die. We are not big tobacco. We are the gatekeepers to adult-only products. Our adult-only establishments account for less than 1/3 of 1% of underage infractions in the state. Help us help you finish making Connecticut a smoke-free community. I'd love to take any questions you may have.
Thank you for your testimony, though I confess that after everybody's testimony today, I'm thoroughly confused as to what the facts are and what the conclusions are. And, that happens sometimes when we have testimony, but it does make it very challenging for us to move forward.
I understand.
But thank you for offering your facts in a very straightforward fashion. I don't see any questions, but it was important that you hung with us and that you had an opportunity to testify, because it sort of balances the scales a little bit. We've been hearing from both sides quite a bit.
I appreciate you sticking with me.
That's what we do. Have a great evening. Next up is Thomas Steen, followed by Andrew Harapal.
Good morning. Good evening, everybody. It's been a long day. I salute you all. My name is Tom. My name is Tom Steen, and I'm a volunteer for the American Foundation for Suicide Prevention. I'm their past chair, and I am one of the tri-chairs of the Connecticut Suicide Advisory Board, which is in the new legislation that is about in front of you, Senate Bill 368. I'd like to share a little bit of my background with you. I'm one of two master trainers in QPR. I've trained hundreds of trainers, trained thousands of gatekeepers across the state in the past 8 years. And I'm here to tell you that a lot of that has happened through the Connecticut Suicide Advisory Board. It's a well-run, well-organized organization. And I encourage you to go to our website, preventsuicidect.org, where you can read all of our minutes and see all of the fine work, especially the strategic plan that we recently did I guess it's last year, maybe even a little longer, because as most folks say and see, having a strategic plan or a highway to follow is really important. And this certain committee it does that. This board does that quite nicely. So I very much support it. And when my time is done with the Connecticut Suicide Advisory Board as one of the tri-chairs, I certainly hope through this legislation and I kind of look at it as just kind of formalizes the Connecticut Suicide Advisory Board so we can continue forward with our work. I strongly support it. One of the comments or maybe even concerns that I've heard is that the current legislation is focused on youth, and the new legislation really focuses on lifespan. And we've heard a couple of testimony today that really the Connecticut Suicide Advisory Board supports all. It's integrated. We need to support adults, and we need to support people, not only young, but also of all ages. The most risk folks, for suicide in our state are white non-Hispanic males, ages 25 to 55. We don't hear a lot about that, but we do hear about the youth suicide. So we have to do the work together. It's so important. And I believe we have taken on that task nicely, and you should be all proud that I think we have one of the best programs. We have other states calling us to how we doing our work at the Connecticut Suicide Advisory Board. And then finally, my last comment, I am too a survivor of loss to suicide. I lost my son, Tyler, in 2009. And I share that with you because my journey obviously has been long. But I had to tell you, my wife and I and my other two sons, when my son Tyler died, there were no services in Connecticut. There was no suicide prevention training. There was no education. There was no postvention, how to deal with families that have experienced such loss, and certainly grief support. We have that today. It's growing. It's happening. And so I encourage you all to really consider this legislation very strongly and to get it approved at the legislative level, because we need your support. It can be really the lifeline of all the things we do in suicide prevention, postvention, and grief support in the years to come. So thank you again, chairs, as well as esteemed members of the committee, and be willing to take any questions you might have.
Tom, thank you for your testimony and for being that lifeline to so many people. Our condolences on your loss and on I'm sure the angst you must have felt back then, because there was no support, there were no services, there was nowhere to turn. And then look where we are today. And we are, I think, justifiably proud of where we stand, but it's people like you who have been so dedicated to this task for so many years that have brought us to this point where we have a good program in place, and we want to make it stronger, and we want to recognize the good work it's doing. And we recognize we still have a lot of work yet ahead of us.
Thank you.
I see Representative Carpino has a question or comment.
Thank you.
Thank you, Mr. Chairman. Tom, I just wanted to say hello and to say thank you during the pandemic. Not only did I have the opportunity to take Tom's training, he was kind enough to give me some extra time and do some training for individuals within my district, and that will never be forgotten. I thank you then, and I'll thank you now for your time and your dedication for sharing a bit of Tyler with us. And I see that graphic behind you again, and didn't know if you wanted to tell the committee members about that. It was something that I took away from your training, and I thought it was very, very powerful.
Thank you, Christine. Yeah, this is a drawing that my son Tyler did while attending college. He was a junior at Savannah College of Arts and Design, and it's his kind of rendition of the Van Gogh Starry Nights. And so I kind of lean oversized. You can take a peek of it. He was a growing artist. He showed a lot of love and compassion. He loved people, and we miss him every day. We really, truly do. But I hope what I can bring to the table, not only his story, but we need to save the Tylers of the world going forward, and so having his drawing in the back kind of keeps me close. And when people ask me, I love to share, because he truly was a great kid. Thank you for
sharing a part of your gifted son with all of us.
Thank you.
I don't see any further comments. Again, thank you for your good work. We're counting on you going forward to keep us going in the right direction, and we're hopeful we can have a real impact on suicides in the state. Thanks again, Tom.
Thank you. I'm honored to do it.
Next up is Andrew Herapol, followed by Sheldon Taubman.
Good evening. My name is Andrew Herapol. I represent several retail convenience stores and liquor stores. I am opposing the Senate Bill 367. Banning the sale of vapor products could shift sales of these products from law-abiding retailers to potentially illegal sources who do not check IDs. We are navigating through difficult times, and the state trying to take away yet another item in our mix that we sell, which will yet again knock us small business owners down. We take IDing very seriously and do not want to risk selling to a minor. That is our sole job, to make sure that these age-restrictive items don't reach our children. As a parent, this hits home even more so than before. We join programs like Pride to help educate our staff to identify possible minors trying to make an illegal purchase. We also have 3D scanners integrated with our registers that allow us at the point of sale to stop the sale once we scan their ID and we scan the items. Then it asks us to follow up with an ID check. And if without that ID, it would not allow you to sell the item. Taking away these products from our control will lead to illicit markets, people driving to different bordering states, buying product and selling it to our minors and anyone else who may be of age so they can get what they want. Once they leave the state to make their purchase that will no longer be legal in this state, they will make all purchases out of state, such as gas, other convenience items, and products. This Senate bill is almost no different than the menthol ban that was trying to take place earlier. All reasons against it basically falls in this exact bill. With that being said, I guess one main takeaway from this is what's the difference between the flavored tobacco and the vape versus the big alcohol companies promoting attractive flavors to kids such as watermelon, fruit punch, and lemonade. Once again, my name is Andrew Herapol, and I am opposing Senate Bill 367. Thank you for your time, and good evening to you all.
Thank you for your testimony today. We really appreciate it, and for your hanging out with us as long as necessary to get it across. Thank you. We appreciate the fact that you feel very strongly we're impacting your business. I don't see any other questions, so have a great evening.
You too.
Next up is Attorney Taubman, followed by, I'll get to that in a minute.
Representative Steinberg, my camera's not working for some reason, so I'll just begin speaking, I guess.
I think we all remember what you look like, Sheldon. So go
yeah,
ahead.
you're exactly. Okay. Good evening, Representative Steinberg, Senator Anwar, other members of the Public Health Committee. I'm Sheldon Talbot. I'm litigation attorney at Disability Rights Connecticut. We are the protection and advocacy system for Connecticut, serving individuals with a full range of disabilities. I'm here to testify about the impact of HB 5275 and SB 331 on people with disabilities. I do have more detailed written testimony, but just to highlight a couple of things. In Section 331, Section 1 requires a report by DDS on how to expedite services. This will benefit people with disabilities, but we want to ensure there's stakeholder input that will be particularly helpful for them. Nothing about us without us, as is often said. Section 6 is clarifying the proposed requirement of a mental health examination. It's important for there to be informed consent on this so that people with disabilities are respected in informed decision-making. Mostly, I want to speak to you about Section 7 and 8 of 331 and 5275. First, the term step therapy is not about concerns that a person get the right kind of therapy or even about therapy at all, but rather it's a tool used by insurers to control costs by requiring patients to first try and fail on cheaper drugs before they're allowed to pay payment for a drug that their physician or other provider prescribed. Insurers don't interfere therapeutically unless it will be cheaper for them. It's like calling capitation prepayment and then pretending it's no longer capitation. A far more appropriate term for this cost-cutting technique is fail first. It's particularly problematic to use it for people with mental health conditions because, as you already heard, this is a very challenging situation for providers. Some behavioral drugs are capable of causing not just serious, but even permanent side effects. The experimentation for the insurer's financial benefit may reasonably cause some of these reluctant individuals to give up on any medication entirely. And in any event, delay from this will bring unnecessary suffering, placing them at risk of harm and costly institutionalization or even suicide. There is another bill, SB 415, pending before the Insurance Committee, which would provide an exemption for any drug prescribed for a behavioral health condition or a chronic, disabling, or life-threatening condition or disease. That would benefit other people with disabilities. And I note that the Medical Society submitted testimony saying we should get rid of all fail first. But recognizing the reality for providers of patients with behavioral health conditions in a difficult pharmacological environment, the severe side effects of these drugs, and the frightening results of delays in appropriate treatment, exempting these drugs from fail first will significantly improve access to appropriate therapy. I think I'm out of time, but I would be happy to respond to a couple things said by the industry. One is that there's somehow an automatic override. There is no such thing in the law. I'd be happy to walk through the statute to explain that. And the other thing that was said is that there are unscrupulous providers. Let's just posit there are unscrupulous providers. That makes absolutely no sense as being relevant to the whole step therapy fail first issue. But I don't have time to get into those things. So thank you very much for the opportunity to speak to you. Thank you for staying so late. I greatly appreciate it and happy to answer any questions.
Well, thank you, Sheldon, for all the good work you do representing those who are often most vulnerable. We appreciate that. We appreciate your support of our efforts to try to work through many of the misconceptions and myths relating to how we're able to get patients to the right treatments. Any questions or comments? I don't see any, so thank you again for staying with us. We really appreciate it, and we look forward to seeing you again soon, which I'm sure we will.
Thank you.
Next up is Giovanna Mazza, followed by John Kostakopoulos, which I just blew terribly, but I'm sure you know who you are. Giovanna.
Thank you. Good evening to the chairs and esteemed members of the Public Health Committee. Thank you for the opportunity to offer testimony regarding HB 5419, an act concerning DEMAS's recommendations regarding regional behavioral health action organizations. My name is Giovanna Mozo. I am here to testify in strong support of HB 5419 on behalf of the Connecticut Prevention Network and as the director of the Hub. The Connecticut Prevention Network consists of 5 regional entities known as the Regional Behavioral Health Action Organizations, also known as RBHAOs. The Hub, a division of RISAP, is the designated RBHAO for Southwestern Connecticut. RBHAOs were established in the spring of 2018 by DEMIS to maximize services and improve integration related to mental health and substance use program planning, training, advocacy, and resource development. After dismantling of the previous regional mental health boards and regional action councils were replaced with the new RBHAO infrastructure, while still fulfilling to the best of our ability statutory requirements. The RBHAOs continue to perform the previous statutory functions as strategic community partners who work across the behavioral health continuum in the areas of mental health, prevention and substance misuse, problem gambling, and suicide. Each RBHAO is responsible for a range of activities in planning, education, and advocacy of behavioral health needs and services for children and adults within one of the DEMIS's regions. The Hub is in support of the bill that establishes the structure and role of the RBHAOs across the state. Some of the previous accomplishments of the Hub in Region 1, but are not limited to, is annually awarding 14 local prevention council grants, up to 14 state opioid response mini grants awarded to local communities within the region, assist in coalition capacity building activities to address local substance misuse concerns. We continue to engage the voices of individuals with lived experience through supporting the ongoing catchment area council meetings. Over 1,000 naloxone kits distributed to various stakeholders in the region, provided evidence-based suicide prevention training, completed the 2020 priority report to address prevention, treatment, and recovery for behavioral health across the lifespan, established the regional gambling teams to increase awareness and promote integration, coordinate the regional suicide prevention and post-vention response teams, provided education and awareness on public policies and regulations at the regional and local level, serve as a strategic partner and liaison between local, regional, and state initiatives, attended over 100 meetings in each quarter every year. The Hub and my counterparts work hard to be at the forefront through our countless relationships and submission of annual reports to DEMIS on priority service prevention, treatment, recovery, and mental health service needs, which are instrumental in 2 of Connecticut's federal block grants. We urge you to pass the bill.
Ms. Lazo, your time is almost up. Thank you.
Thank you. We urge you to pass the bill to support Connecticut's prevention infrastructure and sustainability. Thank you, and I can answer any questions that you may have.
Thank you for your testimony, Giovanna. You're finally getting codification in statute. You've heard that DEMIS is dedicated to assuring that we have a federal funding stream. But given all the different responsibilities you just enumerated, all the things you've taken on, particularly since you were created as a combined entity more recently, is that enough funding? Is this getting it done for you? Are you doing the job that you are being entrusted to do? What could you be doing if you had adequate funding?
I think as a nonprofit, we are doing the best to our ability. Is there enough funding? No, there isn't enough funding. However, I can say I started as a RAC, Regional Action Council, back in 2016, and I was a one-woman show, doing a lot of the things that I've stated here today. But then I also had only 4 towns that I needed to focus my efforts on. Now we are dealing with 14 towns. And I'm sure you've heard my other counterparts, my team members of the Hub today talking about different bills. But I can say that I'm not a woman of a one program show. I have multiple people behind me now doing the work. However, we have been able to get funding from other revenues, right? From other agencies. So that's how we really try to expand the work that we are doing. So yes, we do need more funding so that people, at least program coordinators, will be able to really just focus on one topic of the behavioral health realm of topics. And that's hard because we're stretched thin. I like to say that I'm playing Gumby all the time, every single day, being stretched. And at this point, it depends on what the priority is, of course, in the day.
Thank you for that. I'm sure your days are quite varied. I see Representative D'Amico has his hand up.
Yes. Thank you, Mr. Chair. Thank you, Ms. Mazzo, for coming to testify. So I wanted to ask you just one question about the catchment area councils. So it has been suggested today in a couple different testimonies that we received that even though the catchment area councils still exist, that there's not enough lived experience of people, with experience to evaluate the efficacy of the mental health services. Do you find that to be the case under this new arrangement, or not?
So I do think that we are lacking, and I can't speak for my other counterparts, okay? I can only speak for Region 1, and that is something, when the regional mental health boards were dismantled and the RACs, a lot of people stopped coming to the table because they were so upset about the infrastructure and how it changed. And then, of course, the changing of the guards, right? So there's a lot of relationship building that we all need to do, and that is taking place. However, that takes time, building relationships, getting to know people. And sadly, we're in a pandemic where that actually impeded on a lot of our building of relationships with a lot of people. But for Region 1, I do know that that is something that we always talk about, and we try to build capacity that way. Under the statute, it says 30% of the committee members need to be or have some type of lived experience, and that's the goal always.
Okay. Enough said. I wanted to bring up that issue and give you an opportunity to explore that a little bit. But thank you. I appreciate it. Thank you, Mr. Chair.
Thank you, Representative. And again, thank you for your good work, Giovanna.
Thank you.
We all know the good work the hub does, and I can only imagine what it's like trying to take care of 14 towns, but we really appreciate it.
We appreciate you.
Have a great night.
Thank you.
We'll see you next time. Next up is John Kostakopoulos, followed by Nick Carden.
Hi there. Thank you for having me, and thank you, Madam Chair, Mr. Chairman, and distinguished members of the committee. I'm John Kostakopoulos, and I'm here in support of House Bill 5396. Although I'm in New York, Connecticut has a very special place in my heart, as I lived there for a few years while I attended the Salisbury School. In 2015, I was the first study participant in an NYU Langone clinical trial researching psilocybin-assisted therapy for alcohol use disorder. I never experimented with psychedelics out of pure fear, but at the time of enrolling in the trial, I had already tried all available treatments for almost a decade, none of which worked. With nothing to lose, I applied for the clinical trial. The research team at NYU Langone saved my life and cured my alcoholism, and I don't say that lightly. I haven't had a drink since my first psilocybin session, and I haven't used psychedelics or any other drugs, illicit or prescription, or needed any other therapy or medical attention since completing the clinical trial. This treatment worked like an antibiotic. I went into the study suffering from a disease. I did psilocybin-assisted therapy, and I was cured and haven't needed help since. Due to my fortunate experience from this research, I launched an education and advocacy nonprofit called Apollo Pact with other study participants and a former Republican member of Congress, Mimi Walters. Launching Apollo Pact is my deal I made with God. I was so desperate before the trial, I promised myself that if this therapy worked, I would do everything I could to make this accessible for others. As some of you know, Apollo is the deity of light and healing, and the work we're doing is our pact and promise to help others, hence the name. This committee and the great state of Connecticut have a wonderful opportunity to lead the nation, help solve the mental health crisis, and save lives. Thank you for your time, and I will be happy to take any questions.
Thank you for your testimony and for its directness. We appreciate the experience you've been through. We've heard so many stories today of people simply desperate for a good answer, and it's very gratifying to hear so many people have been helped. And we take your testimony very seriously. Thank you. I don't see any questions, so thank you for being with us today. Have a great evening, and we really appreciate it.
Thank you.
Next up, we have Nick Carton, followed by Susan Oosterman.
Thank you. Co-Chair Abrams, Co-Chair Steinberg, ranking members Wang, Summers, Pettit, and members of the Public Health Committee. My name is Nick Carton, and I work at Juul Labs as a Senior Manager of State Government Affairs. On behalf of Juul Labs, thanks for the opportunity to testify regarding SB 367. We're concerned that several provisions of the legislation would lead to significant negative consequences, such as an increased or sustained cigarette use, reduced switching to potentially less harmful products, increased cross-border sales, reduced tax revenue, and a proliferation in illicit trade in black markets. Juul's mission is to transition the world's billion adult smokers away from combustible cigarettes, eliminate their use, and combat underage usage of our products. To succeed in that mission and to preserve the harm reduction potential of vapor products, we're focused on listening and building constructive relationships with regulators, policymakers, and other stakeholders. The U.S. Food and Drug Administration provides extensive federal regulatory oversight of tobacco products, including vapor. FDA has exercised this authority by issuing guidance related to flavored vapored products that removed all non-tobacco, non-menthol flavored cartridge-based products until authorized through a pre-market tobacco product application, PMTA, which you've heard several times today. FDA can also regulate nicotine content and delivery of such products through the PMTA process or by establishing a tobacco product standard. The PMTA process is a rigorous science-based process conducted by career scientists and technical experts, which we believe is the appropriate forum to determine the role of vapor and other innovative products can play to transition and completely switch adult consumers from combustible cigarettes. FDA has issued guidance related to flavored vapor products in January 2020, which removed all tobacco non-menthol flavored cartridge-based products until authorized through the PMTA process. As it stated, the agency's decision sought to strike public health balance by maintaining vapor products as a potential off-ramp for adults using combustible tobacco, while ensuring these products do not provide an on-ramp to those underage. FDA did so after careful consideration of the data and made the decision to continue enforcement discretion as to both tobacco and menthol flavored vapor products pending PMTA review. The agency can regulate the flavor of any new tobacco product, including vapor products, through the PMTA process by determining what flavored products, if any, will be authorized. In July 2020, Juul submitted its PMTA for the Juul system to FDA, as well as proactive data-driven measures that address underage use of our products. We believe our robust submission will help inform the FDA's science-based decision on whether to continue marketing of Juul's system is appropriate for the protection of public health, accounting for both adult current users of tobacco products and non-users, especially those who are underage. FDA has made significant progress in its review of the PMTAs, taking action on about 93% of the total timely submitted applications. As of January 2021, the FDA has issued market denial orders for more than 1.23 million vapor products and issued a marketing grant order for a tobacco flavored product. Applications for products with the largest market share, such as Juul, remain under review. As a number,
Mr. Carton, your time is almost up. If you please summarize. Thank you.
At the very least, we believe any state level restriction on flavors should provide an exception for tobacco and menthol. We also believe state level restriction on flavors of nicotine concentration should provide an exception for any vapor product that receives a market order from FDA after going through this rigorous process that I've discussed. Thank you for your time, and I'm happy to answer any questions.
Nick, thank you for your testimony. It's staggering just to consider that they've already turned down 1.2 million products, which tells you the magnitude of what we're dealing with here. though I think we're all concerned. It's really about the if and when FDA gets to some of the thornier aspects of issues still remaining. So that's why we're here and we're talking about it. Senator Anwar.
Thank you, Mr. Chair. Thank you so much, Mr. Carton, for your testimony. You have spoken before. I wanted to ask you, with your company, Juul, what they had done with the marketing for the children. Is there something that you would like to be able to say in this testimony about the wrongs that may have been done by the company for our benefit?
Sure. And it's actually part of our PMTA application as well. But I think what you're referencing to is when Juul really first came out onto the market, there was a brief campaign called Vaporized at the time that has been displayed in many news outlets. It was a colorful campaign that included what looked like young people that ran for a very short period of time. And while we're not necessarily proud of the campaign that was run, it quickly did come offline. However, we know that the youth usage of our products was unacceptable, which is why the colors in the campaign actually mimicked the flavors that our products or our company sold at the time. Before FDA actually issued its guidance around cartridge-based products like ours, Juul voluntarily took our flavors, such as mango, fruit. We had a variety of other flavors off the marketplace because we knew that the youth usage numbers were unacceptable. And so, as part of our PMTA application, we actually dive into the publications in areas where we would potentially in the future market or advertise our product, and they are primarily focused in places where our adult combustible cigarette consumers already exist, or places where tobacco is already advertised. But I do know the campaign that you're referencing, and I'm happy to provide more information in my written testimony, which I've already submitted as well.
So there's a formal recognition that wrong was done to the children of our state and the country.
I wouldn't say that it's a formal recognition of wrong that was done. I think in retrospect, we would have used folks who looked and were older in the advertisement that we used. We realized that, when our product was first in the marketplace, there were aspects of the campaign that, were not out there for its intended use, and youth then got access to the products. But moving forward, we're really laser focused on making sure that youth don't have access to the product.
Well, at least what I would say is where you may not say it, but I will say it on my behalf, not on your behalf, but my behalf, that Juul did wrong and harmed our children in our state and our country. And a lot of them have been addicted to nicotine since that time. I recognize that the company has rebranded itself and is working towards being more responsible. So I'm watching very carefully about the positioning. I think that the menthol part should still go, but then you've been smart enough as a company to try and remove all the other. You have far better data than what some of the scientists may have, which and I know, and most of the people on this public hearing and the Public Health Committee know. And as a result of which, you guys have gone ahead and removed all the flavors already, being proactive, recognizing what's at stake, and that was going to be the end of your company altogether if you did not do that. And I think menthol is where you're looking at the market share, but that's also the market share that is the gray zone, and that's probably the area that I hope the rest of the committee will join and say, look, if it's going to be dangerous for the children, it's not worth it. But I wanted to thank you for your testimony and thank you for at least accepting that wrong was done. Thank you, Mr. Chair.
Thank you, Senator. Yes, Juul has progressed, but has a ways to go before necessarily you've earned everybody's trust to do the right thing going forward. But thank you for your testimony. It's really important that we hear from all parties. I don't see any further questions, so we'll continue on to Susan Osterman, followed by Michael Madden.
Hello? Hello?
We can hear you, Susan. We can't see you.
Hi, I can't get my camera on.
But we see the lovely flower and
Is there somewhere I can turn it on? I only have a microphone icon.
Okay, well, we may have missed your opportunity to take advantage of us being able to see you. So if you
Okay.
don't mind, why don't you just go ahead?
Okay. Good evening, Mr. Chairman, distinguished members of the Connecticut Public Health Committee. My name is Susan Osterman. I'm here to provide testimony in support of House Bill 5396, an act increasing access to mental health medications. I appear here today from Bensalem, Pennsylvania, because this is an issue that affects us all, and my hope is that Connecticut will continue to lead the nation in public health solutions and others will follow. I want to share with you some of my son's story. My son, Tyler, was a kind and radiant spirit. He lit up the room with his genuine smile and his optimistic outlook on life. His concern was always for others. He never hesitated to go without in order to provide for someone else. He often brought friends and strangers home on holidays when they had nowhere else to go. He was very forgiving and an empathetic person. He always looked beyond people's actions to see what caused them to be hurtful. Although he was immature in some ways, he was also very wise beyond his years. He was adventurous too. He tried everything, every sport, game, religion, and food. He had no fear. But he fought a silent battle with anxiety. He began experimenting with drugs after high school in an attempt to ease the pain. And thanks to the flood of prescription opioids in our country, it wasn't long before he began injecting heroin. As is true with most people, my son didn't use drugs to be high or escape responsibility. He simply wasn't equipped with the tools that he needed to manage his addiction or his anxiety. He received traditional treatment on over 15 occasions, and at one point he maintained sobriety for almost a year, just long enough to walk me down the aisle in 2019. As any parent of a child with a life-threatening condition, I dove headfirst into research. We tried everything: Suboxone, medical detox, sober housing. None of it worked for my son. I learned about psychedelic-assisted therapy from a trusted physician. The treatment would cost close to $10,000, but was not offered in this country. I was hesitant to receive medical care abroad, but it had a great success rate, better than anything in our country. He was excited. But the pandemic struck and we couldn't get his passport renewed. Soon after, Tyler developed endocarditis and required heart surgery. This precluded him from receiving the specific type of psychedelic-assisted therapy that we were pursuing. On October 5th last year, he relapsed again. He came home, but we sat and talked, and it was probably the best conversation we ever had. He explained so clearly how he felt like he had no control over the drugs. He got no pleasure from using, but he couldn't stop it from controlling his thoughts, no matter how hard. We planned to start fresh in the morning to look into other options. He walked to the corner store and he didn't return. After about 30 minutes, I went to look for him. Seeing his lifeless body on the bathroom floor, less than an hour after him telling me about his desire to be free, I finally understood at that moment what he had been telling me for years about addiction stealing his free will. He suffered from the disease of addiction, a disease that this country, the healthcare system, is not currently offering any viable solutions. If psychedelic-assisted therapy had been available in the US, my son might be here to tell his story of recovery. He wanted so badly to make his family proud, and I couldn't be prouder of my son. He was the kindest person I ever met, and I miss him every day of my life. We have a moral obligation to offer as many life-saving options as possible to people. It's time to be proactive in saving lives rather than reactive. That has cost us almost a generation. Please pass House Bill 5396, and thank you for your time today.
Well, there are simply no words for us to all express our heartbreak on your behalf. He sounded like a wonderful person. I'm just glad he was there to be able to walk you down the aisle. But we've heard too many such stories of people struggling against a disease that seems to always have the upper hand, no matter what we've been able to offer people. And we take your words very seriously about making sure the next person has more options that may lead to a longer life and a better outcome. As you imagine, it's as hard for us to listen to your story as it is for you to deliver it to us. But it was really important that you did so. It strikes very much close to home for many of us. I believe Representative Parker would like to say something.
Thanks, Mr. Chair. Yeah, I thank you so much, ma'am, for sharing your story. I just want to echo the sentiments of Chairman Steinberg, and to thank you for sharing with us testimony that's really connected together so many issues we've been hearing about today. This is a reminder of how interconnected all of these issues are and how interconnected our solutions have to be. So just want to send you a heartfelt thanks for taking the time to share with us tonight. We'll be thinking of you and your son.
Thank you.
That's all the questions we have. Have a good evening, and thank you for testifying today.
You too. Thank you.
Next up, we have Dr. Michael Madden.
Thank you very much. You can hear me okay?
Yes, we can.
Great. Okay. So I'm a family doctor and former chief medical officer of a multi-state managed care company serving Medicare and Medicaid populations. I've worked extensively on issues such as opioid addiction, HIV, and smoking. While Reynolds has compensated me for my time in preparing my testimony, let me be clear that the opinions expressed are my own. I speak today in opposition to the portion of SB 367 that would ban the sale of flavored vapor products. I urge you to consider the public health need to balance limiting youth access to e-cigarettes and the enormous potential e-cigarettes present for tobacco harm reduction. Smokers die prematurely, not because they consume nicotine, which is not a carcinogen, but because of how they consume it in a combustible form. Leading health authorities have agreed that vapor products may substantially reduce smoking's harms. Industry data show that more than 53% of adults who make the switch to vapor products choose non-tobacco flavored products. Youth should not be clear. I want to be clear. Youth should not use tobacco products of any kind in order to prevent illness and death many years in the future. But today's adult smokers can reap the greatest benefit from moving away from combusted cigarettes to vapor and other modern nicotine products. Solid public health laws should balance the needs of both groups. The state and federal laws banning the sale of tobacco products to those under the to ban it to those under the age of 21 are the proper tools to address youth access to these products. Enforce them aggressively. CDC data collected just in 2021 suggested that they are working. Youth experimentation with vapor products, that is any use in the last 30-day metric often cited by the bill's proponents, has dropped more than 60% in the last 2 years to just 11% of high school seniors. And reported just last week by the CDC, the youth smoking rates are at the lowest levels ever recorded. Only 1.5% of youth had used a cigarette even one time in the prior 30 days in 2021. References for these data are in my written testimony. Remember that the prohibition for all age groups has not worked for alcohol or marijuana, and it won't work for flavors. True tobacco harm reduction should reduce smoking deaths in the near future, and it requires a broad array of non-combustible tobacco products be both accessible and appealing to current adult smokers. There is no data that flavor bans reduce youth use. I urge you to reject this proposal that would limit the choices available today to adult smokers in Connecticut. And I'm happy to answer your questions.
Thank you, Doctor. You made mention of the fact that this is not anything having to do with the carcinogenic qualities of combustible products, but aren't you equally concerned about the path to nicotine addiction by young people?
Nicotine addiction certainly can be a concern, but the question is balancing that concern versus the other. I think one of the points some people have made about that is that vapor products are a gateway to cigarette smoking. Well, given that every year that's gone on over the last 5 or 10 years, the rate of combustible cigarette smoking continues to decline in youth, there is no gateway effect that seems to be evident in the real data. Could some become addicted to vapor? I think that is a possibility, and that's the thing that we have to try to balance. But remember that those, if there is a long-term impact of vapor smoking, vapor use, I should say, that's many, many years in the future. And right now we've got people dying of cigarettes, and we need to do something to help them as well. So it is a balance. There's no question, Representative. Both are important issues.
Thank you. I see Senator Anwar with his hand up.
Thank you so much, Mr. Chair. Dr. Madden, what is your financial relationship with the Reynolds Company?
As I said at the beginning of my testimony, they do compensate me on an hourly basis for the time I spend preparing and giving testimony.
And could you tell me what this company does?
What Reynolds does? You're saying?
Yes.
Yeah, it's Reynolds American, and so they produce both tobacco products as well as a number of vapor products.
So why are they paying you for your time?
Because their current policies are to offer to current combustible smokers the option of using a vapor product. And they do have a vapor that has been approved by the FDA through the PMTA process. In fact, the only one at the current.
But Dr. Madden, I don't think you heard my question correctly.
Okay.
Why is a tobacco company paying you money for your time to come and speak to the Public Health Committee?
Because they do have a vapor product. They want it to be able to stay on the market, and they would also like to see less death from combustible cigarettes.
And do you mind my asking?
I'm probably not the right person to answer that question, but that's how I would surmise their interest in that. Yeah.
And do you know how much are they paying you per hour, sir?
I do.
And you're willing to share? I just want to know what the market price is nowadays.
It's $275 an hour, which is similar to as an executive for a managed care company.
Okay. Again, thank you for coming, and good luck with your future endeavors. Thank you, sir. Thank you, Mr.
Thank
Chair.
you, Senator.
I see Senator Summers has a comment or question.
Yes. Hello, Dr. Madden. I had a question about the approval that the company has to go through. What is the actual labeling on the vapor product that is approved by the FDA? Is it a smoking cessation device, or could you expand on that a little bit?
Sure. The official title is that it's appropriate for the protection of public health. So this process is not necessarily to look at a product as a cessation product, but as a lower risk product for current smokers.
Okay, product appropriate for.
That's actually the exact wording, is appropriate for the protection of public health.
Okay, and then what products do you have that have this? I'm sorry, was it a PMTA? Is that what you called it?
Yes, the PMTA process, very extensive process. Some of the other speakers I know have referenced it, but that's the process that every vapor product had to apply to the FDA to achieve that status in order to be able to stay on the market. So anything that will stay on the market going forward does have to have that designation once they finish that process. And it's thousands.
Is that similar to a pre-market approval for other medical device that you go through, and it's millions of dollars to get that approval for the FDA to clear you to be able to sell it? Is that correct?
So pre-market approval is different from the PMTA process, because that's before it's on the market. This is a process for after a product is already on the market. But
okay, so it's on the product and you go through
the very extensive process, which is why the large number, 6 million, have been rejected because they didn't provide the appropriate amount of data to the FDA to achieve that status.
So do you know, and maybe I'm getting too in the weeds here, but on this PMTA process, do you have to submit, safety and efficacy?
Absolutely, yes.
Okay.
Yes.
And so the FDA has approved a certain number of these products to be sold as appropriate for the protection of public health. Do your products that work in your device, do you have the flavors that we're talking about here today, or do you just have non-flavored products?
So currently, the only one that has that status from the FDA is tobacco flavor. There are additional applications that the FDA has not decided on for menthol, and so others are still under review. But the one that has been approved is the tobacco flavor.
So it is possible that this legislation could ban flavors per se, but allow this PMTA product that is just a tobacco flavor to be allowed on the market, which has the labeling and the approval from FDA that says it's appropriate for the protection of public health.
Correct.
And,
I think the concern about the other flavors is, as I said at the end of my testimony, to encourage current smokers to move away from combustibles, they really need to have products that are available and acceptable to them. And a menthol cigarette smoker may not want to move back to a tobacco flavor, for instance.
Okay, thank you for that. That clarifies a lot, about the process. And so you are saying that there is no fruity flavored product that has gotten this PMTA clearance or approval from FDA at this point in time.
Correct.
Okay, that's very clear. Thank you so much for your testimony. I appreciate it. And with all due respect, I do think it's inappropriate to ask somebody what they're earning per hour. We have a lot of people that come to this committee that are an advocate or a lobbyist based on whatever their interest is. So I don't think that we should pick depending on how we personally feel and ask people those questions. I find that inappropriate. Thank you.
Well, thank you, Senator, but I do want to be transparent with you as I can. And I hope it's a good demonstration of the ability of why I will be completely transparent with you about what I know.
This is not to you. It's just, I think it's inappropriate. So, for us to do that, we don't ask, Tesla advocates and everything what they earn per hour. So I just think it's wrong. Thank you.
Okay. Thank you.
Representative Pettit.
Thank you, Mr. Chairman. Thank you, Dr. Madden. Did you say right in the beginning that you were a family practitioner first?
Correct.
So maybe a global question. You're number 143, so I've heard from a lot of people today. So flavors aren't banned. What, as a family practitioner, took care of people with lung disease, tried to get people to quit smoking, what would your approach be if you could craft the legislation or law to try to help things? What would your approach be?
If a patient came to me and said, I want to quit smoking, and I would say you should use the FDA approved products for quitting smoking as well as getting counseling. That's really well accepted as the best choice. We all know that not every patient makes the best choice. Some of them don't really want to give up completely the sensation that they have of something in their hand, moving things in and out of their mouth, what they do during conversation. And so if that person is unable to quit with tobacco cessation devices that are approved by the FDA, then vaping is a reasonable alternative for harm reduction. Just like I don't think people ought to ride motorcycles without a helmet. But on the other hand, if they're going to ride a motorcycle, I hope they use a helmet.
But taking it a step further from a policy point of view, so you would allow nicotine containing vapes and some flavors, and how would you control it from the kids, and what other things would you put in place to control public safety?
You all have relatively recently, of course, moved to 21. And we don't know all the things that contributed over the last couple of years to the really dramatic drop in youth use of vapors. But I think that's a big one because high school students were probably getting it from their 19-year-old friend or cousin or whatever. So that 21 law is really important at decreasing youth use. I think that controlling where they're sold, controlling advertising, all of those things are the things that the FDA is putting in place before they will give a PMTA approval.
I appreciate that. Thank you, Doctor. Thank you, Mr. Chairman.
Thank you, Representative. And I'll just leave you, Doctor, with the fact that we're still struggling in the state of Connecticut to get a law passed to require helmets when you're riding a motorcycle.
Harm reduction is a difficult concept for a lot of people to accept, whether it's tobacco or narcotics. I mean, Suboxone is a harm reduction tool. It's not a cure, and vapor is a harm reduction tool.
Well, thank you for your testimony and have a great evening.
Okay, thank you. Thank you for hanging in there on a very long day.
Yeah, this is what we do regularly, which we got a question. Next up is Abigail Friedman, followed by John Martin.
Hi, can you hear me?
Yes, we can.
Fabulous. Thank you for having me, chairs and esteemed members of the Public Health Committee. I'm Dr. Abigail Friedman. I'm an associate professor of health policy at the Yale School of Public Health. I've come to testify before you regarding Bill number 367 as both a Connecticut resident and an expert on the intended and unintended effects of tobacco and nicotine policies. I want to be clear that I do not now and never have taken funds from the tobacco or vaping industry. None of my work has ever been retracted, let alone due to misrepresentation of the analysis or findings, and my statements should not be construed as a position of Yale as an institution. As a public health researcher and a mom, I want our state to implement policies that have the best chance of minimizing tobacco-related disease and death. Since the bulk of scientific evidence indicates that e-cigarettes are less lethal than combustible tobacco products, like conventional cigarettes, achieving this goal is going to require careful attention to how e-cigarette policies impact smoking. In this respect, e-cigarette flavor bans pose two key concerns. First, that they might increase youth use of more lethal combustible products, and second, that they might reduce smoking cessation among existing smokers. And there's evidence supporting both of these concerns. In the first case, multiple studies show increases in youth smoking after San Francisco's flavor ban went into effect. And I'm the author on one of these studies, and I know you've heard prior testimony and commentary on it today. I hope you will ask me to discuss the reasons why those comments are misleading, because I don't want to spend all of my time talking to you defending that work. Instead, I'm going to focus on the fact that that's not the only paper that shows this evidence. So there is a paper by Yang et al. That finds increases in smoking among 18 to 24-year-olds following San Francisco's ban. There's retail sales data that shows increases in cigarette sales following state flavor bans. Also, these results are consistent with a longer line of literature that shows that when we make e-cigarettes less accessible or more expensive, it tends to increase youth and adult smoking. So the concern about flavor bans' effects on youth smoking is substantive, and it doesn't hinge on a single paper. If you look at adults, we have multiple studies showing that smokers who take up flavored e-cigarettes are more likely to subsequently quit smoking than those who use tobacco-flavored e-cigarettes. There's also evidence both from randomized controlled trials, so the gold standard, and from meta-analyses, which are looking across studies, that link habitual vaping to increased smoking cessation. And obviously, if you tried an e-cigarette once, we wouldn't expect that to cure your existing addiction to cigarettes. So it would be habitual vaping that you would expect to need to show this relationship. Given smoking's lethality and the health benefits from quitting, this should warn us that flavored e-cigarette bans may risk millions of adult lives. Now, critically, youth and adult tobacco use are not independent, and I would hope that people would pay attention to this, because I know anyone here who's a parent knows this. Not only are 18 to 25-year-olds considered in these adult smoking studies, but also getting adults to quit smoking is good for kids. The primary risk factor for kids taking up tobacco products is parental use. So the reason that I'm coming here is not to say don't regulate. Actually, the exact opposite. I think Connecticut can regulate better. I think Connecticut can be at the vanguard on this. For example, there are alternative policies that are likely to reduce youth smoking and youth vaping without reducing adult smoking cessation. One example would be restricting the sale of all tobacco and nicotine products and their accessories to adult-only venues. This would drastically decrease.
Your time is almost up. If you please summarize. Thank you.
So this would Thank you. This would drastically decrease children's exposure to these products, adolescents, and temptation for adults. And it's actually a stronger version of the Oakland policy that you heard Ms. Liu describe earlier as evidence that flavor bans work, because Oakland's policy is not the same as what's being proposed in Connecticut. I would love to speak more, but I know my time is up.
Well, thank you Professor, for respecting the time limitations. I have to confess that after today's testimony, I think we need a meta-analysis of all the meta-analyses, because we've kind of reached that point. But I see Representative Foster wants to engage you as usual.
Thank you, Representative Steinberg. Dr. Friedman, I have a couple of questions. My first is, I'd love for you to expand upon what you think would be an effective policy. And before I have you do that, I'd like to sort of take a moment to say that we've heard from a lot of different entities with a variety of different biases and motivations and reasons for advocating for a specific policy. But as you sort of talk about what your goal in this policy is, you said you'd like to see public health gains, you'd like to see less smoking, but you have no financial interest in seeing continuation of use in tobacco products. So can you sort of explain to me what you're proposing and why?
Okay, so, and this should tell you I don't have alternative interest, because what I'm about to propose is basically going to piss off 90% of the people who like what I said already. All right, so what I mentioned was Connecticut restricting the sale of all tobacco and nicotine products and their accessories to adult-only venues. This would be the ideal case. And the reason this is an ideal case is because it drastically reduces incidental exposure. So where kids see this in passing when they're getting a snack at a convenience store, it also reduces adolescent access, but it also helps adults who don't want to be confronted with temptation to purchase an e-cigarette when they're going to the pharmacy or the grocery store. And the policy in Oakland was actually not a full flavor ban. This policy that you heard earlier described by Ms. Liu in her paper that hasn't yet been published as evidence that flavor bans work. That policy exempts adult-only tobacco stores. So it literally is, it's almost exactly what I'm saying, but what I'm saying is a step further. I'm saying move the combustible products too. Now, there is a lighter version of this because I know that's a really hard thing to pass. An alternative to this would be to say that if you are going to sell nicotine tobacco products or their accessories in a store where kids can enter, then those products have to be stored out of sight and you can't promote them in the store so that adults could still buy them, convenience stores could still sell them, but no kid is going to accidentally come into contact with it in that context if the store is behaving legally. In that scenario, adult-only retailers can still behave as they would like with respect to putting their what they're selling on the shelves and promoting in store, because kids aren't going to see that, right? There are options that reduce youth use, are great for adults who are trying to quit, and don't take away options from adults who are using reduced lethality products. Now, I actually think that that's a great way to go. I think it's a wonderful option. I think it's good for everyone. I think politically it's probably more tenable than what I would prefer, which is just only sell them in adult-only retailers. But it would definitely reduce exposure and access among youth, and it would help adults who are trying to quit. It also offers a benefit that an e-cigarette ban can never offer. And I want to be really clear about this. E-cigarette bans will cover e-cigarettes, but the next hot nicotine product is not going to be an e-cigarette. And then we're going to have another delay where the government doesn't act and kids have access until we act. But if you put a policy into effect that applies to all products that contain nicotine and their accessories, and someone should ask me what I mean by that, then you've preempted the next novel product that our kids might be exposed to. And that would put Connecticut at the vanguard of policies to reduce youth use and protect adults.
So one of the things that I've heard a lot of folks talk about today, which I think is really important, that is like a academic sort of nuance thing that not everyone would get, is about how expertise is variable. And a lot of different people have displayed their credentials today as relevant. Can you explain to me about the type of research you do and why it is different than some of the other academics who have presented their findings?
Yeah, and I will try to explain this without using jargon as much as possible. I'm a health economist by training. I'm specifically trained to, and my research focuses on, using policy variation from state and local policies in the US to identify a causal effect when you can't randomize of policies on behavior. You've seen plenty of people who have PhDs who are studying association. That's very important. You've seen plenty of people who have MDs. I am specifically trained in running policy analyses to look at the effects of state and local policies on behavior. And I have focused my research on tobacco and nicotine products. This is what I do.
I appreciate that explanation. I think that a lot of times folks also are sort of jarred when someone presents a finding that's different than their institutional knowledge. There was a specific faculty person, or former faculty person, I should say, an important distinction, who spoke significantly earlier today, who had some retractions of papers. And we don't need to go into who and what. I would like to sort of talk a little bit about the peer review process that you have engaged in a paper that people have talked about, where people are allowed to provide commentary, and you were allowed to, by a peer-reviewed journal, respond back. So what does that mean in that peer review process, and what did that look like?
So that basically means that I submit a paper, or my colleagues and I submit a paper, and the editor chooses experts in the field who are not affiliated with us. So they can't be people that we work with, they can't be on the paper, et cetera, to anonymously review and give feedback on the credibility and the conclusions of our work. Those individuals, it's always multiple, it's usually 3, sometimes though it can be up to 7, depending on the journal, write the editor both a letter that I get to see as the author and a letter the editor gets to see, which I don't know what it says, with their recommendation. And if the editor feels that the combination of expert opinion is legitimate, they usually ask you to revise it. They don't immediately accept because there's always something that needs to change. And then you have to run additional tests and revise the paper. And if it's accepted into a journal, then it's either accepted or there are more revisions. It's an iterative process, and it does make a big difference, right? There's a joke, you'll see people walking around with t-shirts that say, what do we want science? When do we want it after peer review? Because even the best researchers make mistakes. And I can tell you, the first time I started the first time I started studying e-cigarettes, I did not expect these results. I tried 6 ways to Sunday to figure out why I was seeing that when you restricted youth access to e-cigarettes, we found more smoking. I know people that also tried a million ways to try to break those results because they didn't like their conclusions. I am not interested in anything other than what's true and what will best serve the health of our communities. So I will be the first person to stand up if my work is discredited and say so. In fact, I will happily write a letter to go along with the paper that does that. But the weight of the evidence is very consistent in showing that if you're going to reduce access to e-cigarettes or increase how much they cost, and you don't do anything else, if that's the only thing you change, you're going to see an increase in smoking.
So, Dr. Friedman, my last question for you this evening is, you've asked us about accessories, and you have made this reference to the flavor card. And so one of the things that we're talking about doing in this policy is a ban of the vape products in particular. But one of the concerns with that policy initiative is that people who are already addicted to vape products will switch to combustibles. And people will say, well, but if we're restricting flavors, perhaps then they won't have an appetite for combustibles. Can you tell me a little bit about a flavor card and what that is and why that is the next frontier of tobacco product concerns that we have?
Right, and I might even, if you're in the EU, it's already a present issue. A flavor card is essentially a card that you can put into your cigarette pack. You leave it there for a certain number of hours and it imbues your cigarette with whatever flavor is on it. It's not marketed as a tobacco product because it doesn't have nicotine in it. And so what we're going to see in the next 10 years, which I can already say because we know this, are more people being able to flavor their own cigarettes so they can get around bans that way. And probably at some point, some kind of additive that's similar for other tobacco products. And a ban on e-cigarette flavors isn't going to do anything about that. We have to start thinking the way the industry is thinking. And the industry is thinking, well, people like flavors. Let's find a way to get them to people without the nicotine so they can add them to our addictive products. If we want to forestall that, and I think what that is, I can't say because I haven't been able to get data on this yet in the US, but I think what we're going to see is exactly that people who liked cherry flavor, whatever, are going to find a cherry flavor card and put it in cigarettes and switch towards that if that's their option. I think what we have to start doing is thinking about nicotine and tobacco products and their accessories as a category, because there are too many workarounds and we are playing whack-a-mole. The best way for us to avoid playing whack-a-mole is to have a universal policy that affects every product that has nicotine in it and anything that is categorized as an accessory, and empower some kind of definition of how you would tell, or someone who can decide at the state level whether something should be categorized as an accessory.
I really appreciate your testimony today. And before I sort of end my questions, I want to say first, I've been really impressed and sort of like blown out of the water by your ability to sort of to dissect and disseminate your research findings to policymakers who have a variety of different expertise. And I know that a lot of times with policy, it's easy for us to say, like, to look for something that's a broad stroke application, but it sounds like what we need here is a scalpel and not a mallet, and that might give us more lasting power for this policy change. So I really appreciate your ability to talk to me. I know that you're willing to talk to other folks, so I hope people will take Dr. Friedman up on this opportunity. And I also hope that people will take a moment to sort of think about the context and skills that the variety of people who have testified before us have today, because I think there has been a lot of attempts to promote one or another that have been done in a way that's sort of malice. And I really encourage people to take some time to talk to Dr. Friedman. Thank you so much for your time. I see Dr. Pettit has his hand raised, so I'll put my hand down. Thank you.
Thank you, Dr. Representative Foster.
Thank you, Representative Foster. No, nobody would enter into today's debate with any sort of bias or promoting any particular point of view. We just don't do that. Representative Pettit.
Thank you, Mr. Chairman. Dr. Friedman, thank you very much. Very on point, very, very measured. Really appreciate your testimony. No big question other than I'm hoping you've submitted your testimony. When I just looked online, I didn't see it. Maybe I looked in the wrong place, but hopefully you will submit it so that we're able to review it again. Thank you.
I did submit it today, but it may not be up yet. If it doesn't go up, please tell me and I will resubmit it. Would be some problem. Representative Steinberg, if I may, you asked a question earlier that no one could answer, that I ran the data for you while waiting my turn in line, and I'd like to answer it for you, if that's okay.
That sounds like a gift. How can we not take it?
So you asked essentially, where are these kids getting e-cigarette products? The 2019 YRBS has state representative data for Connecticut. So I pulled up the state representative data for Connecticut, and it asks the kids, where did they primarily get their vaping products? So if you look at under 18-year-olds, and I'm saying under 18 because 2019 is when Connecticut passed their T21. So I just want to make sure that we're looking at an age group where the policy on access didn't change. 42% of under 18-year-olds who vaped in the past 30 days in Connecticut report borrowing their vapor product from someone else. 18% report buying them from brick and mortar stores. 16% report giving someone else money to buy the product for them. 11% say a person age 18 or older gave them to them, which to me sounds like borrowing from someone else, but you get the point. If you look at minors who vape daily, it looks a little bit different. You get more of them saying brick and mortar stores, about 29%, but still 24% report giving someone else money to buy them on their behalf. 17% say 18 or older age person bought them for them. 9% say they borrowed them from someone else. So this is not to say that we shouldn't be restrictive about retailers' ability to sell. We very much should. It's just to say that we have to remember what it's like to be an adolescent. They're pretty good at finding workarounds.
Thank you for that. And I am very much intrigued by your offer to help us craft policy that would address all nicotine products, regardless of delivery system.
I would love for us to get that done before my daughter's a teenager.
We're not going to ask how old she is, but we have work to do in either case. Thank you for your testimony. I don't see any further questions. We're in the home stretch, but we still have, I think, another 8 or 9 to go. So we're going to thank you and wish you a good evening.
Thank you very much.
Next up is John Martin, followed by Bright Johnson.
Good afternoon. It's been a long day. Can you hear me okay?
Yes, we can.
Okay, great. My name is Dr. John Martin. I'm a professor emeritus of psychology and a former professor of psychiatry at 2 major U.S. medical schools. I'm a licensed clinical psychologist specializing in addictions and health behavior change. I'm here today to express my concern over SB 367, an act concerning electronic nicotine delivery systems and vapor products. As principal investigator, I've been awarded more than $4 million in federal and state research grants on smoking assessment and treatment and health behavior change, some of which was cited in the Surgeon General report on nicotine addiction. I published approximately 70 scholarly articles, 20 book chapters, and 2 books in the areas of smoking, behavior and treatment, alcohol abuse, and health behavior change. I was responsible for the largest clinical treatment program for recovering alcoholic smokers ever conducted, the findings of which were published in flagship psychology and addictions journals. My research group was among the first to address the question of compensation and smoking topography as it relates to treatment. My statement today is addressed in greater detail in my written testimony, supported by recent studies from major scientific journals. In the meantime, from my public health perspective, I have the following 5 major concerns with this proposed law. First, there's a growing scientific consensus that e-cigarettes are substantially safer than combustible cigarettes, presenting a real opportunity for tobacco harm reduction. By capping nicotine at 3%, you will eliminate a key harm reduction treatment choice for those of us in the trenches who treat smokers through gradual reduction approaches. Second, e-cigarettes have proven effective in smoking cessation, outperforming nicotine replacement products by a margin of 2 to 1. Third, clinical evidence suggests users of e-cigarettes, whether for quitting, cutting down on their smoking, or deciding just to not become smokers at all, e.g. youth, frequently find that the lower nicotine concentration products are considerably less satisfying and lacking in the ability to reduce their urges to smoke. In fact, a recent abuse liability study showed that users of a 5% nicotine product had a greater reduction in urges to smoke than users of a 3% nicotine product. Fourth, as demonstrated by 3 major recent controlled studies, capping nicotine concentration exposes users to greater levels of potential toxins because they will compensate by taking more or longer puffs to achieve their desired level of nicotine, thus defeating the harm reduction benefits of e-cigarettes. Fifth and finally, it should be noted that the FDA is already reviewing all these e-cigarette products and will evaluate whether flavored products and at differing nicotine levels are appropriate for public health. Respectfully, this legislation may be premature and could potentially undermine the process of achieving tobacco harm reduction, both in the short run and the long run. I've been compensated for my time here by R.J. Reynolds, but my comments are my own. I hope that my presentation will help guide your decision-making on this very important public health issue. Thank you for giving me the opportunity to speak to you today.
Thank you, Doctor. Yeah, we've been waiting on the FDA for a number of years. We've been talking about premature for so long. We could have had this policy in place for 5 years by the time they're going to get around to actually ruling on it, which is very frustrating to us, as we might imagine. Let me ask the question that I believe Senator Onwar might ask. You're listed as president of Smoke Fade Incorporated. What is Smoke Fade Incorporated?
Well, that's the gradual reduction approach to treating the most high dependent smokers that I developed in the university, in my time in the VA hospital, at medical schools. And then when I retired actually twice from the university and medical school settings, I took the program that I had developed, and it's now online as smokefade.com. But the smoke fade means that we can gradually reduce people's dependence, including the behavioral breakdown that we do. So we fade the habit down step by step. Initially, we change people's the cigarettes from higher nicotine substances and yield to lower step by step to get them down to the ultra lows, where we found it easier for them to jump then to zero by doing it that way.
Yeah, you make the argument that data suggests that people are on a better path at 5 than they are at 3.
Yes.
Using that argument, why wouldn't you argue for 10 then? Because then they would get fewer toxic puffs.
It's a good question. I think there's a significant difference between 5 and 3. Maybe we don't want to push that too far, On the other side, that we don't want people to be taking more nicotine than necessary to produce the effect that we're seeing. And I think that 5% is more consistent and similar to what a smoker will get from a combustible cigarette.
Thank you. I see Senator Anwar with his hand raised.
Thank you, Mr. Chair. Dr. Martin, do you mind if I ask you a few questions?
Sure.
Tell me, let's focus on children for a second. Do you believe that nicotine is safe for children?
Well, safe is a difficult term, but I would say I don't agree with giving nicotine to children. And I don't think the vapes it's a good policy to allow children to be vaping. So I'm completely in support of requiring people to be adults to be able to use the vapes as well as cigarettes. So is it safe? I would say no, it's not completely safe. Although a lot of the studies are showing that it's not nearly as harmful as we might have otherwise thought. So I think it's probably a good idea to not promote it with children.
And you said you're a professor at 2 medical schools?
Yes, I was, and the VA as well.
What kind of a professor? What was your specialty?
I was a professor of psychology at the universities and a professor of psychiatry and preventive medicine at the adjoining medical schools.
Okay, so it's not like lung diseases or things that would actually give an insight into the deterioration of those functions. Okay.
No, I'm a behavioral scientist. So my specialty was helping people to change addictive behavior.
Yeah, that's a very critical part. The other question was that when you tell me your understanding of the on-ramp of this nicotine addiction for the children right now with the flavored vapes. Based on...
Yeah, I think social psychology has a role here. There's peer pressure. When we look at what is the on-ramp for kids, it may be nicotine, but it's more likely to be social, psychological, and behavioral factors. We know that the kinds of youth who take up smoking are risk takers. These are the same kids who try illicit drugs, who take risks in other lifestyles. So nicotine could play a role, but only kind of in combination with this risk-taking and other sorts of social and peer pressure forces.
And so after they are on ramp, when they get addicted to nicotine, then it's difficult to get rid of that. Do you agree that nicotine is addictive? Okay, good. Thank you.
And it's why I'm so in support of options to help people to get off the combustible cigarettes or to never go there. And I know there's a question of, is that an issue if they start with vaping? Do they frequently go on to actually smoking combustible cigarettes? We find that a large percentage of do not. There are some who obviously do. But ultimately, I work with adults, smokers. I don't want this tool to be taken out of our hands where we can use a level of nicotine in the vape that they would find satisfying, and we could do the fading more to drop the combustible cigarettes, go more to the vapes, and then we step you down on the vapes, hopefully to be nicotine and cigarette free.
So if you can give me shorter answers, I want to get to a place hopefully.
Sure.
But when you say that you're against removing flavors, so do you know adults using bubblegum flavor to give up cigarettes, combustible cigarettes?
I have heard of that. It's a literature it's just new, and so I'm not really prepared to talk about that. But we do know that can be a preference for adults. They like the sweetness, although we certainly know that's true for menthol and some other flavors, tobacco being one.
And do you know why are tobacco companies hiring individuals and to try and stop the sale of vapes because the tobacco industry should be promoting their combustibles. So why are they interested in spending so much money at this time?
Well, I think it makes economic sense since society is moving away from combustible cigarettes. In America and in the West, for sure, we know that. There's more government restrictions, if not laws, and maybe down the line, who knows, maybe the combustible cigarettes will be banned. I know there's been efforts to do that. It's still a legal product.
That's a good idea.
Yeah, and so
that's a good idea.
At this point, vapes are legal, they're useful, and they don't nearly have the risk as compared to the benefits right now. And we hope that we'll wait, maybe not indefinitely for FDA, but that we'll wait for more research. It's a complicated issue.
It's not that much complicated, but I want to ask you, what do you know about lead time?
How do you mean that?
When there's a latency period between an exposure and a continuous exposure and a disease development.
Yeah. And
so I think in psychology, we may not study that much, but what happens is, I'll give you an example. In the 1950s, there were doctors and professors, and actually it's important to look at that. And anyone who's listening, they should go and look at the doctors in 1950s used to do. They used to actually promote the cigarettes. Yeah, they used to promote and say, this is safe product and use this. The reason was when in the 1930s or so, when people started to smoke, there was a latency period before the cancer and other illnesses developed. So till 1950s, it was great marketing. It was the time that we're living in where everybody is in the latency period. So doctors and individuals come in and they market the products because the cancers haven't started, because it takes a long time for the cellular breakdown in the cancer development.
Yeah,
so that is part of the situation that we are in, because we have not had the latency period. And right now, knowing that there have been latency periods for asbestos, where people said asbestos is the best thing that has ever happened, except 30 years later, we found it was one of the worst things that happens. People in 1950s, the doctors used to say it's one of the best things. It soothes your throat, it helps you. And then you had cancers, and you had an increase in the number of cancers, the cohorts that we know. And it's well-known recognition of those epidemiologic studies that have proven that.
You bet.
So as a result, right now, because the vapes have not been there for that long, we know their immediate problems. We know immediate terms, they're causing respiratory problems, they're causing asthma exacerbation, they're causing various illnesses of the respiratory tract, including infections. But they're also leading to more cases of COVID when the people actually were vape users. So I'm sure you've looked at that data. So that data is there to show that there's a problem, but the long-term issue is real because the lungs were not made for these fumes and not for flavors. Wouldn't you agree that we would have lungs were not made for that purpose? They were made for breathing. Can we at least agree on that?
Indeed, and especially in youth with developing lungs and a developing brain.
Okay.
Although I think some of the conclusions that that the vapes are so harmful to the lungs and to the whole respiratory system, I think are not balanced. And I would love to suggest a review that I could send to you, the most recent comprehensive review by a group of distinguished tobacco researchers. And it sort of covers the balance of the risks and the benefits. I think maybe with suggestions of what kind of legal efforts we should make, but I would love to send it if you have interest, and especially given your passion for this area.
So again, we're in the midst of a latency period. There are illnesses that it can lead to. And again, what we can do is probably, why don't you send me the review, but I just wanted to make a few points, and I just wanted to help people recognize that there are cohorts and there's a latency period and there's immediate health effects as well.
Could I mention one thing that in the research on the harm, especially to youth of vapes, apparently, they're finding that there's a corruption in the data. in the sense that a lot of those youths where they found damage, they were also using other illicit drugs. Sometimes the THC in marijuana was corrupted by other substances. And I think we should look at that data with that in mind. Let's make sure that it was the vape and the nicotine that was doing the harm.
Yeah, no, I know about that part. So
Sure.
that's a different data set that we're looking at.
Sure.
Thank you, Mr. Chair. I will stop here.
Thank you so much.
Thank you, Senator. One more question for you. Representative Berger-Gervallo hasn't said much today, so your opportunity.
I was talking when you were in another one before. Thank you, Mr. Chair. And thank you, Doctor. I just have one question, and actually you've kind of circled back toward it just at the end of Senator Anwar's last question. You talked about how the youth who vape tend to be children who are natural risk takers, even imply that they're the ones who are using in tandem with illicit drugs. Do you have a study that you can share that has that information? My experience with my high school age children and their peers does not reflect that in any way. And in fact, for many of them, the only risk-taking behavior that they demonstrate is vaping. It is not, and these are athletes and kids who are strong academics and don't actually go down that path. So I would love to know if there was some sort of study.
A great question. My studies have not gone in that direction. I'm more of a clinical interventionist, but I'm familiar with the literature, and there's kind of it's two parts there. The ones who vape and go on to be smoking, oftentimes doing it together, they tend to be more likely to be the risk takers. All right, with other issues, maybe other drugs that they're doing. The ones that are not, shall we say, at higher risk, that tends to be more an experimental phenomenon. They're just finding out what vape is like, and they have friends that are vaping, and they do it for a temporary period of time. Again, the review I'm going to send to the other Senator Anwar, you might be interested in that, but it's the latest one in American Journal of Public Health of August of last year. It's the most thorough review, and it touches on that.
And it touches on it with reference to actual data and actual studies.
Absolutely, yes.
And that, we would definitely. I think everyone on the committee would probably like to see
Great.
that.
I think it would be helpful. You're committed to doing the right thing, and you don't want to do harm. I have an article I've been writing on doing harm to harm reduction. So I think we want to be careful not to go too far in our efforts to protect, that we might actually be resulting in more people going back to tobacco combustible.
With all due respect, I think to look a mother in the eye and say you never want to go too far in our efforts to protect is probably a little presumptuous, but
okay.
Thank you very much.
You're welcome. You're welcome.
Thank you, Representative. Seeing no further questions, Doctor, thank you for sharing time with us today. We look forward to your sending any information that will help us in our deliberations. We do want to do the right thing, and we appreciate your understanding.
Thank you.
Next up is Bright Johnson, followed by Gregory Conley. Bright, where you been all day?
Waiting patiently. I'm Bright Johnson, Connecticut Government Relations Director for the American Cancer Society Cancer Action Network. We have submitted longer written comments on HB 5364, so I'd like to use my time to hit upon a couple of main points. First, we are incredibly gratified and appreciative that the committee raised this bill. It is a bipartisan issue, and this year there are a number of bills relating to tobacco control funding that have been raised that all told have over 50 co-sponsors from both sides of the aisle. I'd also point out that for the first time in my 15 years on the job here, Appropriations has raised a committee bill in support of restoring tobacco control funding. The need is clear. Tobacco-related diseases are the single most preventable cause of death in our society. Yet according to DPH statistics, tobacco use continues to kill more people in Connecticut each year than alcohol, AIDS, car crashes, illegal drugs, accidents, murders, and suicides combined. Tragically, 4,900 adults will die in Connecticut from tobacco use this year. That's 13 per day. Connecticut spends $2.03 billion in healthcare costs related to tobacco use every year, including $520 million in Medicaid expenses. Connecticut is tied for first in tobacco taxes, but is last in tobacco control and prevention funding. In fact, we are the only state that does not allocate state funds to help people quit and to help prevent kids from ever starting to use these products. With that reality at the forefront, we are asking that the bill be amended to restore $12 million in funding for statewide tobacco control programs that follow proven CDC best practices to help alleviate and reduce the staggering annual economic toll tobacco use costs Connecticut. Over the years, just over 1% of the cumulative total that has been deposited into the Tobacco and Health Trust Fund was actually spent in support of tobacco control programs and services. Since its inception, the fund has been raided, swept, or it had funds redirected over 80 times. And in 2017, the fund was eliminated entirely. We would therefore also urge the committee to insert stronger protections in the bill to prevent future raids, redirects, transfers, and sweeps. The Centers for Disease Control and Prevention recommends Connecticut invest $32 million annually in our state tobacco control program. Yet we have not spent that much cumulatively in more than 2 decades. As the governor said in a 2019 press conference when asked about the diversion of funds for tobacco programs, that's got to stop. Continuing on the path we are on now will ultimately do nothing to address an entirely preventable problem. Restoring funding for proven and effective tobacco control programs aimed at educating parents and kids and that reduce tobacco use is critical so our children can grow up not as next generation tobacco users, but as the first tobacco-free generation. Thank you.
Thank you for testifying so quickly. I see Representative Gilchrist has a question or comment.
Thank you, Mr. Chair. It's a comment. Just wanted to say to you, Bright, thank you for your ongoing advocacy all these years. It sure does take time, right, to move the needle, but you've been so persistent and beating the drum of the need for this investment. And I just want to thank you.
I appreciate that very much. And if I could just make one comment about, we've been waiting on FDA action for decades, really. And for the last 10 years or so on e-cigarettes and whatnot. But I would point out that the Master Settlement Agreement was agreed to over 20 years ago, and there are still existing lawsuits that are preventing various aspects of it from being followed through. And if the FDA does end up banning flavors or taking further steps, you better believe there will be lawsuits that will delay implementation of these regulations for potentially years.
Thank you, Representative Bright. Before I turn it over to Senator Anwar, I want to put a stake in the theory that we don't have $12 million in the bill. If you look at Section 2, lines 79 through 88, it's in there. It's convoluted, but it's 12 million.
I saw that, but I'm concerned about the language, the language differences between may, the board may allocate those funds as opposed to shall allocate those funds. That's the fatal flaw of the master settlement. And the reason why so much of that money has been diverted is because the master settlement says that money may be spent on the healthcare costs related to tobacco use, not shall be spent. If we simply had shall in there rather than may, I think that would alleviate a lot of concerns. I do have one question that I'd like to ask you if I could. And that is, the bill early on says that the transfer of funds from the tobacco settlement fund to the general fund, and then $4 million will be left over, and any remaining funds. Have there ever been remaining funds? My concern is that there won't be remaining funds that will equal $12 million of availability.
Well, since I don't have the answer for you, I'm going to say you're not allowed to ask me questions.
Okay, I'll save that one for appropriations, where it's probably a little more appropriate. My apologies.
Not at all. Senator Anwar.
Thank you, Mr. Chair. Good to see you, Bright. And
good to see you too.
Thank you for waiting the entire day. Bright, I just wanted to say that how can your testimony be complete without giving some data and numbers and percentages of cancer and so on? So I'm missing that because every time you come, you tell us the probability of cancers with different activities.
That's a good question. Our written testimony, I think, goes into more detail about some of the specifics. According to the U.S. and I'm looking at that right now. According to the U.S. Surgeon General, smoking is a known cause of cancer of the oropharynx, larynx, lung, trachea, bronchus, stomach, liver, pancreas, kidney, cervix, bladder, colon, and acute myeloid leukemia. In fact, smoking is responsible for an estimated 25.3% of cancer deaths in Connecticut. I don't know if that answers your question specifically. I can get you, we produce a document every year called Cancer Facts and Figures that delves more specifically into the percentages, and I'm happy to share that with you if you'd like.
Yeah, we'd love to get data from you, which is very helpful. And the other part I wanted to mention is, can you speak to the latency period? As American Cancer Society, do they have latency period issue? For example, a few years ago, PFAS was okay. This year, we're trying to get rid of PFAS. You know how there's a time it takes for cancers to develop and people wait for them till we start to develop and then we go back and clean things up? Is there anything?
Go ahead. I'm sorry.
No.
Well, I think you hit the nail on the head with the prior speaker to me in that, we have short-term results, we have some midterm results, but with electronic cigarettes and vaping products, we have no earthly idea about the long-term results because those products haven't existed for long enough to have to have that data yet. E-cigarettes were approved for sale in this country, I believe, in 2007. So we have less than 20 years of information to go with. And the fact that they were largely unregulated for so long with so many variations out there in terms of the nicotine level in these products and the products themselves not being regulated, and so many variables and thousands and thousands of different flavors, thousands and thousands of different products. I think it's going to take a considerable amount of time for some of these emerging issues to reveal themselves. And again, I can see what I can find internally and share that with the committee as well.
Thank you. And about popcorn lung and some of the other parts too, so people, you can share. Sometimes it's better to come from you. Thank you so much, Mr. Chair.
Well, we've been doing this too long. When the mention of popcorn lung makes me hungry. Hopefully we're closer to the end here. I don't see any further questions. Thank you, Bright, for your patience and perseverance. We appreciate the ongoing dialogue about how best to proceed. Next up is Gregory Conley, followed by Michael Schoenfeld.
Mr. Chair and members of the committee, thank you very much for hearing from me. My name is Gregory Conley. I serve as the president of a Connecticut nonprofit called the American Vaping Association, which advocates for sensible policies towards vaping products with the end goal of eliminating smoking in America. And for that reason, we are here today to oppose SB 367 because it will needlessly impact adult smokers and ex-smokers throughout the state, all while opening up new black markets, while youth vaping, meanwhile, has plummeted over 60% since 2019. First, I would just like to take this opportunity to dispel a myth that was put forward earlier today by a graduate student from Harvard. She claimed, quote, adults don't need flavors, and that's what is shown in the literature. Just hearing that comment, I took it upon myself to submit written testimony to the committee a few hours ago with at least 5 different studies that have appeared in peer-reviewed journals over the last 3.5 years, all of which go to the fact that the vast majority of adults who have switched to vaping use flavors, value flavors, and in fact, in one study, 50% of the adult flavor users said that if a flavor ban came, they would either make their own or buy from the illicit market. So this isn't a product that people, if it's taken away from them by the government, they're just going to sit back and say, oh, well, guess I have to use tobacco flavors. Second, Senator Anwar, I'd like to address your concerns about the latency period. With regard to cancer, studies of the urine and blood of ex-smokers who switch to vaping consistently show that the carcinogen levels are often indistinguishable from non-smokers, never smokers. So there is a vast difference between the carcinogen exposure to a cigarette and that exposure from vaping. We don't have all the answers that we wish we had, but there's a reason why tobacco control professionals who have fought their entire lives against cigarettes, like Abigail Friedman, why they are encouraging you to take a step back. Second, there is no evidence linking vaping, nicotine, to lung infections. Those diseases were caused by illicit THC products. There's also no good evidence linking vaping to COVID. Just last year, the Mayo Clinic published a study with tens of thousands of patient records that found no connection between vaping and COVID severity, et cetera. There's been an inordinate amount of attention paid to the backgrounds of those testifying against this bill. In the spirit of an in-depth background investigation, I'd just like to point out that first, the Campaign for Tobacco-Free Kids, the leader of tobacco control in pushing this bill, they receive tens of millions of dollars a year from Mayor Michael Bloomberg, who is very clear that he wants all these products banned, and he's not going to support an organization that actually takes a thoughtful look at this approach. And second, the former UCSF professor that spoke, Jane O'Donnell of USA Today, extensively covered his retraction scandal, and BuzzFeed extensively covered his 2 sexual harassment lawsuits, including 1 settlement. So I would just encourage you, please speak to Abigail Friedman. We don't agree on everything, but she has the right outlook on this. She understands we need to help smokers and protect youth. Thank you very much.
Yes, and I understand there's no correlation between vaping and the death of Jimmy Hoffa either, but there are many things we still need to evaluate. Any further questions or comments? If not, thank you for your time. Oh, sorry, Representative McCarty.
No, I apologize, Mr. Chairman. I'm going to go very quickly. Could you just comment, because we've heard a number of times today that the drop in e-cigarette use with our students in the population, couldn't some of that drop be attributable to the fact that we were going through a pandemic and that many of the students were learning at home? They weren't socializing in the school environment. I'm just pointing that out to see if there were any studies that looked at what was actually causing the drop in the e-cigarette use.
That is a great question. First of all, just as others have mentioned, at the end of 2019, you saw President Trump, one of his last actions in office was to sign Tobacco 21 into law. And then we also had the PACT Act expansion restricting online sales. And what we found in the data from the 2021 NYTS, which is the National Youth Tobacco Survey, is that yes, there was a difference in the usage of vaping products when you're looking at students who took the test, took the NYTS, the survey, at home versus those who took it in school. So it was about 11.6% of high school seniors overall that had vaped in the last 30 days. If you're looking at people who took the test at home, you're at around 15%. If you're looking at people who, took the test at school, you're around 15%. If you're looking at students who took the test at home, isolated, you're looking more at the 10, 11% range. So yes, there is a variability between the students who have been living fairly normal lives going to school and those who were taking their classes at home, but the difference is not that wide. And we absolutely have seen this decline, and we believe it will continue.
Okay, thank you.
Thank you.
Thank you, Representative, and thank you for your testimony, Mr. Conley.
Thank you.
Seeing no further questions, have a good evening. Next up is Michael Schoenfeld, followed by Todd Bieri.
Hello, can you hear me and see me?
We can hear you. Unless it's very dark where you are, we can't see you.
Okay, let's try one more time. Hang on. Okay, I might have a technical difficulty, so I will just read if that's okay.
That's fine.
Okay. First of all, thank you everyone for your breakfast, lunch, and dinner to do what you're doing. My name is Michael Schoenfeld, and I'm one of the owners of Manchester Tobacco and Candy Company, a family-owned business since 1948. I'm testifying in opposition of SB 367. I want to be clear. I'm not opposed to tackling the vape epidemic with children, but I'm opposed to some of the details and verbiage on how this particular bill is drafted. In 2020, the federal government restricted pod-based vape system to menthol and tobacco only and prohibited all of the other flavors. They did this because pod systems were at the time is what kids were using. Today, it's disposable vape systems, which have thousands of flavors and are the newest fad among today's youth. This should be the focus of SB 367, closing the loophole that exists for these flavored disposable systems. The bill also goes too far by including menthol as a flavor. There is a reason the federal government left this flavor in place when it cut back all pod flavors. It's because it recognizes vape as a potential reduced harm product, not a cessation product, but a reduced harm product. Considering the enormous market for menthol, banning it would be an accident waiting to happen. Once outside the regulated market, Connecticut could not enforce, just like Massachusetts is experiencing now with all the flavors of tobacco. The proposed bill also does not allow FDA-approved products via their science-based PMTA process to be sold. For a vapor product to get PMTA approval, it must demonstrate it is appropriate for the protection of public health. Respectfully, if the FDA determines this, then why would Connecticut not want to have them available? I understand there's been a lot of anti-vape proposals over the past few years, but the truth is the federal government has taken sweeping actions since 2019 and continues to do so. I worry that Connecticut, in its zeal to do something, will go too far and create a series of unintended consequences that is ill-equipped to address and will contradict what the federal government is doing. This is dangerous for public health and puts wholesalers and retailers that I supply at a disadvantage. So banning menthol and creating a barrier for PMTA products isn't the answer. Now, if the state really needs to do something now, I suggest to apply the same restrictions used by the federal government to disposable products that are in place for pod-based systems. This would eliminate the exotic flavors that currently exist in disposable, even though the PMTA process will do this shortly. And it won't put our state in a position of having to enforce products that continue to be readily available in neighboring states and online. This will allow regulated adult vaping to take place while curbing youth access and appeal. The legal tobacco and menthol vapes will continue to allow a tax revenue stream in a controlled environment, which should be used for enforcement, education, and even new technology like utilizing verification ID systems. If we do that, we can all win by protecting the kids in our community, our businesses, and our state. In essence, Connecticut should compromise and fix the problem with a scalpel, not a chainsaw. Thank you very much for your time.
Thank you. I don't particularly care for the chainsaw illusion, but thank you for that. And if you have some good compromise language, something that will help us achieve our end by different means, we're very glad to look at it. So we encourage you to send that along. I don't see any questions or the like. It may be more of a reflection about our exhaustion than the quality of your testimony, but we really appreciate it and have a great evening. We do take very seriously what you had to say.
Thank you very much. And I really appreciate you guys staying until like 12 hours doing this. It's very, very commendable. Thank you.
Thank you. Not everybody on the committee thinks it's that commendable, but we'll do what we have here. Next up is Todd Bieri, followed by Matthew Diamond.
Greetings, Senator Abrams and Representative Steinberg and esteemed members of the Public Health Committee. You have to excuse me, I'm very nervous and tired, but I'll do my best. Giovanna Mozo explained beautifully in depth what, most of what I was going to say. The only follow-up I would have, I didn't say, my name is Todd Bieri, did I say that? Okay. Anyways, I'm a meeting facilitator for Amplify and also a member. I would like to support 5419 and also ask you to please restore the roles of the CACs in the study and evaluation of the delivery of mental health services, as this is a vital process of evaluation. I'd like to thank you for continuing to provide opportunities for people with lived experiences to advocate for systems of change, because our firsthand experience with behavioral system can inform you and all of us of issues like the efficacy of present treatment modalities and potentially shape future needed improvements. I also believe there should be more training for law enforcement by social workers so that people with behavioral issues and people in general can be given a more caring and compassionate response while experiencing a crisis. Most police officers are good at their jobs and could benefit from training from social workers, the training that social workers can provide. I'm proud to live in West Hartford. West Hartford has recently hired a social worker to go along with the police officers on mental health calls. But like I said before, I think this social workers could help in not just with the training for mental health clients, but also the public in general. My experience with Amplify CAC-18 has taught me that my experiences, good or bad, were not wasted, but have informed me and given me the opportunity to share my experience with you in hopes that in some small way I could contribute to the care and well-being of my peers. Thank you for hearing my testimony on HB 5419, Act concerning the regional behavioral health organizations. If you have any questions, you could refer to my testimony. I'm a little nervous about answering questions, but if you give me an easy one. No, I'm just kidding.
Well, I don't know why you were nervous. You did a great job. You touched on many of the key points of the bill that we're considering. We really do appreciate it. I see Representative Berger Gervalo has a question for you.
I don't have a question. I just have a comment. I just wanted to say, I remember the very first time I testified and I was terrified and I looked it. You did not. And thank you very much for sharing such personal and important information with us. And you did a wonderful job.
Thank you.
We look forward to you doing it again sometime in the future, but thank you for today's testimony.
Thank you. I appreciate it.
Seeing no further questions or comments, we will move on. And we have up next Matthew Diamond, followed by Thomas Burr.
Hello and good evening. Senator Anwar, Representative Steinberg, Senator Saunders, Wang, Representative Pettit, and other esteemed members of the committee. I'm Dr. Matthew Dumont, speaking on behalf of the Connecticut Chiropractic Association on House Bill 5430, Act concerning opioids. I just want to say, with respect to the lateness of this testimony, we as an association are absolutely delighted to support Section 1 of this bill. And the message you are sending to the public through the actions in this bill are just tremendous. That you don't have to just rely on drugs if you have pain, and that there are other viable alternatives. The bill is meaningful to me specifically. Excuse me, if I may. I actually lost a brother to opioids about 8 years ago, and I can't even imagine what could have been possible for him had that not actually been the case. So just, again, thank you for your work on the opioid issue. Each year, you do an amazing job enacting legislation. It's extremely helpful in combating this epidemic. And Section 1 of House Bill 5430 continues that trend.
Thank you for your testimony. Very succinct, to the point. We appreciate it. Seeing no questions, we'll wish you a good evening. Next up is Thomas Burr, followed by Marcia Dufour.
Yes, good evening, Senator Anwar, Representative Steinberg, and members of the Public Health Committee. My name is Thomas Burr, and I am the Community and Affiliate Relations Manager of the Connecticut chapter of the National Alliance on Mental Illness, NAMI, Connecticut. I am testifying today in support of the following bills: HB 5275, an act prohibiting certain health carriers from requiring step therapy for prescription drugs used to treat mental or behavioral health conditions. HB 5396, an act increasing access to mental health medication. SB 368, an act concerning suicide prevention. And HB 5419, an act concerning the Department of Mental Health and Addiction Services recommendations regarding regional behavioral health action organizations. Okay. NAMI, you should know, is dedicated to building better lives for those with lived experience with mental health illness in their families. NAMI Connecticut and its 9 local affiliates provide support groups and education programs for people with mental health conditions and their loved ones, and advocates for policies to improve the lives of people affected by mental health conditions. The committee leadership should have received some emails from our members echoing our written testimony that contains the facts, figures, and studies we cited. So I'd just like to briefly summarize our take on each of the bills. Regarding HB 5275, Step therapy is bad practice, even in the best of times, but especially now, while we are in a mental health crisis, it's time to stop this cost-cutting scheme. Insurers should not be experimenting with people's medications and health, period. Therefore, we support the passage of HB 5275. Regarding HB 5396, for far too long, Connecticut has seemingly been stuck with the standard treatment methods around mental health conditions with correspondingly lackluster results. We feel it is far past time to study different, perhaps even unorthodox treatments that show great promise. Therefore, we support the passage of HB 5396. Regarding SB 368, the Connecticut Suicide Advisory Board has been a tremendous asset for Connecticut in the area of suicide prevention for many, many years. NAMI Connecticut is proud to be a member of the CTSAB, actively assisting them in their mission, and therefore wholeheartedly supports the passage of SB 368. Regarding HB 5419, the regional behavioral action organizations were created just a few years ago when the regional action councils and regional mental health boards were combined. NAMI Connecticut as an organization frequently refers people to the RBHAOs when we get calls from people looking for service providers in a particular region. While we appreciate that these 5 regional entities will now be codified in state statute, what would be even better would be a significant infusion of funding, as their work is just so vital. It would also be good to codify the role of the catchment area councils and increase their funding, as well as the feedback function that they have historically performed in the regions is so vitally important. Therefore, we support the passage of 5419 with the proviso that the committee seriously consider these recommendations about increasing the funding. I would also draw your attention to the testimony of both Marcia Dufour and Margaret Watt, who are both former executive directors of RBHAOs and offer great insight. Thank you for your time and attention and for hanging out so long tonight, and I'd be happy to answer any questions you might have.
Thank you for your testimony. You covered a lot of ground in very efficient manner. We really understand your point of view and all that. I'll just disagree with you on one point. I'd rather listen directly to Marcia Dufour rather than refer to her testimony. And since